ಇವರೆಲ್ಲ ನಿಂತಿರ್ತಾರೆ ಹೆಂಗಿದ್ರು
Good morning, everyone. On this illustrious forenoon of 16th December 2023, I extend a hearty and warm welcome to all the dignitaries, faculty, and delegates to KRSSDI 2023. As we celebrate 20th anniversary of inception of KRSSDI, it gives me immense pleasure and privilege to invite all of you to this academic extravaganza that has been curated with care by Dr. Manohar, Dr. Vijay, Dr. Y.S. Ravikumar, and their illuminous team. At the outset, as it is a tradition of Indian culture, I would request Dr. Preeti Prabhu to kindly do an invocation and begin our academic program.
प्रणमामि गणनायकम् प्रणमामि गणनायकं वरदायकं प्रणमामि गणनायकं वरदायकं विनम्रश्रुतजन विघ्ननाशकं प्रणमामि गणनायकम् विक्रमोर्जित वक्रतुण्डं शिरोद्भूषित चन्द्रखण्डं विक्रमोर्जित वक्रतुण्डं शिरोद्भूषित चन्द्रखण्डं भारतरचनाकारणकान्तं भारतरचनाकारणकान्तं तरगृहपाशाङ्कुशेक्षुदण्डं प्रणमामि गणनायकं वरदायकं विनम्रश्रुतजन विघ्ननाशकं प्रणमामि गणनायकम् Thank you.
Thank you, Dr. Preeti, and I'm sure Lord Ganesha will bless us with knowledge and happiness throughout these 2 days of academics. As we begin this program, I would like Dr. Ravikumar YS to share few words of wisdom about the aim of this program.
Good morning, everybody. It's both an honor and a privilege to welcome you all to this prestigious conference. As the scientific chair of this event, I am thrilled to stand before you, a gathering of experts, professionals dedicated in advancing the field of diabetology. Our conference brings together clinicians, researchers, postgraduate students, educators, and healthcare professionals who play a pivotal role in addressing the challenges posed in diabetes. The conference is designed to provide a platform for exchange of knowledge, research, and exploration of innovative strategies in the field of diabetology. The agenda covers a wide spectrum of topics, from the latest advances in the diagnosis and management of diabetes to practical clinical insights, various workshops, debates, interesting debates, and discussions on emerging scenarios. As we engage in the sessions and discussions, let us keep the mind with broader implications of our work, which will ultimately improve the lives of millions of individuals affected with diabetes. I encourage you to actively participate, share your insights, and forge new connections. The success of this conference lies not only in presentations, but also in the conversations and collaborations that take place within this wall. Thank you for your commitment for KRSSDI, and I have no doubt that the knowledge shared and the connections made during this conference will contribute significantly to our collective mission of combating diabetes and enhancing the well-being of those we serve. I wish you a productive and inspiring conference. Let us embark on this journey together, united in the pursuit of excellence in diabetology. Welcome you for this 19th KRSSDI conference. Welcome you all.
Thank you, sir. Without much ado, we would like to start the academic sessions. And we begin this program with a very interesting session, which is aptly called as open mic. The word literally means a session where anyone is welcome to speak. And to chair this session, I request three dignitaries, Dr. Shekhar sir, Dr. Sanjeevra sir, and Dr. Sydney sir to be on the stage, please. And to present their discussions, we have three speakers with us, Dr. Linora, Dr. Shweta, and Dr. Nirnay N. Prasad. I hope all the three of you are here. Dr. Linora, I hand over the stage to the two dignitaries, please. Dr. Linora, Dr. Shweta,
A very good morning. Heartfelt gratitude to this esteemed stage and great congratulations to the entire team of KRSSDI and thanking for this amazing opportunity to speak at this lovely stage. And let me begin with the topic of impact of personalized medicine on this diabetes management. In the era of chat GPT and artificial intelligence, where everything, right from electronics to grocery delivery, personalization has become the core of its existence, but at the cost of a premium price. But when it comes to healthcare, it is slightly different since right from the beginning, we are personalized as one patient's prescription is relevant only to that patient with respect to the age of the patient, disease, comorbidities, or complications, or if it is a pregnant patient, or breastfeeding, or it could be or any other diseases that the patient is having. So how are we going to do different when it comes to personalization, and why do we even bother about personalization when this field, there was no choice of personalization or there was no mass customization which was possible? So the problem why we are having bothered about this is because every industry, there is a sweep of personalization happening at every industry. So before we begin, I'll tell you three cases from my own practice. The first case is 46 years old female patient, type 2 diabetic, recently diagnosed. And if at all we see her previous 6 months earlier report, she is not having diabetes, or it is hardly 5.8 to 5.9, that is pre-diabetic, not treated. And in a span of 6 months, she comes up at 10.8 as her HbA1c. And after repeated consultations, we hear that the patient witnessed her own mother's death. And after that, she developed health anxiety, and then immediately after that, she also gets to be diagnosed with type 2 diabetes mellitus. This is one case, and we started her on therapy and also with treatment hand to hand. Now the patient is able to control her sugars. Now the second case, where the patient is a 39-year-old male patient, is coming back from Australia after his work, and he has already tried keto diet for his diabetes reversal, where he was having 7.9, now it is reversed to 6.4 with keto diet. So he's coming here with questions on keto diet and asking, because he is unable to follow this keto diet with his homemade food or with Indian cuisine. So he's having a lot of questions on how to reverse pre-diabetes. Now this is the second case. Now the third case is a nightmare of every doctor, I would say. Person with Apple Watch and comes with sleep tracker and diet tracking, calorie count, step count, counting everything, tracking everything, and he comes up with lot of data to make sense. And he's also having a HbA1c of around 8.6. But he is not able to control his sugars, and he also uses CGM on his own without any expert guidance. He's just bought it from Amazon, and he thinks he can control his sugars with the data from the CGM, and he also reduces the medications based on CGM on his own. But he's unable to control his sugars. Now, these are the 3 case studies, and we can see that the common ground was diabetes, but on the background, all the 3 cases were entirely different, looks like a different department itself. So this is where the personalization of diabetes care seems important. Now, when I say personalized medicine, most of my colleagues or the diabetologists would think, is it slightly more oriented towards patient-centric? Because earlier, it was completely doctor-centric, where the diagnosis of diabetes was happening at the doctor's clinic or at a hospital setting, where the doctor was informing the patient, telling, you are a diabetic, so here the journey begins. Diabetes is forever, and you start taking medicines, or if at all medicines are not enough, probably in future you might also go for insulin. So this is the dietary recommendation, and this is the recommendation for the physical activity. But today, the patient's diagnosis of diabetes begins at their smartwatch or their applications. And they start having the knowledge through the WhatsApp University, or it could be YouTube, it could be an influencer who is speaking about diabetes and fitness, it could be their fitness trainers in the gym who is giving them advice on how to tackle their diabetes. So there is a hell lot of information on the background. So the moment the patient comes to a doctor with diabetes knowledge, the patient is already empowered with personalized data. So this is where today we stand at diabetes management, especially in metro cities like Bangalore. So now, can we make it completely patient-centric? Can we make it complete? Can we surrender this personalized medicine to the data from the continuous glucose monitor? Or can we just surrender it to some application giving us conclusions on how to navigate that data only? Why should it not be patient-centric, and why should it not be doctor-centric as well? I would suggest, or I would personally think, that this is a doctor-patient partnership that we are talking about, and neither patient-centric nor doctor-centric, since if it is patient-centric, then scientific data is given at a non-scientific end, and if it is doctor-centric, probably we are not looking at the data from which the patient is coming up with. So this is the first thing to understand, that it is neither patient-centric nor doctor-centric. Now, the second thing is, can we give up this personalized medicine completely to the wellness industry, since we know how many advertisements we are bombarded right from the morning to evening from the wellness industry? The reason why I would say it should not belong to wellness industry is because treatment cannot go to wellness, and treatment is essential for diabetes. This is not some weight management at its own, without any complications or without even developing diabetes. We are not talking only about wellness, we are talking about treatment of a disorder. And when it is treatment of a disorder, it has to be with a doctor's guidance only. So it can neither be doctor-centric, nor be patient-centric, nor belonging to the wellness industry. So how do we, so if every responsibility
May
is on the
because there is this time limit for these things, if you can wind up in 30 seconds.
Sure, sir, I'll do it. So if this is neither patient or nor doctor-centric, so how do we do and what do we do different? So we can have 2 teams. One is from the doctor's side, one is from the patient side for this doctor-patient partnership. From the doctor side, we can have psychologists, we can have special therapists if at all they are suffering from anxiety, depression, or a psychiatrist whenever they require it. And then we could also have a nutritionist, fitness expert, the diagnostics. And from the patient side, we could definitely have their data, we could have their fitness trainers, and we could have their family members as an essential component. So the doctor-patient partnership would give us a best and long-lasting results in the changing era of technology trying to take over, or the wellness industry trying to take over the diabetes care as such. Thank you so much for a wonderful
Thank you. Thank you. Any other? One more person? 2 more. Very nice. I would comment only one thing. Medicine lies in its simplicity. With all your AI and all those things, finally it is you and the patient which matters. And if the patient is with you for in the 20 years, I'll tell you that patient will be benefited because of the association between you and the patient. Thank you.
Okay, good morning, everyone. I was just wondering why it's called open mic. The young Turks of KRSSDI, Dr. Manohar, Dr. Arvind, and you have a group of people sitting here, I say LSM, etc. Do you know what is open mic? A mic that's not open to everybody. Invariably, it is defined as open mic concept. It's in a club where anybody can come and sing, dance, perform a stand-up comedy. I hope this was not a comedy. Now, you were talking about patient-centric and doctor-centric. Let me give two bit of mine. How many hours a day you live with yourself? Don't say 2 hours. It should be 24 hours. How many hours does a patient spend with the doctor? So, do you think it should be patient-centric or doctor-centric? I would go flat out patient-centric because it's the patient who has to live with himself or herself for the rest of the hours. Just 10 minutes, doctor-centric doesn't make sense. My 2 bits. The second one is, whatever you do at the end of the day, as my good friend said, the benefit should be offered to the patient. That's mine.
I will only say one important thing which everybody must realize. We as doctors always think to see what disease the patient has got. But you must also see what kind of patient the disease has got. So once you put this on the other foot, it becomes personalized medicine. So as the first thing you do when you tackle a patient is, what kind of patient am I dealing with? Some patients may be anxious, some patients may be irritable, some patients may be worried. So you have to first sort yourself out in your mind, what am I dealing with? The disease comes later. Because the fundamental adage of a physician is, comfort always, cure seldom.
Thank you, Dr. Shweta. I request Dr. Lenora to present her case. I think we have begun our session with a lot of discussion on the technology. That's a very interesting way of doing it because we have moved on and the discussion everywhere is about technology. We have a second presenter now, Dr. Lenora.
Is she there? Yeah.
Well, there is some glitch with her presentation. I would like to announce this to the postgraduates waiting here. We have the preliminary rounds in the Hall B, Nandi Hall, at sharp 10 o'clock. All of you, please be ready there by 9:50 because we have to wind up the session in half an hour. So any postgraduate here, please be ready.
See, there is a saying, never offer a mic to a retired teacher. ಅವರೆಲ್ಲರೂ ಮೈಕ್ ಆಸುರ ಆಗ್ಬಿಡ್ತಾರೆ ಅಂತ ನಾವು ಆಗಲೇ ಕೈ ಈಚಿಂಗ್ ಇಟ್ ಇಸ್ ಗೋಯಿಂಗ್ ಟುವರ್ಡ್ಸ್ ದ ಮೈಕ್ ಪ್ಲೀಸ್ ಆಸ್ಕ್ ಯಂಗ್ಸ್ಟರ್ಸ್ ಟು ಕಮ್ ಓವರ್ ಟು ದ ಸ್ಟೇಜ್ ಪ್ಲೀಸ್.
Dr. Nirnay Prasad.
Yeah, Dr. Nirnay, if you can finish your presentation in 4 to 5 minutes, that would be great.
Yes, sir, sure. A very good morning to all the esteemed delegates. Today, my topic is, are we doing enough? Okay. Yes, sir. My name is Dr. Nirnay Prasad, and the topic I've chosen for today is, are we doing enough for the safe disposal of diabetic supplies? Living with diabetes, as we all know, involves regular monitoring using various medical sharps. So it is very crucial to understand how to dispose of these sharps safely. These medical sharps include needles, syringes, lancets, insulin pens, infusion sets, and connecting needles of CGMs and infusion pumps. Why proper disposal matters? Improper disposal of diabetic supplies is a direct risk to our sanitation workers and wildlife. Unsafe disposal could cause millions of these sharps to appear in the municipal solid waste stream, posing a substantial health risk. Moreover, M-cresol, which is a chemical used to stabilize insulin formulations and a preservative to extend its shelf life, is considered as a hazardous waste. Therefore, it is of utmost importance that point-of-care education is necessary. A study conducted by Montoya et al. Indicated that 64% of the patients had not received education on safe sharps disposal practices, and 84% had never visited their municipal website for information on medical waste disposal. Hence, a broader health campaign involving the local municipal corporation, authorized medical waste disposal services, communication organizations, and healthcare institutions is the need of the hour. How to prepare for disposal? For the diabetic test strips, we would recommend use a puncture-proof container, label it as biohazardous waste, and store used strips safely until disposal. Do not overfill the container and seal it tightly when done. Store it in a safe and secure place, out of the reach of pets and children. Lancets and insulin needles. Again, here we would recommend a puncture-proof sharps container with a secure lid, making it leak-proof, labeled as biohazardous waste, or has used lancets or used insulin needles. After each use, the lancet or insulin needle should be carefully placed into the sharp container and never overfill the container, and never attempt to recap, bend, or adjust your lancet or insulin needle. For the waste generated from the use of CGM sensors and insulin pumps, different recommendations provided to patients from the various vendors can be followed. The local disposal options in India. They include the municipal collection programs, the authorized medical waste disposal services, community initiatives for the waste disposal. Incineration, autoclaving, and designated landfill sites are some of the commonly employed methods to dispose the waste. The regulations may vary across states and cities within India, but at a national level, waste disposal regulations are overseen by the Ministry of Environment, Forest, and Climate Change. Contributing to safe disposal, spreading awareness, sharing information online, collaborating with the healthcare providers, and organizing community workshops for education. Connect with the waste management authorities and advocate for improved infrastructure to support safe disposal, such as additional safe disposal drop-off and collection services, more accessible sharps collection points, or specialized collection days for medical waste. The conclusion, disposing of diabetic supplies should be done responsibly. We must understand our items and follow safe disposal instructions.
Very nice. I have one question for you.
Yes, sir.
How do you dispose of M-cresol?
Sorry, sir,
How do you dispose of M-cresol? It's hazardous.
Yes, sir.
What is the hazard to the humans?
So, M-cresol at a higher concentration, sir. The usual limit is 200 parts per.
What is the hazard?
So the hazard is it has shown to decrease the leukocyte count, and those receiving continuous insulin infusion, sir, it has found to cause subcutaneous irritation also, sir.
Skin irritation, that's it. So how do you dispose it of?
So there is an alternative to it called as methyl P hydroxybenzoate.
You please tell me how do you dispose it? Then we'll go to alternates and we'll bring some other Nirnay to talk to us about.
So the correct approach to dispose of M-cresol would be whenever we have the insulin vials and there's residual insulin, they must be processed appropriately by the waste disposal services, sir. It should not be it should not be part of the recycled material. It should not be part of the recycled material program. It must be put into a separate category, and that is how we can.
Very nice. I really like your self-confidence, but please find out how it is disposed.
back to you with the exact answer, sir.
Very good thought. As doctors, we also don't advise the patient as to how to dispose this. We tell them how to give an insulin injection, but never tell how to dispose things. I think fault lies with us as well. Having said that, I think most of the hospital, they have the policy that it shouldn't be a problem in the urban area. What about rural area? Is it still a problem? How are you going to confront with that problem now?
So for rural areas, we have to bring in a broader campaign where we have to bring in the healthcare
From
provider.
where? How do you do the campaigning? That's where probably media comes. Instead of spending a lot of time on political news, safe motoring and safe disposal probably would be ideal. If we can coax them to do at least 10 minutes a week, I think it's worthwhile.
For the one good news on the horizon is the new Apple Watch, which is already supposed to release next year, will monitor your blood sugars. So perhaps half your waste disposal will go out. Next is the insulin, once a week insulin will again take away a large chunk of your testing facilities. And the patch, which should be, I feel, should be promoted more than these lancets, are again more eco-friendly than these things.
Yeah, the thought process, how we present also is important. In the sense, in the discussion during the rounds, what came up is, we spend a lot of time lecturing or reading about how late we start insulin, what better insulin, how to monitor, how much to monitor. But in practicality, how many of us talk about this to the patient, about how to dispose the needles and the glucometers, the strips. So that is a core of the thing where you should have started off like that, but anyway. So that was the idea behind that we should emphasize on this part, which is hazardous to others also. Thank you.
Thank you, sir. Thank you, everyone.
Thank you, Doctor. I think it was a very thought-provoking session because, as all the experts pointed out, this is something we don't pay attention to. And just to emphasize more on this, I had done a study on use of insulin therapy, almost 500 patients. And in that study, we found out that 98% of the patients were disposing of their disposals in the general waste. So that was a shocking news for us, and that led to installation of waste disposal for all these patients. We have a bin where we tell our patients that you can collect your needles and all the stuff, and when you come to hospital, you can leave it behind. Because our municipal system also is not much aware of this, and possibly that is a bigger cause which we probably have to, as an organization, highlight more. The third talk of the session, Dr. Lenora, please.
Good morning, everyone, and all the esteemed delegates. My name is Lenora. I'm a PG from Vaidehi Hospital, PG General Medicine. I'm a PG General Medicine from Vaidehi Hospital. I would like to present a rare case of head syndrome that presented to our OPD. So, head syndrome is a rare multi-system autoinflammatory disorder characterized by cutaneous hyperpigmentation, hypertrichosis, hepatosplenomegaly, heart anomalies, hearing loss, hypogonadism, and short stature. It is caused by homozygous or compound heterozygous mutation in the SLC29A3 gene on chromosome 10q22. Head syndrome is commonly reported in Arabs, with only a few cases reported from India. Here we report an Asian Indian patient with syndrome H. Head syndrome usually presents in the first or second decades of life. Histopathology demonstrates widespread fibrosis and thickened collagen bundles. Histiocytes may be CD68, S100, and CD1A, and demonstrate emperilopolysis as appreciated in Rosé-Dorfman syndrome. The diagnosis is suspected based upon the clinical findings, mutational analysis analysis will confirm the diagnosis when there is uncertainty or in patients with mild or incomplete phenotypes. Differential diagnoses include TODG, Winchester syndrome, hemochromatosis, Poems syndrome, and Rosset-Dorfman disease. There is no established treatment for Head syndrome, but therapies have been attempted, including systemic corticosteroids, immunosuppressive agents, and management of blood sugars, interferon alpha, adalimumab, and radiotherapy. So, a 22-year-old male born out of a non-consanguineous marriage with no similar complaints in the family, and father being a case of type 2 diabetes mellitus with significant and patient with a significant past history of bilateral hearing loss since 13 years, type 1 diabetes on insulin therapy since 10 years, celiac disease since 8 years, and hypogonadotropic hypogonadism on testosterone replacement from 7 years. On examination, there was generalized dry skin, hypertrichosis, and hyperpigmentation over the medial aspect of the both thighs. So clinical diagnosis was Head syndrome. So till date, around only 130 patients have been described in the world literature, with only 10 of these being from India. Most are initially misdiagnosed as type 1 diabetes mellitus, which is further misled by association with another autoimmune syndromes. But deafness is a clue that differentiates this condition from type 1 diabetes. Genetic testing of SLC 29E3 confirms the diagnosis, and this testing is awaited in our patient. So, conclusion, we report a rare case of Head syndrome from India. A high index of suspicion is required to diagnose Head syndrome in children and young adults with Head syndrome. Mutation analysis will confirm the diagnosis when there is uncertainty or in patients with mild or incomplete phenotypes. Thank you.
Nice. I have two questions. Can you go to the patient case report or whatever? Right. What is this hypergonadotrophic hypogonadism?
So, hypogonadotrophic
Hypo or hyper? So 10,000 rupees fine. Next, what was the idea of presenting this case here? I would have been happy if you had shown us some prevalence and incidence of this disease in India or in the world. It would have given a better impact. This is just an observation. Do you have an idea? You said it's more common in Arabs, Middle East, but in India, what is the incidence prevalence? Are we to be worried? Because I was just reminded of a syndrome called MIDD. You remember what is MIDD? What's it?
It's a type of mitochondrial diabetes.
Maternally inherited diabetes with
Deafness.
deafness. So I was reminded that's pretty common. In the sense, if you look at type 1, we usually don't look at deafness, right? But if you had given some incidence prevalence, it would be relevant. Thanks.
If there is no comment, I think we can conclude this. I thank all three of you for a nice presentation. You have started breaking the ice, so I think this conference will go ahead in proper tempo and we'll finish everything in time. Thank you very much.
As we close this session, I would request all the three speakers on the stage for a memorable photograph with the chairpersons, please.
Don't ever give mic, I told you. Christian Bernard was asked this question, how did you come up with heart transplant concept? He said, I am from a farming community. When I was a child, please come. When I was a child, my grandfather took me to the farm. I saw two horses being put to plow. One old horse, another young horse. This is the concept. Old horses are wise, young horses are very, very energetic.
Thank you to the speakers and chairpersons for this wonderful discussion. Without much ado, let's welcome the experts of the next session to begin the talk. I request Dr. Suresh Kolapuri and Dr. Amal Selvam to chair the session, please. I also welcome Dr. Anup Amarnath, our distinguished speaker of this session, and the topic is elderly diabetes, how different should be the approach. I hand over the dais to the chairpersons, please.
Hello. Good morning, everybody. I would like to introduce Dr. Anup Amarnath, who is the chairman from Geriatric Medicine. He is in Manipal Hospitals, Bangalore. He is going to speak on elderly diabetes. How different should the approach be? Over to you, sir, for your expert lectures.
Thank you very much, chairpersons, and thanks KRSSDI for inviting me, Dr. Manohar, Dr. Suman, Dr. Arvind, Dr. Sanjeev. Thank you very much. It's always a pleasure to be opening the session after the young Turks. Not that I'm very old, but begin with the elderly diabetes. So, I think it would be good to start with a question. Number one, would you rather get diabetes and then grow old, or would you grow old and then get diabetes? I think that's an answer we'll come to a conclusion once we end this talk. But let's begin with this. Is there a pointer? So this is as of yesterday. We were doing rounds at the hospital, and if you see the top, 15th of December at around 1:15, an elderly patient who was admitted in hospital came into the emergency, unresponsive, sugars of around 40, and this was some of the investigations which we had, HbA1c of 4.6. So HbA1c of 4.6, and this was as of yesterday. And unsurprisingly, this was a list of medicines. So there's a lag between here and here. Yeah, I think there's some issue with the slides, but essentially, if you look at the presenting issue with unresponsiveness and sugars of 40 with a hemoglobin A1C of 4.6, and then if we saw what the medicines list were, a wonderful list of medicines. So you have a DPP-4, you have a biguanide, you have sulfonylurea, and as well, you have an insulin almost about 10-20 units per day. So no wonder the patient came in with hypoglycemia and unresponsive episode. But I think the bottom line is, no doctor would get a big trophy for the biggest reduction in A1C. So no trophies for reduction in A1C in the elderly, and I think that's the point from which we'll take this entire thing forward. In terms of just starting on with epidemiology, there's a huge increase in the number of diabetes in the elderly population. That's probably somewhere which we are, 14.1 million, and this is in India. And in terms of percentage, there's approximately 20-30% of the elderly population. In some studies, we've also seen a prevalence of around 55%, especially in urban centers where diabetes is much more prevalent. So between 20 to 30% in an overall setting to almost up to 55% prevalence is what we're looking at in terms of prevalence of diabetes in the elderly population. So highly prevalent, and then especially the over 65, and India being a capital of diabetes in the world, we also look at an upper extreme of 55% in the elderly population. With that quantum of prevalence, let's also look at what could potentially be the pathophysiology of diabetes in the elderly. So with obesity, there's also sarcopenia, which is very common in the elderly. So there's a lot of muscle loss as and when we age. There's also metabolic stress, autoimmune phenomena, age-related changes in glucose metabolism, and longevity longevity itself is a risk factor for diabetes in the elderly. But this is another common thing which we see, polypharmacy in diabetes in the elderly, and that's the example which I gave when we started off this entire talk. So multiple factors which contribute to diabetes in the elderly. Having looked at the prevalence and pathophysiology, I think a very important factor is to understand the presenting and the distinctive features of diabetes in the elderly. So they may not classically present with polyuria, polydipsia, and polyphagia, but I think these are some of the very important things that we need to keep an eye on. Confusion, a very common presenting form in the elderly. So usually we tend to neglect that as confusion is very common in the elderly, but an underlying diabetes is something which we really need to look into. Number 2 is falls, again a part of the geriatric syndrome. Reduction in weight and failure to thrive. So failure to thrive is not something which we only see in the young, but also we see in the elderly. And sarcopenia is a big contributing factor to failure to thrive. Visual symptoms and hyperosmolarcoma. So a lot of these unique features, distinctive features, are something which we need to keep in mind while initially diagnosing diabetes in the elderly. The geriatric giants, cognitive dysfunction, depression, physical disability, and polypharmacy. I think these are extremely important when we're managing diabetes in the elderly. And I would probably bring all of your attention to this one, polypharmacy. A few years ago, we presented a paper looking at potential inappropriate medication prescribing in the elderly. And unsurprisingly, even in urban centers, in teaching hospitals, the prevalence was almost about 25%. So what we treat the elderly with, how much we treat the elderly with, and how frequently we treat elderly with are extremely important factors in determining polypharmacy. So polypharmacy is something which we really need to keep an eye on. Now, before I get into the actual pharmacotherapy and lifestyle management, let's look into certain basic tenets of treating diabetes in the elderly. So a few core management principles, as I started off saying early, there are no prizes for the biggest reduction in A1C, but what we need to be looking at is this. How do we classify our elderly patients before we begin on the treatment? So you have healthy elderly with few comorbidities and functionally and cognitively intact. There, the A1C of 7.5 and sub 7.5 is something which is acceptable. Then you have the intermediate and complex elderly with multiple chronic issues and 2 or more. IADL stands for instrumental activities of daily living. So if they need some assistance in terms of activities of daily living, that's when the A1C reduction can go up to 8 and glucose levels of 90 to 150. And then there's also a third category of severely impaired elderly, multiple health issues, cognitive impairment, end-stage chronic illnesses. In these kind of instances, there's no point in having a very tight sugar control. And in fact, the recommendation is that we can go up to about 8.5 of HbA1c. In summary, I think what these slides tell us is even before we begin treatment of the elderly, it's important to classify the elderly and then decide on treatment protocols based on these kind of classifications. So invariably we find this category who come into hospital, there's never a single organ involvement in diabetes in the elderly, it's always multi-organ involvement. And with multiple issues, I think we have to be more prudent in terms of how we manage. You have limited life expectancy and the benefits of aggressive diabetes control is extremely uncertain. So that is where we need to ensure that certain broad guidelines in terms of hypoglycemia prevention and these kind of things are taken care of before we manage diabetes in this category. Now, of late, what we've also seen is that apart from classification of elderly into these parts, it also depends on who is going to take care of the elderly, because the diabetes management also gets impacted by that. If they're self-managing, there are different guidelines. If they're institutionalized, there are different guidelines. So let's also look at who's managing the diabetes for the elderly? You know, we were talking about doctor-patient relationship. Here in the elderly, you have doctor-patient and caregiver relationship as well, because that becomes very crucial in determining what treatment we give and how much treatment we give. So in that context, these guidelines become important. Are they community dwelling, assisted living facility, or any rehab center, or they're totally dependent on care? So depending on these, I think we need to categorize the treatment because it makes a huge impact. So for those who are community dwelling, high functioning and medically stable, you can have complex regimes, and then the cognitive function becomes very important. So those are the category where we can have complex regimes. However, when those who are in an assisted living facility or even at home who are being assisted by caretakers or their children, it's important that these are the category who need assistance in both oral medicines and injectable medicines. So tailoring those treatment and therapies becomes very important. And then, of course, the last category, the totally dependent one, who are bedbound, need a lot of caregiving, both in terms of medicines and diabetes evaluation. So these are the ones where patients have no control over the timings. So they're entirely dependent on the caregiver for their diabetes management. And that's when the higher the side effects and also in terms of higher the risk of acute illness in these bedbound. So we need to tailor our diabetes therapies accordingly. So there is no self-care in this category of patients. There's always assisted care. So broadly, the consensus is that depending on whether they are able to take care of themselves or somebody else is taking care of them, we need to do the tailoring of therapy according to that. I think when we opened in the morning, we looked at personalized medicine, and this holds good for the elderly as well. There's extremely personalized medicine, not just based on the doctor and the patient, but also the caregiver. And this is what I was talking about, risk of hypoglycemia. Hypoglycemia is an independent risk factor for death, mortality, independent risk factor for cognitive dysfunction and worsening of dementia, and for falls as well. So I think if there is one takeaway in terms of managing diabetes in the elderly, it would be prevent hypoglycemia at all costs. I think that would be one single takeaway. There's one more major entity in the elderly called hypoglycemic unawareness, and I think that's something which we need to be aware of. There's reduced counter-regulatory hormonal mechanism because as and when we age, autonomic system becomes weak. There's reduced physiological response to hypoglycemia, so you may not have the classical hunger, sweating. All they do is come in a totally unconscious state. And usage of beta blockers. Most of them, the old timers, usually have beta blocker as a first-line therapy as an antihypertensive. So hypoglycemic unawareness is an extremely important thing that we need, because if you tell them that, okay, I'm putting you on this amount of insulin, and in case you have any symptoms of hypoglycemia, please let us know. I think that's a dead giveaway that they wouldn't know what the symptoms of hypoglycemia are. Not because they don't know, but because of the physiological changes as and when we age. And that's the reason hypoglycemic unawareness is an important factor. With those principles in mind, in terms of what are the core therapy goals, who's giving therapy, and what, how much therapy is to be given. Okay, I think it'll be great to have conversations outside of the hall. Okay, that's fine. So let's begin with the pharmacotherapy per se. So I think the core principles remain the same, but now let's look at individual therapeutics, what drugs we can use and why we tend to use the drugs which we tend to use. So let's start with the basics: bicunides, metformin, the good old first-line therapy as usual, safe to use as long as there are no contraindications, low risk of hypoglycemia, so still remains the first line of therapy. GI disturbances is something which we often see with metformin in the elderly, but I think if it's tolerated well, both in terms of cost, efficacy, reduction in risk of hypoglycemia, it's a very good molecule for us to use. There is an element of weight loss, especially in those elderly people with high doses of metformin, and a lot of them come in with weight loss as one of the presenting features. So GI disturbances and weight loss is something which we need to look at, but otherwise a wonderful drug to use. Sulfonylureas again still have a pretty good role, but the risk of hypoglycemia is extremely high, and we do tend to use it with extreme caution in the elderly. And of course, in the last half a decade to a decade, these molecules have totally changed the management of diabetes in the elderly. The GLP-1 analogs, DPP-4s, and of course the SGLT2. Although the thiazolidinediones are something which is there as a part of the recommended therapy, in practice, we rarely tend to use pioglitazone, rosiglitazone, higher risk of heart failure, fluid retention, and things like that. So in practice, we would definitely avoid this, but very rare instances where we tend to use that. But I think between these two, the DPP-4s and GLP-1 analogs and SGLT2, a phenomenal change in the way we manage diabetes of late. Especially with DPP-4, low risk of hypoglycemia, and these are weight neutral practically. So along with metformin, they're clearly the next line of management of diabetes in the elderly. And of course, the SGLT2 inhibitors. Low risk of hypoglycemia, added advantage of weight reduction in the elderly. But the most common issue that we tend to face is recurrent urinary tract infection. So I think a high index of suspicion for UTIs if some elderly person is on SGLT2 inhibitors. But with the data that we're getting off late in terms of cardiovascular risk reduction, mortality benefits, morbidity benefits, I think SGLT2s, as long as not contraindicated in terms of urinary tract infections, I think these are clearly one of the better drugs to use. Moving on to the good old insulin. I think one of the basic tenets while we are using insulin in the elderly is the fact that using a basal insulin, and that too in the morning, I think these are recommended guidelines than using mixed insulins 2 times a day, or the standard practice of using basal insulins at night. So using basal insulins in the morning once daily, although the risk of hypoglycemia is still a disadvantage, but I think those who are uncontrolled and can manage, especially the institutionalized ones, once daily basal insulin, especially in the morning, is definitely something which is on the recommended guidelines. And although this may appear a bit complex, the insulin regime, the simplification of insulin regime in the elderly is extremely important. And what the guidelines clearly say is a basal insulin in the morning and probably a mealtime insulin or an OHA is more than sufficient in the elderly to get the A1Cs under control and ensuring the sugars are under control. So probably a different day and a different talk altogether, only looking at this particular component. But suffice to say that a basal insulin in the morning and probably another mealtime insulin or changing over that to a secondary agent like an OHA would be the best combination for the elderly to have. So this is one key takeaway, changing timings from bedtime to morning, because the practice is that we tend to give a nighttime basal insulin, but in the elderly, the recommendation and the practicality is that it's always better to use a basal insulin in the morning along with the OHAs. So I think we're still on time, 3 more minutes left, so I'll stick to that. In summary, I'll go back to what I started off with. Managing diabetes in the elderly, it's extremely personalized. It requires a lot of assessment of not just the clinical part, but also the functional part, psychosocial parts. The psychosocial becomes important in terms of who's the caregiver, and the functional part becomes important in terms of determining the extent to which we manage diabetes. And before developing glycemic goals, I want my A1C to be here, A1C to be there, I think it's the overall health and coexisting medical conditions along with the preference of treatment. It cannot be didactic. It has to be triactic, doctor, patient, and caregiver together deciding on what treatment regimes to have. And the biggest bottom line, it's the quality of life. Trust me, if someone comes in with hypoglycemia, it scars them for life. And then they would always want to ensure that the triggering factor is removed from their treatment regime for the rest of the life. So personalized psychosocial factors, individual factors are what is required. And finally, definitely no trophies for the biggest reduction in A1C. Thank you so much. I think I'm on time.
Yeah, that was a wonderful talk, Dr. Anup. See, this elderly patient management itself is a big challenge, not only for the doctor, it is again the domestic problem within the family, because it is like the timely food, timely medication, and monitoring. And most of the elderly patients are ignored by the family, so they are not on a constant follow-up or the sugar checkups or anything of that. So here we were talking about only about hypoglycemia, where we should be more concentrated. But what I see is the hyperglycemia itself is a very big challenge, especially the diuresis, because I see lot of elderly patients mainly complained about because they are immobile or they are restricted. So frequent urination itself is a big problem when we keep the HbA1c on the higher side. And as you said, one episode of hypoglycemia, patient never wants to go up with that level of reduction in sugar. And the urinary tract infection, which is very common with the elderly patients. So what is your recommendation for the maintaining of HbA1c, like you said, like 8.5 and all? Normally, most of the elderly patients do develop diuresis and urinary tract infection.
I think that's a fantastic question in terms of diuresis. What we see commonly in the elderly, it's not just the hyperosmolar state which is contributing to the diuresis. So when I talked about the giants of geriatrics, urinary incontinence is a big factor. So right from prostatic enlargement, bladder dysfunction, autonomic dysfunction of the bladder, being on diuretics and high sugars, all these contribute to diuresis. So I think each one of these needs a very proper, thorough evaluation and then treating accordingly. Alpha blockers to a large extent help in the prostatic issue. Tolterodine, and a lot of these medicines which we tend to use. And of course the proper evacuation, whether they're on diapers, catheters, indwelling catheters, male catheters. So a lot of these is what we need to look into. But I think, the thing with managing diabetes in the elderly, it's always multifactorial. There's no single drug which can cure them of everything. And it's the doctor, patient, and the family who kind of get together to treat this one.
Dr. Anup, fantastic lecture. I wanted to come back to the question that you started off your talk with. In my opinion, I think it's better off for a patient to have diabetes and then grow old, because as we all say, an experienced patient is better than a good doctor. So he would have already kind of know how to deal with the symptoms and then go ahead with this. So probably that could be the answer to your question.
Fantastic. Dr. Manohar, do we have a debate at some point of time in terms of pros versus cons? I would probably go with, I would become old and then get diabetes than the other way around. But I think that's a fantastic debate for another day. Dr. Sanjeev Rao.
The only thing you have to do also when treating patients in the elderly is looking at the EGFR.
Right.
That's a very, very important thing, because that will entirely change your pharmacodynamics and what drug you choose.
Right. So a quick point on that, that's a very good point Dr. Sanjeev made. EGFR is, especially the 4-point MDRD EGFR is not a good criteria to check for kidney function, especially in the elderly. We know that 4-point MDRD is not valid less than 18 and more than 80. And especially in the subcontinental population, 4-point MDRD is not valid. So one of the things, and when you age with sarcopenia, there's loss of muscle mass. So creatinine per se is never a good indication of overall function. So the best option that we have seen is the CKD-EPI. So CKD-EPI is something which will give us a better understanding of the overall kidney function and then titrate it accordingly. Great, thank you so much. I think that was wonderful. Chairpersons, thank you so much.
Thank you, sir, for the wonderful session. Now I would request Dr. Anup, Dr. Suresh and Dr. Amarselvam for a memorable photo, please. I also request the chairpersons and speakers to collect their mementos from the faculty lounge. Thank you so much, sir. As we learn how to take care of our elders, we now move on to our next session. Before I do that, I'd like to extend my hearty welcome to the seniors who have come, Dr. Nadagowda sir, Dr. Vijay Vishwanathan, and many more who are joining us. Hearty welcome, sir. The next session would be a talk on peculiar infections in diabetes. And to deliberate on this talk, we have Dr. Surajdeep Sengupta, and to chair this session, I would request Dr. Syed A. Jawaz and Dr. Baswaraj Patil on the stage, please.
Congratulations, Dr. Manohar and team, for having invited me as one of the chairperson. And I invite our speaker, Dr. Gupta. So for the peculiar infections in diabetes, diabetes being a chronic metabolic disorder, multisystemic disorder, immunocompromising disorder, there are a lot of peculiar infections in individuals, age-wise, and even country-wise for that matter. Being our country, developing country, we have a particular infections in grading from, right from the chronic kidney disease infections to various upper respiratory skin infections. I welcome our speaker to go ahead with his topic.
Thank you very much, Chairpersons. Let me at the outset thank Dr. Manohar, Dr. Arvinda, Dr. Vijay, Dr. Suresh, and the entire team of Karnataka RSSDI for inviting me to do this presentation. Greetings from Delhi. Now, peculiar infections are indeed peculiar. While in the context of diabetes, they are almost like the sine qua non of diabetes. In the status of uncontrolled hyperglycemia, you have to have a very high index of suspicion of diagnosing this at the outset, because they tend to be extremely aggressive, have high levels of morbidity and mortality. So if you don't pick it up at the outset straight away, then the treatment becomes very difficult. And often they incorporate extremely aggressive and mutilating surgeries. And I'll be alluding to that during the course of the presentation. And this would be the flow of my talk. After a brief introduction, going over to the predisposing factors, the general infections that we see routinely in our cases, and coming on to the specific peculiar infections, and then summarizing. Now, this is very well known that diabetes has emerged as a disease of major public health importance in India, affecting the rich and poor alike. We know that very well. Comprehensive diabetes management is aimed at prevention of micro and macrovascular complications. And morbidity and mortality due to infections is again very significant. Now, poor glycemic control increases the risk of infection in diabetes, we all know that. And a recent meta-analysis of almost 85,000 patients plus showed that the infection rates rose steadily with rise of HbA1c, and they became all the more dominant when the A1c was 11% or more. Now, if you look at the pathophysiology of infections associated with diabetes, you see in the diagram out here pretty much all the bad things that you'd anticipate are going wrong out here. You have a decreased T lymphocyte response, decreased neutrophil function, disorders of humoral immunity appear, antioxidant system depression, angiopathy, neuropathy, large number of medical interventions are required often, low secretion of inflammatory cytokines, glycosuria, GIT dysmotility, and hyperglycemia. In this state, we see increased virulence of infectious microorganisms and apoptosis of the neutrophils. And acute metabolic decompensation is commoner in diabetics, and conversely, patients with metabolic decompensation are at an increased risk of infections. And there are several limitations which exist in the management of such cases. We know that comorbidities like cardiac and renal can, impose severe limitations of treatments especially when we're looking at renal doses of antibiotics, they often pretty much lead to resistance, drug resistance, and we have seen it practically very commonly. And other variables remain the duration of illness, severity of associated complications, and the severity and type of infection along with concurrent illnesses. Now, it is an imbalance between the host and the organism or the microbial factors, and the imbalance between these two results in the extent and the severity of infection and their corresponding complications. Now, derangement of host factors, like there is derangement of immune response, it could be sensory neuropathy affecting diabetic foot ulcers. Professor Vishwanathan is here, his pet field. Autonomic neuropathy, vascular insufficiency, increased skin and mucosal colonization can happen, which all predispose to bad infection. And there is an increased susceptibility because there is an imbalance between this triad, immune dysfunction, organism-specific factors, and complications of diabetes. But there are also some specific invasive factors. For example, rhizopus species have ketone reductases, which allow the disease to thrive in hypoglycemic conditions like decay. Candida has glucose-inducible proteins which promote adhesion to buccal and vaginal epithelium. And as adhesion impairs phagocytosis, host-resistance is gradually overridden. When chronic complications of diabetes like bladder dysfunction, etc., which impair voiding and increase the risk of urinary tract infections. Peripheral diabetic neuropathy contributes to motor, autonomic, and sensory components of neuropathic foot ulcers. Pulmonary autonomic neuropathy, there is decreased mucociliary clearance and predisposes the lung to infections. And hypoglycemia and insulin resistance, they impair the collective surfactant-mediated host defenses, so that is impaired. So these are common bacterial infections that we see in diabetes of various degrees and various degrees of severity and status of complication, and which is quite common in the clinical scenario. And these are common viral infections that we see. All of us have been accustomed to these. But now let me come to the peculiar infections, which we will be referring to Fournier's gangrene, rhino-orbital cerebral mucormycosis, which came into more, kind of disrepute during the pandemic, invasive malignant otitis externa, emphysematous cholecystitis, emphysematous pyelonephritis, emphysematous cystitis, and the last melioidosis. Now, why are they peculiar? These are peculiar because they occur most commonly or almost exclusively in uncontrolled diabetic patients, uncommon or rare in occurrence, rapidly propulsive, potentially fatal, and needs a very high index of suspicion early during the course of the illness. For early diagnosis, an aggressive multimodality treatment is required, which includes urgent hemodynamic stabilization, glycemic control, broad-spectrum antibiotics, and surgical intervention as and when necessary, and often these can be extremely aggressive and mutilating surgeries. Unfortunately, despite the best of treatment, the morbidity and mortality is significantly high and alarming. Now coming to the first, rhino-orbital cerebral mucormycosis, also known as black fungus. Its causative organism is zygomycosis. The areas involved are nose, paranasal sinuses, brains, and the orbits. Symptoms of unilateral headache, rhinorrhea, facial pain, numbness, black nasal discharge, etc. The signs of nasal and orbital cellulitis can be there. Redness and swelling of the nasal bridge and skin of the cheeks, palatal erosions, along with cranial nerve palsies. The diagnosis is made on histopathological examination. Nasal scraping and appendices, they would demonstrate the fungal variety, and an MRI and CT scan would be done to dictate the extent of the invasion. Grows rapidly, aggressively, fulminant and potentially life-threatening. Liposomal amphotericin B is one of the cornerstones of therapy, and dose adjustment has to be done very aggressively. Often requires surgical debridement, and whichever center has hyperbaric oxygen therapy, that is also an additional modality which should be offered. Coming to the next, invasive malignant otitis externa. The commonest organism is Pseudomonas, also Proteus species, Klebsiella, all the gram-negatives that are there, and fungi like Aspergillus. The parts involved are the external auditory canal, temporal bone, skull base, and the facial planes of the area. The diagnosis is done on the basis of what is known as the Cohen and criteria. Major criteria are pain, edema, exudate, granulation, and microabscesses, and a positive technetium 99 scan, and failure of local treatment for more than 1 week. That should be leading to presumptive diagnosis, and one has to follow it up very aggressively. What happens in this is that the cerumen in the ear, the rats, that loses its the lysosomal activity also, and the antibacterial activity goes down and becomes very aggressively locally invasive, along with associated invasion. And the minor criteria are cranial nerve involvement, age, debilitating conditions with positive radiography, exudative in culture, and positive raised WBC count. And the radiological investigation, MRI and CT are done, and the follow-up is done with the gallium-67 scan. Signs are of cranial nerve involvement, as I have shown, and it's a potentially life-threatening disease again with high morbidity rates. Antibiotics like fluoroquinolones have significantly improved the prognosis, again supplemented with surgical debridement and hyperbaric oxygen therapy and multimodality support. The next, emphysematous cholecystitis, caused by gas-forming bacteria like Clostridium perfringens, E. coli, Aerobacter, Proteus species, etc. There is gas in the gallbladder which may perforate and cause pneumoperitoneum. The symptoms and signs are of pain, fever, nausea, vomiting. Gallstones can be there with progressive jaundice. The diagnosis is based on ultrasound and X-ray and CT scans. And there is air in the gallbladder lumen wall, and there is pericholecystic fluid along with pneumoperitoneum, what is known as the effervescent or the champagne sign. Prognosis, systemic sepsis can be there and potentially fatal. Again, conservatively, antibiotics, fluids, analgesics. Surgical, often open cholecystectomy is required, and on a background of hyperbaric oxygen therapy, whichever center is having this modality. Next is emphysematous pyelonephritis, again caused by gram-negative bacteria, staph, Clostridium, Candida, Cryptococcus, and Pneumocystis jirovecii. The area involved is accumulation of gas leading to necrotizing infection in the renal parenchyma and collecting system of the perinephric tissue. The symptoms and signs are of dysuria, fever, rigors, nausea, vomiting, and flank pain, along with loin tenderness, thrombocytopenia, acute renal failure, and microscopic hematuria. There are 3 levels of classification which are based on the level of gas accumulation, and it is a CT scan-based diagnosis. I can, if somebody is interested, I can show you the classification. But basically, once you have diagnosed, obviously the management becomes paramount. Poor prognosis in patients who start developing hypotension or have a background of chronic kidney disease. Again, medical management incorporates supportive care, oxygen therapy, IV antibiotics aggressively, and where required, a percutaneous catheter drainage or open surgical drainage is required. Emphysematous cystitis, it's again a rare complication of UTI on a background of uncontrolled diabetes. The causative organisms are again the gram-negative ones, as I have shown. There is gas in the urinary bladder and lumen. Fever is present in 50% only. Abdominal pain, gross hematuria and pneumaturia, urinary urge, and dysuria would be there. The diagnosis based on X-ray, CT, urine microscopic culture sensitivities are done. And on a CT of the abdomen, there is what is known as the classical cobblestone or beaded necklace appearance. Again, potentially life-threatening. Mortality rate is significantly high. Depends on good management, multimodality management of antibiotics, bladder drainage, and astute glycemic control. Necrotizing fasciitis or gas gangrene, or also known as streptococcal myonecrosis, caused commonly by the Clostridium species, Staph aureus, and Strep pyogenes. Risk factors are all the immunosuppressive states like patients of uncontrolled diabetes, patients who are on immunosuppressive therapy, chronic kidney disease, malignancies, and trauma. The symptoms and signs are of erythema, edema, hemorrhagic bullae, necrosis, or crepitus can be there. Anybody who has palpated subcutaneous emphysema knows what kind of a crepitus feel would be there. The pain is out of proportion and it is decreased at a later stage because of numbness of the nerves. Generally, there is general symptoms are of fever, altered sensorium, tachycardia, decay may be there, hyperosmolar, hyperglycemic, non-ketotic coma could be there. There is something known as the LRINEX score, which is the lab reference indicators in necrotizing fasciitis. That is the acronym for this, which incorporates factors like CRP, WBC, creatinine, elevated blood glucose levels, and on the basis of this, the diagnosis is done. And also, obviously, clinical signs are extremely important. The prognosis is, almost 100, up to 100% mortality would be there without surgical intervention, and it incorporates extremely mutilating surgeries, and what surgeons recommend is to keep on cutting out the dead and sloughing tissue till such time you see fresh tissue, and at least a 1-inch margin would be there of fresh tissue. Medical management incorporates IV antibiotics, IV fluids, intravenous immunoglobulins, especially in staphylococcal toxic shock syndrome. Also, where possible, hyperbaric oxygen therapy. Surgical treatment, surgical debridement is one of the essentials out here. And rapid action is there, otherwise it could be a threat to life. Foneous gangrene or fulminant necrotizing fasciitis is the next one. It is based, the etiology incorporates urogenital strictures or background of surgery or trauma, anorectal abscesses or surgical procedures, gynecological infections, infected Bartholin cyst, etc. Causative organisms, again, E. coli, fungi like Candida, other bacteria like Lactobacillus, Klebsiella, or Staph could be there. Risk factors, again, immunosuppressive states like diabetes, chronic liver disease, HIV, chronic on patients on chronic steroid therapy. Parts involved are the perineal, genital, or the perianal regions, and cellulitis is adjacent to the portal of entry, and systemic signs are out of proportion, and gradually it develops very significant necrotic patches. The diagnosis is clinical mainly, and if somebody wants to see the, the facial plane involvement, then only an ultrasound or a CT would be required. High mortality, recent estimates of almost up to 40%, again requires a multimodal approach, and medical, comprising of medical therapies of IV antibiotics, fluid supportive care, early surgical deprivement, and where possible, if required, vacuum-assisted closure or negative pressure dressings. That is the way to go. This is again one of the ghastly pictures that you see in such a condition. Coming to the last, which is melioidosis. The problem with this is that this is often missed as the bug which is there, which is Burkholderia pseudomonas, is often mistaken as a contaminant on cultures. Again, it thrives on a background of immunosuppressive states like the ones mentioned, diabetes, chronic liver disease, HIV, chemotherapy, etc. Parts involved are cutaneous, pulmonary, perineal, genital, or perianal regions. The cutaneous manifestations are the bacterial site, which may range from absolutely no systemic manifestations to extensive pneumonias, to extensive inflammation, to sepsis and death. Clinical diagnosis is based on, like I said, grossly underdiagnosed because it is often discarded as a contaminant. So one has to have a very high index of suspicion and also look for other associated features if and when they are developing, like systemic inflammatory reactions. Unfortunately, the bug also has strong antimicrobial resistance, so cultures should be done early. And though there is some amount of susceptibility to beta-lactam antibiotics, so one can start off with a beta-lactam, but at the same time go and modify therapy depending upon the culture reports that one gets. So, in summary, what I would like to say that diabetes mellitus is considered very well as a secondary immune deficiency disorder as per WHO, and it has direct inhibitory effect on the adaptive immune mechanism as well, and an altered immune system response often dictates the prognosis in situations like these. And the immunocompromised state predisposes the patient to increased risk of infection and sepsis, which are contributing factors for increasing rates of morbidity and mortality in diabetic subjects. Frequent, severe, prolonged, and recurrent infections occur generally on a background of poor glycemic control, and prognostication to the patient's attendance is again extremely important. Certain specific but uncommon infections are associated with increased incidence in diabetes. Keep a very high index of suspicion. Very aggressive management is mandated since morbidity and mortality are significantly high. And well-controlled glucose levels may not only help prevent complicated infections, but also aid timely recovery. So thank you very much for a patient hearing. And it's my proud privilege to invite you to the National RSSDI meet that we are going to host for all of you in Delhi in 2024. A very warm welcome to all of you to join us in November in 2024.
Thank you, sir. You have covered exhaustively, and this diabetes with infection, it will affect from head to toe. Any questions from audience?
Did you see these peculiar infections, did you see any difference in the pre and the post-COVID era?
See, in COVID, in our observation, we did not come across any of these infections because most of the people were being treated and they had other problems. And the ones who were sick enough obviously succumbed to COVID per se. But for some reason, we did not see these infections during that time, at least in the group of patients that I saw, and not reported also, at least from Delhi. These are not very common. Though they occur in, these situations, they are supposed to be there in the more immunocompromised states. But for some reason, it was not very, well observed, at least to the best of my knowledge at that time.
Thank you.
I don't know about reports from other parts of the country, but routinely whatever gas gangrene, etc. is seen, that was the only thing. But those were because of, with other complicating factors also.
Any questions, please? If there are no questions, I think with this excellent of your presentation, we will conclude it.
Thank you, Chairpersons.
Thank you. I now request the chairpersons and the speakers for a photo, please. I also request all the three of you to collect your mementos from the faculty lounge, please. Thank you once again, sir. In the world of type 2 diabetes, I think now it is time to give some place under the sun for type 1 diabetes also. So we have a session on type 1 diabetes beyond glycemia, and to deliberate on this, we have with us Dr. Swaraj Vadanakeri, and to chair the session, I would request Dr. Praveen Gangadhar and Dr. Sudhindra.
Good morning, everyone. It's my honor to be present here. Very interesting topic ahead on type 1 diabetes. For that, we have a very dynamic speaker, Dr. Swaraj Vadanakeri. Sir is a professor, Unit of Diabetes and Endocrinology, Department of Medicine, MRMC Gulbarga. He's also a chief consultant in Anugraha Diabetes and Endocrinology Center. He has a lot of publications in national and international journals, and his interest has been with young onset diabetes. He's also the first doctor in North Karnataka to be awarded with the prestigious Fellow in American College of Endocrinology distinction. With these few words, I will hand over the session to Dr. Swaraj. Over to you, sir.
At the outset, I'd like to thank Dr. Manohar sir and team for giving me this opportunity to talk. Also, I was hearing the past two speakers talk. I could see a lot of AI-generated slides that were used, but my slides are going to be dedicated to my PGs because they have helped me in making them, and they're more likely to be a PG presentation, so kindly bear with that. So I am Dr. Swaraj. I am working as a professor in the Department of Medicine. I also have a dedicated diabetes endocrine center wherein I take care only with respect to patients with diabetes and other associated endocrine diseases. So the last talk was a very exhaustive talk. Sir spoke at length about everything, but the topic that has given to me has a lot of things to be covered in this 20 minutes. I don't think so I'll be covering. So this is a non-exhaustive talk. I will be touching time that I have on my hand. So what are all the conditions we need to look beyond glycemia? I'm talking of non-metabolic. I'm not going to talk about hypertension, dyslipidemia, and the microvascular or the macrovascular complications. I am talking only with respect to the associated autoimmune diseases that are associated. So what are the conditions that we need to look for? When do we look for these conditions? How do we screen, or rather how do we diagnose? And how the glycemia affects this disease, how that disease affects the glycemia. And then finally I'll be giving a small conclusion. So the numbers and the need, why this is needed, why we should all be worried about. Type 2 diabetes, for the past 20-30 years, we have been talking about the microvascular complications, macrovascular complication, dyslipidemia, hypertension, and it is not a single disease. We'll have to look it into as a blanket. We'll have to use a big blanket and then make sure that we are taking care of the type 2 diabetes. We have been beating our chest and drumming it all around for the past 20-30 years, and we have been successful. But the same thing, are we doing it for type 1 diabetes? No. Type 1 diabetes, if you ask anybody, they will tell you that yes, it is about only insulin. But type 1 diabetes is just not about insulin. We'll have to look into so many other things also. The numbers say that, this is the increased prevalence with respect to type 1 diabetes. We are all very aware about it. Across the globe, this is happening. 3 to 4% increase is what is seen in the European countries. Indian studies are not much data that is available, but definitely it is increasing. We have a population of 140 million, so even if I take around 2 to 3% increase, that is a huge number that we'll be considering. So what are the associated autoimmunity in patients with type 1 diabetes? So it is type 1 diabetes doesn't come alone. It comes with its own set of friends, foes, or whatever we want to call it. So what are these friends and foes? Type 1 diabetes, of course. And then we have Hashimoto's thyroiditis or thyroid disease, which can be either be hypothyroid or hyperthyroid, with Addison's disease, autoimmune hypophysitis, autoimmune type A gastritis, pernicious anemia, and celiac disease. These are the commonest autoimmune conditions. Then there are certain other common autoimmune conditions like rheumatoid arthritis, Sjogren's disease, vitiligo, alopecia areata, that I'm not going to touch upon because of the lack of time. And mostly these are the cases that land up in their respective specialty than they rather being coming to us. So they are the ones who are taking more care of. We are being referred only in terms of the management of glycemia. So if I have to look into the prevalence of these conditions, so if I have to look into anti-TPO, the anti-TPO prevalence in the general population is roughly around 2 to 10%, but whereas it is around close to 30% in people with type 1 diabetes. In Graves' disease, the prevalence is around 1 to 2%, whereas it is around close to 18% in patients with type 1 diabetes. Addison's disease, although very rare, the general prevalence in the general population is around 0.6%, whereas in Addison's disease is around 2%. So that's around 3 times more likelihood. And if I have to come to about celiac disease, transglutaminase antibodies are generally seen in the population around 1%, whereas around 12% in the patient with type 1 diabetes. So to put it in perspective, if I am seeing 10 type 1 diabetic patients, there are roughly around 2 to 3 people who are having either one or a combination of these diseases. So we just can't neglect. We just can't say, yeah, their basal bolus is what is good for you, please take basal bolus and forget rest. No, that is not going to happen. We have to look into all the others and see how best we can manage this. So autoimmune thyroid disease, the Haynes 3 study reported a higher prevalence of thyroid disease in patients diagnosed with diabetes than compared to the general population. So anti-thyroid antibodies are observed more frequently in girls. As we all know, the autoimmune diseases are more prevalent in the female gender. So this also, especially thyroid is more even prevalent than compared to any others. This is dependent on the age, diabetes duration, and the pubertal status. Thyroid hormones exert a profound effect on carb. We all know this about what they do to the carbohydrate and the lipid metabolism. If I have to look into the neonatal stage, what happens? The neonatal beta cell receptors for thyroid hormones. So the neonatal beta cells have, and their exposure to T3 hormone when they are growing up or in the developmental stage, their exposure to T3 hormone determines beta cell maturation and stimulation to insulin secretion. So if you have a patient, or if a patient of type 1 diabetes has gone undiagnosed, there is, of course, they are talking respect to type 2, but even in type 1 diabetes, if there is hypothyroidism that has gone unrecognized, they are more likely to have more dysglycemia than a patient who is euthyroid. So it becomes very, very important. So T3 promotes the proliferation of the pancreatic islet cells. Thyroid hormones increase hepatic glucose production by increasing the hepatic expression of the GLUT2 and stimulate endogenous glucose production by increasing the gluconeogenesis and the glycogenolysis. And coming to the lipogenesis and the lipolysis, both of which are stimulated by T3 and T4. Lipolysis is largely mediated through the increase in the number of hepatic receptors for the molecular density, for the low molecular density lipoproteins, and accelerating the LDL clearance. So which, if it is unmanaged, can lead to increased CV risk. We know about the type 2 diabetes and the risk of cardiovascular disease in type 2 diabetes, but it is probably even higher if they are having the associated dyslipidemia. Hyperthyroidism and hypothyroidism both cause insulin resistance in with a different mechanism. So Hashimoto's thyroiditis. So if I have to suspect a patient, especially a young individual, 5, 6, 7, 8-year-old individual, as we know, type 1 diabetes is trimodal. Peripubertal is the more likely, wherein you are more likely to get diagnosed, and the second to that is around 5 to 7 years, or close to around 5 to 7 years, and then it comes in the 50s. So if I am seeing a young individual who is having type 1 diabetes, when do I suspect the other associated autoimmune thyroid diseases? Like, for example, decreased linear growth. Any type 1 diabetes that we are seeing in our clinic, make sure that we should be plotting them on their growth chart. If we are not plotting their growth chart, we are doing gross injustice to them. So we are seeing that they are growing, they were growing well, and then suddenly you see that they are below the 3rd centile. That is when one of the important consideration to, ideally we should be screening everybody, but yes, if you want to look into clinical features and then plan for a treatment, then yes, decreased linear growth, a painless goiter, cold intolerance, bradycardia, these are all classic presentations. Hypoglycemia. So if you see that a patient who was doing pretty fine for a good number of days or months, and then you say more frequent hypoglycemias in that patient, then hypoglycemia could be a presenting feature wherein we'll have to look for screening them with the TSH. So risk factors: age, duration of type 1 diabetes, presence of celiac disease and GAD antibodies. These are also risk factors for developing a autoimmune hypothyroid disease. So how do we screen? TSH is the best screening tool. Do a TSH, it is normal, unlikely that it is going to be primary hypothyroidism. Secondary, very, very rare, wherein we'll have to do a FT4. So what are the antibodies that we will look into, especially if we are suspecting hypothyroidism, is anti-TPO antibodies, if they are elevated, and even if the patient is having subclinical hypothyroidism defined by a TSH of 5 to 10, even then we are supposed to be treating them. Overt hypothyroidism, especially in type 2, we would defer treatment till the TSH is 10, but in type 1 diabetes, if the TSH is between 5 to 10, treating them is far more beneficial than not treating them. Screening recommendation, of course, at diagnosis, and then every 2 years, sooner if the patient is having antibodies or if he is having any associated symptoms. Graves' disease or hyperthyroidism is the most commonest cause of hyperthyroidism. Persistent hyperthyroidism, so classical presentations of weight loss, palpitations, heat intolerance, proptosis, goiter. So again, the risk factors of age and duration of type 1 diabetes. In hypothyroidism, the best screening tool is TSH. In hyperthyroidism, it is the whole panel of T3, T4, TSH. If you have facilities, you can use a FT4 and not FT3. Again, the screening recommendation is not, we need not have to do an anti-TPO every yearly or a TSH receptor antibodies on an yearly basis. If the patient develops symptom, that is when we are going to be doing a TSH receptor antibody to document the autoimmunity, so that our care will be far more superior than the general care that the patient is going to receive. So children should always have their thyroid gland palpated yearly for the development of the nodules assist. So it is just not about hypo or hyperthyroidism, it is also about the nodules that we should be looking into. So another next commonest condition that is usually overlooked, physician inertia, patient inertia, or symptomatology inertia. I think celiac disease has a lot of inertia which comes, it is hidden most of the times, and the patient will not have overt manifestation. They have very covert manifestation, and it requires a lot of application of our mind so that we can diagnose this and then probably even consider treating. So this is a chronic autoimmune condition of the small intestine that is characterized with the destruction of the intestinal mucosa through an immune mechanism occurring on a predisposing genetic background in response to the exposure to the gluten. So gluten is the culprit which needs to be addressed very, very significantly. The prevalence of this ranges from around 1 to 16% among children and adolescents with type 1 diabetes. They are diagnosed in the first year, so it is very important. So when I see a patient with type 1 diabetes, I should be having a baseline anti-TTG done. That is when I will be able to give a better control with respect to glycemia, with respect to overall quality of life. So if I am not screening for these antibodies, I will be doing gross injustice to the type 1 diabetic. So adolescents with type 1 diabetes may develop at diagnosis or within the first year of diagnosis or within the first 5 to 10 years of the diagnosis of type 1 diabetes. This was the ISPAT 2022 guidelines. So clinical features, as I've said, it has a myriad of symptoms, plus it has no symptoms at all. So it can be asymptomatic, it can have indirect markers, it can have intestinal markers, or it can have extra-intestinal presentations. Asymptomatic, usually we do not do anything unless until we have done an antibody and patient is having some mixed symptoms, that is when probably we may consider treating. Indirect markers, definitely, because as I've said, it is not a single disease type 1. If it is patient is going below the third centile, then definitely I'd want to do a impaired, if I want to do a TTG, anti-TTG, impaired linear growth, poor glycemic control, fluctuating glycemia. This is one moment the patient is in hyper, the next very moment the patient is in hypoglycemia. So that is an indirect marker that there is associated some other conditions that we are missing. Then we have the classical intestinal presentation like the nausea, vomiting, pain abdomen, increased flatulence and diarrhea, extra-intestinal like associated iron deficiency anemia, and this is very, very important, decreased bone mineralization. Type 1 diabetics are more likely to have a poor bone health, and of which celiac disease is one of the important criteria. And of course, unexplained hypoglycemia. So screening, first screening of IgA levels should be done at the time of diagnosis, and if the IgA is deficient, IgG specific antibodies test must be done, that is our anti-TTG, IgG antibodies. Then if you have the facilities, you can do endomysial antibodies. And in children with normal IgA antibodies, TTG IgA is an initial screening test. Levels which are excreting more than 10 times. If you just see that it is twice or thrice elevated, we should not be bothered about. It should be more than 10 times the upper normal limit. Then we do a confirmatory test with anti-endomysial antibodies in the second sample, and then you can start the patient on a gluten-free diet. In people with diabetes, a positive TTG of less than 10, the upper normal limit, but you still feel the patient is more likely to have a celiac disease, then that is when we do a small bowel biopsy. 4 sites of biopsy sites should be taken, and then the celiac disease by demonstrating the subtotal villus atrophy. 4 sites. It is not from one side the biopsy has to be taken, it has to be done by a qualified pediatric gastroenterologist to give a proper diagnosis, especially when we want a tissue diagnosis. In the symptomatic child, a biopsy sparing approach can be used. So when we know that the patient is symptomatic and we have antibodies are positive, symptomatic, type 1 diabetes, no need to go for a biopsy. We can directly treat with a gluten-free diet. That is what most of us do in our clinical practice. So upon confirmation, gluten-free diet is the standard treatment, although very easily said, but very, very, very difficult to practice in the day-to-day scenario. Autoimmune gastritis, I am running short of time, so I'll be speeding up my presentation. Hypo or achlorohydria, hypergastrinemia, and iron deficiency anemia, these are the commonest presentation. How do we screen? We do a parietal cell antibodies, we do a blood count, we check for vitamin B12. If the patient is having vitamin B12 deficiency, plus parietal autoantibody cells are positive, then probably treat it. So these patients are more likely to also have associated autoimmunity to thyroid as well. Growth disorders. Whenever I'm looking into a type 1 person who is in the age group of 5 to 14 or prepubertal, plotting a growth chart is of highest significance. We just cannot neglect the growth aspect of type 1 diabetes. Lower glycemic control, which can be because of lower socioeconomic status, inadequate dosage, poor family support, emotional issues, and other factors causing compliance issues can also lead to poor growth. The frequency of growth retardation is roughly around 11 to 14%, similar to the incidence of chronic complications like what we see in type 2 diabetes, which is hypertension, retinopathy, and dyslipidemia. Diabetes control has a major impact on the adult height, with near adult height correlating with the negative. So if your glycemic control has been poor for 10 years, then that child is going to be stunted. So, and that is also the part and parcel of the type 1 diabetic armamentarium that we should be looking into. Eventually, this leads to short stature, delayed puberty, poor bone health, and other health-related problems. So Addison's is another common condition that we look upon symptomatically. Again, poor glycemic control, repeated frequent hypoglycemia, and a patient having orthostatic hypotension. These are all evidences wherein the patient may have Addison's disease. 2% of people with type 1 diabetes will have anti-adenine antibodies. When we know or when we have diagnosed a patient with type 1 diabetes, we should also be looking into certain other type of diagnosis like PAS, type 1 and type 2. How do we diagnose Addison's disease? Symptomatically, postural hypertension is the most commonest manifestation that we see in our routine outpatient department. Plus, we do autoantibodies. You do a serum 8 AM cortisol, then you do a short synactin test. A short synactin test of 30 minutes and 60 minutes. If it is less than 18 microgram per deciliter, that is when we diagnose a patient with Addison's disease. Treatment we know is lifelong. It is more likely to be primary and not secondary. Lifelong hydrocortisone and fluorocortisone are the replacement that we should be doing. So as I've said, it doesn't come alone. It has its own set of other diseases that we should be looking into. These are PAS type 1 and type 2 and apex. They follow a particular set of order in which they appear. First is the type 1 diabetes, then we have the hypoparathyroidism, then Addison's disease, and then the autoimmune thyroid disease. So this is also a way in which nature takes care that Addison's disease comes last, because cortisol is required for survival. So if a patient is having Addison's disease, that means he has come towards the last, the progression, natural history of that disease. Type 1 related skin disease, we all know insulin-induced lipodystrophy and hypertrophy. Part of our treatment or the education that we give to the patients should be proper injection technique. The etiological factors that are described are substandard injection technique, insufficient injection rotation, repeated injection into the small area, and reuse of insulin needles. So lipohypertrophy, lipoatrophy, both are very, very common things that we see in our clinical practice. Proper education is the only way out, because there are no medicines per se to treat lipohypertrophy and lipoatrophy. So CGM related issues like erythema, pruritus and induration, scarring, potentially dermatological complications, a team of doctors associated with the dermatologist is what we would be looking into to give a better quality of life. As I've already said, bone health is a very important parameter that we should be considering, especially in type 1 diabetes. Accumulating evidence suggests that bone mineral density, bone structure, fracture risk, and bone turnover markers and bone metabolism is related to are all altered in type 1 diabetes. This is associated with the increased risk of fracture of 14%, which is very, very significant. And the risks are multifactorial, as I've already said. It could be celiac disease, overt hypothyroidism, poor glycemia, or Addison's disease. DEXA, we do not have the correct picture with respect to the DEXA screening, especially in younger individuals. But we have what is called as a bone trabecular score, or the trabecular BMD, which will tell us more correctly whether the patient is osteopenic or osteoporotic. Of course, if the patient is coming with fractures, then the diagnosis is very clear. Regular assessment of bone health using bone densitometry is still controversial and not recommended in specific populations such as celiac disease. Evaluation of bone health should be considered. Make sure that we are giving proper calcium and vitamin D for this type 1 diabetics. So impact on glycemia. So this is what happens if the patient is having hypothyroidism, decreased intestinal glucose absorption, decreased glycogenolysis, decreased insulin catabolism, and increased insulin sensitivity. So these are all the kind of things that we should be aware, especially when we are seeing a patient with type 1 diabetes. So these are the diagnostic pathway for autoimmune conditions in type 1 diabetes. Clinical presentation is one thing. We being upfront and having a prediction. Okay, see, this is, you have type 1, you are more likely to have this, and then working on that will make our things and our life easier as a caregiver for type 1 diabetes. So finally, to conclude, it is not a one thing. Type 1 diabetes is not a single entity. 1 out of 5 or 2 out of 10 individuals will have other associated autoimmune conditions. Here is where I would say and request KRSSDI to have at least a pool of patients of type 1 diabetes, wherein we can have individuals who are autoantibodies positive. We do a screening for all of them at diagnosis or within the first 5 years of diagnosis, and maintain a registry of autoantibodies positive. Just positive antibodies. Negative who are not affordable, that is a different issue beyond the scope of my talk today. But at least if we can maintain other autoimmune markers of patients with type 1 diabetes, just maintain a small registry. Let us say we have 1,000 patients of type 1 diabetes across the globe, or across India are probably around 500, 600 in Karnataka, and maintain and see how they are doing compared to the others. So that is where we can probably have a more better caregiving, and we can have a region-wise specific data of these associations as regional and ethnic variations have been largely seen. This data can thus help us improve in decision making. Personalized diabetes care, as important to type 2, is probably even more important to type 1. And that is how I'm going to end. Precision diabetes is far more important in type 1 than compared to type 2. Thank you.
Thank you. Thank you, Dr. Swaraj. It was really exhaustive and very good presentation on type 1 diabetes with autoimmune. All these days we are just concentrating on insulin. Type 1 diabetes means insulin care and just care of those conditions. But you have thrown light on just all the autoimmune conditions also, and having a data. This is the real thing, keeping a data on those anti-antibodies. And we personally have seen lot of cases. I have seen the one patient as coming with all your conditions: thyroid, stunted growth, and decreased weight gain, thyroiditis. Lot of these have come. The problem is the socioeconomic condition. We can't work up all those things. That is the problem in our country. So if you work up, we can do lot of this data and presentation. Of course, type 1 diabetes is growing in a lot of way, 2 to 3% per annum it is going, and more in Southeast Asia versus growing in a big way, more in our children's, of course, AK Das only has told in 2015, highest number in our children, Indian children. So in that way, we have to keep a data. This is definitely important, and we have to screen at the earliest type 1 diabetes. All the antibodies we have to screen. At least thyroid antibodies we can do. Of course, celiac is very rare. Gastritis is maybe rare. At least these growth markers we can do, BMD and growth markers. I have seen patient coming with thalassemia. I have seen patient coming with and so many conditions. Of course, data is there. I can't disclose my small number I have. So they are coming with patient coming with dialysis and type 1 diabetes. So many things are there. So if you keep a data, definitely we can present in our bigger forums and RSSDI, Indian forums and all, and national forums and international forums. Thank you for this exhaustive presentations.
Vijay sir is here, sir, so I think
Yeah.
we are a right person.
Yeah, you can
to
throw
take
some
care
light.
of. Sir.
Hello. You said antibody positive. We should have a type 1 diabetes registry itself. Actually, when I was the secretary, I wrote to all the hospitals for data on type 1 diabetes. I got only from 2-3 hospitals. So we should have a type 1 diabetes registry.
Yes, sir.
Afterwards, we can have antibody positive and antibody negative.
Yes.
And even in, I think, national RSSDI should also have type 1 diabetes registry.
Vijay sir is here.
Because I don't know, now there is no registry as such. We have different type 1 diabetes statistics in different centers. For example, we have about 1,200 type 1 in our, and Dr. Prasanna Kumar has several.
got.
Yes.
So like
maximum.
that, we don't have. In Karnataka, we should have one registry, and maybe national level, we should have
Yes.
one registry. That will
Yes, sir.
definitely
There are geographical variation and ethnic variation. So India is a country within a country. So we have to see how diverse is this.
Thank you.
Sir, as far as type 2 diabetes is concerned, there is news every 2-3 months, every 5-6 months, there is a new molecule and something coming up for type 2 diabetes. Whereas for type 1, we stand almost where we were 10 years back or 15 years back or 20 years back. There is not much of news about type 1 diabetes. What I would like to ask from you is, say early recognition of say antibodies like TPO antibodies for thyroid, can it prevent, is there any breakthrough where we can reduce the incidence of type 1 diabetes or we can prevent it? Because there is nothing available other than starting insulin. Compared with the type 2, there is a revolution going on in type 2, whereas type 1 is lagging behind for decades. There is nothing much, any recent breakthrough where we can early recognize, prevent the incidence, Any information from you, sir?
Sir, you said 10 years, 20 years. I think we are 100 years away from what in 1923, after diagnosis of insulin, after the discovery of insulin, where we are in respect to treatment of type 1, we are still there. But yes, now we have certain other kinds of treatment. We are not sitting still. We in the sense, not me, but the scientific community is not sitting still on type 1 diabetes. There are a lot of works which are being done. Only thing is, it is not being reflected in our clinical scenario. Like for example, there are we have pancreatic transplantation, we have other forms of treatment, but over a period of time, because of its autoimmune nature, the treatment is not on a continuous scale. So that is where the halt has come. Now we have, so this precision medicine, whatever the article that I am quoting, so what they have said is, if we are able to identify this into a different set of patients. So if we see an X antibody is higher, for example, GAD65 is there, ZNT8 is there, and IA2 is there, and these patients are more likely to respond to a particular kind of treatment than compared to others. So there are certain drugs which are in pipeline, but right now for the routine clinical use, I don't think so that is a feasible thing. But the scientific community is not sitting still. There is work which is being done, but to reflect into our clinical practice, I think it will take probably. Definitely, I don't think so. In my course of
to add to it,
time.
we have this immune checkpoint inhibitors, a lot of trial net data, and where if the antibody is, the HLA phenotyping happens, and by adding this anti-monoclonal antibodies, you can delay the progression again by 2 years, but cost and affordability is a factor in the research post setting. Thank you.
There is no more questions. We'll end the session. I thank Dr. Swaraj.
Thank you for this interesting discussion. I'd request the chairpersons and the speaker to join on the stage for a photograph, please. I also request the speaker and the chairpersons to collect their memento from the faculty lounge, please. Thank you so much, sir. Hoping that we'll someday talk more about something beyond insulin, as pointed out by the delegate. We'll move on to the next session. The topic is how to set up clinical research and clinical practice. And to deliberate on this, we have with us Dr. L. Srinivas Murthy. And to chair this session, I'd request Dr. Karnesh Kumar and Dr. Shobha Naidu on the stage, please. And here is an important announcement. To make our senior citizens, if at all I can call that, more comfortable, we have a separate dining area for them at coffee shop on the ground floor. Please make use of it. And also there is an ambulance standing by in our venue. I hand over the session to both the chairpersons, please.
Good morning. At the outset, I congratulate Dr. Manohar and team for the excellent organization of this conference. I am happy to introduce Dr. L. Srinivas Murthy, my very good friend. He is at Life Care Hospital and Research Center. He is Vice President of National RSSDI. He is having a lot of publications in the national and international journals. He is a very good, excellent speaker, and I think most busiest speaker in the medical field, touring all over the country, both in APA and RSSDI. And this is very interesting topic. I request Dr. Srinivas Murthy to start.
Thank you, sir. Thank you for those kind words. Good morning, everyone. I think, my first slide is on. Today, it is going to be something different, and I do not have any conflict of interest. In fact, today, I am running negative balance. So let's move on to the topic, the clinical research in clinical practice. Of course, few of the august audience who are here, Dr. Anil, Dr. Vijay sir, our mentor, Shekhar sir, all of them are here, Nadagoda sir. And this is only few of us are involved in the clinical research, especially phase 2, phase 3. Basuraj Patil is doing a big time ICMR project. So despite their close relationship in clinical research and medical care, there has been a clear-cut boundaries, and none of us attempt to cross that boundaries in our routine clinical practice. And that is what we try to do today, is to give the feel of how a research can be done, set up amongst your busy practice. So the evolution towards patient-centered medicine and patient-oriented research, and there is a gradual standardization of medicine, which is contributing the closer ties between the clinical research and the medical practice. So the history of clinical research, I'm sure all of you are aware about Jenner, the cowpox, and he had heard from the milkmaids that anyone who had cowpox before hardly ever gets smallpox, and that's what made him in clinical practice to detect and invent the vaccine. And they learned about the lemon juice in the sea travelers, the scurvy. And these are the various people which looked at the clinical research early in the life. And this is the historical perspective, how clinical research came into limelight, and there was a standardization following this thalidomide tragedy, where the Nuremberg Code was introduced way back in 1946, that was in the Second World War. And we clearly talk about transparency in clinical research, and why and how is what we're going to discuss today. This is something, a common terminology used in research called GCP, good clinical practice, which is nothing but a transparent way of life. Now, what is GCP? It's a standardized design, conduct, perform, monitor, audit, record, analyze, and report of clinical trials that provides assurance that the data and reported results are credible and accurate, and that the rights, integrity, and confidentiality of trial subjects are protected. So this is the basis for all the research, the GCP part, what we look at. Of course, clinical research, the current knowledge about healthcare, by continuously developing and testing new ideas about diseases, product, procedures, etc., goes on. And it's an activity of perpetual questioning, and that's what most of us should look at. We should look at two aspects in the process of research: getting an idea and verifying it and validating it. And these are the crucial must-haves in research: the deduction, the dependency, the association, the plausibility, and the possibility. There are unmet needs in this field. The doctors need to be familiar with the scientific method and trained in applying it to test different ideas. And this is neglected with respect to the education and training of our fraternity. Experienced pharmaceutical physicians can help doing this. And there are factors which can affect the validity of research, like which is clearly shown there. The dichotomy, we will not get into this, the integration, but there are reassessment of 3 solutions and associated ethical principles in the old and new models of clinical research and medical care. And as you can see, the traditional approach and the new model, very clear cut, it is a patient-centric approach what we have. And these are all the methodological proposals to integrate the clinical research and the medical care. Eventually, the benefits for individual and average patients now and in the future, and that's what we look at. So there is evolution of research to practice, which comparative effectiveness research and real-world evidence movements, patient-centered outcomes research institute, and the patient-reported outcomes, PROs, which we apply in various clinical trials. And this is the contributions of patient-oriented research, patient-centered medicine to the integration of clinical research and medical. For lack of time, we'll not get into the details. And this is what drug development pathway happens. We know the in vitro, the basic research, early discovery, preclinical studies, then comes to the human testing, and then the data review and the surveillance. And look at the topmost line where it talks about the duration of each phase of study. It takes about 10 years for a molecule to come out, and about $1 billion is the amount spent to develop a new molecule. That is why if you see any new molecule when it comes to the market, it's very expensive, and this is all is about. And we conduct a lot of phase 2 and phase 3 trials. And once the approval and launch, these are the post-marketing surveillance what most of us tend to do. So who can be an investigator? And this is a basic question many of us keep asking each other, that who can be an investigator? A qualified physician who is responsible for all trial-related activities, must have suitable education, training, and experience, must be trained in GCP and have knowledge of GCP and applicable regulatory requirements, may delegate some of their responsibility to other individuals, we call co-investigators or sub-investigators, should permit monitoring and auditing by the sponsor and inspection, and that is what we end up. Last year we celebrated 16 years, that's not my actual age, it's a 16 years of clinical research experience what we celebrated. Adequate resources, of course, the investigator should be able to demonstrate the potential for recruiting the required number of subjects. That is what we enter something called as a CTA. The investigator should have sufficient time, and this is where the second point is most of us neglect because we think signature, signing a coordinator's notes or a sub-investigator's notes is our responsibility, but instead you need to give every day about 1 to 2 hours minimum based on the project, number of projects you have to the clinical research, and the investigator should be available an adequate number and qualified staff. That is again the onus is on the investigator, and he should ensure that all persons assisting with the trial are adequately informed about the protocol and the IP, investigational product. So the medical care, obviously the PI or the sub-I are responsible for all trial-related activities across the trial, and the investigator and the institute should ensure that the adequate medical care is provided to the subject for any adverse events, including clinically significant laboratory values related to the trial. That's again a very important point in the audiovisual consenting when we consent patients, that we need to explain that when they have adverse event, for example, in any new anti-diabetic drug, you have hypoglycemia where required assistance or hospitalization, the cost of the hospitalization is provided until otherwise that it is proved it is not related to the investigational product. So the patient is rest assured that whatever the AE or SAE happens, if it is not related to the IP, that is the investigational product, until then you would be given free of cost, and that's again a clause written there very clearly in all the consent forms. Who are the key players in clinical trial? The sponsors, the investigation site team, the IRBs, that is your ethical committee, regulatory authority, subjects, and of course sometimes CROs versus sponsors. So these are the key players in the clinical trial. And principles of ICGCP, what we talk is conduct trials according to the GCP. You need to weigh risk versus benefits, protect the subject rights, have adequate information to justify trial, write a sound protocol, receive the approvals, and only when approvals are received from your local IRBs and the regulatory authorities like the Health Authority of India now, you need to start, and this is one of the protocol violations or GCP violations. People tend to screen the patients before even got the approvals, and that's a GCP violation. And this is the most important when we sign this FDA 1572 form in any trial. That means your doors are open to FDA inspections, and that is where I ended up facing 2 FDA inspections in a span of about 12 years in my center. Any trial which you sign FDA 1572, mind you, that you are open to the FDA inspections up to 15 years after the molecule is approved in the market, not after the trial is closed out. 15 years after the trial closed out. So that means about 18 years you need to archive all the records. Like the recent FDA I faced in September, the trial got over 2 years back, and they visited me 2 years later, that is this year. So the role of investigations in investigator in clinical trials, this is the GCP, the sections are quoted here. Each section, the investigator qualification, adequate resources, medical care, communication with the EC, compliance with the protocol, IP, randomization procedures, ICF, records, progress reports, safety reporting, premature termination or suspension. All these are to be monitored on a daily basis. For example, recently we had a flow trial, which was, flow is your sema-injectable in renally compromised patients. That was prematurely closed. So we had 39 patients, all 39 patients had to reconsent and tell them that it's prematurely closed because the advantages of the trial shown are the molecule shown. So that is again the responsibility of the investigator. To conduct the trial according to the protocol and GCP guidelines, compliance with the Appendix 7, which is there in India, SOPs are required to be documented, adequate medical care is provided, and investigators shall report all serious and unexpected AEs. And this is again, a lot of us do some conjugacy in reporting the adverse events, whether it's not related to the study or not. For example, somebody develops malaria in a diabetic trial, we think malaria is not related to that, or a simple itching, you need to report. Because once you do not report that black box warning what the FDA issues ultimately, that you will be cheating yourself. So that's something, it's a onus on us to report all the AEs, whether related or not to the study. That's the definition of adverse event in fact. So the research versus medical practice, how do you go about? The patients versus subjects. Once any patient in the OPD gets on after the ICF into the research, they are called subjects. So you need to look at the risks in the research study whenever you accept it, because there is a lot of multinational trials where there is a double-blind placebo arm controlled trials where the placebo arm is something the onus is on you to explain the patient before they sign the consent that 50% is the only possibility that you will be getting the investigational product and 50% you may not get the product. So there the standard of care comes into picture, your ethical committee role comes into picture, where how do you protect those set of patients who will go on to the placebo, because we will never know until the study is over that the placebo, because unblinding is done only during the SAEs, not during the course of the trial. And the documentation is mostly very extensive. For example, in routine clinical practice, we write 120 by 80 millimeters of mercury. But in a study based on your site SOP or the protocol, you need to write 120/80, right arm, sitting upright after 5 minutes rest. That will be the documentation just for a BP. Imagine for other things. And mind you, the FDA inspector can read your written notes, which is supposed to be contemporaneous documentation. That's the GCP language which is used. That means real world, real time documentation to be done. And they identify the paragraph, 2 paragraphs or 3 paragraphs, there was a gap and this was not written continuously. They ask you, why did you have a gap in writing this, which is supposed to be in front of the patient? And that is the extent they scrutinize your handwriting, your flow, your stroke, what you use for your documentation of the ICF process. They identify to that extent that there was a gap writing between the 3 paragraphs. It is differently in time documented. And of course, what is an informed consent? It has to be voluntary. That is something you need to stress when you are doing the audiovisual consenting. And legal and ethical considerations have to be looked at, and that is what the ethical committee plays an important, huge role to protect the subject's rights. And you need to specify another thing is, you can withdraw from the study at any point of the time. For example, the flow study, which I was giving an example that came, that was over after 4.5 years. And patients can withdraw at any point of time, even tomorrow. Today they sign the ICF and tomorrow they can withdraw. That's the subject's rights. And the second point in the ICF, most important to explain patient, that it's a voluntary participation and there is no force on the patient to participate or sign the ICF document. And the third one, they can have alternative therapy, which is available in the market today or in the practice, and that is what you need to specify. These 3 points, the FDA inspectors calls for a translator when you do a Kannada or other local language ICF. A neutral translator officially is called, and they will play the video, and they see and they ask questions in front of us, open the video in the laptop, and ask us what does this mean to the translator, and they question me. And that is the extent they scrutinize whenever they come. Of course, audiovisual recording, it happens only in India because in most of the countries now it is not there, and as per notification of July 2015, the AV recording now is compulsory for all vulnerable population and also for newly detected drugs, which is first time coming to our country. So this is the flow in the informed consent form, informed consent process. You need to explain the study purpose, risks, benefits, ask questions, document that, and your coordinator will be simultaneously documenting that, and you need to read the consent form, questions and consider, and the legal representative, if it's a LAR illiterate patient, you need to take into consideration, and you need to sign, and you should always give a copy of the signed informed consent process to the patient or the relative. Of course, the current IRB approved ICF only you need to use, and people use not the amended ICF, the old ICF, then they get stuck again in the inspections. Understand subject's potential interest in participating in the study. Obtain primary and secondary contact details, because when you have a trial of 5 years duration, the patients might change their mobile numbers, sometimes they shift their houses, etc. So you need to have a backup contact details for them. Reconsenting is an important initial consenting. Delegation log is something which we do it after the site is initiated, and 80% of the findings in the inspections is because of the delegation log mistakes. You are wrongly delegated a task or wrongly delegated a person. For example, a phlebotomist is only to draw the sample and process the sample. They cannot do the packing, they cannot come to the site, the research wing, and do it. So that is the amount of scrutiny the FDA inspections they do. Of course, you need to write the appropriate site contact details. For example, the address, if the first line and the second line differs in 2 different consent forms, they will question. For example, my site address is 27152 8th Main 16th E Cross. In somewhere I written 16th E Cross first and 8th Cross next, they'll ask why this discrepancy. The patient might get confused. That is the extent they scrutinize. And of course, the source document is something which is very important in our research. For example, the patient calls me now, we are not in site, and I need to scribble on some paper here, for example, on the menu of whatever this available. I need to take that sheet and write there, patient called me at 11 a.m. today when I was in a conference, and this is what the patient complains, and I have to write in my clinical letterhead the documentation. Many times I've done this for hypoglycemias in the night at home or early mornings at home, and that is the extent the source documentation is appreciated and taken. So source documentation can be your railway ticket, bus ticket, anything. You need to just scribble and take it, pin it with that when you write the elaboration of the event which has happened and when you are not in sight. So the informed consent is the key, the basis, and this involves all these points which we just discussed. And the The green one is what? No effect on their medical care is something you need to ascertain, especially in the placebo arm studies. Of course, compliance with the protocol, that is again the onus is on the investigator. We should sign the protocol page, IU, what we call investigator undertaking, that we will not disclose this study, and there will be a lot of other things, like example, tirzepatide recently I've done a trial. So the Lilly has sent me from US saying that I should not be talking this to the media or to the people without their consent, because they have not launched in India. So it is only sent for the Indian investigators. The investigator or a person designated by the investigator should document and explain any deviation from the approved protocol. For example, what is the deviation means, protocol deviation. Somebody has to come every 4 weeks for the site, and they cannot come at the end of 7th day. Then I need to document why and how it is affected the study. For example, weekly once insulin we did last year, we're doing one more now, weekly once. They're supposed to come on every 7th day, upload their data in their phone, and it comes to our iPad. And if somebody does not upload on the 7th day, then it's my duty to call the patient and document the reason why he did not do it. It may be low battery, no signal, or he is traveling, he's got a function at home, then it is accepted. See, the deviations are accepted, but you need an explanation. So in the GCP, the commonest proverb we use is, no documentation, not done. That means if you're not documented, you're not done that procedure. IP, it is again responsibility of the investigator. This is what the IP room looks like. On the right side, you see the -70 deep freezer. Left side, you see the -20. And you see those which are labeled. I've got about 10 refrigerators like that to store the IP. Any deviation, any time of the day or night, we need to report, quarantine that, and take permission from the medical monitor who will be sitting somewhere abroad. And only if he issues that, it is okay to use. Otherwise, the entire batch of insulins or whatever the investigational product has to be shipped back, and I need to hold until the next batch arrives to my site. So it's very important to know that the generator backup and the power backup is a must for all these trials. In fact, the FDA lady who visited 2012 went to the generator and she said, switch off the current now. And I told it takes 6 seconds to take the power from the raw power to the generator. And she looked at her timer and it took 8 seconds on that day for my bad luck. And she says, you said 6 seconds. And I just smiled at her and I did not add answer. That is the extent they scrutinize. When you say documentation in the ICU process, it is taken at 10:30 a.m. and the ECG is done at 10:35 a.m. They literally go down 3 or 4 floors of your center and say it took 5 minutes to walk down and it did not have time to do ECG leads, all that. Then now in 5 minutes the ECG is done. 10:35 is the consent over, 10:35. So you need to be very, very clear about the flow of events. And this should, of course, have this restricted access. And of course, records, you need to keep it. The communication with the EC is another big time task for us. The progress reports every 6 months based on your SOP, you need to do it. I have 2 minutes, okay. The medical care obviously is by a qualified physician, and this is the difference between a clinical trial and a non-interventional trial. Most of us do the non-interventional trials on the right side, which are like your post-marketing surveillance. GCP is strictly followed. Scientific evidence, efficacy and safety of a drug is very documented. It's protocol-driven, ideal conditions. That is, a controlled environment is there for a patient whenever they are in the clinical trials. Randomization of a trial product. There is a homogeneous subjects, and it evaluates the efficacy and safety of any new molecule. And it's called subject when they are in the study, and patient when they are in the OPD, and investigator versus physician. Safety reporting within 24 hours. These are the events where you need to report to the DCGI or the Health Authority of India now. And this is the team you need to have, and you need to ensure proper handover when the team member quits or resigns, and that's again a big task to do it. Site practices, you need to be familiar with the trial with regard to the protocol, oversight, roles and responsibility of as a PI. Conduct of the trial, remember the more taxing days are also more error prone. So if you have OPDs more on that day, so during screening, during the trial screening period when we initiate the patients, I give less OPDs and more time, because each audiovisual consenting is at least 45 minutes to be recorded. When it's a live, you need to record and save that, make 2 copies of a DVD or a pen drive and hold it for 15 to 18 years. So that's very important to retain the documents, and that's the ISH GCP 4.5, which talks about the compliance with the protocol. And what is an audit? Audit is a systemic and independent examination of a trial-related activities, whereas inspection is a regulatory authority. Inspection is the highest one what you can face in your clinical routine practice with respect to the GCP. So FDA requirements, these are all the 21 CRF part 1, part 11, which talks about electronic records. This is what we talk about in the EMR. If somebody has got, it has to comply 21 CRF part 11. And that is where you have something called as an audit trial, where you can see who has opened that at what time, in what axis. So that's very important in routine practice. So to conclude, research is evolving towards the assessment of effectiveness under real life conditions, standardization of clinical practice, development of new information technologies like EMRs, and defensive medicine is accelerating the incorporation of typical elements, and clinical research should yield results applicable to individual patients, and medical practice should enable the possibility to learn more from our daily practice. Thank you very much, and any questions, I'll be very happy to take it up.
Thank you, Dr. Srinivas, for that elaborate and detailed, step-by-step procedure, what I've explained to each one of us. And I think really commendable that even with your busy practice, you're able to do this kind of a research. I think what we, as clinicians, what we face is basically one aspect. I would take your input as to how do we enroll the subjects, by explaining them the pros and the cons and the drug and everything, one. And two is having this busy schedule, how do you give your time for research? So I think that is where the challenge for clinicians here is.
Agreed, ma'am. I think the first one, to consent a patient, to convince or to educate the patient. We should not use the convince. Sorry, I'm sorry about that. GCP is you cannot coerce a patient. That's a term typically used. So to talk to about the study, when patient walks in, you look at their profile. For example, BMI. In tirzepatide, we had a BMI cutoff of about 27. So I will have that in the mind, and whoever comes about 27 with whatever 1, 2, 3, 4 background medications, I will look at that, and I will read that patient's mind whether he's inclined towards research by talking few words. And this takes about 2-3 sittings to get the patient on board for the AV consenting. 80% of them agree for research, and when we say it is recorded and it is stored, all of them go back. 80% of them go back. It's only 20% what is it. So imagine if I'm doing a globalized recruitment. For example, in the ICOTAC trial, I did globalized recruitment of 39 patients. India has outbeaten Brazil and Mexico and US, which are the highest recruiters normally in any of the studies. And 39 patients, imagine the proportion of patients I would have spoken and spent time. So you need to have patience, and I would always say passion is something which is required for that. That is why it is not everybody's cup of tea. So convincing the patient is what the common man's or other fellow colleagues say. We say educating the patient about research, and thanks to media giving all the negative feedback about any trial, and that's why we don't get many new drugs to our country. And if you see, many of the MNCs are backing out from India. This is one of the reasons why we don't generate our own data, and that's where the catch is. And what was the second question you asked, ma'am? Sorry.
How do you get time?
Give time, okay. You need to be more organized. That's what, and Karnesh sir was talking about my travel, all that. So I give my OPDs on Sundays, sometimes when I'm not there on Saturdays. I compensate, and I have a fixed timings for research wing where they'll be waiting for me every day. 2 hours I spend, because I've got about 9 projects ongoing now. So I need to give time, and that is something up to you, how you design, and it's individual, how you do it. Vijay sir.
Sir, we are really proud that you are doing so many trials in India.
Thank you, sir.
Thank you so much, and thank you for a good lecture. 2 points. One is what Dr. Shobha Naidu said. How do you recruit patients? They all want metformin, and we don't use metformin straight away. And so it's very difficult to, they want 1500 milligrams of metformin, and so on, 2000 milligrams of metformin. Only metformin as an inclusion criteria. And then you add on your drugs. So that's one thing. Second is, how do you maintain review of these patients?
How do you maintain?
Review, follow-up of these patients. You can't incentivize them. You can give them free glucometers. You can give them their travel reimbursement. But you can't do anything else. So it's not allowed according to GCP protocol.
Correct.
So how do you follow up? And first question on metformin. We don't use metformin alone nowadays. So how do you recruit patients?
I think metformin alone, the number of trials are less. Only when the new molecule comes up, metformin failures as a second line. So metformin, I definitely use 1 gram BD for most of my patients who tolerate. That's number one. So we need to figure out from your EMR the number of people who are on EMR with metformin. That's the easiest way to pick it up. That's your practice, or obviously your practice, because they require minimum 1500 mg and above for most of the trials, whether it's insulin or any new drug. The second question you asked about is a follow-up, the incentivize. No, definitely you cannot, as I said, coerce a patient in research. So you need to have all kinds of the other perks, like seeing a family member, talking to them, spending more time with them. For example, my OPD is only by appointments, but a research subject can walk in anytime without even appointments. That's one of the perks we give, and it's not charged. Somebody has taken part 4 years back in a research. Still today, we do not charge, or we give them some extra perks like no appointments and discounts in these things like investigation, even post-study. So that's what you try to do. And of course, the patient and the duration of your relationship with the patient does matter.
LSM,
Sir.
Being a investigator as well as in the ethics committee, I would in a lighter vein say he can conduct coaching classes in clinical trials, and all of us will attend to that, okay?
Thank you, sir.
Very much.
Thank you, sir.
Very well done, very beautifully done.
Thank you, sir.
Because I've gone through so many times, it was a revision for me.
Thank you, sir.
If no more questions, I think we'll conclude the session.
Thank you to the chairpersons and the speakers for this wonderful discussion. I request all the three of them to join for a photo, please. And I also request all the three of you to collect your mementos from the faculty lounge. This is a request once again for all the chairpersons and speakers to collect your mementos from the faculty lounge. Don't forget it, please. Time now to move on and go into a journey from normoglycemia to hyperglycemia, homeostasis to allostasis. Who better than Dr. M.A. Shekhar to speak on this? Sir, now we hand over not just the mic, the whole stage for you. And to chair this session, we have with us Dr. Kashinath Dikshit and Dr. Kiran Nedagundi.
Thank you, Sureka. Good morning, everyone. At the outset, thank you for this opportunity to talk to you people. And I hope I'll be taken in the right sense, because this is something new, though it's an old wine in a new bottle, as I have put it. And before I start my speech, or whatever you want to call it as, let's take a moment to remember the martyrs and heroes of the 1971 war, which made India a superpower when it comes to army. 16th December is observed as Vijay Divas. Today, let's remember those martyrs. Shall we go further? Okay. To understand the caption I've given, it may take some time for all of you, but anyway, let me try my level best to do justice to this. When I saw this cartoon, immediately my brain started thinking about this caption. This is my cousin in US who wants to be a millionaire. Kaun banega crorepati, crorepati, whatever it is. Look at the question, 2024. Which do you think is the right answer? This is where the ball starts rolling. We have been talking about why we become diabetics, how we can treat, etc., etc. But have we ever thought, paused a moment and said, what is it inside our body that makes hyperglycemia from normoglycemia? Have you ever thought about it? Ladies and gentlemen, be very, very honest. We talk about so many risk factors, octet, cetaceous-7, all those funny things that lead to diabetes. And you talk about immunology that leads to type 1 diabetes and all that. But at the end of the day, what is the common final pathway that makes a person, whether they are 2-year-old or 20-year-old or 60 years old, become hyperglycemic from normoglycemia? Have you ever thought about it? Let me try to help you today. I hope I'll be taken in the right sense. The introduction. Maintenance of glucose tolerance is an important protective mechanism for vertebrates. I do not know about invertebrates. It's a statement that all of us have to take it in a very, very important manner, because reduced glucose endangers the function of central nervous system, leading to inability to compute, etc., etc. Elevated glucose leads to protein glycation and all the general organ failures that we have been talking about. But what happens in your body? Low glucose, high glucose. the so-called TIR or TA, whatever. I always get confused with all these new acronyms. Time above, time below, all those funny things. It's very narrow. Have you wondered how your body, the wondrous body that nature has given or God has given according to what you believe in, how it keeps your blood sugar in such a narrow level? This is the introduction. This is what we have to think about. So what came first? Chick or egg? Anybody? Today it has been proved, it seems, just about few months ago, it's the chick which came first. So believe me, you can Google, there are 2 papers which says chick came first, then they become ovulating stupid people. Otherwise, it was instantaneous evolution. Similarly, as far as diabetes is concerned, which came first, insulin resistance or insulin deficiency? Give it to experts sitting in the front lines, they will go on and on and on for next few weeks and nobody will come to a conclusion. But let me try this. I hope you remember it's a 2-hit disease in which insulin resistance is necessarily accompanied by beta cell defect, preventing compensatory upregulation of insulin secretion. I'm sorry, I'm not a good reader. It's a 2-hit disease, type 2. Type 1, I'm not going to talk to you people at all. Pardon me. It's type 2 disease we are talking about. It's a 2-hit disease. Resistance versus beta cell dysfunction or insulin deficiency. And I hope you remember your physiology. What came first in open loop and closed loop concept? Open loop, they say it is insulin resistance. The other open loop is beta cell deficiency. And hands down in open loop, insulin resistance wins. It's the insulin resistance, whatever the reasons, at the end I will tell you what is the real reason. Whatever the reason, insulin resistance wins hands down as the reason which leads to beta cell dysfunction. Type 2, mind you. In closed loop, it's complementary. You know, insulin resistance, there is some amount of beta cell dysfunction of genetic origin or environmental influences, whatever you're talking about, leading to hyperglycemia. Open loop, insulin resistance. How many for insulin resistance as the first pathophysiology? Stand up on the bench. How many for complementary? Both insulin resistance and dysfunction. It goes on and on. After some time, hyperglycemia. Sit down. Lot of reasons: lipotoxicity, inflammation, hyperglycemia, mitochondrial dysfunction, ER stress, genetic mutation, lipotoxicity, inflammation. Oh, I put inflammation twice, I'm sorry. Why do you think I put inflammation twice? That is the beginning of your insulin resistance. Let me defend myself. Now, having said that, homeostasis to allostasis is what we really have to look at, discuss, and then talk about it. Otherwise, with so many risk factors, we are talking about 16 risk factors or pathogenetic mechanisms, we are talking about genetics at the same time, every one of us sitting in this hall should be a diabetic. Don't you agree? If there are so many risk factors that are playing on us, genetic background, which is very high risk for Indians, almost all of us should be diabetics, but it doesn't occur. Not all will become diabetics. It's because that fantastic concept of homeostasis where the body fights till the end before it becomes hyperglycemic. Stability through staying the same is homeostasis. You all remember milieu interior, Claude Bernard. I'm not going in detail, and I have been told by the organizers, no questions. We can always have a cup of coffee, you can ask me questions, okay? There are 4 phases for homeostasis as far as glucose metabolism is concerned. The fed state, when we eat, blood glucose fluctuates. The post-absorptive state, when we have stopped eating and absorption has started, blood glucose still fluctuates. Fasting state fluctuates, and prolonged fasting state or starvation state, 4 homeostatic mechanisms. which work in such a smooth manner. Your high blood glucose is never beyond 130, 140. Low is never beyond probably 100 or 96. Very narrow. That's homeostasis. And what are the players, organs? We have already told. I don't think I should talk to you about it, and you will all laugh at me if I say brain, GI tract, pancreas, fat tissue, and all that. And with this so-called homeostatic model, we have come up with the risk factors. Brain as a risk factor, GI tract as GLP. You know the whole story. So primary perturbation in the journey towards diabetes is high blood glucose. We all agree. It's called as increased flux of glucose into bloodstream. This is the first thing that happens. Please understand, postgraduates, the first primary perturbation for a homeostasis model to go to allostasis is increased flux of glucose into the bloodstream, not into the cells. That comes later. How does it happen? You blame brain, you blame eating habits, you blame GI tract, you blame liver, etc., etc. It doesn't matter. But in homeostasis, what happens? Whatever the increased flux or whatever that is happening in either digestive state or post-absorptive state or whatever it is, three mechanisms: increased insulin secretion, increased peripheral glucose uptake, and inhibition of endogenous glucose output keeps your blood glucose at that level. These three. Normoglycemia is achieved by a tight coupling of nutrient-stimulated insulin secretion called as acute insulin response, AIR, and metabolic action of insulin to stimulate glucose disposal, M. So AIR, we call it as beta cell dysfunction. M, we call it as insulin resistance. Simple. In healthy individuals with normal glucose tolerance, normoglycemia can always be maintained by compensatory increase in AIR in response to decreasing M. This is it. AIR, M, in steady state, beautiful glycemia. If M starts decreasing or insulin resistance increases, normally acute insulin response take care of that. Later beta cell dysfunction leads to type 2 diabetes. Hyperglycemia is different in type 2 diabetes. And plenty, the players, hormones, receptors. Sweet proteins, have you heard of? I just added it day before yesterday to this slide set. Sweet proteins, sweet. I have already written it. Sugar will eventually be exported, transported. It came from fungi, plants, and today we know there are proteins which facilitate glucose transport from GAT to cells, etc. like that, not just glut. But there is another sweet protein. I have forgotten the names, I'm sorry. I can always look into my notes and let you know. There are 6 or 7 proteins from the plant kingdom which are, I was surprised to know, 10,000 times sweeter than sucrose. 10,000 times sweeter than sucrose. That's a sweet protein which is going to mask all your so-called sugar substitutes in future. And this is it. The players are hormones, receptors, etc. But at the end of the day, all these things keep your body at a very narrow level of blood glucose. Simple concept, okay? Now, brain islet axis, this is for postgraduates. I know I will leave my slide sets here. You can always take it and work on it. Brain islet axis, entero, hypothalamo, insular axis, liver islet axis, gut islet, etc., etc. These are the concepts of homeostasis which leads to something. Now, from homeostasis, which keeps your blood glucose, whatever the problems that is happening in a very narrow range, leads to allostasis. Stability through change. Allostasis is not pathogenetic, it is still physiological. Because of these problems of high influx of blood glucose, there is some changes in your hormones, some changes in your organ function, which leads to some stability. But from 100 milligrams, it goes up to 110. From 110 to 120, 120 to 130, 130 to 140, 140, blah, 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 blah. Over the years, it goes to 200 and we call them as type 2 diabetics. This is allostasis. But what is allostatic load, glucose allostasis, is the one that you should read to know. Allostatic load, wear and tear on the body. In simple thing, the load, the more you eat, there is more flux of glucose into the bloodstream, more wear and tear. Simple concept. The allostatic load is mainly dependent on glucose influx. The reason is what we are supposed to look at it. I will not explain this slide because it's extremely simple. Okay? So perceived stress, whether it is endogenous or exogenous, is this first step that leads to allostasis and allostatic load. Simple concept. You can go on working on that. But what is the denominator today for allostasis to occur? Not more eating, not more sugar in your food. It is the perceived stress, endogenous or exogenous stress, that starts the ball rolling towards allostasis and abnormal glucose metabolism. And stress and glucose metabolism is something every one of us should open our eyes, internal and external eyes, every time we see a type 2 diabetic sitting in front of us. What is it, that first thing that should come to your mind? Not blood glucose, not kidney function, not retinal levels, it is the stress. What is the stress? I'll define it later, but keep this in mind. I have been practicing this for many number of years. The first thing I always talk to my type 2 diabetic patients is about stressors. Take care of that, half your problem is taken care, it's my philosophy. And finally, high GI meal, whatever. Postprandial hyperglycemia, glycated proteins, dyslipidemia, insulin resistant, blah, 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 leads to diabetes and end stage dysfunctions of the so-called diabetics. What is it? Homeostasis. The body tries to keep it at a very narrow level for a very long time. Allostatic load, aka stress hormones, lead to abnormality of this homeostasis. Allostasis still physiological. Sometime later, 5 years, 10 years, 15 years, what happens? Your friend, your neighbor, your family member becomes a diabetic. This is normoglycemia to hyperglycemia in a nutshell. Newton had been seeing his pee go downwards in entire life. Every day he used to piss, it never went up, but it needed an apple to tell him gravity. Ladies and gentlemen, please waken up your common sense, not your medical sense, to help your type 2 diabetic. Thank you.
Thank you, Shekhar sir, for making the things very simple and understanding. So hence we are lacking of time. We'll have the questions.
See, we see a lot of diabetic patients. We treat them with so many medications. And patients will be happy, we will be happy, we get some money. But when a 30 or 35-year-old man comes, he says, my sugars are high. Why I got diabetes? My parents are not diabetics. I am not obese. I walk daily. Why I got diabetes? I'll tell him, I can treat your diabetes, I can bring it down. But why you got diabetes? You meet our Vice Chancellor, Dr. Shekhar.
Okay, definitely. See, recently, RSSDI in Mumbai, I spoke about this, why people become diabetics, even though there is no genetics, even though their lifestyle is good, even though they eat the right food. It all goes to blame your mother. I'm sorry, don't take me the wrong. FOAD, fetal origin of adult diseases. If they allow me, I'll talk, but this is not the podium. Thank you.
Thank you, Dr. Shekhar, for an excellent presentation. I think we'll hand over the mic to organizers. And thanks to Manohar and his team for an excellent program. Thank you.
Thank you so much, Shekhar sir, for your wonderful deliberation. And here is a Kodak memento for all of us to remember. I would request the chairpersons and the speakers also to collect their memento from the faculty lounge. Please do not forget this. Thank you so much, sir. The next session is another interesting session where we talk about avenues for revenue in diabetology. I'm sure all of you are really interested in this. And to talk on this, we have with us Dr. Neeta Deshpande. And to chair the session, I would request Dr. Pradeep Kumar TJ, Dr. Srihari Kulkarni, and Dr. Prabhakar. Thank you, sir.
Good morning, everyone. Welcome to the session. I call upon the next speaker, Dr. Neeta Deshpande. I am sure she does not need any introduction. She is a diabetologist and bariatric physician from Belgaum Diabetes Center. She is a professor and head Department of Medicine, Dental College, Belgaum.
I believe my slides are not loaded yet, but until that time, I will just do the preliminaries at the outset. I am so glad to be here for the KRSSDI, the 20th year, and I'm so happy that I have been one of the founder members from the very first year and part of the committee from the first year and a past president. So thank the current team for calling me here today for this wonderful conference. That is number one. Second, my topic is not for people who in this hall who are already very rich and who have a lot of money, like maybe Arvinda, and they don't need to hear this lecture at all. In fact, they can add to this. So this topic was something that we've been talking about for a few years now, about avenues for revenue for doctors. So in the past, this was blasphemy because doctors are not supposed to talk money. It's a noble profession. But then I always look back and tell them, we need to live and live well. And we have children. We also pay taxes. There is no concession on taxes for the noble profession. There is no concession whatever. Our kids also go to school, pay the same fees. And hence, avenues for revenue should be open to us also. And there's no harm in talking about it. So the disclaimer for this talk, so so what I'll do is, I'll tell you some parts which are already there in my slides and then run through those slides when the slides come on, right? So the disclaimer for this is that I have absolutely no conflict of interest for this particular talk. The second disclaimer is that all the avenues that we talk about today are ethical, above board, standard of care. So there is no such thing as that you cannot do this. So I've divided my talk into two parts basically. One part of increasing your revenue, one avenue is to increase the number of your patients or increase the flow of patients, right? So that everyone wants to do and everyone tries to do. So I have a few points to cover on how you can do this simply, easily, elegantly, and without any problems. So that is one part of my talk. The second part of the talk is actual avenues for revenue, what you can do. Unfortunately, unlike surgeons, we would see 100 patients in one day and make less money than the surgeon who sees maybe like 5 patients and operates on 1. So we have to find other ways in which we can augment our income because we have spent the same amount of time, in the medical school and worked hard enough. So I think it's coming on. Okay, so it's here. So this is how I'm going to divide my talk basically. That one part is how to increase your patient base, and the second part is how to actually use certain tools in your practice or introduce them in your practice by way of which you can do it. So, well, I will finish in my stipulated time, so no problem. So this is, these are my disclaimers. I already told you about them orally, and I already told you about the overview, increasing the patient flow. And the second part is the value-added services that you can give, which can increase your, typically I'm talking about an OPD setup. Those of you who are in hospitals, things can be different, but in a typical diabetology OPD setup, what are the things that you can do? So increasing patient flow is very much related to the patient experience. Nowadays, everyone talks about ambience. Every patient, whether it is a lower middle class, upper middle class, and of course the elite, everyone wants a nice place, a pleasant looking staff, or very welcoming and good people and looks nice. So this ambience is what people are now used to. It has now become a norm, a standard, and ambience is no more a luxury. So this is what I'm talking about when I talk about ambience. So you can see if you can make it as nice as possible for your patients. So I got a chance to show you my new venture. This is my our new hospital, and this is the waiting area. This is one of the cabins. So this is how you can increase your ambience, and the patient feels nice to come there. And in diabetes, our patients keep coming back. So if they want, they should want to keep coming back, so you make the ambience better. So that is the one thing. The other part of the patient experience which will make patients come back and tell other patients, go to this doctor or go to this place, is the front desk experience. The front desk experience, I'm telling you, is honestly an avenue for revenue, because this is what patients pay a lot of attention to. Even if they get less time with the doctor, their front desk experience has to be very welcoming. The person sitting at the front desk has to be knowledgeable. If she asks, where can I get this done? She cannot say, I don't know. She has to know she or he has to know everything that is there in that center, where it is located. And it's like a reception come, may I help you counter. So they have to be knowledgeable. They need good language skills, because the same sentence can be said in 3 or 4 different ways. It can be harsh, it can be indifferent, it can be sweet, or it can be just neutral. So that warmth has to come in, and for that a person needs good language skills. The person has to be resourceful. I have already eaten and I've now come for my blood sugar. What should I do? So that person has to be resourceful and knowledgeable enough to say, it doesn't matter, we'll get you a random check and maybe an HbA1c, another avenue for revenue. So that is the thing. So that resourcefulness has to be there on the part of the person sitting there. Last but not the least, in terms of front desk, waiting times have to be controlled. That means that a patient coming in and waiting to get the test results, and then, waiting to see the doctor, then there is a wait time. So if this wait time is too much, patients are going to get irritated. However, there's a caveat here where diabetes patients are concerned. For example, when a patient comes fasting at 7 in the morning and the appointment to see the doctor is at, say, 11:30, so he does not calculate the time that is after his reports have come. He will calculate the time from the time he has come in the morning at 7 and say, I'm waiting here since 7 o'clock. So it's not 4.5 hours. You see, he's come for someone has to sit and explain. You anyways would have had to wait for your reports, but you're waiting for your doctor, and that wait time is not that much. Reschedule appointments appropriately if the patient's reports are going to get delayed. Why am I telling you all this? Because this is the patient experience. The patient experience is the one that is going to get you repeat patients and more patients by word of mouth. Then come the facilities. I'm not talking about the infrastructural facilities related to diabetes. I'm talking about the other facilities. And as many in-house facilities as you can give, these are also avenues for revenue, which I'm going to talk about. But things like clean drinking water, maybe good reading material, television or Wi-Fi, whatever is possible, if you can provide that in reasonable limits and means, that adds to the patient, in the waiting area. You give educational material. And let me tell you, if you continue, that's the policy I follow in my clinic. For a while, we put educational material. After that, we put Bollywood songs. Because everyone doesn't need to be bombarded all the time about diabetes. I know it's an opportunity. However, they also want to relax, keep them, calm. So you just put some nice songs, some good dances, and they're happy to wait. So these are the facilities that I'm talking about. Again, this refers to the patient experience and getting more patients. Then another big part today of increasing patient flow is social media. You have to know how to use it well, and please do not overkill. Overkill is irritating. People will just scroll through. It has to be not too much, not too less, just adequate. So you can have a page. If you have another niche area, like for example, I do a lot of reversal of diabetes, so I have a separate page for that. And then you can also post what you have done in the past. So my colleagues sitting here in the hall, we have done this, and we were exactly doing something like avenues for revenue on this webinar. So you can post relevant things that you have done. This was through KRSSDI as well. So you can do relevant things, post those things so that people, as I said, do not overkill. People do not need to know that you're sitting in the lounge of so-and-so airline. It's not interesting to anyone. So if you have a page, please keep it official, and please make sure for your friends you can show them wherever you are, doesn't matter. But if you want it to hit hard, don't mix up all of that, and that's where you need to learn how to use social media. You can post something that you have done. Like for example, this is a poster presentation in an international conference. Post that. So that can get you more patients, because people will see, oh, this doctor is academic and this doctor is going international, presenting. So of course, by all means, you can post these kind of things. Then if there are certain interesting, webinars that you are giving, or interesting talks that you are giving. This is again the RSSDI Diabetes Bites. So if there's something interesting, do post that. Or if you're doing a campaign, like the Obesity Week. So I'm happy to tell you that these are posters that are designed by myself. I don't have any digital media person. I just do these posters myself. So you do something interesting like this. Like for example, only in obesity treatment you gain when you lose. So this was during the Obesity Week. For example, you can run a question and answer campaign. It engages people. Then they'll try to find out who are you, where are you located. And then you can have, say, World Diabetes Day is coming up. For that entire month, we had at least one post like this. Then this was about weight maintenance mantra. So we had a campaign for that. So you can do designated campaigns as you can, and this is how you improve that. Another important part, people still do read newspapers. So if you can write articles in the print media, that is definitely going to help you. That's going to keep your stocks up, and people are going to search for you, look out for you, and increase your patient base. Next part of my talk is about the value-added services. So I think I'll just take about 5-6 minutes more, that's it. So the value-added services are what you can actually place in your OPD, ask patients to do it, and that's also a means of revenue. Like for example, lab services. If there's space, you can have a small machine and have your own lab. If you don't, or along with the lab services, you can have point of care testing. You have several machines like this nowadays. You can do lipid profile, you can do HbA1c, you can do microalbuminuria, several point of care testing things that you can do. And this also adds to the revenue because one, and second, it's a value-added service. Patient doesn't have to go any other place. He comes to your place, does his test there, waits there for you, does his consultation, and goes back. So that adds value and adds revenue for you. Then you can also put in a unit for diabetic foot assessment. This is at our place. So nowadays you have the actual biothesiometer, or you also have certain digital machines which can do 2 or 3 different tests at a time, easy to teach your staff and easy to get it done. You can train somebody for basic podiatry services like nail cutting, for example. So if there are very bad nails and you need to do nail cutting, you can train a podiatrist and get this done. So these are again, or if you have a nurse, that nurse can fill in for that. So this again adds value. Why foot assessment? Is this something extra that you're ordering? No. Every year, every diabetic patient or persons with diabetes, now you're supposed to say, every person with diabetes has to undergo a foot assessment to assess his risk for foot ulcers. So this is absolutely above board. It's a recommendation, it's a guideline, and if you can provide this in your own setup, it's good for the patient, and it's also a revenue source for you, and you can charge based on where you are located. You can charge for this, and if every patient is going to do it every year, it is certainly a means of revenue. This is the body composition analysis that we have at our place. This is the in-body 770. This is a higher end machine, but there are even lower end machines if you just want the basic body composition. It helps in tracking the patient. You're not doing research on this, so you don't need DEXA or you don't need underwater weighing, but it gives you a basic idea, shows the patient that this much is your visceral fat. If you can see at the far end top right, you can see that graph which is there. Anything above the line shows that there is excess visceral fat. So you can actually show the patient how it is done, and then with this body composition, the patient may be motivated to lose weight, lose fat, and take up exercise, etc. This again can be charged. Fundus camera. If you can keep a fundus camera at your place, train one person, every patient, every year needs a fundus examination. So you can give a fundus photo to the patient. If it shows on the screening signs of retinopathy, then you can send the patient to the ophthalmologist. But the basic screening can be done at your place, and this is definitely an avenue for revenue. Then if ECG everybody has, but if you have the space and if there's someone coming in, you could also place echo and a TMT machine, because we know that cardiac disease is huge in persons living with diabetes, and they need to be screened very frequently, and we often send them off to a cardiologist. No harm in sending to a cardiologist, but you can do the basic testing with yourself, and this again becomes an avenue for revenue. This is something you can definitely easily do. Value for money, very important, and that is ambulatory blood pressure monitoring. So if you have one or two machines at your place and you do this on people with fluctuating blood pressures, patients who have disbelief, I don't have blood pressure, only when I come to your place the blood pressure goes high. So you want to rule out the white coat effect. So you can do this, show the patient, get a graph, and definitely it's just a 24-hour test, and the patient is happy to do that, and this becomes another avenue for revenue. FibroScan is an expensive machine. Almost all our patients with type 2 diabetes have a fatty liver. So you can tie up with somebody who rents the machine, or somebody who can give you the machine, say once a month, get it done. You can charge the patient for this, whether nominal or whatever, but still it's an avenue for revenue. If it's a big hospital, they'll have it anyway. But if it's a small setup, you can rent it once or twice a month. So this is the other thing that you can do. So to conclude, increasing patient flow can be done by improving quality of care. So quality of care is extremely important, as I said, right from the front desk to the services that you offer. Diabetes requires extensive tests on an annual basis. All of us know that. And if you can do that, that's great. Point of care testing for most parameters has come of age. You have got good machines which are quite adequate, pretty much accurate, and you can use those point of care machines. They occupy less space as well. Patients do like to have all the testing under one roof, for sure. So you're giving them what they want. You're also making some revenue in the process, which is great. So it's a win-win situation for both. So offering these services is a means of improving revenue in a legitimate and ethical way. That is what I had said right in the beginning in my disclaimers. There is nothing wrong in all of this. It's just that you are placing all these services in your OPD. Patient is benefited, you are benefited, and we may not reach the revenue of a surgeon, but we'll certainly do better than what we are doing now if you didn't have these particular things. So thank you all for a patient hearing. I hope this has been useful. As I said, this is not meant for the very rich people sitting here. It's meant for people, students and people who are looking to go up. So thank you very much.
So I think hats off to Dr. Manohar for choosing this particular topic in the scientific session, and all the more, no better person than Dr. Neeta Deshpande to have talked about this aspect of avenues revenue. Let's have a huge round of applause to Dr. Neeta Deshpande. Dr. Neeta has done is just by a pleasant personality, just by the way that she deals with her patients, and the way that she's been practicing, she's been walking the talk, and I'm sure all that she has talked about is what has helped her become probably the leading diabetologist at Belgaum. And I'm sure everyone here in this audience would take a leaf out of this particular practice and ensure that you become richer ethically and make sure that you gain more revenue through your practice. Thank you so much. Because of want of time, we are not taking up any questions. Thank you, Dr. Neeta.
Thank you so much, madam, for this interesting and innovative presentation. I request both the speaker and the chairpersons for a Kodak moment again. And I also request the chairpersons and the speakers to collect their mementos from the faculty lounge. Please do not forget this. What a practical session. Coming to the next session, it is to discuss strategic harmony, DPP4 inhibitor plus SGLT2 inhibitor. To deliberate on this, we have Dr. Arvinda Jagdish with us. And to chair this session, I request Dr. Suresh KG and Dr. Ravi Kirti sir to on the stage, please.
Good afternoon. It's a pleasure to introduce my best friend, Arvinda. He doesn't require any introduction. He's a triple FRCP. He runs his own center, Arvinda Diabetes Center. So over to you, Arvinda.
So good afternoon, everybody. At the outset, welcome all to the KRSSDI conference. It's nice to see a nice crowd here. So that shows the involvement in the KRSSDI conference. I think this is for the previous talk. So the buzzer is not for me. So welcome all of you. So for a management of diabetes, always the strategy is needed. Like for any conference or anything, we plan it accordingly. In the same way, to manage it, type 2 diabetes, you need a particular strategy, like how do we go ahead. So this is my talk today. It will be on dynamic duo, that is combination of SGLT2 inhibitors and DPP4 inhibitors. And this will be a special reference to vildagliptin and dapagliflozin combination. This session is sponsored by USV. That is a disclaimer. So we all know diabetes is a global emergency. It is the fastest growing global health emergency of the 21st century. We all know that. And 537 million adults are living with diabetes worldwide. So if you take the ICMR India study, 46.7% of type 2 diabetes is under age 40 years, and 40% type 2 diabetes is between 41 to 50 years. Comorbidities is hypertension 23%, obesity 26%, dyslipidemia 27%, ischemic heart disease 6%, metabolic syndrome high prevalence is like 20 to 32%. So 30 to 40% type 2 diabetes patients have probability of developing ASCVD. So type 2 diabetes is a progressive and complex disease. I am sure all of you will agree on this. A 5-year increase in diabetes duration was associated with an excess risk of about 20% for each of the 3 endpoints. So hold glycemic based diabetes care. This is what in the past few decades has been followed. The newer concept, as like 1 or 2 years or 3 years, you can see the newer things are coming up, new evidence-based medicine is coming up, and we are used to that. It's not only the diabetes glycemic care, it's about the body weight, liver, heart, kidney, everything has to be addressed. That is where the newer guidelines has come. Our own RSSDI, we have so much of guidelines. All of you should visit the website and see what are the guidelines. In all the conferences, we talk of ADA guidelines. No, it should not ADA guidelines. It's RSSDI guidelines. We should talk about RSSDI guidelines because this is where we practice in our country, so we have to follow our guidelines. So we know that there is an increased DPP-4 enzyme activity in non-obese Indian patients with type 2 diabetes. So efficacy of DPP-4 inhibitors is higher in Asians than non-Asians. This is a review article by my friend, Dr. Avdesh Kumar Singh, who has shown that the increasing response in Asian type 2 diabetes are Indians different. So the effect of DPP-4 inhibitors in Asian versus non-Asians, this was a meta-analysis where it showed efficacies of DPP-4 inhibitors is higher in Asians than non-Asians. So pioneer gliptin, when it comes to the first study demonstrating the DPP-4 inhibition with vildagliptin increases GLP. On the left-hand side, we can see the active GLP-1. That is continuous oral DPP-4 inhibition increases this active GLP-1 while improving glucose tolerance. On the right-hand side, you can see in the slide. So vildagliptin as the pioneer gliptin, this has got a durable first-line therapy for early control, no harmful weight gain or weight loss, low risk of hypoglycemia, cardio-renal and hepatic safety, reducing pill burden with once daily preparations. So what are the studies? There are 3 studies. There is initial trial, which showed there is a significant reduction in HbA1c. EDGE trial, which showed a lowering HbA1c to less than 7% without weight gain or hypoglycemia. Verified trial, 3 years back it came. It improves the long-term glycemic durability. So it is an effective and safe in initial combination therapy for early and aggressive glycemic control to prevent macro and microvascular complication in drug-naive patients with type 2 diabetes. So this is a verified trial. What it said is an early combination treatment strategy significantly reduced the relative risk of time to initial treatment failure by 49% versus initial monotherapy. You can see in this graph, the initial monotherapy is on the green, and the early combination, you can see the blue line, how it is better response. You can see over a period of 5 years, the durability and sustainability is achieved. The 4-fold advantage of vildagliptin is better DPP-4 inhibitors, less hypoglycemia, better HbA1c reduction, and better time in range. So the better time in range with the vildagliptin, Dr. Shekhar was telling, time above range, time below range, there are numerous terminology. But if you see the latest concept is to avoid the glycemic variability, where we have to keep this glucose in time in range. So vildagliptin demonstrates the low hypoglycemic risk just like any other DPP-4 inhibitors. In this study, they showed a significantly fewer hypo episode compared with the sulfonylurea therapy, good glycemic and weight control observed in vildagliptin treated patients. So established CV safety of vildagliptin. This is the question always asked with a vildagliptin. This is an original article. You can see the cardiovascular and heart failure safety profile of vildagliptin. It is a meta-analysis of 17,000 patients. What it showed is it is not associated with increased risk for adjudicated MACE relative to comparators. It did not find a significant increased risk of heart failure in vildagliptin treated patients. So question is, are the DPP-4 inhibitors similar to other in terms of molecular binding to the host enzyme? See, vildagliptin is there, sitagliptin is there, linagliptin is there. When it comes to molecular binding, so the vildagliptin scores over. There is a elevated levels of intact incretin hormones are maintained for a longer period following vildagliptin than sitagliptin, less glycemic variability, more time in range, and potent blood glucose lowering. So there is a clinical significant reduction in HbA1c. On the left-hand side, you can see when it compared to other gliptins, the reduction we can expect up to 1.3. And maintaining the HbA1c on the right-hand side, you can see the 66% when it compared to other gliptins. Coming to renal safety is an important thing. It's not any persons having diabetes or diabetic kidney disease, they should be on linagliptin. It's not like that. Even with vildagliptin, with the reduced dosage, it is as equivalent to other drugs. Like for example, in mild renal impairment, the dosage can be 50 milligrams once a day. Moderate, you can see the extensive study from 2010 to 20, the 10 years in all stages of CKD, it has been studied where vildagliptin can be used safely with the reduced dosage. So if you take an update of recent US FDA guidance on CVOT, so they always ask, there are some guidelines to say this particular drug is there. On the left-hand side, you can see type 2 diabetes mellitus evaluating the safety of a new drugs for improving glycemic control is guidance for industry. These are the parameters where the US FDA usually gives, and most of the criteria has been met with vildagliptin with the various studies. So now coming to the combination, the other drug, that is the combination which we are using since past 2 to 3 years, the combination of gliptins and SGLT2 inhibitors. Another blockbuster molecule you can see is the dapagliflozin. It has got a huge scientific data as well. I am sure last 2 to 3 years we are seeing every year there is a new data coming up. With this particular molecule, we have declartimi, DAPA heart failure, DAPA CKD, and deliver trial. So dapagliflozin is an extensively studied molecule and is backed up by 4 landmark trials named Declare, DAPA heart failure, DAPA CKD, and deliver trial. So we know the role of dapagliflozin in obesity, but the different mechanisms are there, like through biological mechanism, and when it comes to distribution of adipose tissue, and their macroscopic changes, how the persons are lose weight, we have seen. The question is, yesterday also I saw one patient, he comes, sir, I'm losing weight. His diabetes is very well controlled, but he is losing weight because he is already on SGLT2 inhibitor. The question is, what to do? I said, you should be happy, but patient's relative says that why you are looking so weak? Get yourself checked. So the problem is you give some medication, if they increase, that is also a problem. When there is a decrease in weight, that is also an issue. So how do we manage this? But once you explain to them all the positive aspect of this particular molecule, the acceptance is definitely good. So SGLT2 inhibitors offers an intermediate weight loss in type 2 diabetes. This is the latest concept. You can see the role of dapagliflozin in NAFLD. It contributes to NAFLD by reduction of hyperglycemia, improvement of insulin resistance, elevation of calorie class and reduction of body weight through glycosuria, reduction of hepatic de novo lipogenesis, hepatic inflammation, apoptosis, endothelial reticulum stress, oxidative stress, increase of hepatic beta oxidation, reduced activation of hepatic satellite cells, and P53 and P21 pathways, leading to amelioration of hepatic fibrosis and HCC development. So we know that dapagliflozin has a benefit to play in heart failure, that is DAPA heart failure as shown. Now coming to the important aspect, how does these two molecules like synergism, what is the synergism between DPP4 inhibitors and SGLT2 inhibitors? You can see on the left hand side of this slide, the SGLT2 inhibitors acts through kidney, causes increased glucosuria, thereby decreasing the glucotoxicity, reduction in weight, and reduction in systolic blood pressure. Pancreas, it is an indirect pancreatic effect that is increases the beta cell sensitivity and increases the glucagon. This is the SGLT2 activity. On the right hand side, you can see the DPP4 inhibitors. It acts through intestine, incretin effect, increased GLP-1 and GIP, and weight neutrality. On the pancreas, there is a dual pancreatic effect. There is increased insulin secretion and decreasing glucagon. So you can see the synergism. If there is a worry about it, there is an increased glucagon with SGLT2 inhibitors, that can be tackled with the DPP4 inhibitors because it decreases glucagon. Ultimately, there is a decrease in sugar level, decreased hyperglycemia, and it has got a pleiotropic effect. Now coming, where do you use this combination? The always asked question is, okay, these fixed dose FDCs are there, but where do we use in our clinical practice? What are the guidelines you can see? On the left hand side, the management of type 2 diabetes is, we know, it is initiated with lifestyle modification. You can go 1, 2, 3 like that. The first one is in treatment naive patient. You can use this. Where metformin is contraindicated, intolerance, or under HbA1c is more than 8%. HbA1c more than 8%. The second one, in treatment naive patients with metformin in combination where HbA1c is high, that is more than 9%. The third one, the person who is uncontrolled on metformin, we can when the HbA1c is 8.5%. So this should be very clear where to use. On the right hand side, that is the continuation of this. The fourth one is uncontrolled on both these things. Either the patient may be on DPP-4 inhibitors or SGLT2 inhibitors, you can use. On the other side, you can see when the person is on insulin also, you can use this particular combination. Thereby, you can always reduce the dosage of insulin, but no need to increase the dosage of insulin because of the good response what we get. So HbA1c criteria, when it comes to CV risk, this is where the guidelines says lifestyle modification, metformin, then what happens? If you see RSSDI guidelines, where it says when it comes to assessment of the next parameters, when it comes to CV risk involvement, so that first drug recommendation is SGLT2 inhibitors because it has got a proven CV and heart failure benefits. DPP-4 inhibitors has shown non-inferiority. So that is where the cardiac issues is not a big thing to when you use this particular thing. When it comes to chronic kidney disease on the left-hand side, once again, SGLT2 inhibitors can be used comfortably because the new data has shown that it helps in the retardation of progression of DKD. On the right-hand side, like you can see, when it comes to weight loss as well, the SGLT2 inhibitor, it promotes weight loss, and DPP-4 inhibitors is weight neutral. So, ladies and gentlemen, the key take-home message from my talk is type 2 diabetes patients usually presents with high burden of associated comorbidities. Healthcare professionals should treat these patients from an integral point of view and not manage each pathology separately. SGLT2 inhibitors have shown to exhibit potential benefit in metabolic diseases. Dapagliflozin and gliptin's combination are recommended for achieving metabolic healthy benefits in all patients of type 2 diabetes with heart failure, CKD, as well as NAFLD, obesity, and established ASCVD. Vildagliptin, in particular with dapagliflozin, provides better glycemic control and pleiotropic benefit. So this is where the strategic harmony of combination of DPP-4 inhibitors and SGLT2 inhibitors, where it can be used in our routine day-to-day clinical practice in the management of type 2 diabetes, where hypoglycemia is not an issue, weight reduction is there, good HbA1c reduction is there, better benefit when it comes to cardiac and renal events. Thank you for your patience here.
Thank you, Dr. Arvind, for excellent presentation. And also one point, if you combine these two, SGLT2 and DPP-4, there is lesser chance of urinary mycotic infection. Okay,
So that
we
is
can take
always
one
a-
question.
That is always a asked question, like why do you see any reduction in mycotic infection? The answer is the DPP-4 inhibitors inhibits the DPP-4 inhibitors of the fungus as well. So that is where the mycotic infection is less.
We can take one question from the audience. I think there are no questions. Dr. Arvinda is very clear. We'll wind up the session.
Thank you, Pastor.
Thank you, sir, for covering the topic on time. And I request the chairpersons and the speaker for a photograph. And I also would like to remind the chairpersons and the speakers to collect your memento in the faculty lounge. Thank you so much, sir. Moving on to the session 3, we have 3 topics here, pre-lunch session. The first one is a debate, and I can see the speakers getting ready to fight each other. The debate topic is LDL is the goal for dyslipidemia management ASCVD. And the speakers for today, speaking for is Dr. Shalini Joshi, and speaking against is Dr. Karthik M. And to chair the session, we have 2 experts, Dr. Arvinda J. and Dr. Basunagowda sir. I kindly request both of you to take over the stage, please.
So LDL is the goal for dyslipidemia management for ASCVD risk reduction. So we have got 2 fighters here.
So debate is all about the fighting, scientific fight, I should say. So here the Dr. Shalini is there. She is for favoring LDL, and Dr. Karthik will be against. I just before this beginning of the talk, in the audience, how many of you are using statins? Okay, so Karthik, you have a hand in job, and how many of you? How many of you think that LDL is the good criteria? Yeah, so what LDL? So what LDL is there? So up to Dr. Shalini Joshi, how do you justify? So talk is for 6 minutes. So kindly stick on to the time.
Thank you so much, and lovely ambience, fantastic audience. I welcome you all today to dive into the dyslipidemia management. To be honest, I won't lie, I was a little surprised when I was told to talk about this topic. You know, I thought it was done and dusted. I don't think we need to, discuss it further. But anyways, I wish best of luck for my friend, Dr. Karthik, because he needs all the luck. Because I think he would have to really tell some strong evidence which he does not have, some anecdotal evidence, some epidemiological studies, and some stories. So with that, I would like you to focus attention on the debate. So let's debate. So basically, this is the culprit. This is our beautiful molecule which looks beautiful, but it is very deadly. It is the culprit. It is like engulfed in the free cholesterol. There is a dense core cholesterol, triglycerides, and has one molecule of apoprotein B on it. It was due to Dr. John Goffman from Berkeley, father of lipidology. He is rightly described as that. Told us a relationship between the LDL and its pro-atherogenic, pro-inflammatory characteristics. Small, nice molecule, 19 nanometer to 22, exactly enough to slip between the endothelial gaps which we have. So basically, this is like our Gabbar Singh. How many people have seen the Sholay? I don't think I need to say the Sholay fans. I mean, my whole family is Sholay fan. So you will see some references. So patient is terrified by this LDL, and we keep talking about this LDL, but we really need to talk about it because the challenges of cardiovascular disease in India is huge. 28% of total deaths, 50% of mortality occurring in very young people, less than 50, which is quite unfortunate that 10% of heart attacks happen in people below 40, prime of their age. When they are earning, they have little kids. And we know that in India, if a person has a CAD, is 44% increased risk of MI. And we have more small LDL particle as in comparison to the Europeans. So we know we target all the risk factors, but as you can see clearly from the graph on the red bar, the dyslipidemia plays a role, 58.7% as mentioned in the InterHeart study. It appears to be the strongest contributor to the MI in Indians. So just for discussion's sake, let's do a 47-year-old non-diabetic smoker, BMI 25, it's a regular OPD patients we have. And the lipid profile doesn't look so bad, nothing alarming. 139, and everybody says, okay, good, go for a walk, eat healthy, and that's about it. So do you think we should assess this patient further, or we should say go for a walk and eat healthy? I think we really need to, because assessing our patient's risk, especially in Indian, is very much necessary. In our patient, this is a very much available calculator on the internet. We plug in all the values in the shortage of time. I will not be able to explain in detail. I'm sure everybody knows about it. But we have to pay attention that the risk is underestimated for South Asians. So we definitely have some modification in this calculation. So our patient says, see, I'm okay, my BMI is 25, why do you want me to start you on a statin? 6 minutes over? 2 minutes, okay, thank you. I think I'll have to rush. Where is the evidence? So, well, we'll go with the evidence fast. I have evidence up till the Mount Everest. So I think I will just have to quickly go. Everybody's familiar with the studies. 30 years ago, simvastatin, Scandinavian simvastatin survival study showed us clearly the LDL risk reduction. After that, the heart protection study done in UK, that was 20 years ago, Prove It trial, TIMI2, randomized with pravastatin and atorvastatin showed clearly how nicely the graphs are diverging. CARD study, primary prevention trial in diabetes, beautiful results, reduction 40%. And I think I have to ask Mr. Chairperson, should I go on? Because there is endless and I would need 1 hour to go through the trials, which I'm sure my opponent would finish in 2 minutes. The Jupiter trial, we have to mention it because it was randomized 20 milligram. It had to be stopped early because it showed beautiful results. Our patients, less morbidity, less mortality, less CV deaths. And here is the hope. Very good trial, very diverse, equal number of men, women, diverse population, Asians, Chinese, Hispanic. So definitely we can extrapolate. I'm not saying this, but the guidelines say it, which has evolved from 30 years, starting from 1988 to 2019, fast forward to 2023. Earlier goal was less than 130, but here we see very high risk at the extreme right-hand side. Goal should be less than 55. On our patient, instead of 139, if we reduce his LDL by 39 milligram, see 21% risk reduction in major vascular events. LDL reduction sure gives a cumulative effect. I really like this slide. If you could pay attention, if LDL-C, if we reduce 1 millimole, that is 18, just 30 seconds, we are going to extend his life 28%. If we do 2 millimole, which is 36, 48% risk reduction. Again, the SCORE guidelines, ESC says the same, but we have health lifestyle, statin, we can add estizimab. LDL is the primary target of therapy. That is the topic of my debate, which is very well. If you can't do it with statin, please add estizimab, and don't forget the PSK standing in the background. If you are not able to achieve it, maximally tolerated statin. Again, 57% lower event rate, 50% reduction. It has a class 1A evidence. Rosuvastatin does wonderful job. It also reduces HRCRP
we have your summary
inflammation.
slide?
And with that, I conclude. It should be a patient-centric approach, engaging the patient, emphasizing, and please assure the adherence of the patient and individualized care plan to address the patient-specific risk factors. And I think this is my daughter in Ramnagara on Sholay, so now you know how good. I think I've done my job already. Thank you so much.
Thank you, Shalini, for, 6 minutes is too short a time to argue for an emphatic molecule to reduce the LDL cholesterol. All hands went up when Arvind asked a question, how many of you are using statin? But he didn't ask the question right to the debate topic. How many of you are repeatedly estimating and targeting LDL, adjusting your the statin? That is the question that is asked. Now I ask a question. How many of you are using statin to target LDL as the key molecule? Now number of hands have come down. Anyway, Shalini will have a rebuttal. Karthik, you have a tough job in hand. And Shalini has shown all the Sole pictures. Gabbar Singh asked Kalia to ab goli kao. कौन सा गोली statin reduce करने के LDL reduce करने के लिए आप बताओ. Now you defend LDL as not the target in risk reduction.
Thank you. So she depended on movies, so that's where she lacks data.
Karthik, now we want KGF 3.
Yeah. So, anyway, good afternoon, all of you. Now, see, this is the UN Agenda 2030. You know what's it about? It's about depopulation, and those people are behind that. And I believe Dr. Shalini is also associated with them. So, the lipid hypothesis says high intake of saturated fat raises blood cholesterol, high cholesterol leads to atherosclerosis and cardiovascular disease, and the hypothesis has successfully misled us for decades. Now, this is what we focus on, LDL and statins, but we actually miss the real risk factors that contribute to CV events.
Now this is a question. What is the evidence that high LDL will actually kill you? A systematic review was carried out to assess this. And 16 of the 19 studies with 68,000 patients above 60 years of age, they saw higher the level of LDL, the lower the chance of death. And closer look at the clinical data suggested that LDL does not accurately predict cardiovascular risk. It was observed that LDL levels in patients hospitalized after a heart attack was below the population average. And these patients who further tried to lower their cholesterol had a greater risk of MI and overall mortality compared to those who did not. So these observations actually contradict the supposed causal role of LDL in atherosclerosis. Now this is the atherogenic lipids, which has an ApoB 100 on its cell surface. So what happens if the ApoB 100 is damaged, the liver can't and the tissues can't take up the LDL, so which leads to increased LDL particle count in circulation, and the absolute volume of these accumulated particles does not reflect the increased LDL cholesterol levels that we normally measure. The excess damaged LDL particles in circulation would get oxidized and form small dense LDL, that which is atherogenic. Now here we have all the patients who have 125 milligrams of LDL cholesterol, but on the right when you see, Maria has the highest risk because she has more number of small dense LDL particles. Now this is another study in 2018, the Women's Health Study based on 15 years of follow-up with 28,000 females, found that volume of LDL cholesterol does not predict heart disease, but the particle count did. So those with high particle count, that is 2.5 times increased, they had 2.5 times increased risk of heart disease. Now here again you see 137,000 patients hospitalized with coronary artery disease, 77% had normal LDL levels that was below 130. So here I want to show that triglycerides is an important marker for coronary heart disease. Analysis of 5,000 patients with heart disease found a clear correlation between triglyceride levels and small dense LDL. The cluster on the left with small dense LDL had much higher triglyceride levels. So here again in the study you see that only 5% of the subjects had small dense LDL when the triglyceride levels were 70 milligrams and less, and was 0 when the triglyceride levels were 40 and below. So here we see that the small dense LDL actually increased when the HDL was below 52 milligrams per deciliter. The PROCAM trial, we see cardiovascular events were 8 times higher in those who had HDL less than 35 and compared to those who had HDL above 65. And again the PROSPER RCT, where HDL was more than 53, was associated with protection from cardiac events irrespective of the LDL cholesterol levels. So again the meta-analysis of 4 population studies showed that every 1 milligram increase in HDL cholesterol, there was 1.9 to 2.3% reduction in cardiovascular risk in men and 3.2% in women. So this is a very important parameter, the triglyceride and HDL ratio, which is better predictor of atherosclerotic cardiovascular disease. A ratio of over 2.2 milligrams per deciliter was associated with greater probability of having small dense LDL. So meta-analysis indicates that ApoB is superior to non-HDL cholesterol and non-HDL cholesterol is superior to LDL cholesterol as a predictor for cardiovascular risk. So this review paper collected data from 11 studies with 90,000 participants on statins to assess the average gain in life expectancy. So you will be surprised, the median postponement of death for primary and secondary prevention in these trials was 3.2 and 4.1 days respectively after taking statin drugs for years. So this observation study showed that statin therapy with or without coronary artery disease does not decrease the proportion of small dense LDL. In 2004, there was another study called the Wyatt trial, which was very scandalous, where Merck fudged the data and hid the data that 88,000 patients died and 38,000 died of heart attack. This prompted US Congress to put in guidelines that say that any study done should be published, because earlier the pharma companies used to conduct studies but never published it, and published only that was favorable to them. Now here we see just before the guidelines came in, the CARS trial with diabetic patients showed 33% LDL reduction and 1.5% mortality benefit. But soon after the guidelines were in place, the ASPEN trial with similar set of patients showed 30% LDL reduction and 0 mortality benefit. And the famous Jupiter trial, which everybody speaks about, showed 50% reduction in LDL but only 0.5% mortality benefit. And the Fourier trial with 59% LDL reduction showed only 0.1% increase in mortality. So dying with a corrected cholesterol is never a successful outcome. So these are some of the beneficial things of cholesterol as intermediate. It's needed for biological function. So in Indians, we have low HDL cholesterol, high triglycerides, and borderline HDL cholesterol. So we can't blame one parameter for anything. There are multiple parameters for the same. Now this is Professor Akiro Endo. If you know him, he is the discoverer of statin. In 2004, he was found to have elevated LDL levels. So his doctor, not knowing who he was, has recommended he take a statin, but he refused. So journalist asked him much later why he refused to take a statin. So he gave a very cryptic answer in the form of a Japanese proverb: the indigo dyer wears white trousers. So if she can decrypt that, I win the debate. Thank you.
Thank you, Karthik, for on-target completion. And now we have 2 minutes for rebuttal by Shalini.
Thank you so much for giving me the chance for rebuttal. Like I said earlier, thank you. So basically, first I would like to point out, I think I have only 1 or 2 minutes. So the first study, so I'm sorry I missed the publication. I'm not sure where that study was published, which Dr. Karthik quoted in the first one. I had given evidence after evidence that, what does show the mortality and morbidity benefit in targeting LDL as a therapy. Just to refresh the audience and Dr. Karthik, this is the Scandinavian study, this is the HPS. Prove it trial. I remember Dr. Karthik mentioning that it does not reduce morbidity in the last section he said, but high intensity, yes, he said that it does not affect the low small LDL, but there are trials after trials to prove, especially the TIMI, which was with the ACS patients, that high intensity statins does reduce the morbidity and the second event. And boy, one person gets one heart attack. Can you imagine having a second heart attack? And if they take advice from Dr. Karthik, I think he will not intensify the treatment, and they will have a second heart attack, and it'll be like a avenue for revenue for the cardiovascular surgeons and the cardiologists. So we definitely need to not forget our diabetic patients, which primary intervention clearly showed. Again, the meta-analysis showed, trials after trial, this ascot is in the hypertension. We have so many risk factors, and who can forget the Jupiter trial? HOPE study, as I mentioned. These are the factors we should take into account, favor treatment, and this is the consensus decision pathway which we should definitely, I totally agree with Mr. Chairperson that like we do in diabetes, like we do in hypertension, we start the therapy, but we call the patient back and assess. I think that sometimes, US is as bad. We have to call them back. We have to see if the 50% lowering of LDL is done, because that's what we want. And the adherence to the medication is absolutely important. We have to not assume, we have to ask them every time. So I believe all the studies which are done for triglyceride, non-HDL, HDL have never ever showed any morbidity or the cumulative benefit which I had shown with the lowering of LDL.
Thank you, Shalini. She insists that we should target LDL as the key target for risk reduction, and she has shown some depending points in the rebuttal. Let us have re-rebuttal for 2 minutes from Karthik.
See, actually, one physician had said that statins are so good, it's proven so well. If you go by what she says, we need to put statin in the water tank, so everybody gets the statins. But then I would say that this is the right place for statins, because I've shown you enough data actually by, statin also blocks one pathway in the cholesterol synthesis where vitamin K1, which is converted to vitamin K2, which actually prevents calcification of the arteries. So when you block that pathway, you're going to promote calcification. So thereby you're going to increase the number of MI and atherosclerotic cardiovascular disease. You want to kill more people. That's why I said it's part of the depopulation theory. And all the studies she showed, it's all pharma driven. So it's $1 trillion pharma driven, thing. So they will promote LDL, whereas they try to ignore the other parameters like triglycerides, HDL, and various other parameters that actually should be taken into consideration. So actually we are barking on the, we're finding the fault in the wrong place. So I think we need some more studies, and we should come away from LDL focused or LDL thing in atherosclerotic cardiovascular disease. I think
Thank you, Karthik. Both the debatants have completed their presentation as well as rebuttals. Now though Shalini said there is no point in putting it for voting, because she believed everybody uses statin, but how many are believing that we should only target LDL? Beyond this, Shekhar also was asking which LDL we are talking about. Now let us put to voting for fun purpose. Now, how many agree that we must target LDL, adjust the dose of statin, and go according to the current guidelines, which Karthik says it is pharma-driven promotion? The research in LDL-related activity is much driven by the pharma, and it's hyped. That's what he defended. Indian dyslipidemia, which is high triglyceride, low LDL, HDL. Should we talk about that, or should we believe and follow what the American industry or the European industry says? Now we put for voting, how many agree for LDL is the molecule to be targeted in risk reduction? Please raise your hands. Is it proper way to put question? Okay. Now I request those who believe that it is not the appropriate target molecule or target parameter, we must look into others and not only LDL itself. Somebody raised right hand for argument for and left hand for argument against. Yeah, there is a provision for quick comment. We found
30 seconds.
marginal votes for and little less, but almost equal. Congratulations to both the debatants.
My comment is for Dr. Shalini. We do not have Indian data, unfortunately. Even the Salim Yusuf's data, which you said, had only 28% Asians. So we need to have Indian data, number one. Number two, one of the main guys of LAI is from Chennai, my city, Lipid Association of India. And he says the target is 100 LDL, then 70, now he says 40. Very soon he'll make it 0. So where are we? Where is the data? Where are we heading from 100 to 70 to 40? Where is the data? So I think we need studies from India. Studies, prospective studies, not just, I think Karthik is right.
So match is being tied. I think we needed a super over actually, but we never done for looking at the audience response. The match is being tied. As winner.
3 cheers for the debaters, and I think the debate will go on. Thank you, chairpersons and speakers. Please remember to collect your mementos.
Dr. Basavangauda, Dr. Basavangauda, I was there upstairs just about 5 minutes ago. There, everybody was bombarding me about triglycerides. They will improve. When I came down, it became LDL. Now what should I do about it? That reminds me of a small poem for a lighter way. Sugar is a poison, don't even look at it. The fat will clog your coronaries, so don't even eat it. Proteins will destroy your kidneys, so don't even eat it. Finally, let your life be decided by all the guidelines, and you die with malnutrition with the coronaries intact. That is the last.
Yes, I think that definitely summarizes the way we are heading. Moderation is the key, is what we all believe. And I think the evidence is for LDL. Triglycerides and HDL therapy has not yet much evidence. Though we know they are the risk factors, there is no evidence for improving these factors has any better outcomes. Moving on to the next session. Another interesting session, common medico-legal issues, how to handle. I think as clinicians, this is something that we ignore, but we need to pay attention on. And to chair the session, we would like to call Dr. Sanjeev Rao and Dr. Mohan Kumarian. And to deliberate on this issue, we have with us Dr. Ravindra KR.
Good afternoon. It is my pleasure to introduce Dr. K.R. Ravindra. He is my batchmate in Bangalore Medical College 1981. And also he is my professor and HOD Geriatric Medicine, Bangalore Medical College and Victoria Hospital. This topic is his favorite topic. He most frequently speaks in various conferences. So I feel that it's also very important for the present practicing doctors. So I over to Dr. Ravindra.
Indeed, it's a great pleasure to be here at the state RSSDI conference. Thanks to Dr. Ravi Kumar and Manohar for giving me the opportunity. I think slowly, in the next 20 minutes, I'll take you out of diabetes, just to our other aspect, medical to medical legal world. We will see where we stand right now. Just I'm explaining what is the role of a doctor, how doctors are suppressed and depressed of late, maybe from past 20, 30 years. Those are the years, I think this was in 1887, when doctor was considered as a flower of civilization. Now things are entirely different. I'll just run through some slides where we stand right now in front of non-doctors. Maybe politicians, maybe bureaucrats, maybe your patients and their relatives. Just go through some few slides. Doctor gets noticed for ignoring patients, chatting and phone. Most of us would have experienced nearly to this actually. Death of newborn, doctor gets 1 year. If baby dies, doctor is imprisoned. I don't know who is controlling. Take a NEET examination, you get a seat. You need not write also, if I am not wrong. So health ministry, still government wants to open medical colleges. Why they are opening medical colleges? Who is asking these colleges? Why do you want doctors? Some students who scored 0 or less to get MBBS seat. The answer is mob vandalizes hospital, assaults, and okay, these are very common issues. Any death in India is often considered as a medical negligence. Any death, anywhere, medical negligence first, okay? If you are cured better, it is not because of doctor. Okay, so many issues will come. Patient dies during MRI, 3 doctors were booked, soft target doctors. For everything, okay, I think they are the targets. Violence at work leads to doctors who leave the country. So many have left the hospital, so many have closed the clinics. They have left their countries. Somebody is out of service and out of practice. Doctors die. For all these reasons, at the end of the day, stress will come to the doctor now, here and there. Doctors die earlier than the normal public. Hospital bill goes up, doctor's bill goes up. That is unfortunate actually. Recently it has put around 5 years back where a dengue patient who died in the hospital with dengue shock syndrome, the bill was around 25 lakhs. But they were blaming the hospital, doctors were attacked actually. Hospital bill is different from doctor bill. So, bridge courses in between, tamasha from government, Ayurvedic people, homeopathy can take up MBBS, etc. Consent to surgery does not extend doctor's negligence. At some point, everybody is against doctors. That is very important. A murderer is innocent till proved guilty. If a doctor is guilty, same thing. See, no Oscar, no teller. He can give any advertisement. I can cure anything with homeopathy, etc. But you and me cannot do this. 22-week-old fetus dies, doctors fired. But 14 people were burnt alive. Nobody is responsible. Fetus dies, not only patient. Fetus dies, doctor responsible. This is a famous case in 2011 where first time 11 crores plus was okay, fined actually to the hospital and doctors. After this, lot of people have become intelligent and smart actually, means defensive practice. 4 out of 10 doctors under stress study. This is the most generic prescription what government is telling, generic prescription. This is what government wants. In one time they want quality, second they want this. Doctors told to compensate for immobility after C-section. Any surgery you do, I think surgeon will be held responsible. That's why MS seats are not picking up right now. So I think I've shown you some important pictures, real-time pictures, to show that doctors are held responsible for each and everything in this world. Very important. So where is the problem? It is a semi-educated patient, single patient, multiple consultants. For example, a physician writes ecosprin tablet, cardiologist writes ecosprin AV, neurologist ecosprin gold. This patient is taking ecosprin in the morning, ecosprin AV in the afternoon, ecosprin gold in the night. So this is the problem right now, real practice. Too much of subspecialization. I am type 1 diabetic in charge, he is type 2 diabetic in charge. So I think a lot of fight is occurring in between. Google.com, false advertisements, high expectation from patient side, aggressive journalism, interference, daily routine affairs, interference, and lack of faith all cause the today's modern dilemma where we stand right now. I always say consultation chamber or hospital is a battlefield. It is no more a consultation glorious thing. It's a battlefield drawn between two people, doctor versus patient relatives, doctor versus hospital, doctor versus media, doctor versus judiciary, doctor versus government, and lastly, and the fun is, doctor versus doctor is more dangerous. So we are back to square one with two important problems, either is a medical error or a medical negligence, end of the day. So we should know what is an error, what is a negligence. Failure of a planned action to be completed as intended, that is called as error of execution. The use of a wrong plan to achieve aim, this is called as medical error. Failure to meet the standard of practice of an average qualified physician practicing in a same specialty, it is called as care, that is simple care is not given, it is medical negligence. How do you compare an error to a negligence? Anything and everything may become error. For example, not thinking of COVID. If somebody comes with fever, in the COVID pandemic, you have never thought of COVID, never asked COVID test. That is called as a medical error. Suppose nothing happened, nothing will happen. If something happens, he becomes COVID next day, then bulav. Why you never thought of COVID yesterday? Because he came with fever. Not thinking of fever as COVID pandemic in that day is a medical error. For example, prescribing a AC inhibitor to a pregnant is a medical error. Nothing happens, no problem. Something happens, it becomes a medical negligence. So, thanks, all medical errors are not becoming medical negligence. If all medical errors becomes medical negligence, nobody will practice. Medical course will finish. Nobody, okay? So, medical errors are very serious issues in America. Leading cause of death in America, one of the leading causes. Cost is of approximately 20 billions. Mainly, they are about surgical causes. Thanks, physicians are not that, I think you are not charged that much. It is mainly OBG, sensitive OBG, pediatrics, and surgery cases. Most of the malpractice claims in hospital, surgical errors are very important. In the medical field, it is an OPD. Suppose, technically, you see a patient on Monday, Tuesday you admit in the ICU, 80-90% of job is over. Somebody die in ICU, no problem. Somebody die in the ward is a problem. That's why ICCUs came, to keep the patient relatives away from patient. That is very important. So a lot of studies have come that problems have come because of the practice. Causes poor knowledge. What are the important causes of medical errors? Why somebody doesn't have a knowledge? One is poor knowledge, clinical skills, plan, communication. Quality and quantity, unfortunately, they don't go together. So many colleges, do you expect quality? A person who enters NEET examination, takes MBBS seat, bar MD seat, will you accept quality? Quality was there in 1970s, not in 2023. Deficiency in education, training. How many professors are there? How many are teaching? If you are coming to hospital, how many classes you have taken? How many seminars you have conducted? Who told you what is correct, what is not correct? I think those are the days when professors should take class. Third Naru, Akilamatar Naru, 3 hours class. 7th Naru, 1.5 hour class. They should take. Nowadays, how many of us are taking real classes for students? Students, they are simply coming, beauty parlor, go visit, and go back from the hospital. So the quality is lacking now, probably because of quantity. Lack of consistency in procedure, inadequate staff, technical failure. So many colleges, they don't have proper facility. They give money for cement and sand, that is buildings, not for humans, that is professors. You have to put money on professors to have good teaching faculty so that good guys will come up. Forget the extra laboratory, forget extra building. That is very important. Unfortunately, we give importance for not for that, but we give importance for the buildings, AC room, waiting hall, etc. Type of error may be diagnostic error, maybe treatment error, preventive error, etc. For example, one diagnostic error, asking for a Vidal test on day 1 of fever is wrong. Which book he has given? Davidson says 10th day, 2nd week. What test you do? You fail in MBBS if you ask for a Vidal test in 1st day or 2nd day fever. Fever with chills, why you are not for malaria? Malaria is still there in India. So these are called medical errors. So, for in diabetic, lot of cases also come up in Supreme Court and other courts in diabetic patients, not controlling diabetes during pregnancy, GDM. So they go to court actually. Somebody said, big baby, some problems occurred because of uncontrolled diabetes. Yes, come on, who has treated diabetes? Why you are not controlled her diabetes? Because of these two, a big baby has born, something like that. So for example, surgery. So recently around 7 lakhs were sued for a patient where a patient has undergone surgery, uncontrolled diabetes, still there is an emergency surgery, patient underwent surgery, finally went to ICU, sepsis, septic shock, then came care. All because of uncontrolled diabetes, he said, surgeon. My surgery is okay, but that fellow physician has not controlled the blood sugars. So now it comes to business now actually. It is your duty to control somebody's blood sugar, so that they say sepsis is because of diabetes uncontrolled. Okay, you have to pull down the blood sugar levels at any cost. You have not done it. Or you have given 7 days time. So doctors were fined under 7.5 lakhs for that was a punishment. So what are the important factors? Not consider individual patient factors, allergy, pregnancy, etc. When somebody comes to consultation chamber, please ask all the questions, etc. Spend 2-3 minutes, allow patient to speak. Please speak, please speak. You don't speak. Second, please ask one question, anything to add. Patient says, nothing to add, should be your statement in the OPD slip, or inpatient. Anything to add. They will take, you write chest X-ray, then they tell you, I am pregnant. Lastly, they'll tell you. You understand? That is a negative point, ask, okay? In the inpatient, ask in America and all, they ask patient related to write the case sheet. My husband is a chronic alcoholic, takes alcohol every day, right from cottage days, takes alcohol. Today morning, he has taken 2.5 liters of alcohol. Let them commit on the case sheet. Let them commit. You write, okay? This patient, see, wife writing. You let a patient himself will write. I am an alcoholic. I take alcohol day in and day out. Today also I have taken 100 ml of alcohol and came to this hospital. So these are all the defense for your lawyer to fight in the court of law, okay? So many times case sheets are incomplete, not at all documented, no timings, vitals are not checked, okay? These are all error, gives to good chance for the opposition to fight for your case actually. Error in delay diagnosis, okay, patient has come to you 3 times, you have not made a diagnosis. Do you think it's difficult to make a diagnosis? You can order any test of your choice. Why this test is not ordered? Why blood for MP is not ordered? Why tuberculosis you never thought of when somebody has got cough of 2.5 weeks or 3 weeks? In everywhere we are printed, somebody coughing in India more than 2 weeks, please suspect pulmonary tuberculosis. You never thought of. So lack of deficiency, that is thinking capacity is less. So that is, they can be punished for this actually. You are not fit to become a doctor because you never thought about it. Okay? And of course, so failure to take an ECG. Emergency services is important. You cannot say no. So for example, in diabetic practice actually, where blood sugars are reduced, you never followed up actually. HbA1c was not done immediately. Please ask, don't think that somebody is poor or rich, etc. Please write whatever the investigation. One COPD patient has gone to the court saying that lung transplantation was not advised for that patient. So you have to write, whatever Harrison says, please write. The only fellow who can save you in the court of law is latest edition of Harrison textbook. I mean, as far as the physician is concerned, latest edition. Nobody can save. Nothing will save. Constitution will not save. It is a Harrison textbook. Okay, that will save you. If you are thorough with Harrison, if you are okay with Harrison, if you are copied from Harrison, you are safe. Okay. So surgeons are the more problem. Okay, and writing also important. That's why people are writing. Write, print and give. Capitals you write. You ask somebody to write for you. See, for example, Amlopress 80 has become Amlopress 80. Okay? and so many medical, there is rheumatoid arthritis drug actually, and insulin, somebody, I think this patient died actually. 20 units become 200 units because of U and O, U and 0. No, okay, there is no gap between 20 and U, okay? So 200 units were given and patient died also. So that's why, okay, this is the, how much, 6 units actually. So sister has given 60 units. So I think these are the real problems actually. So of course, surgically there are a lot of problems. Wound infection, wrong surgeries, wrong procedures, latest technology not used, etc. So delay in treatment, lost patient, okay, these are other things actually. Use of generic drugs is also a possibility actually. So I think, is there any standard study saying that paracetamol 650 equals Dolo 650? No study so far. Any study? At least let the government do some study and give us that. Both are same. Why generic drugs are given? Because they're poor. Patient here is a fellow who goes to IPL match and Bahubali film. They want free drugs. Here is a fellow who want to go to America and will blame, they go in auto rickshaw to the airport. See, there are so many things. When you are spending money, you have to spend money. Quality will comes with money only actually. So, good antibiotic has to be charged. Newer antibiotics, if government goes with generic, then there will be a day where quality will be deficient. Who takes responsibility? See, this is the beautiful thing. Government doesn't take any responsibility. It is your patient, just like Indian marriage. So it's your patient now. It's your headache now. It's your headache. Court will ask you, yes, Dr. Ravindra has seen this case. Come on, Dr. Ravindra has seen this case at 3 a.m. on midnight, etc. So he has advised. Immediately they type in the court. So not you. My unit has to. What is unit? It is you have seen. No, sir, I was the head of the unit, but I did not see the patient. Next day morning, 9:30 I saw. Oh, Dr. Ravindra declares himself he has not seen the patient at the first time when he arrived. These people have seen the patient in the OPD. See, a lot of headache is there. You seeing the patient and your team seeing the patient. But I own up the moral responsibility, but not the responsibility. Why I should own up actually? Why I would have sent for blood for malaria parasite in the midnight. Somebody is coming with fever and chills. Our PG has not sent the pay for that. So I think some degree of headache is always there with this. So generic drugs actually you take up. So when you write a tablet, when you write a generic tablet, you should not own up the responsibility. It's just like treatment of a COVID patient. Guidelines given by patient. COVID has come from China. You are simply seeing the patient actually. So why you should own up every responsibility of COVID pneumonia? Why we should own up actually? It is not your guidelines, not a scientific guidelines. Government hurried guidelines. So a lot of things are there. You should be doubly careful. You write a drug, you own up responsibility. You write telmisartan, you own up. Because telmisartan is a drug of choice for all diabetics and hypertension, whatever it is. You own up the responsibility. Guidelines says that. Science will say, common sense will tell. So problem is actually somebody advising you to write, but court will not ask you. You have written, you are handwriting, and you are responsible. So a lot of things are there, and of course, how much you are, why your IQ or whatever it is, intelligence will come down immediately because of stress, because of less knowledge, because of overworking. In Victoria Hospital, we see 600 patients for medicine OPD. 600 patients, around 60 to 70 admissions. At least 10 people with unconsciousness, at least. How much you can own up the responsibility? They go to some neurology hospital, somebody removes cerebral cortex for head injury, patient still unconscious, send the patient to another hospital, patient let us say consciousness is not come, somebody has taken away your consciousness by removing the cortex, because we have read cortex is the center for consciousness. How to get the consciousness back in a patient whose cerebral cortex is not there? And referring the patient for hyponatremia. You got acute MI, hyponatremia, refer the patient for hyponatremia. So a lot of headaches are there. How to take this patient in? How to solve the problem? Who will solve the problem? And why original problem is not solved. Acute MI, a cardiology hospital refers this patient for hyponatremia to another hospital. Is it possible? Okay, 2 minutes, I'll fix. So we have to prevent as far as possible. But my answer today is save your skin before you save other skin. Forget everything. Don't see patient. See patient as a patient. Nothing more than that, nothing less than that. Okay? As a guest, friend, relative. As far as possible, don't treat your relatives. Send them to your friends. Okay? Don't send. Don't treat them. Send them. So very difficult because you have to own up the responsibility throughout actually. So detailed PGs, detailed history taking is very important. Documentation is important. More you write, more you are safe. Even if it is ugly, write more. Okay? Negatives of the patient should be written. Negatives of the written should be written correctly. Negatives of the patient. At the end of history, bar examination, list out all DDs. 5 days fever in Bangalore is a diagnosis, my diagnosis. 1, dengue fever. 2nd, chikungunya. 3rd, malaria. 4, enteric fever. Write down all the investigation. Let them work up. At least one will catch sometime, okay? Write all differential diagnosis. Don't write costly tests at the cost of simple tests. Not asking for blood for MP, but don't go for MRI immediately. So blood for fever, blood for MP is more important than MRIs. Say for example, emergency patient, don't say no, attend, write vitals and send them. Attend vitals and send. Okay? Hospital should also own up the responsibility. They cannot escape, okay? You know your role as a consultant. Don't go to other field and do whatever you want. Don't admit a diabetic foot patient in your ward when blood sugars are normal. So you should tell your surgeons to look after. Otherwise, if he dies of sepsis, then multi-organ dysfunction, some renal failure, etc. You basically, first question in the court of law, is it a cup of coffee? Diabetic foot is your cup of coffee? No, sir. Why did you admit? So there is no answer from your side actually. And others will discuss. So there are a lot of medical council issues. They go to medical council, they go to court. There was a case on Nimans recently. Beautiful. There was a case on Nimans also. Nimans also not spared. AIMS also not spared. If Nimans and AIMS also get cases to be investigated, etc., then you and me are nothing. So our tips is last, concentrate individual patient. When you see one patient, spend at least 1 or 2 minutes. Don't see anything else. Seeing a mobile in between, during the patient, it will become medical negligence. Don't talk on mobile. Send the patient out and then speak on mobile. So consider DDs, emergencies first. And lastly, medical indemnity. Please put some money on your this thing. All of you go for the insurance. Not simple lakhs, at least physicians 1 crore. At least 1 crore, at least. Because, okay, rupee doesn't have that much value. 1 crore is a must actually. So develop a hospital SOP. SOP is very important for the hospital. And last, so many questions are unanswered in medical field. Person dying in the waiting room, you are sitting in the inside. Somebody comes and dies in front of you. Who is responsible? Already medical dilution has occurred. And of course, ethics are going down, faith is coming down. Day in and day out, everybody want to spoil this career. Day in and day out, they are competing with each other. And of course, the problem is the expectation and reality. They expect too much. If you do MRI scan, patient thinks a big scan, big money, therefore you will cure. MRI is only for doctors to diagnosis. No, MRI will not help for the patient immediately, okay? And last sentence, very important. It is the third person. Judge will give judgment, not you or me. Let us say if your case comes to a professor, if his case comes to a team of doctors, I am happy. Unfortunately, it goes to a judge. In the court of law, you have to argue. You have to have your own lawyer. And most important is judge gives the judgment based upon the evidence. Evidence is all what you have written in the case sheet. Case sheet. Pen is yours. Pen is mightier than sword. That is very important. Write till the pen disappears. So writing is very important. Writing is important in the case sheet. Even if you see, in America, they see for 5 minutes, they write for 15 minutes. In India, we see for 15 minutes, we write for 5 minutes. Somewhere something has to be done. Please write. Anywhere you see, seen at midnight, 2 o'clock, this patient, vitals, write all details. So that you attended the patient. We attend the patient in the midnight. Only equals for us is soldiers working in Pakistan and China border. All others are sleeping. But unfortunately, you are controlled by sleepers. Tomorrow, they will come to take up your case and decide this doctor is good, negligence. I think you are seeing the newspaper day in and day out, how doctors are punished. So please take care of yourself, because when you laugh, the whole world will laugh with you. When you cry, nobody will cry for you. So have a safe time in your practice, very important. So legally should be safe actually. At the end of the day, what counts is legality. And make money and all for parallel game. But how safe you are. Night you should sleep. When you see 20 patients in the consultation, when you go back night 10 o'clock or 11 o'clock, you should have a good sleep. I have got my friend surgeons, no surgeon will sleep for next 2-3 days after surgery. I don't know why. Things are different right now. And any doctor may be punished for smaller issues. One small quote where doctor asked, why ICU, appendicectomy surgery done, some problem, cardiac ICU. Why this hospital did not have cardiac ICU? That's a big, beautiful question in the High Court. They are asking, why ICU backup is not there? Although generator backup for current, they are asking. So earlier, 10 years back, nothing was there. So many, that's why middle hospitals have collapsed now. All middle, either in the OPD or in ICU. Today's dictum is either you are in OPD, next choice is ICU. So patients are suffering indirectly, but we can't help. So thank you for patiently hearing, and it was thank you very much. Thanks, Ravi and Manohar, for opportunity.
Okay, ladies and gentlemen, I must thank Dr. Ravindra for giving a very panoramic view of the problems we are facing today and how it will mount tomorrow. So I think we have to compliment him for this. Thank you, Dr. Ravindra. So I will give you a few bits of wisdom on what I do. This is practical in the ward. This is practical in the ward. When all of us are going to be confronted with some angry patient, or generally it's not the patient, it's the patient's second relative, what do? The first thing you do is you listen. The acronym which I follow is called LISTENS. L stands for listen. So you just patiently listen to what the outpouring of this tale of woe is, or what his feels is wrong. The very fact that you let him vent his fury will decrease the tempo of the episode. The next thing you do is you keep your wits about you and you look at the patients around you. Out of 4 or 5 of them, one will be a little more docile. Pick him. Once you pick that person up, you pull him aside. So that's the L, this is I. Now, S stands for space. Pull him out of that place. When you pull him out of the ward and take him to another room, he is in unfamiliar surroundings. So he becomes more docile. This is what I do. Third, when you talk to him, after he expounds his tale of woe, you talk. When you talk, there should be temperance. Talk in a very empathetic manner. That is T. Then E is empathize with the patient. That is E. And when you are talking, notice what is that. Some patients will get aggressive, some patients will break down, or some people will just give up. These are 3 common situations. So when the patient breaks down, you always keep some tissues with you to give it to them. So you have won a battle there. It's a non-written communication which helps. The last word is S, for listens, is right, statement. It has to be in detail. Everything has to be written. Whether what he said, I have had patients who have told me on the face. I work in Manipal Hospital. Doctor, you're doing all these tests for making money because you get a cut. So that has been written down and that was brought up. How can you say that? And the management came to our rescue then. So remember this acronym, listens, and please do this, you will be safe. Time and again, this has saved my skin and I hope this saves your skin too. Thank you.
Thank you so much, sir. I now request the chairpersons and the speaker for a photo moment. And I also request the chairpersons and the speaker to collect their memento from the faculty lounge. And the last session of the morning session, before we begin that, I'd just like to make a short announcement. Yes, the lunch session is open. The senior citizens can have their lunch in the ground floor coffee shop. Apart from that, if anybody is interested, they can have their lunch and come and join the session. We'll now begin our last session, which is oral presentations by the young. We now begin our presentation, oral presentation by young researchers. And to chair this session, we have with us 3 dignitaries, Dr. Ravi Kumar Y.S., Dr. Pradeep and Dr. Swaraj.
Okay, pre-lunch session. So we would be asking for the individuals who have submitted. We had around 31 submissions for the studies, out of which we have selected the top 5 for stage presentation. The rest all have been given an opportunity, saying that yes, we will not be cutting down on the entries that we have received. We will be giving you an opportunity to present your data. So the rest others are the posters. So the top 4 which have been, top 5 which have been selected, sorry. So what we'll do is we'll call them and we will be judging them on the parameters which we have already discussed with them. I and Dr. Pradeep will be doing the scoring. Dr. Sidney sir and Dr. Ravi sir will be overlooking if we are doing the right thing or not. So the first presentation, Dr. Manisha Bellam, please come. Sorry, 6 minutes for your presentation and 2 minutes for discussion. Make one point very, very clear. 6:01 and you are disqualified. So by 5:55 you should be winding it up. Am I clear? Yes. And sorry, before I start, we will be marking you separately. The two of us will be marking you separately. So the top one person will be getting the prize. And I think your time starts now.
Good afternoon, one and all. I'll be discussing today about topic association of fasting C-peptide levels and vascular complications in type 2 diabetes mellitus patients. So we all know diabetes will lead to multiple spectrum of vascular diseases. We divide them into micro and macrovascular complications. Microvascular being nephropathy, retinopathy, neuropathy, and macrovascular being cerebrovascular accidents, cardiovascular diseases, and peripheral vascular diseases. We know they occur at a variable time frame from the onset of the disease, from the onset of diabetes, and they are dependent on individual glycemic control, C-peptide levels, insulin resistance, and also on the genetic susceptibility, and also on many other factors. So various biochemical markers are being used to know the at-risk population for these complications. Recently, C-peptide, a novel hormone with defined physiological action, is being evaluated for its protective role in vascular complications. So here, first I would like to tell the C-peptide normal levels in the laboratory which we measured are, it is 0.8 to 3.4 nanograms per ml after an overnight fasting of 12 hours. And C-peptide, it has multiple physiological actions in the body. It prevents retinopathy and diabetic kidney disease, neuropathy, and also macrovascular diseases like coronary artery disease by improving the microvascular blood flow, and because of its anti-inflammatory and also anti-apoptotic actions. So our objectives of the study are to study the strength and association between fasting C-peptide levels and vascular complications, and what does C-peptide levels, how does C-peptide levels change with the duration of diabetes? It is a cross-sectional observational study. GSS inpatients and outpatients were studied for a period of 18 months, and sample size is calculated with 95% confidence interval and 5% error, and it came out to be 100. These are our inclusion criteria: age more than 40 years, and already the diabetics who are on treatment and at least with one of the vascular complications. And exclusion criteria are secondary diabetes, pregnant women, and patients on steroids and dialysis. These are the results. First, we divided the patients into the 4 groups based on the duration: less than 5 years, 6 to 10 years, 11 to 15 years, and more than 16 years, where we can see with the increase in the duration of the diabetes, the C-peptide levels are decreasing. This is a graph showing, box and whisker graph representing the same. So progressive decline in the C-peptide levels might contribute, like how does it contribute is, it might contribute to the increase in the fluctuations of the blood glucose, which will contribute to the development of the various vascular complications. So fasting C-peptide level estimation by itself can predict the future and also overall outcome in the diabetic patients independent of the HbA1c levels. These are the HbA1c levels and microvascular complications. Just a introduction that if you see this graph, the patients who are having macrovascular complications, the mean is around 8.4, and who are not having macrovascular complications, the mean is around 10. What is happening to the C-peptide in macrovascular complications? It is at the higher end of normal. We can see the mean being 2.44 with standard deviation of 0.72, which implies the C-peptide levels in macrovascular complications are at the higher end of the normal. And HbA1c in microvascular complications, HbA1c is much elevated in microvascular complications than the macrovascular complications. And as we see here, C-peptide levels are very much decreased in patients with microvascular complications, majorly being retinopathy. So what do we conclude from this study? So it is evident that low C-peptide levels is associated with diabetic microvascular complications, but not macrovascular complications in type 2 diabetes. Hence, the normal levels of the fasting C-peptides, as we saw, there will be low levels of fasting C-peptide in the microvascular complications, but if they might have been in the normal range, there might be a possibility that we can prevent the development of the microvascular complications, and more such studies are needed for the C-peptide to be used as a prediction and also prognostication of the complications in future. And serum C-peptide levels, as we see in the macrovascular complications, it is not related because they are in the normal range in macrovascular complications. These are our references, and thank you.
Yeah, fantastic presentation, Dr. Ballam, and well in time. So you score a 10 out of 10 on the time. So that's for all of you to understand this. Yeah, one thing, one simple question, I think probably would have been asked in the rounds also. Why do we treat diabetes?
To prevent complications of diabetes.
So you have to be specific. Complications as in?
Majorly, we can see macrovascular complications in the initial, if we can't control it in the initial stages. So majorly, both microvascular and macrovascular complications to be decreased. So euglycemia will help it.
MCQ question, we treat diabetes to prevent microvascular complication, macrovascular complication. No, we should not be treating. Answer is all of the above. Which one do you choose?
All of the above.
No. We treat, I think your study also proved that we treat diabetes to prevent the microvascular complications and not macrovascular complications. You could see that your C-peptide was pretty low. Can you give me some valid scientific evidence for the low C-peptide in the microvascular group than compared to the macrovascular group?
Sir, low C-peptide in microvascular complications is because of most of the microvascular complications are duration dependent. And with the duration, the beta cell exhaustion also will happen, and which will lead to the lowering of the C-peptide levels. But there are few studies which proved the C-peptide supplementation would help in decreasing the progression of the microvascular complications.
Fantastic presentation, Doctor.
Thank you, sir.
Do you have any therapeutic implications of this study?
Yes, sir. Actually, we can think of like supplementing C-peptide levels. In future, there is a possibility that we can introduce the C-peptide injections, and that would help in because of its anti-apoptotic and anti-inflammatory action. If we maintain it in the normal range, and that would help to prevent complications.
No, a C-peptide will not help. What does C-peptide? What is C-peptide?
So C-peptide is a peptide molecule which is a byproduct of the insulin.
Exactly. So
yes,
insulin will do whatever you are saying. It is not the C-peptide that.
yes, sir. But recently there are they showed there are physiological actions for the C-peptide also, sir. Recent studies proved.
Thank you, Doctor. Good job.
Thank you, sir.
So let's move over to the second presentation. The presenter is. The topic is association between cardiac autonomic dysfunction and type 2 diabetes mellitus. The presenter is Dr. Preeti from JSS Medical College, Mysore. Your time begins now.
Good afternoon, esteemed judges and respected dignitaries. Today, my topic for discussion is about diabetes and the heart's hidden dance, association between autonomic dysfunction, predominantly cardiac, and type 2 diabetes. So why this study? It's because the heart is racing against neuropathy of its own. And there are a lot of autonomic challenges that a diabetic person faces. It's often the most underdiagnosed complication of diabetes mellitus, and such a common manifestation: resting tachycardia, orthostatic hypotension, intraoperative morbidities, increased risk for silent MI and sudden cardiac death. And the biggest drawback is that it does not have any reversible treatment options. The only way to prevent complication, prevent cardiac autonomic neuropathy, is by optimal glycemic control. So in our study, we did a study in our tertiary care hospital. I chose 74 patients as my samples and included all diabetic patients between 18 and 69 years of age, and excluded patients with other causes of potential autonomic neuropathy, like pre-existing heart failure, hypothyroid, Parkinson's, or other causes of autonomic dysfunction, critically ill patients, or if patients have a eGFR of less than 50. So these tests were done in our autonomic function lab using a Power D40 machine, heart rate and BP variability to deep breathing, to Valsalva for isometric hand grip, to standing, and a special test called head-up tilt table testing was done using Italian protocol if patient is symptomatic for cardiac autonomic neuropathy. What we observed in this study, we basically did all these tests and calculated the total score using Ewing's criteria, and we correlated it with the duration of diabetes in number of years, as well as the glycemic control using HbA1c as the parameter. So this is a brief Ewing's criteria. There are 4 possibilities: either it's normal, or it's early CAN, definite CAN, or severe CAN. So what did we observe? Results based on HbA1c. As you can see, out of 74 patients whom we tested, all being diabetic, 59 already had autonomic neuropathy. That's a whopping 79% of our population. And only 15 of these 74 patients actually had symptoms of cardiac autonomic neuropathy. So a large number of them are undiagnosed, even with regular follow-ups. Out of 14 cases, if we see the severe category, out of 14 cases with HbA1c more than 12%, 10, that is 71%, had CAN, severe CAN. Out of 17 cases with severe CAN, 10 had a HbA1c of more than 12%. What I'm trying to implicate in this is that the severity of cardiac autonomic neuropathy correlates very much with the poor glycemic control in terms of HbA1c. So this is a graphical representation of the same. And similarly, with duration of diabetes, here we can see out of 11 cases who were diabetic for more than 10 years, 6 of them had severe CAN, that is 54%. And out of 17 cases, if we take it the other way around, out of 17 cases who had severe CAN, 6 of them had diabetes for over 10 years. And the special mention goes to this point: there were 4 cases of cardiac autonomic neuropathy, even with patients who were just 1 year of diagnosis. So my results were as follows. Out of 74, 59 had evidence of cardiac autonomic neuropathy. That was statistically significant result. There was a positive correlation between severity of CAN as well as duration of diabetes and poor glycemic control. So in conclusion, I would like to mention that cardiac autonomic neuropathy is a silent killer lurking around in the society. Early detection not only helps to prevent cardiac morbidities and cardiac catastrophes and predict them, we can also educate the patient and their attenders regarding the same and improve their early glycemic control to prevent the further progression of established cardiac autonomic neuropathy. The lesser your HbA1c, better days your heart will see. Thank you.
Fantastic study, Dr. Praiti. Congratulations on that.
Thank you, sir.
In your observation, you also mentioned the duration of diabetes being less than 1 year also had a higher incidence of CAN.
Yes, sir.
Could you also elaborate on what were the HbA1c levels in these subset of patients, even though the duration was less?
Sir, actually, in that we did not find any significant HbA1c values, particularly being high or low. Out of these 6 odd patients who had, 4 patients who had CAN under 1 year of diagnosis, 2 of them had HbA1c of 12 and 15. Another 2 had 7 and 9. So they didn't have any particular relationship to the severity of CAN in those 4 patients.
So my question to you is duration of diabetes more important than HbA1c, or is it vice versa for development of CAN?
Sir, I feel both of them are equally important. No matter how good HbA1c may be as a marker, it is after all going to tell you only about the last 3 months of control. Whereas duration of diabetes can give us a hint into how long this patient has been dysglycemic. So I would like to say that both the factors are equally important and we cannot outweigh one over the others.
Did you look for what is called as HAAF, hypoglycemia associated autonomic failure in them? What was the incidence? And yeah.
Sir, actually it was not a part of the study as such, but 15 patients had symptoms of cardiac autonomic dysfunction.
No, I'm not talking of cardiac. I'm just asking specifically with respect to HAAF.
No,
so,
sir.
because you are saying ki even when the duration of diabetes was lesser than 1 year, they landed up with cardiac autonomic. So, is it fair to say that autonomic neuropathy precedes cardiac autonomic neuropathy, or other way around, or they are two independent things?
We did not study HAAF in this study, sir. I would like to consider adding more subjects to the study so that I can take this perspective also and test it.
Good. So, what is your message at the end of this study that you've done? What would you like to do further based on the study?
Sir, I feel these are a set of 5 tests which are quite easily done and they're not even expensive. And if they're done more often, we have so many diabetic patients in our OP. And if most of them can undergo this test, then definitely it will help us to educate the patient and their attenders better so that they're aware that a non-diabetic person undergoing a certain surgery versus a diabetic person undergoing a certain surgery, there's a very big difference, even though they may not have the symptoms for it. So I feel it's a huge role in patient education.
Thank you. Thank you, Dr. Preeti. We call upon the next presenter, Dr. Shahnawaz. His study is very interesting and clinical. A study of neck circumference in metabolic syndrome and its correlation to other cardiometabolic risk factors from MS Ramaya.
Good afternoon, one and all. I am Dr. Shahnawaz from MS Ramaya Medical College, and my study is...
Just a second. The clock, please. Yeah, start.
My study is a study of neck circumference in metabolic syndrome and correlation with cardiometabolic risk factors. I was guided by Professor Dr. Shrikant and Dr. Rutwa. Coming to the introduction, metabolic syndrome, as we all know, is a constellation of metabolic parameters which have an increased risk for diabetes mellitus and cardiovascular abnormalities. Cardiovascular disease risk can be related to adipose tissue distribution, and a criteria like BMI, which is predominantly based on the lean body mass alone, will not be able to identify the body fat distribution. So neck circumference, what we did in our study, is a good measure of assessing upper body adiposity, and it has been correlated well with insulin resistance and with visceral adipose tissue. And what we would like to conclude in what we wanted to see in our study was if it could be used as a cost-effective measure in resource-poor settings. Coming to the aims and objectives of our study, it was mainly to assess the neck circumference in patients with metabolic syndrome and to assess the association between the neck circumference and cardiometabolic risk factors in patients attending to the medicine and allied departments in our hospital in Ramaya. Materials and methods, it was a hospital-based case control study. Patients were screened and categorized as cases and controls, 80 each in cases and controls, as per the NCEP ATP3 criteria. And this was modified to the South Asian the criteria, which I'll be discussing in the next slide. And those satisfying more than 3 out of the 5 criteria were considered as cases, and less than 3 were considered as controls. And the exclusion criteria was patients who are pregnant because that can alter the waist circumference. Thyroid disorders, because if goiter was present, the neck circumference can be varied. And thyroid disorders is a reversible cause for dyslipidemia. So that we wanted to exclude. Any neck surgeries, any malignancies because cachexia can be there, type 1 diabetes, and IHT or any macrovascular complications because we wanted to look for the risk factors for cardiometabolic factors. So this was the NCEP ATP3 criteria that we followed. Waist circumference more than 19 men and 18 women. The actual NCEP ATP3 criteria takes 102 and 90 for men and women, and triglyceride of more than 150, HDL of less than 40 in men and less than 50 in women, BP of more than 130 by 85 millimeters of mercury, and fasting blood sugars of more than 100. And the neck circumference was measured below the laryngeal prominence with the subject looking straight in the Frankfurt plane. And the cutoff in our parent article was males more than 37 centimeters and females more than 34 centimeters.
Just a second, can you just go back to the previous slide? You mentioned Frankfurt plane. The patient was sitting or standing?
Standing.
Oh.
After taking institutional ethical committee approval and taking informed consent, the following information was collected. We collected demographic data and comorbidities of the patients. Anthropometry-wise, we measured the weight, height, waist circumference, hip circumference, and neck circumference. Blood pressure measurements was done, and investigations, fasting lipid profile, fasting blood sugars, serum TSH, and ECG was done to look out for any old changes. Coming to the results, the mean age in the cases was 58.9 plus or minus 9.7 to standard deviation, and in controls 54.9, which tells us that most of our patients were around the age of 50. Among cases, we had 46 male patients and 34 female patients. Among the controls, we had 48 male patients and 32 female patients. The mean neck circumference in cases was 37.4 centimeters, and in controls, we got about 33.5 centimeters. And what we found out was the neck circumference positively correlated with waist circumference, hip circumference, waist to hip ratio, LDL, and BMI with a significant p-value of 0.001 with a 99% confidence interval. And in our study, we got a new cutoff of 36.76 in males and 34.5 in females. So these were the baseline characteristics that were taken for all of our patients: weight, BMI, waist circumference, and so on and so forth. And that was correlated with the Pearson's correlation coefficient. And we found for all the patients as cases and in controls, the LDL, waist circumference, hip circumference, waist to hip ratio, and BMI positively correlated with a significance of less than 0.001. When further gender stratification was done, it was found that almost all the parameters, weight, BMI, waist circumference, hip circumference, FPS, LDL, total cholesterol, and triglyceride positively correlated for males and a little less in the females. Even the blood, the ones that are marked in purple correlated with a confidence interval probably of 95% because the values were more than 0.01. And the ROC curves and how we derived was, we can see this is the ROC curve. The one on the left is the ROC curve for the males, and one on the right is the ROC curve for the females. And the ROC curve here shows us the area under the curve for neck circumference is 0.863. And with, I have a specificity and sensitivity value after. And for the females, it was 0.855. And we can see for the waist circumference and hip circumference, it's a little more, 0.922. Coming to the discussion, identification of metabolic...
Last 40 seconds.
Yes, sir. Identification of metabolic syndrome is weighted by various criteria, where various measurements and blood investigations are required, and neck circumference becomes a very economical and a very convenient method to use. In our study, the neck circumference had in males had a sensitivity of 76% and a specificity of 89%. In females, about 34.75%, a sensitivity of 67% and a specificity of 90% was there. Coming to the conclusion, because it correlated positively even with waist circumference and BMI, we can also tell it's a measure of central obesity. So this is what we wanted to conclude. It's a simple and inexpensive test to tell us to diagnose metabolic syndrome even in a resource-poor setting. Thank you, and these are my references.
Fantastic study, Dr. Shanawaz. Some of the questions that we had were, on what basis did you choose these cutoff points? Are there any references available?
In our the other articles that are done, there was a parent article done in Japan by Noen et al., where they had a cutoff for males as 37 and for females as 34. But it's a limitation in our study which I wanted to mention, that we don't have a clear cutoff and further studies are required. In our study, in our population, because there was no study done in the South Asian population, we had done a study and we got a cutoff based on the Youdens index to be 36.76 and 34.7 in males and females respectively.
So, according to you, going forward, do you also establish this to be one of the criteria that could probably be used as an effective, non-costly clinical parameter to diagnose a metabolic syndrome?
Definitely we can use it, sir, because even waist circumference has certain limitations, like because it can only measure subcutaneous abdominal fat, but we need a CT or an MRI to tell the fat density to know it properly. Even though waist circumference is still very well used, neck circumference will still be a very good anthropometric measure, an inexpensive measure to be used.
Very well done study. I should really congratulate you trying to add to the already existing clinical measurements that we have. But in most of the study, all of the findings in your study, it was directly syncing in with BMI. So there is no difference between BMI and neck circumference. So why do we want to add this?
But BMI actually measures only a lean body mass. It will not give us
Evidence.
body.
Yeah, whatever data that you gave, neck circumference didn't show anything against BMI. So
Yes, sir.
we already have one. Adding one, will it be more troubling measurement to do, or will it help us? Okay, we have to take height, weight, and BMI. No, we don't want to take height and weight. We'll just do the neck circumference. Is it as simplistic as that?
It will not be as simplistic as that, sir. But maybe if there are more studies done, then we'll have a little more clarity on the same.
One other question that I had was, were you evaluating any of these patients who were also having regular exercises?
Yes, sir.
Were those patients part of your study, excluded in your study?
No, they were included in our study. For all the subjects who are included in our study, in both cases and controls, we had stratified based on the amount of work as sedentary, moderate, and severe work. So in both the sites we had done it, but we didn't use it in the stats.
Okay, so there was no correlation?
There was no correlation, yes.
Thank you.
Because both in cases and controls, we had significant number of patients who had some amount of activity that was called.
Very good study. Thank you so much, Dr. Shanawaz.
The next one is a study of glycated HbA1c and outcome in acute coronary syndrome patients by Dr. Mohammad Shahid Goria from Shifa Hospital, Bangalore. Timer, please. Time starts now.
Good afternoon to esteemed judges and respected dignitaries present in the audience. Myself, Dr. Goria Mohammad Shahid. Today we are going to have a discussion on a study of glycosylated hemoglobin level and outcome in acute coronary syndrome patient with type 2 diabetes mellitus patients. So coming to talk about introduction, so as we all know that incidence of type 2 diabetes mellitus and complication due to impaired glycemic control are rising nowadays because of macrovascular complication including coronary artery disease and particularly due to occlusive coronary artery disease due to atherosclerosis is a baseline process. So chronic hyperglycemia in type 2 diabetes patient obviously will increase the risk of macrovascular events as well as complications. So this study is going to be attempted by me in order to know the association or to correlate the actual link between the glycosylated hemoglobin level and outcome in ACS patient with type 2 diabetes mellitus patient. So coming to a less brief talk about diabetic burden in India, as we all know that India is a diabetic capital country nowadays. So in India, diabetes has been considered as a major public health problem. So India now turned out to be diabetic capital with the highest number of diabetics among the whole world. So a greater incidence of type 2 diabetes was noticed among the Indians who have migrated from to the another countries for the various reasons. So when compared with such population, suggesting then Indian have a particular phenotype or ethnic propensity to have diabetic, because Indian phenotype is such type of phenotype which have higher calorie conservation nature, right? So data showed that type 2 diabetes mellitus occurred at a younger age among the Indians, a decade earlier than compared to the Western world population. So decline in the productivity has occurred as a result of higher rates of morbidity and mortality due to earlier age of onset, earlier diagnosis, late diagnosis, and inadequate care. So we all know that the risk factors can be classified into non-modifiable risk factor, modifiable risk factor, and newer risk factors. Non-modifiable and modifiable, we are all aware of this, but newer risk factors are just for a concern of us. These include elevated homocysteine level, plasma fibrinogen, tissue plasminogen activator inhibitor 1, CRP, lipoprotein A, and metabolic syndrome, including syndrome X. These are the newer risk factors. So coming to talk about my actual study, the aim was to study the correlation between HbA1c level and outcome in acute coronary syndrome patient with type 2 diabetes mellitus patients. Objective, I have classified into primary objective as well as secondary objective. Yes, the primary objective will be to study the association of HbA1c with ACS in type 2 diabetes patients, and the secondary objective will be to assess the complications and outcome in the patients in relation to HbA1c level. So coming to talk about materials and methods, study area will be obviously in Shifa Hospital, Bangalore. Study duration March 2020 to April 21, at least 18 months I have selected for the study. So study population I have selected is IP patient who satisfy the inclusion criteria. Okay, so what is the methodology I have employed is, so admission time, whenever the patient got admitted either in EMR department or outpatient basis because of any complication. So we have sorted out the patient on the basis of taking the blood sample, and we did the random blood sugar level, HbA1c, cardiac troponin I, electrocardiogram, as well as 2D echocardiography. All investigations are done in all the patients who satisfy the inclusion criteria. So previous hospital records and all the cardiac comorbid data are also included and they are recorded. So patients are subject to necessary investigation.
Two more minutes.
And they are followed up for the HbA1c level. So inclusion criteria will be ST elevation, MI, non-ST elevation, MI, and unstable angina. They are included for the study. Exclusion criteria will be patient with hemoglobinopathy, hypothyroidism, and blood disorders are excluded. So patients who have more than one episode of acute coronary syndrome are also excluded from the study. And this study is going to be purely observational study. For the ethical clearance has been taken. Sample size as per my study taken is 150. Statistical analysis method by qualitative data I have summarized in the form of mean and standard deviation. Chi-square test I applied whenever necessary, and the p-value less than 0.05 will be considered statistically significant. So ethical consideration accordingly was taken. So these are the data and results which I have done. So this data also includes non-diabetics as well as unknown diabetics. So patients who don't know the history of diabetes and they detected diabetics after hospitalized. So unstable angina 19%, NSTEMI 35%, STEMI 46%. Adverse cardiac events found to be having acute LVF in 25% of the individuals. Okay, so cardiac outcome 87% has fortunately recovered. Residual function is found to be having 11%, 2% unfortunate, they succumb to death. So this is a correlation of mean HbA1c level with the complication. So number of patients, 40 number of patients, mean HbA1c was found to be 7.85. Okay, and 110, all complications were absent. Mean HbA1c was found to be 5.9. Okay, so these are the admission RBS and HbA1c computed data. To conclude, so more than 50% of the patient with non-diabetic indicating the diabetic patient higher incidence of acute coronary syndrome. Mean HbA1c was found to be having 8.1 indicating poor glycemic control in my selected patients. Okay, so most common adverse cardiac events occurred is acute LVF. And high HbA1c level can be used as a useful marker for prediction of adverse cardiac events. So what is the take-home message or recommendation? Blood sugar control is absolutely essential for the diabetics to prevent acute coronary syndrome. Long-term follow-up studies required to evaluate the uncontrolled diabetes following ACS. So acute hyperglycemia in acute coronary syndrome patient require actually the better evaluation. Okay. So as for all the study is having strength and limitation. So strength of the study is both HbA1c and RBS value taken at the time of admission can be used as a predictor for outcome in acute coronary syndrome patient. So HbA1c can be used better than fasting blood sugar it is the most important tool for differentiating stress-induced hyperglycemia from diabetic hyperglycemia, actual hyperglycemia. Limitation of this study was, this study was limited to patients of hospital stay only. Follow-up of this patient were not done successfully because they were discharged and they were lost to follow-up, some of the patients. Large sample size is required to confirm the age and gender difference and to prevent the gender-related bias. And long-term follow-up studies required to evaluate further HbA1c level and outcome in acute coronary syndrome patient. So I would like to thank all of you for the kind listening and best regards from my side.
Yeah, good study, doctor.
Thanks.
You have been disqualified because you've exceeded your time, but nevertheless, it was a good attempt on the concept of the study that you've done. The question that I had for you was, you were talking about that slide. Can you just go back to your results slide, which showed the description of your results slide? Previous slide. Yeah. One more slide after this. Right. So, were there patients in your study? You said your total number of patients that you have taken is 150.
Yes, sir.
Out of which known diabetics are only 90.
Yes.
Remaining were non-diabetics. So in those non-diabetics or newly diagnosed diabetics, could you please let us know what was your HbA1c correlation between good outcomes and worse outcomes?
Test slide actually, that computed data I didn't collect.
You did
Sorry,
not.
sir. Didn't collect.
Isn't it important?
Yes, sir.
Yeah,
It is
what's-
crucial.
What was the, why did you decide to do it? I mean, like, the aim, what was the source to do it? Because the data that we have already has established this fact since past at least not more than, I mean, definitely more than 20, 25 years. So, novelty. So, why did you do this study?
Sir, it's evident from the study that many of the patients who are
No,
non-diabetic-
not this study. What is the source of inspiration to do this study? Let me put it in simple. Why did you do this study?
Actually, just to prove the real association between HbA1c level and outcome. So.
Okay.
Okay, thank you so much.
Well,
We'll wind up as of now because we are running late. We have 4 presenters. We have scored them. The marks and the results will be announced tomorrow at the valedictory function. Today only. Okay. So we will announce it. You want us? During the inaugural function. Okay.
So the reason why we cancelled the other paper was this is part of our organizing team member, Dr. Hem Kumar, Dr. Manohar's paper, and it was also not considered to be discussed, evaluated for the awards, and that's the reason why we are not going ahead with the presentation because of lack of time. All those other members who have presented their abstracts, be ready. We will have adjudicators coming over for evaluating the posters. The posters will be evaluated under 2 sections. One section is for the best case presentation and one award for the best study research paper. So case report and the research paper. So I would want some closing remarks from Dr. Sidney and Dr. Ravi.
For a change, we have included during the prime time, this is the real objective of KRSSDI, where research should be given prime importance. So this is the first attempt that we have done to include it during the prime time. Maybe we will do it still, refine it for a better crowd and more responses. Number two, the judges have done extremely good job. They are very objective. I want all of you to give applause to them. And I congratulate all the presenters. They have done a very good job. Thank you very much. Dr. BG, you want to say something?
I appreciate the efforts of Sydney and his institution for coming forward to encourage research through this method. They are going to award cash prizes and certificates that will encourage many people to do meaningful research and make a presentation in a meaningful conference of Research Society Conference. Thank you for that effort, and I appreciate the judges' work and the presenters for having done a good job. And let us hope the best presenter who has done a very good presentation win the prize, and then they inspire the others to compete for the next time. Thank you.
Thank you, sir. So we wind up for lunch, and we'll start our post-lunch session bang at 2 o'clock. So all those people who have completed their lunch will come over. What's the time now? 2? We are going to start the session in the next 5 minutes.
I hope all of you have finished your lunch and ready for the postprandial session. We have some interesting talks on complications of diabetes and many more special situations where we need to know more. So can I have all the audience attention? Everybody who is outside the hall are requested to get in. The first session on painful neuropathy being deliberated by one of our guest speakers, Dr. B.K. Singh. And to chair this session, we have with us Chandrasekhar N. and Dr. Naveen R. I hand over the stage to the chairpersons, please. Before we begin the talk, I just have one announcement to make. The academic sessions are being followed by two interesting and important events. One, the inaugural, where there is going to be keynote address by Dr. V. Mohan and also the presidential oration. This is then followed by 20 years KRSSDI celebration, a very interesting lineup of events during that. Kindly join us all during that and hence stay on throughout the afternoon and evening.
Good afternoon to all the delegates and welcome to the conference. The next speaker is Dr. B.K. Singh, who is a past chairman of API Bihar chapter, immediate past chairman of RSSDI Bihar chapter, and is a governing member of the national API. So welcome, sir, and the time is yours.
Thank you, chairpersons. And at the outset, I must thank the organizing committee of this Karnataka RSSDI chapter for giving me opportunity to speak on this platform, especially Dr. Manohar, Dr. Vijay, and Dr. Arvinda, and all the dear colleagues. Good afternoon to all of you. My topic is the painful diabetes neuropathy. As you know, the diabetic peripheral neuropathy is defined as the presence of symptoms and or sign of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. The diabetic neuropathy is a very broad and heterogeneous term which encompasses a number of mono and polyneuropathy as well as plexopathy and radiculopathies. If you can see the epidemiological data, it is the most common and most troublesome of all diabetic complications and nearly affects more than 90% of the all patients with diabetes at some time or the other in their life. Half of the patient experience pain, that is one of the painful complication, and majority of them have the features of chronic sensorimotor peripheral neuropathy that is known as DSPN. And the hidden complication is erectile dysfunction. The diffuse DSPN, the diffuse symmetrical polyneuropathy, is the most common presentation of diabetic neuropathy. It is chronic sensorimotor polyneuropathy, but symptoms are predominantly sensory in nature. There is a slow and stalking pattern of involvement, and the positive symptoms include pricking, burning, and lancing in nature, and numbness, sensation of walking on the cotton wool. The paresthesia are common, and allodynia can occur occasionally. In later stages, there is an amelioration of pain and gradual loss of sensation that is one of the ominous signs of peripheral neuropathy. If you can see the pattern of involvement, there is a small fiber or large fiber. The small fibers affected first, there is maybe a burning pain, lancing pain, paresthesia, cutaneous hyperesthesia, and loss of pain and temperature sensation that can lead to the foot ulcer. If the large fiber affected, it affects late. There is loss of proprioception, loss of reflexes, and there may be slowed nerve conduction velocity. If you can see the pathophysiology of this diabetic neuropathy, you can see the insulin resistance and obesity is one of the major factors that leads to the dyslipidemia, the energy overload, reactive oxygen formation, impaired mitochondrial trafficking, endoplasmic reticulum stress leading to the axonal failure. Or it may be hyperglycemia, there is a bioneurologic failure, there is a mitochondrial depolarization and loss of ATP, inflammation, apoptosis, and axonal failure. This is the nutshell is the pathophysiology of diabetic polyneuropathy. How can you diagnose this diabetic polyneuropathy? All patients with the diabetes should be screened of DSPN starting at the time of diagnosis of type 2 diabetes mellitus, or 5 years after the diagnosis of type 1 diabetes mellitus, and at least annually thereafter. The assessment should include the careful history, either temperature or pinprick sensation, that is the small fiber, that is a small fiber function, or the vibration sensation using 128 Hertz tuning fork, that is the large fiber functions. So all patients should have an annual 10-gram monofilament testing to assess the feet at the risk for the ulceration and abrasion. The electrophysiological testing or referral to the neurologist is indicated where the clinical picture are atypical in nature, that is motor greater than the sensory neuropathy, there may be rapid onset, or there may be the atypical presentation. Or if the diagnosis is unclear or a different etiopathology you are suspecting. So management of the diabetic neuropathy is glycemic control offers the symptomatic management, agent that restores the improved nerve function and avoidance of the nerve toxins. The control of hyperglycemia and the risk factor management. Evidence suggests that enhanced glycemic control decreases the risk of development and also worsening of the neuropathy. So glucose control is very important factor. However, better glycemic control can prevent painful symptoms remain uncertain. The smaller study have shown that the bigger fluctuation in the glycemic level are associated with the greater intensity of the neuropathic pain. Hence, it is logical to emphasize the importance of stable glycemic control to the patients. It is also necessary to avoid rapid correction of high blood sugar level, as it itself may cause acute neuropathic pain. It is also important to optimally manage any coexisting comorbidities such as the hyperlipidemia, the hypertension, which are the usual known risk factor of diabetes. The one entity is the hyperglycemic neuropathy is also there. It is a reversible symmetrical neuropathy found in poorly controlled diabetes, presents with the uncomfortable sensory symptoms in leg, clears rapidly on controlling the sugar, and the nerve conduction study shows slowing of the nerve conduction velocity. So that will be go with control of the hyperglycemia. So painful diabetic polyneuropathy, it is difficult to control. No single agent is universally accepted. Most patients require combination therapy. Medication should be added to stepwise manner at 2 to 4 weeks interval. Non-pharmacological management include psychotherapy, acupuncture, physical measures like cold water, immersion, and electrical stimulation, that is transcutaneous electrical nerve stimulation, may be of benefit in selected patients. So the management depends upon how you choose the non-pharmacological therapies. There may be the pharmacological therapy, there may be a combination therapy, or if not control, the tropical treatment. So non-pharmacological therapy. There is a health behavior intervention is very important, and one of the factor of is exercise. The regular aerobic strengthening and balancing exercise alone or in combination have demonstrated positive outcome. Exercise supervision by the exercise specialist can reduce the risk of exercise-induced energy. So exercise is very important in controlling this neuropathic pain, and that should be supervised because there is a risk of fall in diabetic neuropathic patient. You must reduce the sedentary behavior, and dietary modification is also needed. Reduce calorie intake and increasing plant-based food and polyunsaturated fats have demonstrated beneficial effect in the diabetic polyneuropathy. The energy or nerve stimulation, as I have already said, the high-frequency spinal cord stimulation provide long-lasting reduction in the neuropathic pain. Refractory to the medical treatment must be balanced with the potential complications. The one point is the nutraceuticals, which is nutraceuticals should not only supplement the diet, but aid in the prevention and or treatment of disease or disorder. The efficacy and the safety of many nutraceuticals, including the ALA, the venpetiamine, the acyl L-carnitine, vitamin D, vitamin B12, vitamin E, and PUFA-GLA have been studies. And based on this evidence, the efficacy in reduction of symptom and excellent safety from RCT, ALA, alpha-linoleic acid, and the venpetiamine, currently approved in some country but not approved by the FDA, may be added for persistent neuropathic pain. The confirmatory RCT can clarify the use of nutraceuticals in painful diabetic polyneuropathy over long term. The analgesics and the anti-inflammatory drugs. The opiates, the oxycodone and the tramadol has shown to have moderate efficacy in the treatment of painful diabetic neuropathy. However, opiates should be considered only after the failure of the other drugs because of their potential risk of drug abuse and the long-term endocrine and immunological adverse effect. Recently, a randomized double-blind crossover trial suggested that the opioid receptor antagonist naltrexone 2 to 4 milligram daily might be effective in the management of painful diabetic polyneuropathy. The non-steroidal anti-inflammatory drugs, they have a beneficial effect in acute phase of neuropathic pain, especially the grounding time of pain, and caution is advised regarding their propensity to impair renal function and cause of gastrointestinal bleeding. And the most important thing is the pharmacological therapy. The effective pharmaceuticals therapy for the painful diabetic neuropathy includes antidepressants, that is the duloxetine and the tricyclic antidepressants, and the anti-epileptics like the pregabalin and gabapentin. They are often effective, but may require high doses which may not be tolerated and have higher incidence of side effects. The duloxetine is the first-line drug in painful diabetic neuropathy, as per the NICE guideline, and only antidepressant approved by the FDA. Nortriptyline is better tolerated because of the fewer anticholinergic side effects. So duloxetine is the first-line drug in painful diabetic neuropathy. The pregabalin is recommended second-line agent in NICE after the amitriptyline and duloxetine. The combination therapy with the 2 or 3 agents may be more effective at much lower doses. And we can use the pharmacological and non-pharmacological approach both in the treatment of diabetic polyneuropathy. In topical agents, in painful diabetic neuropathy, capsaicin 0.075% cream was found to be effective. The topical preparation of capsaicin and extract from the chili powder and leads to the depletion of the substance P, which is the most commonly implicated neurotransmitter in the pain transmission pathway. The lidocaine 5% patch has been shown to reduce diabetic pain alone or in combination with pregabalin in RCT. The topical nitrate resulted in significant reduction in pain and the burning sensation over the 4 weeks in diabetic patients. The topical TCA, topical doxepin, have been demonstrated a noticeable decrease in the pain scores. So you can use this topical treatment also. There may be some newer agent which is in pipeline. The NMDA, the N-methyl D-aspartate antagonist, like ketamine and memantine and the dextromethorphan are tried with this various response. The aldose reductor inhibitors, the rate-limiting enzyme, decreases glucose to sorbitol formation is also in the pipelines. The neurotropic factor shows effect on rat model, but unable to show effect on the human trials. The vascular endothelial factors, the vascular endothelial factor gene administration has shown to restore nerve conduction velocity, nerve blood flow, and nerve vessel number to normal in the diabetic polyneuropathy. There are other newer agents like protein kinase C beta inhibitors. The neuronal vascular insufficiency is a key factor in the development of neuropathy. So robenxiamine methacrylate is a protein kinase CB inhibitor, showed a statistically significant improvement in the symptom of robenxiamine-treated neuropathy groups. The other modality may be immune therapy, the hyperbaric oxygen therapy, the physical and surgical therapy. Acupuncture has been found to be associated with the reduction in the use of other analgesics and benefits last for the 6 months. The surgical sympathectomy, spinal cord stimulation, central neuroaxial blockade, static magnetic field therapy, low-intensive laser therapy, and monochromatic infrared therapy are the other modalities present. So we can see this treatment algorithm for the painful diabetic mellitus. If there is a pain in a diabetic patient and you suspect that this pain is due to the diabetic polyneuropathy, then you can use any of the drug like voltage-gated alpha 2 and delta ligands like pregabalin and gabapentin, or the serotonin inhibitors like duloxetine and venlafaxine, or the secondary tricyclic antidepressant or triptyline or desipramine. Anyone can be used. If no significant clinical benefit from one of the drug, then switch to the another drug. If both fails, then try to combine the drugs. If there is no effect, may add the tramadol or tapentadol. Or if there is no meaningful effect or the patient does not tolerate the drug, then refer the patient to a pain clinic or the neurologist. So to conclude, that painful diabetic neuropathy affects around half of the patient with diabetic neuropathy, diabetic patient. It is not only underdiagnosed, but also undertreated. The majority of patients experience severe pain, affecting sleep, emotion, and overall quality of life. A comprehensive neurological examination with a specific focus on the sensory system is crucial in making the diagnosis. The management should be tailored individually and encompass a multidisciplinary approach. TCA, duloxetine, gabapentinoid constitute the first-line agents, and drug selection to be based on other comorbidity, drug interaction, and the patient's tolerance. Thank you very much for your patient hearing.
Thank you, Dr. Singh, for the elaborate information on the diabetic neuropathy. Now the floor is open for the questions.
Important that lots of pain, we are talking on the painful neuropathy. So suppose already you told like duloxetine you are using 20 mg, our patients tolerate. The moment we increase the dose to 30 or 60 mg, there is hardly I have seen any patient tolerating it. So what's your in clinical practice, what you do?
Actually, in my clinical practice, I usually use 10 milligram.
Only 10?
Only 10. Or you may go to 25. TCA is available. So, the better you have to a combination of therapy, both first line and second line should be combined. So, minimal dose can be used. So, there may be a lesser side effect. The mainly side effect is dry mouth and something else. So combining the low dose of the
do you use tramadol for that?
No, I never used.
What do you use?
I never used this analgesics purpose. Only I use tramadol only when the patient is intolerable and impatient.
Hello, sir. Your experiences with the use of carbamazepine and valproate in diabetic neuropathy? Carbamazepine and valproate.
Valproate.
In some cases, I use this valproate also and found to be a better result. But it is not written in the guideline whether the valproate is used or not.
Have you tried carbamazepine, sir?
I have not used carbamazepine. I have not used carbamazepine.
I think a spinal nerve stimulation is a very good technique. Only thing is very costly, around 60,000 to 70,000 per sitting. I think few of our known at Chennai, they are doing, I don't know, maybe in the Bangalore people are doing that. But in the retractive painful neuropathy, a spinal cord stimulation, there lots of paper has come up and the role is being established these days.
Yes, definitely it is better. But it's an invasive therapy, no? Costly also, yes.
Thank you, sir. Thanks to the organizers for giving us this opportunity.
Thank you very much.
Thank you, sir. I would request the chairperson and the speaker, sir, to join for a photo moment, please. And I also request the chairperson and the speaker to collect their memento from the faculty lounge. Thank you, sir. The next session is a talk on erectile dysfunction and diabetes. And to deliberate on this talk, we have with us Dr. Bobby K. Matthew. And to chair the session, I would like to call in Dr. Shashidhar B. and Dr. Harish Kumar K.N. Dr. Shashidhar B. and Dr. Harish Kumar. Welcome, sir.
Good afternoon, Dr. Bobby. I think this is a very burning topic nowadays. We have seen that ED not only affects people with comorbidities, we've also seen a lot of cases nowadays. It's become many sporadic cases happening, affecting both physical and mental and also marital life. Nowadays, we have seen the prevalence is equally the same in both extremes of age, probably younger age group, say beyond 20 to 30 we have seen, and also the other age group with comorbidities. It's a very good important topic to speak about, and I welcome Bobby to deliberate his speech.
something about erectile dysfunction. Basically, when we all used to study for MBBS MD, ED was used to be called as impotency. During my MBBS days, I finished MBBS 93, 99, MD 2000, 2003, DM from KEM 2003, 2006. That time, Harrison 16th edition, second volume, second chapter, the name was impotency. But by the NIH revised guidelines 1992, the term impotency itself is deleted from all the textbooks because addressing a guy or a male as an impotent male, we used to tell he is an impotency, he was granted divorce in the bail of impotency. So addressing a male as an impotent male is thought to be a great insult to manhood per se. So the modified term of ED or sexual dysfunction. And there was the same during our Davidson-Harrison days. There was an MCQ question, which is the most common risk factor for ED. People used to answer during our MBBS days, diabetes mellitus. Now we know diabetes is no longer the biggest risk factor for ED because it is nothing but abdominal obesity or metabolic syndrome with or without diabetes, which kills the penile endothelium. So as of now, studies have shown that even in children with type 1 diabetes, you diagnose a child with type 1 diabetes 10 to 15 years, you follow him with a poor glycemic, let us say HbA1c be more than 10, you follow him up the third or fourth decade. From 15 years till 30, 40, 50 years, you ask his penile function is intact even in 90% of type 1 diabetes children, whereas 25% of the young adults, 35 years, coming with an HbA1c more than 6.5 has an inability to attain and or to maintain erection. That means that it is not the HbA1c or glucose that is killing your penile endothelium. It is the metabolic syndrome, insulin resistance, low testosterone, and the abdominal adipocyte. During your MBBS days, we used to study that which is the largest endocrine gland in the body. The reply was thyroid. Now we know it is the adipose tissue, which was once considered a waste energy depot, that is now considered the largest endocrine gland. So as your abdominal adipocyte get more and more bulky, more and more free radicals are released, and that kills the endothelium. So basically understand, as of now, you open Harrison, what's the biggest risk factor ED? It is your abdominal obesity, more than 90 centimeter, without sugar. Second most common risk factor is smoking. Third is hypertension. And ED is the first marker of an evolving coronary artery disease. So understand the concept, how ED is related to diabetes. So it is just like that. So how does the process of erection occurs? Don't look at the slides, just concentrate on me. Your penis, just remember what we have studied in Ganong and Gaita. Because I have just 20 minutes, understand the basic pathophysiology only. Because we know penis is made up of two groups of vascular smooth muscles. A central midline corpora spongiosa, which bulges to form the glans penis. On either side, there's a pair of corpora cavernosa. So vascular smooth muscle means it is just your penile cross-section. You have smooth muscle is the endothelial lining. Suppose you are having the libido. Now you are hearing the sound of a female you want to have sex with. You are seeing a prawn clip. What occurs? Your penile endothelium produces nitric oxide. We know nitric oxide is the most potent vasodilator in the body. The moment you are thinking of a lady, when your age of 18, 20 years, that time, during our time, we had Liril soap advertisement or the crowning glory with Dimple Kabadia, and you are sitting at home, and your parents may be sitting, but without even having the instinct for sex, you have a tight erection of your penis, even without touching your penis. That means that your endothelium is so fresh, it is not contaminated with sugar, BP, cholesterol. That is known as a neurogenic erection. The thought of a lady, the sound of a lady, the visual stimuli causing a tight erection of your penis without even touching, that is known as a neurogenic erection. As your body gets contaminated with HbA1c, BP, cholesterol, your cigarette smoke, and sleep apnea, age more than 50 years, even the strongest desire to have sex with a lady, even the touch of a lady or the hearing of stimulus or a porn clip will not cause a 100% erection. It will cause a touch and flicker of movement of the penis. You have to touch and stimulate the penis to have an erection. That is via stimulation of the pudendal nerve. The sensory nerve supply of penis is S234. So there, your penis is just working 20% remaining. You are touching and stimulating the S234. From there, the fibers are stimulating the penis. So that starts the start of an erectile dysfunction. The moment a guy 40, 50 years thinks that, previously I was thinking of a lady, I used to kiss a lady, my penis is getting erect. Now I am not having a tight erection. I need to have a foreplay to have an erection. That means that your penile erection is falling down. That means that your coronary is getting blocked and blocked with your HbA1c, BP, cholesterol. So understand this concept. There is nothing known as a treatment for ED. We have so many VIPs who come to us in Kerala and all people with so much money. Because 15 days as an endocrinologist, I work in Kerala, 15 days in Dubai for the past 13 years. Because people have so much money. People make so much money. So ultimately they come at the age of 40, 50 when they made 10 or 15 super complexes, superstars in Malayalam industry and other things. Once you have so much money, the quality of life comes down. That time only they think that penis erection is not working. There are so many businessmen in Kerala which they don't buy Tadalafil or Tasilov ready. They go to Dubai, buy Cialis, but Cialis doesn't work. They tell that, doctor, these drugs are not working, drugs are not good. No, these drugs are good. Your penile endothelium has killed and it is failing and failing. So that is the cross section of erectile dysfunction. The moment your age is about 16 or 18, from that that moment you keep your HbA1c less than 6.5. From the moment your BP is more than 130/80, take a losartan, telmisartan, olmesartan. Sartans are the safest antihypertensive drug in a person with organic ED to keep your BP less than 130/80. The age above 6 years or 10 years, when your LDL rises more than 70, with a pre-diabetic, take a statin, and a statin to keep your LDL less than 70. You control the 3 metabolic parameters. Keep your HbA1c less than 6.5, keep your BP less than 130/80, keep your LDL less than 70, and quit your smoking. Your penile endothelium will be fresh like anything. That's the concept of ED. So understand the principle only. Treatment of ED is limited. You may be the multi-millionaire with $5 million in your hand, but still the treatment of ED is just sildenafil, tadalafil, vardenafil. It is not working. You can go for an intracavernosal alprostadil injection. That doesn't work. You can go for a penile pump or prosthesis, but your spontaneous erection will not occur. For that, your metabolic parameters should be controlled. That is why now ED is known as endothelial dysfunction. Understand this cross section. The penile artery has a diameter of 2 millimeter. Your coronary artery has a diameter of 3 to 4 millimeter. Your carotid has a diameter of 5 to 6 millimeter, and your femoral has a diameter of 7 to 8 millimeter. So the narrowest artery in the body, which can be blocked by HbA1c, BP, cholesterol, is your penile artery. So the moment your HbA1c is more than 6.5, the moment your BP is more than 130, the moment your LDL is more than 70, the moment you continue smoking, the moment you snore with an abdominal obesity, the narrowest artery gets blocked first, then only your coronary and carotid. That is the rule of 65. 65% of the people above the age of 45 years with an organic ED have an underlying coronary artery disease. Vice versa, 65% of the people who already have a coronary artery disease has a history of ED if you take the history 5 to 10 years prior to that. That's why my age may be 45, another doctor's age may be 25, another may be 52. This is the time where you have to prevent the blockage of your endothelium, whereas your sildenafil, tadalafil, vardenafil cannot regenerate your endothelium. It can just prevent the breaking down of a cyclic GMB to 5-GMB. And this is the concept of ED. That is why ED and diabetes. It is not diabetes that kills the erection. It is always the metabolic syndrome which kills the erection. Now coming to the definition, I'll be touching and finishing. I just wanted, we have limited doctors, only 50, 60, 70, to understand the concept. So treatment of ED is another ballgame, because whenever you start treatment of ED, your endothelium has been finished and your coronary has almost been covered. And what's the definition of erectile dysfunction from Harrison? It's an inability to attain and or to maintain erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. That is, if a person is not able to attain erection, that is ED. A person is able to attain erection, not able to maintain the erection, that is also ED. A person is able to attain erection, maintain erection, but not of the sufficient rigidity he wants for a sexual intercourse, that is also ED. A person is able to attain erection, maintain erection, that too of the sufficient rigidity, but his partner doesn't get a satisfaction. She's telling that he did something and went away, I didn't feel anything. That is also ED. That means that your purpose of erection is not your own enjoyment, making your partner tell that your sex was good, your happiness is there. So ED, the basic definition is inability to attain and or to maintain erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. Many people think that ED is a total lack of erection. That never occurs. ED is a progressive thing. Right from the age of 45, you think that your neurogenic erection is coming down, your tumescence is coming down, your rigidity is coming down. So invariably after 15 years, you know your penis is not at all working. Then you start PD inhibitor. That is the moment you should start treatment for prevention of ED much before. And the biggest risk factor of ED is always age. Massachusetts male aging study shows that only 10% of men less than 45 years have organic ED. So 10 persons coming to the OPD of an endocrinologist or urologist less than 45 years with complaints of ED. 1 in 10 only have an organic, but age more than 60 years, 50% have some sort of organic ED, and age more than 80 years, some sort of organic ED is there in almost 80%. And what about the stage of libido? Just I'll be touching and finishing these points only from endocrine. Libido, or the sexual drive in a male, is always controlled by testosterone as well as mental state of mind. How much ever high the testosterone is, if a guy is in the depressed state of mind, or the smell of the lady or the voice of the lady he didn't like, he may not have the libido to have sex. What about libido in a female? For centuries, people have been thinking, what controls actual libido in a female? It is the female hormone of estrogen or male hormone of testosterone present in female in minute amounts. Now, studies have shown that female libido is more controlled by testosterone than by estrogen. So, females, postmenopausal females will decrease libido. Some ladies come to us and say, doctor, I have undergone a hysterectomy for endometriosis, pan hysterectomy with both ovary. My doctor has put me on Premarin 0.625. I increased it to 1.25. My husband is also a doctor. My libido is coming down like anything. There you know your estrogen is not playing the role. Your ovary produces 50% of your androgen, and your adrenal produces 50% of your testosterone androgen per se. So you have an adrenopause and the ovary has been removed. So ultimately you give them a small shot of testosterone, 50 milligram injection. Once in 6 months, it dramatically improves the libido. The same occurs with females with adrenal insufficiency. Females with Addison's disease with decreased libido and quality of life, even after adequate hydrocortisone and fluorocortisone record replacement have a dramatic increase in libido after giving the male hormone. So female libido, always testosterone, then mental state of mind, then estrogen only. That is why in US FDA, you can give low dose of testosterone in females with decreased libido or adrenal androgen. Now, process of erection, I have told you. Cause of ED, I have already told you, because we have time that is limited. Understand, ED is no longer erectile dysfunction. It is known as endothelial dysfunction. Just understand the imaginary point which I have told you. A person, after having adequate libido, in the absence of stress with normal testosterone, a person 35 years is having good libido. Seeing a lady, he is not having stress. His testosterone is more than 4 nanogram per ml. Still his penis is not getting erect. That means that his corporal cavernosal endothelium is not able to produce adequate nitric oxide for penile vasodilatation. The same is occurring in his coronary also. That is why ED is endothelial dysfunction. The moment you take a metformin to keep your HbA1c less than 6.5, the moment you take a statin, we were an argument whether LDL should be targeted. What's the argument? I was thinking that why such a topic should be there, because LDL should be targeted. There is nothing against an LDL. The only thing, just like vitamin D should be kept in 40 to 6, let it be anything. Let the theory be there 15 years back during your DM days, normal dose level of vitamin D was thought to be 14, even in JIPMA. Sadish has done studies that Indian normative data of vitamin D may be 16 nanogram. Let it be anything. But a tablet of vitamin D costs you 20 rupees. Per month you are giving a maintenance of 260,000. It's just 40 rupees. Not even a 1 can of Pepsi. Some benefit somewhere. So why do you argue about vitamin D? You are getting some benefit. Take that. Statins, the only single drug which can probably give you at least 1 day of life in this world himself, probably other than corona vaccination, is nothing but statin, and a statin. And still even one doctor having a concept that maintaining the LDL target, less than target is not good, that itself sends a wrong message to the society. So basically, statins are always saving. You have only one evidence-based medicine for heart. It is just lipids. Then 42% only smoking, hypertension, diabetes, maybe particulate matter, air pollution, less than 2.5 micrometer, directly killing the endothelium, maybe coronavirus. But the only thing that can be preventable for us is nothing but keeping the LDL less than 70 or 55. So statins never contribute to ED. Many people come and ask, but does atorvastatin reduce the erectile function? No. We know that testosterone is synthesized from cholesterol. Cholesterol, 17-hydroxyprogesterone, androsterone, and testosterone. So statins, when you give, the testosterone level may come down by 1%, but it does not affect the erection, because statins always clear the endothelium from endothelial dysfunction and always improves the erection. And what about testosterone? Understand the concept? So what are the routine tests? Suppose any doctor sitting here, or his brother or any relative is coming for erectile dysfunction. Tomorrow you are asking, Dr. Bobby, he is having an organic ED, non-psychogenic ED. Age more than 55 years, no one comes hardly with a psychogenic ED, because they are married for 20-25 years. They know the difference between psychogenic and organic ED. 25-35-year-old guy may come with psychogenic ED, premature ejaculation, gender role, gender orientation, confusion. 55-year-old guy is very, very clear. He knows what psychogenic ED. He tells that, no doctor, I'm a doctor, my wife is doctor, we are not able to attain and or to maintain erection of sufficient rigidity, and this is deteriorating for the past 10 years. What all differential tests should I do by Harrison? The 5 basic tests to be done in a person with ED is FSH, LH, testoprolactin, T3, T4, TSH, lipid profile, LFT, RFT, HbA1c, and PSA if age is more than 40. This all we know. What is the importance of doing testosterone? Because testosterone is the male hormone. Females hardly have to do an estradiol, FSH always, because females have a wonderful thing that's known as a menstrual cycle. A moment, suppose my wife is 41 years, she's missing her menses for 3 months, 4 months, she has done a mini lap or a copper T or a Marina. What will she do? She will go to a gynec, she will do an ultrasound to pick up a PCOD because she's gaining weight, or the gynec will do an FSH, prolactin, TSH to pick up a premature menopause, hyperprolactinemia or a hypothyroidism. Suppose a doctor at age 48 or 50 years is having an inability to attain and or to maintain erection. What will he do? He will never check his testosterone, he will never check his TSH, he will never do even a TMD. He will attribute to the stress he is having, smoking, alcohol he is having, sugar, BP, cholesterol he is having, the uterus of the wife that is removed, children studying for MBBS, umpteen excuses, but he will never go and check his testosterone, because females always check the hormone. That's why commonly we know hypothyroidism complicates 10% of females and 1% of men. So 1 in 10 lady, 1 in 100 men have hypothyroidism. How many of you and me have checked the TSH with an antibody or free T4 TSH with an antibody for past 6 months? How many of the doctors sitting here, including me with age more than 40 with a decreased penile function or penile rigidity, have checked the testosterone in the past 1 or 2 years? Men hardly check their hormone. That is why hormonal checking is mandatory in any guy with organic ED, FSH, LH, testoprolactin, TSH, lipid, SGOT, STPT, creatine, HbA1c, and PSA if age is more than 40. And what about andropause? We know estrogen coming down in a female after the exhaustion of the ovarian follicles, that is menopause. But andropause is not male menopause, because the erectile function comes down after 50, 60, 70, but the reproductive capacity never comes down. You can become a father at 80 or 90 years. So andropause is not the apt term now. Now it is LOH, or late onset hypogonadism. Age more than 40, suppose me, you, anyone want to check the testosterone, go to any good lab in the morning and ask them for a total testosterone level in the morning. A total testosterone more than 3.5 nanogram per ml above is absolutely normal, just like subclinical hypothyroidism. Suppose tomorrow morning you are checking your total testosterone, it is less than 2 nanogram per ml is diagnostic of hypogonadism. More than 3.5 seconds, 2 to 3.5 is a gray zone where you can treat if there is decreased libido, erectile dysfunction, or decreased frequency of morning erection. Don't remember everything. Just cut off two values, 3.5 above normal, less than 3.5 after 3 weeks, check your FSH/LH prolactin, testo low with an FSH/LH equally low or normal, think of an andropause. You may do an MRI pituitary for a cellular mass or an MD cellular, otherwise you can start treatment with testosterone. How do you treat with testosterone? Previously we used to think any female, even at the age of 35 years, having a premature menopause, you give estrogen, it causes breast cancer. Any guy taking testosterone causes prostate cancer, never. We know that hormones can be given in two ways. It can be supplemented, it can be replaced. So it is known as testosterone replacement therapy. Your testis is not producing testosterone, so you're replacing. Your thyroid is not producing thyroxine, you're replacing. So just like that, testosterone replacement therapy in hypogonadal men never induces prostatic cancer. It only uncovers the microscopic prostatic carcinoma, what is present in individual. So before starting testosterone replacement, check your PSA PCV. More important, repeat the PSA PCV 3 months, 6 months, and annually. The rise in the PSA more than 1.5 nanogram shows the uncovering of prostatic CA. Otherwise, always testosterone is safe. You have 3 methods of testosterone injection during your MBBS days, once in 3 weeks, sustanon. Now it is once in 3 monthly testosterone undecanoate depot, Serenos depot. Now testosterone capsule is there, Serenos or Andreol testo cap, and testosterone gel is there. Just understand, every doctor, including superficiality, our HODs even, who taught us in the Trivandrum Medical or even KM Bombay, so many, maybe doctors, maybe other department HODs, because for sexual function and all, they don't want to go to any doctor at times, because they know that they have so much knowledge, but at least the subclinical hypo, HbA1c, prediabetes, everyone knows. But testosterone, wife having menopausal hormone therapy, people can confuse. So just remember the value, total testosterone 3.5, just remember the value, total PSA more than 4, or rise in PSA more than 1.5. For ED, you don't require injection testosterone. Injection testosterone is usually required in severe hypogonadism due to hypopituitarism or a Klinefelter. Just ask for a Serenos testo cap, Andreol testo cap, 40 milligram 3 times daily. Now coming to the last slide, last two slides, how to treat a guy with organic ED. Better than treatment as a diabetology or endocrinology or physicians, it's prevention of ED. Treatment many times rests with nothing but urologists or other people who does for surgery. Because otherwise, just think that ED, don't think it's impotency, don't think it's erectile dysfunction, think it is an endothelial dysfunction. ED is the first marker of an evolving coronary disease. Think of a rule of 65. A person having an organic ED about 30, 35 years, you do an angiography, 65% of your coronary is blocked. So it is blocked due to HbA1c, BP, your lipids, your smoking, and lack of exercise with an adipocyte that is killing the endothelium. So how do you treat a person with ED? Suppose a 55-year-old business person who is a diabetic for past 25 years come to an endocrinologist or a physician or anyone with complaints of ED. How do you treat? You check testosterone. If it is low, you are giving that. Thyroid low, you are replacing. Your HbA1c, you are maintaining. OTPT, you are maintaining. Prostate is normal. So you have treated all the symptomatic measures. Still he is telling the doctor, my penile erection is less than 50% good. You are starting him on a PDE5 inhibitor, sildenafil, tadalafil, vadinafil. So what is sildenafil? Is Viagra. Tadalafil is nothing but Cialis or Tadabilis. Abenafil has also come. But why people prefer in US tadalafil or Cialis over other thing? Because tadalafil, 1 minute or 2 minutes, I'll finish. So tadalafil has a duration of action, it's a flight of thing like that. Viagra has a flight of activity for 4 hours. Tadalafil or Cialis or Tadabilis has a flight of activity for 36 hours. What does it mean by flight of activity? Suppose you are having an intercourse with a wife or partner today evening at 8 o'clock. You want to have a second intercourse tomorrow morning at 3 o'clock. Your Viagra acts for 4 hours only. You have to take another Viagra tomorrow morning at 3 o'clock. Whereas Tadalafil has a duration of action of 36 hours. So you don't have to repeat it once in 48 hours. That is why Tadalafil is sold throughout the US. It is known as a weekend pill. Suppose a person, you are giving a patient 55 years, or you yourself is taking Tadalafil 6 tablets. Because many people come and say, doctor, I took Tadalafil. It is not working, doctor. It's not a good drug. No, don't start with 1 tablet or end with 1 tablet. Always ask patient to buy 6 tablets of Tadalafil, 20 or 10 milligram. Ask the patient to take Monday, Wednesday, Friday. That's a pulse therapy, Monday, Wednesday, Friday. The first day he may not be taking with full hope, so he thinks that erection is not going to be good. So he takes first day, no effect is there. Wednesday he's taking again, headache, he will not be going for intercourse. Morning he rises up, he has a 30% flicker of the penis, he gets a confidence. Friday he may be looking and going and sleeping with the wife, thinking that erection is good. Friday morning gets up, he has an 80% erection. Next Monday he thinks that he doesn't need the drug, he has a cumulative erection because cumulative effect of nitric oxide causing augmentation of cyclic GMB occurs. One shot you may be taking, your sympathetic activity may be so high, you may be having so much stress where your adrenaline is causing vasospasm, you are taking tadalafil, it's not going to work. So always think that you give 6 tablets, Monday, Wednesday, Friday, Monday, Wednesday, Friday, even 6 tablets taking, still the penile erection score doesn't improve, then you know that it's an organic kidney, your endothelium has been thoroughly destroyed by your smoking, sugar, BP, cholesterol. Then go for a second line therapy, it is nothing but intracavernosal injection, and third line of therapy is nothing but penile processes. In people where failed first line therapy, age more than 55 years, where the partner demands a sex more frequently. Suppose a partner wants a sex once in a month or once in 2 months, it's okay to go for an intracavernosal cover, get Pfizer's injections there and have a sexual intercourse. But if your partner wants a more frequent sexual intercourse, it is nothing but always penile process that is going to work, and that always works and works penile process. Now coming to the last slide, with this I am finishing. This is known as the new US FDA drug. I didn't know that this drug has come. 2 weeks back I was sitting in the OPD in UAE, and one guy came and told me, one businessman, that country person I am not telling, he came and told me, Dr. Bobby, I went to Philadelphia, no, he went to San Diego for some conference, a builder from there, from Gujarat. So he got some cream for penile erection, he's telling me. I thought that all these people come with all the nitrate jelly, Chinese herbs from US. So I thought that what is that? I just asked him. So he told, no, it is a US FDA approved, over-the-counter pill. It was approved in June. That is known as Erexon. Till now, there was only one US FDA approved drug for the treatment for erectile dysfunction, oral drug with PDE5 inhibitor, sildenafil, tadalafil, vardenafil. This June 2023, US FDA has given approval for a topical gel for ED that is known as Erexon. It doesn't contain anything, it just contains polyol with glycerin. Just like our Iodex cream, when you apply it topically, it's a single-use tube. One tube costs $8, single-use tube. Apply it 10 minutes before intercourse, just in the head of the glans penis for 15 seconds only. So it's just a single, just like pimple. Just apply it 10 gram, 10 minutes before intercourse. How does it work? It is not a Viagra. It is a coolant effect. Just like your Iodex, when you apply, or a capsaicin B, there's a cooling effect. That cooling effect causes stimulation of the parasympathetic nerve fibers covering the corpora cavernosa endothelium, and your nerve fibers secretes nitric oxide, not the endothelium. So if your endothelium is totally destroyed, if you give the parasympathetic nerve fibers secretes 20%, your erection improves in up to 50% of the people. That is Erexon, that is future pharma, that is going to come in India, but it's very, very costly. Some people have applied for that. So someone asks you, any topically applied US approved gel for the treatment of ED, it is nothing, but it is Erexon gel, it is nothing but polyol and this thing. And what about premature ejaculation? Only one more sentence. Premature ejaculation is the most disastrous form of sexual disorder that a man can have right from the time of marriage up to the 80. Because suppose a guy who is working for the family, doctor, engineer, has a heart attack or a diabetes for 15 years, have an ED, wives have no problem because they know they have worked for the family for so much. From the first night itself, a guy is having erection and ejaculate in 1 minute before the female partner has orgasm, female partner always is ditched out, and that is the biggest catastrophe. ED is not that a problem. PME is the biggest problem that many of the guys face right from the time of marriage till 60 or 80. Previously, PME, the treatment was yoga, Ashwini, Vajroli Mudra, stop techniques, cues therapy. People used to come from Dubai with jelly. People used to know Dubai spray. It is nothing but 1% lignocaine for dental anesthesia. Now we know the trick of choice for premature ejaculation, nothing but SSRI, fluoxetine, paroxetine, sertraline, citalopam, and dapoxetine. The best drug for premature ejaculation is nothing but fluoxetine. And your Fludac works, but Fludac kills the libido. So you kill the libido and you have a PMA, nothing is going to work. So ultra short-acting SSRI, dapoxetine always works, and dapoxetine can improve the ejaculated time from 2 minutes up to 8 minutes. This is the story of erection. With this I am finishing. It's not the story of erection, how to prevent an erection, that's more important. You have to know the concept.
Thank you. Thank you, Dr. Bobby. Nicely elaborating on ED, what called it is the endothelial dysfunction. Anything on that?
I think, Bobby, that was in a single breath, I believe you presented your talk. Probably, I think, I think you'll need. I agree with you. Definitely, 20 minutes too short a time to discuss the topic. Thank you once again, Bobby. I think the floor is open for discussion. Any doubts? I mean, you can just ask Bobby. Thank you.
Any questions from the audience? The floor is open. Yeah, there's one.
I think all agree that this, I will tell a oration, was just like a bullet train. But this train has become a bit late, but given a great message. Excellent. Can you tell just one question that Evanafil is also in market, 100 rupees per tablet. So I have tried it. It is working much better than the Tadalafil. What is your?
Avanafil, no? So, PD better, sildenafil, tadalafil, vadenafil, avanafil. There is no company which has done a comparative study because these four, because all are giants, and none of the companies will compare a comparative study just like sulfonylurea, glyphosate, glycoside, glymeprene. But thing is that avanafil, the dose is 100 to 200 ml. Only thing is that avanafil has a rapid rate of absorption, just like your 5-ASP you are taking or Novorapid. So avanafil, if you take even before 15 minutes of your intercourse, you have a good absorption. Other than that, there is no interaction with whatever food intake. And the only thing is that sildenafil, tadalafil, vadenafil, avanafil. Sildenafil, tadalafil, avanafil, duration of activity is 4 hours, tadalafil 36. Tadalafil, sildenafil, vadenafil should be taken 30 minutes to 1 hour prior. Avanafil can be taken 15 minutes prior, even with food. But erectile capacity may be 1 with another, 2 with another, but ultimately there is no comparative study. But whenever you give a tadalafil, sildenafil, vadenafil, avanafil, give the maximum dose, that too for 6 shots, and then only think that it's failing, and otherwise it's not failing. Once it's failed 6 times, it is not improving. Think that your endothelium is destroyed. Don't keep on repeating the drug. Ask him for other options, penile processes. One thing I'm telling, penile processes works wonders. It works wonders in such a way that, one example, if you get 30 seconds, I'll tell. One of my patients who was a diabetic, type 1 diabetic, type 1 diabetic since.
I think last question, many people are, I also am using into my patients, 2.5 tadalafil daily. What's the significance?
2.5, 5, 10, 20, anything works. If your penile endothelium is working 80%, your 2.5 works. After 2 years, again it's failing, your 5 works. After 2 years, 10 works. After 5 years, 20 works. After then, nothing works. That shows that just like insulin. So it's just like insulin. You are having a beta cell failure. Initially, you are giving 2, 3, 4. After 20 years, your 90% beta cell is failed. You have to give insulin 1 to 2 units per kilogram, just like that. That is why people who take tadalafil, and what's the dose of tadalafil which can be safely taken without asking for a TMT. Now we know for benign prostatic hypertrophy, tadalafil 5 to 10 milligram has been approved, and primary pulmonary hypertension, tadalafil 40 milligram. So many of the US studies now say that 5 to 10 milligram of tadalafil can be given for anyone without doing a TMD. But we always have to do a TMD as a physician or endocrinologist. Our purpose is treat the ED, but find out the coronary artery disease, which is also complicated in 65% of the patients along with ED. So that's the basic thing.
Dr. Bobby, can you teach us how to speak so fast and also clearly? And to remember things. Because in the quickness, we forget most of the things. And we don't know what we are going to speak about. As the problem is, beautiful lecture, nice. And I tend to agree with you because our paper got published. Erectile dysfunction as a surrogate marker of coronary artery disease. It starts 5 years. It just got published this time. And that's what you have put there. I was very happy to see that. Thank you.
Thank you.
Thank you so much. I think we are all reminded of Shankar Mahadevan's concert. It will remain with us for a long time to come. I would now request the chairpersons and the speaker to join for a photo moment, please.
I tried very, very hard to connect to Bobby, and I think it was all worth it.
Please remember to collect your mementos from the faculty lounge. Now, if all of you are come back from the Shankar Mahadevan's concert, we shall move on to the next session, another important session, to know how to stay young with diabetes. And to deliberate this session, we have with us Dr. N.K. Singh. And to chair the session, I would like to call upon Dr. Rajiv Lokhande and Dr. Mahesh Yam, please. Dr. Rajiv Lokhande and Dr. Mahesh Yam.
Good afternoon, all of you, respected seniors, dear friends, colleagues, and of course students. A very electric shock-like sensation has passed through all of you just now. And the topic which is going to be spoken next by our reverend speaker, Dr. N.K. Singh, is on a similar note, how to remain young in diabetes, staying young with diabetes. But maybe the content will be different. We all know diabetes is a pro-aging process. At one time, it was thought to be equivalent to premature aging. Diabetes was a equivalent of premature aging, just like you say, diabetes and heart disease are equivalent. But now we know it is not so. We have enough mechanisms to prevent this aging accelerated process. A lot of methods are there. I think our honorable speaker is going to deliberate on that. Coming to the introduction of Dr. N.K. Singh, he is a national EC member of RSSDI. He is a diabetic and physician in Dhanbad. He is also the director of Diabetes and Heart Research Center, Dhanbad. He is the editor of CME India. With this short introduction, I hand over the microphone to the speaker. Welcome, sir.
Yeah, good afternoon to you all. After this bullet train journey, let us start with the Rajdhani. So, staying young with diabetes, when Manohar told me that I should talk on how to prolong life in a diabetic patient, I told him that this does not look romantic at all. So, it is not a question that we should prolong the life, rather it is much better to have young with the diabetes. So my agenda is getting over body issues is like getting over a fear of heights. The trick is not to look down. This is not my agenda. And even this Sanskrit shloka of Yavat Jivet Sukham Jivet Rinnam Kirtva Ghirtam Pivet, this is not my agenda. My agenda is that diabetes is an important cause of premature death and disability. I will talk about the crosstalk, oxidative stress and inflammation in the progression of type 2 diabetes complications, and lots of things happening in the mitochondrial induced endothelial dysfunction. Rather, the Bobby which told you, if you remember that he told, if you keep your ED, that is the endothelium dysfunction intact, you can remain young, and this is the secret of whole talk. So lifestyle interventions and how to alter telomerase and respecting circadian rhythms and some drugs. So if you think that staying young, there are lots of things which is happening at the same time. And we are measuring many unmeasurable things. That is the problem with the life. इसलिए कहा गया है कि फासला नजरों का धोखा भी हो सकता है. वो मिले न मिले हाथ बढ़ाकर देखो, एक जगजीत सिंह की एक गजल है. So you have to combine science with the art. And what is the art? धूप में निकलो, घटाओं में नहाकर देखो, जिंदगी क्या है किताबों को हटाकर देखो. If you understand this, you can remain young forever. This is your success story, being a barrier buster, act now and improve decisions. So longevity in our Vedic science is a constant object of Vedic prayers. You are well aware about that. And just see here, Emily says that you can stay young as long as you learn. And Bale says that the secret of staying young is to live honestly, eat slowly, and lie about your age. I think this is again a very good secret. And heart complication, the idea is to die young as late as possible. So that can happen with the diabetes self-medical education and support, which is a very, very important issue. And this is also a very good concept that some people are old at 18 and some are young at 90. So this is a very important thing. That time is a concept that human created. And if you see what is amazing, like this, see my friend Phil Sutherland, when he was a type 1 diabetic, told that he will die something in around 20 years. There's such a serious case of type 1 diabetes developed at 6 months of age. But today he's around 50. He is the role model in type 1 diabetes and exercise, and many of the things which you are following in your books, recommendations, comes from this gentleman. So beta cell is centric constant. You know the beta cell is the final common denominator of the beta cell damage, and today we are talking about the diabetes remissions. But definitely if you talk about the science, targeting the main risk factors is very, very important by the dyslipidemia, your hypertension, the smoking, family history of premature coronary disease. You see the albumin in your urine, the BMI and hyperuricemia. So these are things if you can tackle well, this works wonder. And what causes a shorter life expectancy in diabetes? So this has been correlated with the HbA1c, and it is also a data that females in general live 4 years longer than males, while the racial ethical differences in life expectancy was not significant among type 2 patients and conditional on the trajectory of risk factors across the group. So recommended goal is of biomarkers prolongs life expectancy by 1.3 to 1.8 years compared with the current population average. So this is one study. So let us understand the science. The mitochondrial induced endothelial cell dysfunction in diabetes. This is very, very important, that this is all happening in your mitochondria to a cross-talk about the metabolic inflexibility, oxidative stress, inflammation, and leading to insulin resistance. So you see here what is happening here. The red signal, endothelial cell, the mechanical stress, the high glucose, hypoxia, and with antioxidants, with caloric restriction, and metallic modulation, you can make it green, you can see here. So this is what is very, very important. So relationship between the mitochondrial dysfunction and type 2 diabetes is very, very important, and is the latest research which is happening in this field. And these days, if you want to stay young, the one technique is coming up, that is the organ-specific metabolic pathway that distinguishes the pre-diabetes. So you catch up in the pre-diabetic stage, type 2 diabetes and the normal issues, and this can be done by the mass spectrometry, proteomics. So this is a big technique which is coming up, by which this study will provide you a map of tissue-specific metabolic dysregulation in pre-diabetes and type 2 diabetes. But again, the whole success lies in understanding that in your body, what you are doing, the metabolic oversupply or metabolic undersupply. So this is the secret. By physical activity, high calorie intake and low calorie intake, so nothing more you need to know, because you can see here the normal mitochondria and what is happening with the fragmented morphology, and this all happening with the oversupply of the food which you are taking daily. So you have to go for some undersupply. Then if you are seeing here, the fusion occurs, the fusion of mitochondria occurs if your body is in the undersupply. But if you are by food, less physical activity, oversupply is there, there is fragmented morphology of the mitochondria. So chronic episodes of metabolic oversupply may fragment mitochondrial network, and conditions that favor metabolic undersupply induce mitochondrial fusion. As a result, preserve the mtDNA integrity and optimal function, which may promote optimal physiological adaptation and healthy aging. And this is an interesting study. You can see here that they have correlated with the HbA1c less than 5, 5.7 to 6.4, HbA1c more than 7.8 and more than 10, and they have found that the morphology of the mitochondria differs. You can see here in the healthy mitochondria to how the HbA1c increasing, someone is maintaining the HbA1c at 10 or 9, the severely damaged mitochondria is the result. So this is very, very interesting study which has been published. So increase the mitochondrial function in order to prevent or treat diabetes and keep them young. This is the most important part so far. Now the second part of my talk is the fountain of youth. The journey of science to art, how to do that. The staying young with diabetes, you cannot do without this. So first one is the physical activity. You see here, a sedentary man, how the mitochondria looks. And exercise trend, you can see here, the exercise trend is totally green. This is just a concept proved by the established science that people who are sedentary, their mitochondria looks something very small, you can see, and sick, but otherwise people who is fully active, it becomes green. So make your mitochondria green is my slogan these days. And Dr. Bobby talked about the erectile dysfunction. So exercise has positive effect also on both the sex drives of men, and exercise has positive effects on sex drives of the women. And very recently one paper came up which told you that exercise is more than a Viagra. Even moderate erectile dysfunction, severe erectile dysfunction, the exercise was able to do wonder. And most of time in our patients, we are only talking about tadalafil, evenafil. We are not talking about this very, very important intervention which came up very recently, I think 2 months back, which has given a very good paper that exercise is working more than the Viagra. Now the yoga must be included in your life. The upregulation of insulin receptors and the normalization of the insulin-glucose ratio occurs with the yogic practices. So we need also to demystify the yoga to stay young. This is very, very important. And if you have not time, 30 minutes or 40 minutes to do the yoga, just give 5 minutes, 12 rounds of Surya Namaskar. Why I am talking about Surya Namaskar? Because after 2 to 3 years, very important study will come up on the Surya Namaskar in diabetes. And this work is not being done in India, it is being done in USA. And if they have also proving, because I am in contact with that person, that if you do the Surya Namaskara with the mantra, it works wonder. And I think you are well aware those mantras. Second thing, the work is going very fast in USA, that they are working on the pranayama. An optimal level of AMPK, which commonly declines with the age, can be reversed with the breathing exercise, which you know the pranayama, the kapalbhati, or the anulom vilom. So living a long and healthy life requires maintaining an optimal level of AMPK, and that can be very easily done with the pranayama. And there are lots of studies, like so you see there is a study, the control and the intervention group with the pranayama. The 4 weeks reduces anxiety, increase positive effect, that the changes are associated with activity and connectivity of the brain network involving in emotional process. Lots of things are particularly in the amygdala, anterior cingulate and the anterior insula and the prefrontal cortex. So very high quality studies are going on at present time. And if you look back to our science of the Vedic science, these things have been proved much earlier, 5,000 years or 10 years back itself. And then the intermittent fasting. The dietary interventions are so important. And you see this, I might have seen this cartoon. Someone is taking a 400 calories of oil. You can see here 400 calories of beef and 400 calories of vegetables. Intermittent fasting is a safe diet therapy that can produce clinically significant weight loss and improve the several markers of metabolic health in individuals. It is all depends on the signals from if you are taking the vegetables. So total energy intake is very, very important. I'm not going into all details of that. During fasting, there is lots of science has emerged. So what happens? The ratio of AMP to ATP, everything is happening. So it is a very, very important intervention if you want to keep yourself young and stay young forever. Because the less you eat, the more you live. That is, again, the science is proving that reducing the food availability over a lifetime, the caloric restriction, has remarkable effect on aging and the lifespan in animals. This has been proved. And what our Vedic science told that time, now the time-restricted feeding and circadian autophagy for life has been correlated and established by the science itself. And in our Indian cuisine, you can see what is happening these days. From the 20 years ago of that, you can see that 335 calories. The same thing today we are taking how much, you can see that. So this how this our diet has changed with the low intake of mufa, low intake of fiber, high intake of fibers, and so many things are happening because pizza culture is going on so fast. So even the fat quality and quantity matters, and we need to know all of these things to our life. This is a very famous slide by Professor R.D. Lele. I don't think you have seen it or not, because some people are saying, what happens with the ghee, cow ghee? You see here that for healthy people, we need 1.2 gram per day of the maintenance dose of omega-3 fatty acid. For diabetes, it is 3 to 6 gram per day therapeutic dose. And cow ghee at 25 gram gives you 2.5 gram of omega-3 per day. And this is also you can say something controversy, that wrestler Dara Singh took 250 gram of cow ghee per day and lived for how many years? 84 years. So somehow some missing links in the science is happening. And even it is also proved that even a single junk food you take today, that damages your arteries, your beta cells. And this is a photo of my own city, where reuse of frying oil, this is happening everywhere, in every town, in every kasbah, in every village. And this giving us a very, very poisonous thing, and that is destroying our life of beta cell life of all our young persons. And so we should tell to our patient about the diabetes superfoods, and just see these are the superfoods. The soya beans, tea, coffee, grapes, berries, whole grain, cinnamon, bitter melon, fenugreek. If you take every day, you will remain a stay. There are lots of science in that. Even about nuts. Nuts improve the insulin sensitivity and prevent diabetes, you know. And nuts are as effective as increasing physical activity and trimming the calories to increase the HDL levels. So you can see the nuts are very, very important these days. And you were really amazing that you move with 1.5 to 2 kg of microbiota unknowingly in your body. You know that? 2 kilo microbiota is in my body, in your body. So you need to know what is microbiota, because whole research in the diabetes, in the metabolic disorders, is moving towards gut microbiota. So this is a lot of science, but that green cartoon you see, what he is eating and what he is eating, and that tells too much. So the people are sampling these days own feces for the purpose of science, taking probiotics, eating lots of yogurt and other things to foster the good bacteria, and this is a very, very good science. About the wine, I don't have time, but I will not discuss today, because initially we are talking that if you take 30 ml of red wine or white wine, it is protective to your health. But in 2023, the WHO came with the Lancet paper that a single drop damages your health. So this has become very controversial. I will not talk about that. Then endocrine disruptors, your persistent organic pollutants, your insecticides, pesticides. And there is for the first time in India, Dr. Rajiv Chawla told me to write a paper on that, the pollution and diabetes. And you will not believe, there are clear-cut evidence that persistent organic pollutants are very, very important for the recent epidemic which is happening in India. And lastly, the long and short of telomerase length and diabetes, how to do that, how you increase this telomerase length, how can you keep your DNA young. That is the whole science these days. That recent studies indicate that telomerase length can be affected by several lifestyle interventions. You may be able to alter the pace of aging in addition to natural history of many age-related illnesses by exercise and by all the things, and mindfulness, the meditation. This has been shown by the science itself. Lancet publication, you can see that. I think I got 2 minutes, and this is a simple thing that if you are whistling for 45 minutes, this NRF, the nuclear respiratory factor, it is a substance which got secreted, and that is a factor that controls telomerase shortening. So just by doing that, you can do that. So I will not go for details. Lastly, respect your circadian rhythm, which are totally deranged these days. My own son, he is sleeping at 2 o'clock, and when he is rising at 10 o'clock. I am not able to alter his life. So this is what is happening to your house, in my house, everywhere, the circadian rhythm, because even the gut microbiota, that is all signals coming from this chrononutrition has become very, very important. solved. Then you modify your macronutrient composition and you become an age management diabetologist. This is the aging process in humans is associated with changes in circadian rhythm patterns. And then lastly, the pharmacological. If you cannot do nothing, you at least use the SGLT2 inhibitors to your diabetic patients. You are prolonging 15 years of life of that patient. The study is saying, I'm not saying, the study is saying. And other drugs are metformin and pioglitazone. So lastly, my final takeaway is that diabetes is an important cause of premature death and disability. The crosstalk of sedative stress and inflammation in the progression of type 2 complications, we know the way how to halt it. And this mitochondrial induced endothelial cell dysfunction in diabetic progression can be tackled by the lifestyle modifications, altering telomerase. We know it, but we are not able to do it, respecting the circadian rhythm. And this is our old Indian wisdom, and there are some drugs to consider. Thanks. Lastly, even if you do all things, unless and until you do your mind management, nothing will happen for staying young. And that is so the mind management is a super key to stay young. That is what our Veda told, Tattvamasi, do anant hai, woh kabhi nahi mitta. Thank you very much. Thank you.
At the outset, we would like to thank the organizers of this program for giving us this opportunity. We are really honored. Dr. Singh, it was a wonderful presentation. Thanks a lot. Staying young in diabetes, we are talking about age. Nowadays, we talk about two age. One is the chronological age, and the other one is the vascular age. Dr. Bobby and Dr. Singh both have mentioned about endothelial dysfunction. I think to stay young, what both of them have emphasized is that we need to take care of our endothelium. And when we talk about diabetes, diabetes is a systemic disease. It is a vascular disease. And the primary pathophysiology in diabetes is endothelial dysfunction because of reduced nitric oxide. The vehicle of damage in diabetes is persistent hyperglycemia. The mediators of damage in diabetes is reactive oxygen species and advanced glycation end products. This again is because of persistent hyperglycemia. If we take care of glucose, a great deal of these problems will be settled. And you may have a patient who is 60 years old, lean, non-diabetic, non-hypertensive, non-smoker, non-alcoholic. If you look at his vessels, it will look like a 40-year-old person's. You may have a 40-year-old person who is obese, diabetic, hypertensive, smoker, and an alcoholic, and his vessels might look like a 60-year-old. And the way to assess this is by doing arterial stiffness. So arterial stiffness will give us some indication about the endothelial dysfunction. A lot has been said about diet also. The irony is, every animal knows what to eat, when to eat, and how much to eat, except human beings. We are the only species who go and ask what to eat. Not that we are stupid. We have changed every aspect of food. The look, the taste, the texture, and the taste. And we do not eat food in its natural form. When you eat food in its natural form, it has a natural satiety. When you process the food, when you refine the food, it loses satiety. And thank you very much, doctor. It was very, very nice. If there are any questions, doctor will answer.
Thanks for concluding this so nicely. So I think the main message is when some people got retired, I hate this term, the retirement. I think we people, the more we are aging, the more we are loaded with the work. And we are more, I feel more younger by doing more and more work. I do exercise for 2 hours somehow every day. At this age, around this age, basically in the certificate age it is only 61, but basically it is 64, I think, by my mother's age. So at this age I feel more energetic, and this only happens because in the morning every day 1 hour I walk, I do some Surya Namaskara, I don't take so much burden, what happens, happens, and this is how mind management I do. And if you do that, even the 40 years people, many 40, 30 years, when they are walking, their half shortness of breath is happening. You walk every day, nothing will happen. The heart will itself correct everything. So this is a great thing. I think here the LSM itself, name is LSM, and I think marathon runner is our Manohar, and always smiling is Abinda and Suresh and everyone. So these people are really a role model in our society, and they are real people who give us a wonderful occasion and things to do. Thank you very much. Thank you.
Thank you so much for the message, sir. So all the three of you could join on the stage for a photo. And I also request all of you to collect your faculty memento from the faculty lounge. Thank you so much, sir. To move on to the next session, the topic is in-house management of diabetes, focus on non-insulin therapies. And the speaker is Dr. Pratap Jetwani. To share the session, I'd like to call upon Dr. Govindappa D. and Dr. Srinath KM on the stage, please.
Though it is a post-meal session, the topic is very interesting. Conventionally, whenever patient is admitted in the hospital, traditionally we start insulin. Insulin is the Ramabana for inpatient. It is with the availability of modern glucose-lowering agents with multiple pleiotropic benefits. There is a paradigm shift, as we all know. There is a paradigm shift in the pharmacotherapy in our approach to the management of type 2 diabetes. You know, the recently introduced SGLT inhibitors, GLP-1 agonist, and recently introduced drug tirzepatide, which has got triple agonist. These drugs have got lot of benefits, renal, cardiac benefit. Very interesting topic our speaker has selected, the non-insulin therapies in a admitted pain in an hospital management. This is very interesting. Probably he will going to speak all these new therapies. Let us listen to him. I request my co-chairman to introduce the speaker.
Good afternoon, everybody. I think Dr. Pratap P. Jetwani sir doesn't need much introduction. Sir is a well-known diabetician as well, and is a joint secretary of RSSDI India, and is doing a phenomenal job as a diabetic physician as well as a joint secretary of diabetes. Over to you, sir.
Thank you, chairpersons. Let me first thank Dr. Manohar, Dr. Vijay Kumar, and the entire team of Karnataka RSSDI for inviting me to speak on this subject. I will start with first giving you an idea about the heterogeneity in people who are being hospitalized with hyperglycemia by giving these two hypothetical cases. So first is a male, 40 years, diabetes, short duration, very well controlled with triple drugs, normal renal function, normal cardiac status, was having sebaceous cyst, got infected, and is being hospitalized for that purpose because he's running high-grade fever, very high counts. So he requires intravenous antibiotics followed by drainage of that abscess and removal of that cyst. Second is a female patient that is 72-year long-standing diabetic on insulin and oral drugs, already having cardiac problem, CKD, HbA1c reasonably controlled, and she is being posted electively for surgery for inguinal hernia under spinal anesthesia. So both of these patients, they represent heterogeneity in people who are getting hospitalized with hyperglycemia. There may be new onset diabetes, it may be a recent diabetes, it may be having multiple complications, patients not on any drugs, on complex insulin therapy, and then being hospitalized for hyperglycemia management. And we all know that we still follow that one-size-fit-all approach, which we were using to treat type 2 diabetes previously. That whenever a patient gets hospitalized, for a non-critical care setting, you have to start subcutaneous insulin, and for critical care setting, you have to start intravenous insulin infusion, and oral drugs are a big no in hospitalized patients as per most of the guidelines and recommendations. So there is significant advancement in this field, but still it is lacking a lot of research. And most of the guidelines, they still recommend basal bolus insulin therapy as the preferred approach, but there is upcoming evidence which I will touch upon. And we need to move from that approach of one size fit all to the precision medicine. So we need to individualize therapy depending on various factors taking into account when the patient is getting hospitalized. What is the prevalence of oral drugs being utilized in hospital patients? This is the data from USA, UK, and Spain. The recent paper of 2022. Even in UK, if you see, almost 40% of people, 20% they are on oral drugs and 17.65% on diet only. In Spain, around 9% of people, they are still on oral drugs when they are getting hospitalized. So they are being used. We need to have evidence to support their use, and we need to identify proper subset of patients where we can use these oral drugs for better glycemic outcomes. So I will touch upon every drug and will give you an idea about their merits and concerns as far as their use in hospital is concerned, and if there is some evidence that I will post to you. So metformin is the first line therapy we know, and that is the most commonly used agent in hospitalized patients across the globe, including our country. No hypoglycemia, and the important thing is you can very well combine it with any sort of insulin therapy, basal insulin, basal bolus insulin therapy, you can very well combine. There are some non-glycemic benefits which are there, and there is reduced neurological severity and improved acute phase therapy outcomes in acute ischemic stroke patients. Although lactic acidosis is a big concern, but the real world data say that there is no cases of fatal or non-fatal lactic acidosis in around 59,321 patient years of use. But you have to be cautious, you have to avoid in critically ill patients, those who are having severe renal disease, liver disease, hypoxia, shock, because in that category of patients, it increases the risk of lactic acidosis. It requires dose modification, and we all know that many people in hospital, they develop AKI, so you may have to stop this medication when the EGFR goes below 30, and currently there is no prospective data to support their use in hospital settings, and they are not recommended by any of the guidelines. This is one of the papers where metformin was used in patients with diabetes who were undergoing variety of surgeries, and the post-operative outcomes, the improvement in 30-day in-hospital mortality, there was a decreased risk of septicemia and acute renal failure, the patients who were on metformin, and this was irrespective of their sex or their age or their underlying medical conditions, whether they were 1, 2, or 3, the results were similar. There was no heterogeneity in that data. So among patients with diabetes, those who use metformin and underwent major surgery, they had a lower risk of complications and 30-day mortality compared with non-users, and probably this is the area where a lot of research is going on, particularly in cardiac surgeries, how up to what day you have to continue metformin and when to restart it post-surgery. So a lot of work is being done in this area. Sulfonylureas are the second most common use agents in our country, and they are the most common use agents in hospitalized patients across the globe. Rates must be higher in our country. Good potency, and they start acting very fast. They may confer protection, some neuroprotection, there is some data is there, but the biggest problem with sulfonylurea is hypoglycemia. And currently there is no evidence to support their use in the hospital settings. So 90% of patients who received a sulfonylurea during hospital, they develop one episode of hypoglycemia. This was highest with glyburide and almost similar with glipizide and glimepiride. And the predictors for hypoglycemia, mainly it is old age, GFR of 30 ml per minute or less, and co-administration of intermediate or long-acting insulin.
So it cannot be combined with insulin. It should not be used in elderly people. It should not be used in people who are having renal decline. There the risk of hypoglycemia is very high. Also, there is data to support that if you use sulfonylurea during hospital stay, then the risk of readmission increases by 30%, and probably this might be related to increased risk of hypoglycemia being imparted by sulfonylureas. What about glitazones? They have got no hypoglycemia. They are anti-hyperglycemic agent. Good potency is there. Some non-glycemic benefits are there, particularly in acute ischemic stroke, and they can be used in patients who are having impaired renal function. But we all know that glitazones, they take time for glycemic action. They are very slowly acting agents. So they are not good for immediate glucose reduction. There is a risk of heart failure hospitalization. So avoid combining with insulin. They cannot be combined with insulin. Fracture risk increases, and currently they are not recommended for in-hospital use. DPP-4 inhibitors are the most promising agents which can be used in hospital settings. They are oral agents, no hypoglycemia, good potency, immediate onset of action, can be combined with insulin therapy. Side effects are almost negligible, and they are supported by evidence. And I will touch upon few of the trials of in-hospital use of DPP-4 inhibitors. The problem with DPP-4 inhibitors is a mild agents, less potency as compared to insulin sulfonylureas. There is a remote risk of pancreatitis. They cannot be used in people who are having active gallbladder disease. Dermatological side effects are a concern in few patients. Renal impairment, generally they require dose modification unless and until you use linagliptin, which is not being excreted by the kidneys. And currently, none of the guidelines they recommend their use in hospital settings. So what are the trials which are with the DPP-4 inhibitors in hospital settings? This is the first trial, that is CETA hospital trial. This was carried out in USA in 5 hospitals. This was a multi-center prospective open label non-inferiority randomized trial. It was carried out in type 2 diabetic patients who were having blood glucose, admission blood glucose of 140 to 400, and who were either receiving diet or oral drugs, or a total daily insulin dose of less than 0.6 units per kg body weight. And they were divided in 2 groups. One group was given sitagliptin plus basal insulin, and second group was given the standard of care, that is basal bolus insulin therapy. And the primary endpoint was the glucose control between the 2 arms, and secondary endpoint was hypoglycemia, insulin dose, and complications which are occurring in hospitalized patients. So if you see the glucose control, it was almost similar. This is pre-breakfast, pre-lunch, pre-dinner, and before bedtime sugars. The above graph it shows. And it is almost same in both the groups. And if you see over a period of 10 days, it is also similar between 2 arms. And whatever the range you consider, 80 to 140, 80 to 180, 80 to 200, 70 to 200, it was similar between both the groups. And the sitagliptin basal group, they required less of a bolus insulin, so the overall insulin dose was low in sita basal group as compared to the basal bolus therapy. However, the hypoglycemias were same and the overall complications were same in both the groups. So we can say that sitagliptin with insulin glargine single prick can give an equivalent glucose control like basal bolus therapy in this category of patients, and in places where there is a low staffing and low resources, because we all know that basal bolus insulin therapy requires a lot of adjustment, lot of monitoring, and lot of staff training. That can be curtailed if we can use single dose of sitagliptin with single prick of basal insulin, and it is having equivalent glucose control like basal bolus insulin therapy in this study. So they concluded that you can use incretin-based therapy in combination with basal insulin patients with type 2 diabetes who are admitted to hospital, who were treated with either oral drugs or the insulin requirement was low, that is less than 0.6 units per kg body weight. Then you may think of this option instead of a basal bolus insulin therapy. Is there any evidence with other gliptin? This is LENA trial, LENA surgery trial. This is real world data. And here the patients who were hospitalized in non-cardiac surgery departments having type 2 diabetes and their HbA1c less than 8 and admission blood glucose less than 240, and they were divided in two groups, either basal bolus insulin therapy or same linagliptin plus basal insulin, 1 prick. And here again, if you see, the glucose control is almost same. In this trial, they were able to show that the insulin dose requirement was low, and also the hypoglycemia was reduced by almost 80% if you use linagliptin and basal insulin as compared to basal bolus insulin therapy. So this is one way to treat diabetes or hyperglycemia in hospital settings when the patients are having mild hyperglycemia, HbA1c less than 8, admission blood glucose less than 240. The another trial they have gone based on these evidence, they have done a multi-center randomized clinical trial in USA where they have tried to find out whether we can use only linagliptin and no insulin and compare it with basal bolus insulin therapy. Can we use it in hospital settings without insulin, only linagliptin? And this trial also has shown that in people who are having less hyperglycemia, admission blood glucose less than 200, the linagliptin arm was same. If you see here, it was same like basal bolus insulin therapy. So they concluded here also that in patients with type 2 diabetes who are undergoing non-cardiac surgery, who are presenting with mild to moderate hyperglycemia, blood glucose less than 200, daily linagliptin only is a safe and effective alternative to multi-dose insulin therapy, resulting in same glucose control, lower hypoglycemia, and no insulin requirement. So this was the evidence with DPP-4 inhibitors in hospital settings. Now I will go on to GLP-1 analogs. We all know that they have got a very strong efficacy, cardiorenal benefits, no hypoglycemia, extra glycemic benefits are there. You can combine very well with basal insulin therapy. They are supported by evidence for use in hospital settings, but very small trials, pre-operative use, there are there, but not a very good data to support their use in hospital settings. The potential risk is of GI side effects, and I think now the anesthesiologists, they are wary of giving anesthesia in people who are continuing with GLP-1 analog therapy because they decrease motility and they increase the risk of post-operative paralytic ileus and the chances of vomiting and aspiration pneumonia. So not to be used in people who are undergoing GI surgeries or GI procedures, and patients who are having active gastrointestinal conditions requiring hospitalization, you cannot use these molecules. SGLT2 inhibitors are another class of agents which can be used in hospital settings. Good efficacy, no hypoglycemia, cardiorenal benefits, extra glycemic benefits. You can combine with insulin therapy, and there is support for evidence in the setting of heart failure. You can use these molecules. The problem with SGLT2 is GI, genitourinary infections. If the patient is having indwelling catheter, then this will increase. Euglycemic decay is a particular concern. If patient is not taking anything orally, particularly carbohydrate intake is poor, then the risk of euglycemic decay increases, and therefore there is a recommendation to stop 24 to 48 hours prior to any elective surgery or procedure. You have to stop SGLT2 inhibitors. Also, hypotension, dehydration, and hemoconcentration are some of the issues. But there is a data to support that if the patient is being hospitalized with heart failure, either prior to discharge or immediately after discharge, you have to start these molecules because they decrease the rate of re-hospitalization as well as cardiovascular death in people who are being hospitalized with heart failure. This is data from Soloist WHF, and the same is there from EMPULSE as far as empagliflozin is concerned. And there is upcoming evidence to support their use in hospital settings, particularly in patients who are having cardiac events like MI. They might be having some beneficial effects. And DARE 19, where the dapagliflozin was used in hospitalized patients who were having COVID-19, established the efficacy and safety of these molecules. They may improve survival based on this variety of mechanisms, but this study, which was carried out at Delhi by Professor Kuchoy and his team in patients who were undergoing CABG, and there they have used dapagliflozin on top of basal bolus insulin therapy immediately after CABG, and they have tried to find out whether it improved glucose control and whether there was any increase in plasma ketones. So there was no benefit as far as glucose control was concerned, but there was definitely an increase in plasma ketone levels. So you have to be cautious when you are using SGLT2 inhibitors, because there is a definite risk of euglycemic decay if the patient is not taking proper carbohydrate intake. So in summary, I will say only metformin and DPP4 inhibitors are the two molecules which can be used in in-hospital settings. SGLT2 inhibitors if there is heart failure, otherwise none of the other agents. They have got supportive evidence for in-hospital setting use. What do the guidelines say? The ADA says that there is potential effectiveness of DPP4 inhibitors, GLP-1 analogs in specific group of hospitalized patients. SGLT2 you can use in the setting of heart failure. Otherwise, you have to be cautious because it increases the risk of euglycemic decay. Other agents you have to stop. Diabetes Canada also says them, but there are multiple contraindications to use of oral agents: irregular eating, vomiting, acute or chronic renal failure, exposure to intravenous contrast dyes. All these, they limit the use of oral agents in hospital settings as per this Diabetes Canada guidelines. I will not go in perioperative, so I will say that there are a lot of gaps in our knowledge of managing patients who are having dysglycemia or diabetes in non-critically ill adults. It definitely requires a new studies to generate the better evidence to support the use of these non-insulin therapies in hospital management of hyperglycemia. Till that, this is the algorithm which is suggested by the experts of in-hospital management of hyperglycemia. If the patient is having mild hyperglycemia at the time of admission, blood glucose less than 200, the patient was on 1 or 2 anti-diabetic agents, no insulin was used on OPD basis, was having good control of diabetes, you may start only with DPP4 inhibitor and supplemental correctional bolus insulin if required. And if you are not able to maintain target, then you may add basal insulin in the dose of 0.2 to 0.3 unit per kg per day, and then correction bolus as per the requirement. And still, if you are not able to maintain target, then you may go on basal bolus insulin therapy. If the patient is having moderate hyperglycemia, that is blood glucose between 201 to 300, was already on multiple oral agents or insulin, but the total dose was less than 0.5 units per kg body weight, then one may think of gliptin with basal insulin to start with and bolus insulin as per requirement, and if not controlled, then may shift to basal bolus insulin therapy, may continue gliptin along with that. And if there is a severe hyperglycemia, blood glucose more than 300, multiple oral agents, large doses of insulin, then you have to give them basal bolus insulin therapy. So I think we are always there with old way of thinking, but we have to accept this new evidence and start the new way of thinking of using non-insulin therapies also for in-hospital management of hyperglycemia. Thank you.
Thank you, sir. Wonderful presentation. You have covered almost all class of glucose-lowering agents. Particularly, you have emphasized the importance of pleiotropic benefits of these drugs, particularly the drugs which have renal benefit and metabolic benefit and cardiac benefit. You emphasized very nicely when to give which drug and what condition which drug to give. But I have got one clarification, sir. In hospital patient, there are two classes of patients. Outpatient, the inpatients are there. Invariably, inpatients are admitted with some kind of illnesses. They are sick patient. But giving this, it's all right what you said, well said for OPD coverage of the patient, even though in hospital. But those who are impatient, awaiting from surgery procedures or acute infectious situations, metabolic situations, so there, giving these drugs, though they have got certain benefits, those studies say that they are excellent drugs in so many occasions, but still we think twice to put them on oral hypoglycemic drugs. Exceptions are there, linagliptin, and some of the exceptions are there. But in general, sulfonylureas, metformin,
So the only agent which you can use is the DPP-4 inhibitor, as I have already highlighted. There is now a good evidence to support their use. And the SITA hospital trial, where almost 80% of patients, they were admitted in general medicine ward. They were having infection, they were having pulmonary problems, they were having cardiac problems. And good number of patients were there. And still sitagliptin with basal insulin failed same like basal bolus insulin therapy. So I think now the time has come to use that precision medicine approach also for in-hospital setting patients. Rather than going for a basal bolus for everyone, you have to take a look at the patient in a holistic manner and decide whether this patient is justified to receive gliptin with metformin, with basal insulin, and bolus insulin as per requirement, or a classical, that is basal bolus insulin therapy. Yes. So I think such situations you have to go for basal bolus insulin therapies. There is no other option. But nowadays we are seeing a lot of patients who are undergoing clean surgeries, like joint replacement surgery, where the patient is not having any kind of infection. It will be nil orally for few hours. Immediately after surgery, 4-6 hours, they will start them on oral sips, and they will start diet within 12 hours also. So in that category of patients, you can think of this kind of therapy where it will simplify the management, will not increase the risk of hypoglycemia, and will provide equivalent glycemic control like basal bolus insulin therapy.
As a routine prescription after discharge, even after ACS and percutaneous procedure,
yes.
they started giving dapagliflozin even though they are not diabetics.
Yeah.
Any questions from the audience?
I think his message is very clear. Only the gliptins have certain indications in based on the patient needs. Otherwise, whether it's a gliptin or a glyphosine or glinite, all those are not useful. Only in certain set of patient probably it's a physician discretion to use these drugs. Thank you very much, sir, for your nice message.
Thank you. Thank you.
From the audience?
If there are no questions, we'll hand over the mic to the organizers.
I think any questions are there. Probably it can be discussed offline during the interaction over the tea or even a dinner. Thank you so much, sir, for the interactive session. I would request the chairpersons and the speaker to have a photo together, please. And I also request the chairpersons and speaker to collect their faculty memento from the faculty lounge. Moving on to the next session, we have another talk on wearable devices for diabetes care. The speaker is Dr. Amit Gupta, and to chair the session, I would like to request Dr. Balaji Jaganmohan and Dr. Kiran Nidagundi to come on the stage, please.
So good evening, everyone. Hello? Hello? Yeah. So it's in. So we have a very interesting topic. We know that there are a lot of technological advances in diabetes management. And a lot of patients, at least in urban areas, use a lot of wearable technologies to monitor diabetes. And several other metabolic conditions could be monitored in a non-invasive fashion. So to throw more light on this particular topic, the use of wearable devices in diabetes care, it's my pleasure to introduce Dr. Amit Gupta, who requires no formal introduction. In fact, he's been in a lot of national and international circuits as a speaker. He's been in the committee of various organizations, and you can see there's a rich CV that is there for him. So it's my pleasure to welcome Dr. Amit Gupta to take over for the session. Thank you.
Thank you, Dr. Balaji Mohan, and respected chairpersons. Thank you, Karnataka RSSDI, and congratulations for completing 20 years. I think it is one of the most earliest chapter of RSSDI, which I feel. So today I'm going to talk on wearable devices for diabetes care, and just to give you a glimpse that what is a device type and where it can be placed. So depending upon the device type, it can be a smart cloth, it can be a smart watch, it can be a smart socks, smart watch with a wearable sensor, sometimes it can be a wristband, footwear, neckband, and there can be different types of sensors which can be worn nowadays. And where they can be placed in different parts of the body, right, varying from chest, finger, foot, hand, wrist, arm, thigh, neck, and any other part of the body. And if we divide them on the basis of the technology, we can divide on different technology. And I will not go into the details of these technology, but it can be varying from Actigraph to a freestyle flash monitor or a Dexcom G4 Platinum, or it can be variable on the device operating system also. For example, it can be iOS-based, Android-based, Microsoft-based. Also, the host device where the data will be hosted. So it can be a cloud-based, PC-based, or there are multiple different kinds of devices where the data can be hosted. If we talk about what are the technical features of these wearable devices, they are not only just to measure the blood glucose, they can be measuring various physiological parameters as well, like heart rate variability, interbeat interval of the heart, or the galvanic skin responses. We will see some of the clinical applications of these devices. And again, the data transfer mode can be varying between Bluetooth, internet, Wi-Fi, wired, or a removable media. So this is just to give an outline that when we are talking about wearable devices, it is a very broad spectrum of devices which are there. And they can vary a large number of parameters, varying from the blood glucose to blood pressure, as well as the various physiological parameters as well. And I will be giving you some of the examples. Depending upon the sensing technology, again, this is just a list for the completion that it can be an accelerometer, it can be a galvanic skin response, it can be ECG, it can be a pressure sensor, infrared sensor. So multiple types of sensors may be available based upon the technology they are using for the sensing the desired parameter. So coming to the one of the most common wearable device is a CGM, or the continuous glucose monitor. And if you talk about the devices which are commonly used all across the globe, though many of them are not available in India, for example, Dexcom and Eversense is not available in India. But these are the devices which can be used for the continuous glucose monitoring, and they can be applied for a variable period of time, varying from 14 days to 6 months. For example, Eversense is something which can be applied up to 6 months, and now the latest version of the Eversense can be an implantable device which can measure blood glucose levels up to a duration of 1 year also. They vary in their differences. For example, the Freestyle Libre doesn't require any kind of calibration because it is a factory calibrated device, while a Medtronic Guardian device, while the Eversense, they will still require blood glucose calibration with the SMBG. So just to look at the history of wearable devices, it goes back to the announcement of the Apple Watch by the Steve Jobs, and it announced the first iPhone in 2007, and the Apple Watch was released in April 2015. So I borrowed this slide from Dr. Jyoti Dev, who is one of the leaders in the field of diabetes technology in India as well as globally. And just to let you know that how these wearable devices can be used in day-to-day life. For example, there is many of us are using an Apple iPhone, but still we are not using a Apple Health app. I would like to just have a disclaimer that I am not being paid by Apple any honorarium for this talk, but the devices, many of these applications, they are approved by the FDA for sensing different parameters of the different metabolic parameters as well. So the iOS app, Apple Health app is a very useful app, and the data stays on the device as well as it is encrypted, safe, and highlights different parameters like steps, sleep, or vitals using machine learning. So if you look at the sensors, what type of sensors are there? So just look at the type of sensors which Apple 7 series watch is having. It is having an accelerometer, a gyroscope, a heart rate sensor, a barometer, and always on altimeter, a compass, an SpO2 monitor, and a VO2 max sensor. So your Apple device is having so many sensors on its back that they are able to regulate multiple devices, multiple parameters, for example. This is one of the feature which is very launched 2-3 years ago, and now the FDA has approved it for the detection of atrial fibrillation. This is only the atrial fibrillation which FDA says that if somebody is wearing an Apple Watch, then Apple Watch can sense the atrial fibrillation, and it is a very accurate sensor. Also, this is one of the experience which is shared by Dr. Jyotidev himself, that how one of his patients was wearing only an Apple Watch. He had some chest discomfort. He asked him to record an ECG, and immediately within 30 seconds, the ECG was transmitted to Dr. Jyotidev, and he could sense that there is something abnormal with the ECG, and the patient could get the timely intervention and the treatment. If you look at the different types of health categories which can be monitored, is that you can take body measurements, you can have cycle tracking for the menstrual cycle, you can track the exposure to the sound. For example, hearing can be monitored, heart rate can be monitored, mindfulness, mobility, and multiple other parameters which can be monitored. Heart rate variability is another important parameter which can be measured by different types of wearable devices. This is just one prototype. There are many of these prototypes which can actually measure these parameters. So heart rate variability is a measure of how much the time between two heartbeats varies from beat to beat, and this heart rate variability can be actually monitored by a wearable device in patients with diabetes. SpO2 monitoring, we know, capable of tracking blood oxygen saturation, and it takes around 15 seconds to measure SpO2 level by a wearable sensor, and during which users need to be completely still, and there are now many wearable devices where you can monitor your oxygen levels. During COVID time, it was particularly important. We were told that we need to wash our hands regularly, but it is a common practice that a very little time is spent during the hand washing. So you are not sure whether you have spent the adequate time during the hand washing or not. So how to ensure that you have spent adequate time and followed all the steps? So there is a sensor which automatically detects when user begins washing and has keep going for the amount of time recommended by the global health organizations like WHO. So this can actually help you in sanitizing your hands in a better way. Activity app is another important thing which is of which can be of a great use for person living with diabetes, because there are constant nudges, there are constant pushes, and there are rewards also which a person will get whenever they are using this kind of app or monitoring sensors, where their fitness goal can be targeted. They can have well-defined goals, and they can measure these goals throughout the day for the activity. So there are different challenges as well to participate or achieve targets to get medals and different rewards in the activity app. This is very, very important. We know that sleep apnea is a very big problem in people with diabetes, and it is one of the most ignored and overlooked problem in persons with diabetes. So how do we get the sleep analysis? So now there are many devices where simply by wearing the sensor, you are able to monitor the sleep, and this can tell you whether the person is having sleep apnea or is at high risk of having the sleep apnea. So complete sleep analysis report can be generated by the wearable sensors, and one of the example is the Apple Watch. Hearing, that diabetes is another risk factor for the hearing loss, the age is another one, and how to monitor the exposure to the sound. So measuring the sound levels by different sensors is one of the possibility where these wearable sensors can help the person in limiting the exposure to the high decibel sounds. Mobility is again very important. We know that especially in elderly people, there is a risk of hypoglycemia, there is a risk of frailty, there is a risk of increased fall, and mobility applications and the mobility sensors with the use of gyrometer, accelerometer, and step counters and different pressure sensors, it is easy to assess the balance strength as well as the gait. So this assessment of the balance strength and gait can be very useful for somebody who is at greater risk of falls and all. Another important thing is the medical preparedness. I will skip that slide because it is not a wearable. So you can have a wearable ID, medical ID, which is having all your information, and if in case of an emergency, only one needs to scan your ID and they will be able to get the entire medical data to help that person during the situation of the emergency. It is a dream, but it is not yet true. So there may be a sensor which will be recording glucose levels non-invasively blood pressure as well as the temperature. So recently there is a device by the Omron which is approved by the FDA for the measurement of the blood pressure. And just to see, you can look at the summary of all the health parameters in one window, and this is something which can give a very fair idea of somebody's different vital parameters. So this was something which is very commonly available, but next few slides I will be showing that what is the future. So I am talking about the smart clothes. So smart clothes is something which is having a embedded digital component or a sensor, and this is called smart fabric. And using interactive fabric technologies, these smart textiles are able to communicate information like body temperature, heart rate, blood pressure, and wearer's location. And this is an example, this is already available in the market, and this is the Hexoskin smart clothing monitor, where by just wearing this smart cloth, one can monitor different cardiac pulmonary activity as well as the sleep data. So this is the future of the wearable devices, which is already available and in many of the countries, though not yet available in India. This is the report coming from this Hexoskin, where you can see the continuous respiratory ventilation with chest and abdominal respiratory inductance. Plethysmography is there, and activity intensity can be seen with peak acceleration, steps, cadence, position, and sleep with a 3-axis accelerometer. So sometimes these information which is derived from multiple sensors can be used to translate into medical benefits for the person. This is very smart ring, and this is just the shape of a ring is there, and this can monitor from the sleep activity to the heart rate, and it can monitor the overnight blood oxygen levels also. So one of these smart ring is unlocked by the Aura, and it allows users to monitor different health parameters by wearing only a ring in the finger. This is just an example that how a sleep data from this device would look like. These are different forms of wearable devices, and which just to see, show you the prototype, that they can be worn in the wrist, they can be worn in the neck, and they can be applied in the form of patches also. So multiple types of devices are available. So another important kind of wearable device is a smart shoe. So what is a smart shoe? A smart shoe requires a reliable system for data acquisition. We heard a talk from on the diabetic neuropathy, and we know that diabetic neuropathy is sometimes it is very difficult to treat diabetic neuropathy, and people with diabetic neuropathy, they may be at risk of foot ulcer because the sensory system has gone wrong. So if the nervous system is not working, the peripheral nervous system is not working, then you can have sensors which are outside, and they can support the person to reduce the risk of future ulcerations and how it can happen. For example, this is one of the smart shoe which is developed by the Nike, and the ability of this smart shoe is that it is a self-lacing shoe. So a person only need to put the shoe, and the shoe will only tighten to the required pressure. So it will not exert extra pressure on the person's feet. So it actually decreases the risk of foot ulceration because of the extra pressure from the misfit shoe. This is a DigitoSole. DigitoSole is a smart shoe by DigitoSole, which features a wide range of uses and is fit for everyone. These interactive smart shoe provides personalized feedback to analyze health, fatigue, posture, steps, calories, and they can create precise data for improving health and preventing injuries. So the shoe is providing so much of the information which can lead to improvement in the overall physical health of the person. This is another shoe by the Under Armour, and they have embedded a high fidelity sensor in the midsole of the right footed shoe that digitally connects seamlessly to the Map My Run app via the Bluetooth. So each and every step while wearing the shoe is counted, the pressure is monitored, the distribution, the gait, the stability, so everything is monitored by this app. So this simple seamless connection allows the shoe to track a variety of metrics and data on the run, including distance, pace, splits, cadence, stride length, and the lifetime distance. Another big player in the smart shoe market is Xiaomi, and has developed a chip-laden Misa smart shoes. And these shoes are again easily connected with an app, and they have multiple sensors to record different types of parameters or data during the mobility. This is another example of a smart shoe. Siren Socks is one product which helps providers and patients find potential injuries early and reduce the risk of diabetic ulcers and other foot complications. So there is a smart socks which is having some sensors, and these sensors are able to detect changes in the temperature as well as the changes in the sweating, and by means of that, they are able to warn the person early that there is a risk of some kind of ulceration. Before I conclude, it is important to talk about the virtual reality as well as the augmented reality. The VR we all know, but the AR is something which is going to come very soon. If you look at your Google search now, there is a feature, you will find a camera at the end of your Google search. So this is a Google Lens. So Google Lens is something that it allows you to click photograph of anything and it will start providing you data on that. For example, if you click the Google Lens on a food item, it will tell you that what is this food item, what can be the calorie content in a particular gram. So this is the reality, augmented reality and the virtual reality. So many of the workout, many of the exercise, now they are based on augmented reality and the virtual reality platforms. So this enhances the experience of the user while doing these workout, and this increases the compliance and gives more satisfaction to the user, and they are able to sustain the physical activity levels. So this is the VR, but it is important to understand the augmented reality also. Just last year, the Apple announced their AR platform, the AR glasses. So these glasses, whenever, if a wearable glass, somebody going to shop in the market, and they look at the product itself, and immediately the glass will tell that this product is having so many calories, is having so many disadvantages, and this is healthy or this is unhealthy. So this is how the augmented reality is going to come into our life in near future. So this is just an example that a person who is going to buy a milk, immediately everything comes into the picture, that what is the calorie content, what is the different kind of health parameters in the food label. It will be immediately seen by the person buying the stuff. This is another innovation, that is the premier wearable blood pressure monitor and much more. And one of the recent Omron devices has now been approved by FDA for measurement of the blood pressure by a wearable device, by wearing a wrist band kind of device. Dr. N.K. Singh talked about the circadian rhythm and the importance of staying young with diabetes. And now there are going to be devices and the wearable devices which will be able to monitor the circadian health and the circadian rhythm of a person. So wearable device, you can think of n number of applications, and concerning to diabetes, you can monitor glucose levels, you can monitor physical activity, sleep is other aspect. Important thing is that heart rate variability and the detection of atrial fibrillation is another important aspect, and circadian rhythm monitoring is something which is very, very important. So with this, I would like to thank you. And those who are more interested in learning technology, you are most invited to World Congress of Diabetes Technology, which is going to happen in Kochi in the month of May from 17th to 19th May. Thank you.
Thank you, Dr. Amit Gupta, for your excellent presentation on various devices to monitor blood sugar, ECG, and blood pressure. So, lack of time, any questions we'll take during the coffee session with Dr. Amit Gupta. Thank you.
Lot of interesting devices, sir. I'd like the chairperson and the speaker to join on the stage for the photo. And I also request all of you to take your faculty memento at the faculty lounge. Thank you so much, sir. The next talk is on modern sulfonylureas, the green swan of OAD, to be delivered by Dr. S.R. Arvind, sir. To chair this session, I would like to request Dr. Suman R. and Dr. Prabhakar V. on the stage, please.
Good evening, everyone. It's my pleasure to welcome Dr. S.R. Arvind, who is well known to all the audience over here and is Director Diacon Hospital and Secretary General Diabetes India, who is going to speak on modern sulfonylureas, the green swan of OADs. As all of us know that sulfonylureas we have been using for more than 5 decades. It's the most prescribed oral anti-diabetic drugs for type 2 diabetes mellitus. Apart from its effect on the control of blood sugar, it has also got so many extra pancreatic effects. But it has also, especially older sulfonylureas, has got some shortcomings, especially in the elderly people, with respect to hypoglycemia and also the adverse cardiovascular effects. Thanks to Carolina, studies like Carolina, where it showed, especially newer sulfonylureas are proven the less incidence of hypoglycemia and also the most beneficial effects on the cardiovascular system also, which can be compared to the newer drugs. So to speak all these aspects, we have Dr. S.R. Arvind, and who is going to show us the light on this newer group of sulfonylureas. Over to Dr. Arvind, sir.
Thank you. I think, thank you so very much, chairpersons, and my thanks to KRSSDI, Manohar, and the group. Thanks for the lovely shirt, but I'm not wearing the shirt today, but I'm sure celebrations will wear it. My teacher is here, Dr. Lily John is here, and so wonderful to have her in the front row. And many of my seniors, thank you so very much for being there, and a lot of smiling colleagues from the RSSDI headquarters. And okay, so when I was given this particular topic, I said, okay, let me just check what is meant by the green swan, because sometimes these words were never used when we were young. So this was the meaning I got. It's got nothing to do with the lecture, but if some of you really wanted to know, this is one of the meanings, solutions that take us exponentially towards the breakthrough, right? I'll start with this paradox. I'll come to that a little later, right? The first thing is, I can live with doubts and uncertainty and not knowing. It's very easy. As long as you don't know, you can live with uncertainties and doubts. And it's also interesting to live not knowing than to have answers that are wrong. At the end of the talk, probably some of you will realize why I started with this paradox. Well, 2019 IDF says 72 million, but this is Dr. Mohan's paper from ICMR, 101 million. So the challenge is there. So the next IDF Atlas, I'm sure, will show this as the number. Now, despite whatever we have been doing for the last 35, 40 years, so many conferences, so many new drugs, so many new techniques, I'm sure Dr. Lily John will be very upset because the coronary heart disease, there is a 160% increase. This is 2019 IDF. Ischemic heart disease, there's an increase by 127%. Nothing seems to be going down. It's not even stable. It's on an increase year by year. And this is in diabetics. And that's the problem. And this has been a shocking news. Okay, now, again, not connected to the topic of my choice, but I just wanted to show you that we haven't really done anything, even with the newer drugs. Let's go back to the three eras of diabetes management. The first era, of course, was glucose-centric. When I started my practice, 89, 90, this was the only thing we had, glucose-centric. So I start with this lion. I'll come to glimepiride because glimepiride started to rule from 1995 onwards in the sulfonylurea space. Just before that, there were other drugs. And there were minor fights since the introduction with the elder brother for superiority. And we used to jokingly say at that time, look, this is the French connection because both the drugs were from France, glycoside and glimepiride, okay. One said hemorrhagiologically, I'm better, the other said I'm much more safer. So this kind of a fight continued for some time. But finally, just to put down the fight, both of them were labeled as smart and safe. Now the question comes, I'm not going to be talking definitely the Lion King story, so don't expect a scar to make an entry. This is just anecdotal. Some of you will like it, some of you will think, why is Dr. Arvind bringing in Ganesha? Because it just told that, if you see the moon on Ganesh Chaturthi, you will face false allegations and criticisms, right? And this is exactly what happened to the sulfonylureas. UKPDS 26, we know about it. You know, there were articles in 1998, after glimepiride was released, that within a few years of starting treatment with sulfonylureas, the beta cells show clear signs of fatigue, deterioration in control, so on and so forth. And there were some words used, hyperexcitation and excitotoxic reactions, leading to beta cell apoptosis, with absolutely no evidence. And this article kept coming, kept coming, kept coming, kept coming, right? And we all read it at that particular time. It was as if the beta cell is like a sugar cane, and then you put it into the machine and everything comes out. So you use the you use sulfonylureas, it will suck out all the insulin that is left in the beta cell. Now the problem was, people started taking it a little more seriously. Actually, they spoke of chlorpropamide and glibenclamide. Glimepiride was not involved, totally not involved in any of the things. However, when once people start talking about a particular group of drugs, the doubts start coming in the minds of people. Is it the same with glimepiride? Is it going to happen? So this is the kind of a doubt, because you keep talking, no, elder brothers are not doing well, elder brothers are not doing well. You think the last brother is also not doing well. So my wife also stopped cooking for the fear of losing her skills with exhaustion. She said, okay, I cook so well, now I'm going to stop cooking because exhaustion. So luckily, Dr. Hallman himself came out and cleared this doubt. He said, I'm sorry, there is no solid evidence for beta cell exhaustion. Diabetes may itself cause decline in beta cell function. So this came 2006. So from 1998 to 2006, we kept hearing, beta cell exhaustion, hyperexcitation, sulfonylureas are not good. We kept hearing the same thing. We really don't know. And there was no evidence. And we were thoroughly influenced by this kind of articles. Let's move to the second era. This becomes very interesting. Glucocentric and no hypo, no weight gain. This was the second era, started in 2007. That's when the DPP-4s made their entry and they become the competitors. Now you have an insulin secretagogue, lone insulin secretagogue in the sulfonylurea group, and now comes a competitor. So you have to have something to say that I'm better than you or you're better than me or something, because this happens. The problem was, there was very clever marketing of DPP-4. I should accept it. DPP-4 clearly knew that efficacy-wise, sulfonylureas are so good, DPP-4 was nowhere near sulfonylureas in efficacy. I will show you the slides. So they had to target that little bit of hypo and the weight gain. Now look at this. Sulfonylureas, monotherapy, 1 to 2%, DPP-4 0.5, 0.8, DPP-4, thiazolidinediones, your acarbose, all of them have the same efficacy. So the companies which made the DPP-4 were very clear that, look, we can't compete with sulfonylurea in terms of efficacy, so we have to tackle them with hypo and probably weight gain as the problem. And a new term started coming out that, okay, my way of producing insulin is physiological. I'm not bombarding, I'm not hitting the beta cells, and it's very physiological approach is what you have. So sulfonylureas had to face very unfair comparisons, hypo, weight gain. And then the next target, oh, not cardiac safe. We need proof that you are cardiac safe because there have been some allegations with your elder brothers. Now, when insulin is used, I kept talking about it for the last 7, 8 years. Nobody talks of hypoglycemia because you have to teach hypoglycemia when insulin is used. I don't think we are going to get an insulin which does not cause hypoglycemia. Now, when it comes to glimepiride, when somebody blames, oh, glimepiride causes hypoglycemia, it's not the side effect. It is the effect. There's a good production of insulin. Always it has been told, you start slowly and then step up the dosage of glimepiride. Just like insulin, you start with 10 units and step it up. Glimepiride starts slowly because you don't know how much of endogenous insulin is going to pop out. There is no need to start with 3 milligrams twice a day, 4 milligrams twice a day. You start with 0.5, 1 mg. And this was told, but people did not do it. And this is something to say, hypo is not a problem between DPP-4s and sulfonylureas. It's a very small difference. Luckily, to the rescue of sulfonylureas came this trial, CVOT trial, Carolina, and the weight gain was just about 1.5 kgs at the end of the trial. 6.5 years, 1.5 kg was just the weight gain. And when I was making this slide, I also found a very interesting email. I don't know how many of you saw this email. This came from a pharma company, and it said, during festival season, you can increase your weight by 0.4 to 0.9 kgs, right? Now the question is, who said it? Any guesses? I'm sure many of you would have received this particular email. Uni Krishnan. So I took his permission. I said, Uni, I'm going to use your photograph and then apologize for that. And anyway, I will not discuss the company which said this. This is true. Any festival season, you tend to put on weight. So why blame sulfonylurea for weight gain? Nothing is going to happen with 1.5. So Carolina trial completely cleared this cardiovascular issue. So I will not go into Carolina trial. And it was great to see Dr. Eckel himself saying these words. He says, after Carolina, I'm now comfortable because I would take the patients off sulfonylureas. Now I'm assured I can use this. Now the question is, when such a senior can be influenced with repeated talks of hypo weight gain, definitely it will happen to all of us. So glimepiride has been a victim of very clever pharma marketing. With DPP-4s in the market, they had to target something. So deliberate amplification of minor concern, which was hypo, absence of CVOT, yes, luckily thanks to Carolina, and weight gain. Now I will ask a question to all of you. Do we blame the pharma for this? I will ask the chairpersons for this. Clever marketing, do we blame the pharma? The answer is no. I don't think we should blame the pharma at all. They are just doing their job, well within their limits to do their job. I think we have to blame ourselves because what is happening is we have become too busy. We do get influenced by the pharmaceutical marketing tactics and can sometimes succumb to the repeated dissemination and amplification of trivial issues. So we have to sit back and think. This can definitely cloud our judgment, and constantly when we are bombarded with meetings, hypo, weight gain, over a period of time, we tend to think that maybe this is true. So what's important is CMEs like this, where you interact with the seniors, have a one-to-one discussion that this is what was told to me by in this conference, is this really right, and how do I go about when it comes to prescribing the patients. So after Carolina, clearly I think the king is back. And it's a blessing in disguise. So we have to thank everyone involved in designing Carolina trial. Now what happened was suddenly after 2019 turned out to be cardiometabolic, renal and vascular in approach. So we needed drugs that go beyond glucocentric, beyond just hypo, beyond just weight gain. We also wanted drugs which does something else, reduce the cardiovascular risk. Interestingly, in September, the American Journal of Cardiology came out with this article. Is it time to say bye-bye to DPP-4s? Actually, when I read this, I was a little shocked and I said, what's happening? Why is the American Journal of Cardiology coming out with such a bold article? There's a lot of sense in this article. I want you all to read it sometime. And this is what it says. When HbA1c is more than 8.6, you use a DPP-4, doesn't really come down. So HbA1c more, DPP-4s don't work. Excellent safety profile, no hypo, no weight gain, but no cardiorenal benefits, no weight loss, nothing with DPP-4. So this poses a question today to all of us whether DPP-4s should be used or not. And there are a number of articles that after 1.5 years DPP-4. So this particular article asks a number of questions. For DPP-4s to work, you have to have a GLP-1 production, intact beta cells, neuroendocrine feedback. We know GLP-1 is reduced in type 2 diabetes, and there is enough evidence from 2005 onwards. Michael Knox work. Now the question is, if there is no GLP-1 in type 2 diabetes, if you can't measure your GLP-1, what are we doing with DPP-4? Well, these are questions, but sometimes they still work. And if insulin deficiency exists due to beta cell, how can DPP-4 work? No, these are the paradox. So I started with the paradox. These questions do come into the minds of the treating physicians. So cleverly in 2023 and even the recent 24, the ADA group, which came out with this guideline, finally said, well, please use GLP-1 SGLT2 metformin, and if you want, after this, something which has a higher efficiency, move to sulfonylureas. Sulfonylurea, which was nowhere, is back in the ABA guidelines. And I'm very happy to say it was always there in our RSSDI guidelines. It never left the RSSDI guidelines. It was always there. So ADA guidelines brings back sulfonylureas, and below sulfonylurea is the DPP-4 today. So the best insulin secretagogue among all OADs is still the sulfonylurea. And this should interest some of my senior colleagues here. This came very recently, I think. Long-term continuous glimepiride use is associated with better survival, fewer hospitalization, emergency visits for heart failure. Even Carolina showed, which was not openly discussed, even though the glimepiride group had slightly higher hospitalization, deaths were more in the linagliptin group. So, and they also want to say high-dose glimepiride, and this is from the European Society of Cardiology. I don't know why the cardiologists are now coming with more and more articles, and this is from Diabetes Care, very recent one. Clearly telling, giving a message, given their potent efficacy, microvascular benefits, cost effectiveness, widespread use, please use sulfonylurea, and this should remain a part of the global diabetes treatment portfolio. And this is again September, October. So where do we stand today with glimepiride? I think standing very tall. The best insulin secretagogue, no doubt about it. So the clean glimepiride is truly back. And who is having the last laugh? The king himself is having the last laugh. I'm sure Dr. Mohan is here and Dr. Lily John is here. So my question to them today is, this is the last slide. When Avengers can be recalled, when we have a problem with the world and the last of the movies, you know, all the actors come back, all the Avengers come back. When the world is using it, is it also the time to start using glibenclamide and glipizide? With that, I will stop. Thank you so very much. I think sulfonylureas are truly, truly back, and there is no doubt about it. Thank you so very much. Yes, hypo exists, but like insulin, we just have to educate our patients.
Thank you so much, sir. It was really so mesmerizing. In fact, the timer itself, just gave by. And probably there will be a lot of questions. I wish this was some sort of a debate over there. We could have had a real good debate with the new sulfonylureas, the old sulfonylureas. Now, since it is open, it's open for the questions. Anyone has got any questions? Audience? Sure. Virmani, sir.
Nice talk, enjoyed. One point to remember is that DP4 inhibitors act on the alpha cell also. They inhibit the alpha cell, which has not been brought about in these slides. Would it make all difference between DP4 inhibitors and sulfonylureas?
Sir, I completely agree. It has some action on the glucagon, provided there is GLP-1. Now tell me, how do I measure GLP-1? How do I know that this DPP-4 works? Because from 2005, Michael Nock has been talking about GLP-1 being highly variable in type 2 diabetics. We really need to do this work. Now, if there is no GLP-1, DPP-4s don't act. If they don't act, where is the action on the alpha cells? That is the paradox with which I have left it. I use a lot of DPP-4, definitely great drugs. But the question now is it time like we do CP pride? Is it time that we start doing GLP-1 in our Indian patients to see? The question is, what time do we do? Half an hour after food? 1 hour, 2 hours? Don't know. I mean, I leave it to Dr. Mohan to someday do GLP-1 levels serially in 100 diabetics of different duration and then try to find out. First they said South Asians DPP-4s work extremely well. Now the recent report is GLP-1 levels are very low in South Asians. I didn't show that because that becomes a debate. There were articles which said South Asians do extremely well on DPP-4s. Now you have article which says GLP-1 levels are extremely low in South Asians. Now where are we? We haven't done GLP-1 levels in Indians serially. They said, oh, it's always for research. And surprising articles that are coming out is all from the cardiology group, and ADA 2024 also changing their guidelines, and this surprised me. But we still do use, and there was another paradox. Okay, now there is insulin already, there is already DPP-4. If you want to use a sulfonylurea, would you like to use a sulfonylurea DPP-4 together, or would you like to take one of them off? So there are a lot of things, and I think keynote address, I will request Dr. Mohan to address some of these things, because it will be interesting to listen to seniors, how they think and what happens.
Sir, I would just like to ask one thing. Now we have combination of glimepiride plus sitagliptin. So is it a comeback for glimepiride, or how do you see these combinations now?
I really don't have an answer to that, Amit, and that's a very interesting question. So many combinations, so many interesting, which improves the compliance, but I really don't know. I really don't have an answer to that. Are we okay to use both a DPP-4? See, when we are using sulfonylureas and it did not work, then the DPP-4s came. And we introduced the DPP-4 and the sugar started coming under control. So we thought that, okay, it has a different pathway, so we are targeting the GLP-1. Now these things are coming. I don't know why these things are coming. So the only thing is, I'll request somebody like Dr. Mohan to do work on GLP-1 among Indian patients and to see what happens from day one, at the end of 5 years, 10 years, 15 years, and then try to tell our audience. I think that will be a very interesting thing to see. And by the way, DPP-4 companies pay a lot of money for the conferences, so we have to be careful when we do anything.
Thank you, sir. It was an excellent talk.
Dr. Arvind,
I think we'll have
question.
one more question.
Dr. Arvind, you have been practicing decades, 5 decades, 6 decades. In the real world experience, as you rightly said, if you are smart enough to start these drugs start low, step up, very small increase. And we have seen in my practice, patient taking this glucuride tablet, I don't want brand name, Lemiparide in combination metformin, they are taking for decades.
Nothing has
No
happened.
cardiac.
In fact, most of them are doing well. Those who are
They-
on
no, we-
glibenclamide,
They have been taking for decades. So still we are not a very rich country. Our patient, a driver comes, a maid servant comes, and how can we start this, though there is a paradigm shift, how can we start these costly drugs to a poor man?
Dr. Govindapai, it's not expensive also anyway. Sometimes some of the sulfonylureas cost more than some of the brands of DPP-4. Now that problem is also solved in India with generics. Now the question is, do we use both, and how do we use, and what is the rationale behind it? Okay, and how much of endogenous insulin comes out? See, we grew up in an era where we had to teach hypo because we had only those drugs. So it was easier. So even now it's become a habit. But I think 2007 to 2019, the era where no hypo, no weight gain, kept on coming hundreds of times. The new generation kind of picked up the DPP-4s faster than the sulfonylureas. That's exactly what happened.
Excellent talk, sir. Actually, it was one of the, I think, highlights of this particular meet, I believe, especially the revisiting of our old drugs. I've been practicing diabetes for the last 3 decades. I can definitely say that my patients who are put on this group of drugs still they're doing well without any cardiovascular side effects. I endorse we use as far as the revisiting of this second generation sulfonylureas. Only one last question from my side, sir. Between glucoside and glimepiride, which has got better cardiovascular outcome?
Glimepiride has proved. Carolina, this is the only proof. So today, if you need evidence, glimepiride stands number 1. Glycoside becomes number 2. If you want the proof, if you are evidence-based medicine expert, want to stick to some. So glimepiride definitely wins.
Thank you, sir.
Yeah. Thank you.
Thank you so much, sir, for reminding us that old is gold. I would now request the chairpersons and the speakers to join on the stage for a photo. And I'd also request the speaker to collect the faculty memento from the faculty lounge. As we are ending near the end of the sessions, I would like to request all the chairpersons and the speakers to be here. The next session is Yoga and Diabetes, the current evidence. To speak on this, we have with us Dr. Hemant Bhargav, and to chair the session, we have Dr. Prem Kumar B.N. and Dr. Satish Kumar C.
Less spoken topic, and a forum like this, probably a talk like this will help all the clinicians consider using yoga for the patients in the diabetes management. Over to Hemant, sir.
Thank you very much, Dr. Satish. It is indeed a great pleasure for me to be here. In the next 20 minutes, I would like to give you the overview of the current evidence for yoga in management of diabetes. And also we will ponder upon probable mechanisms of yoga. But before that, it is very important that we get yoga in its correct perspective. So we begin, usually the yoga sessions also begin with a namaste, which literally means that I bow to you. When we say I bow to you, I bow down to the divinity in you. So this is with this kind of a compassionate kind of a relationship that a yoga session begins with the patient. We all have seen, that there is a paradigm shift from the illness model to the wellness model. Patients come to us, they say that, yes, doctor, as advised by you, all my reports are now within the normal range. My thyroid functions are normal, my sugar levels are normal. But still, I do not feel energetic, I do not feel happy, I do not feel the enthusiasm to do my work. It is here that the disciplines like yoga come into picture, which are not only for illness, but they can, contribute to the wellness also. Now, all of us practice holistic medicine. When the patient comes to our clinics, we ask them about their lifestyle. When we talk of lifestyle, diet, physical activity, sleep, stress level, they play a role. And patients are also very smart. They are also searching Google. They know what they should eat, what they should avoid, what kind of physical activity they should do, what they should not do. But ultimately, when it comes to the adherence to the suggested lifestyle modification, we see that the compliance of the patients is quite poor. So what is it that prevents the compliance? It is here that the mind comes into picture. When the mind is speeded up, when I am having a lot of negative ruminations in my mind, when there are negative events that are going on, then I get into a habit of emotional kind of a eating. My eating behaviors change. I use food as a coping mechanism. And then evidence shows that whenever in a negative mindset a person uses food as a coping mechanism, the kind of food that he chooses is always non-nutritious, more tasty, and dense in calorie. And it is here that the mental state of the individual becomes a contributor towards weight gain. So then all these factors, we understand that if the mind is not managed properly, then the lifestyle goes haywire. So why yoga has become so relevant in the current scenario, in the new millennia, we see a renaissance of this age-old science. It is here because the speed of our mind and the speed of our life has become tremendous. We all are exposed to external demanding situations and internal demanding situations. Internal are the situations where I put certain kind of deadline, certain kind of benchmarks for myself. I want to be perfect in everything that I do. And in that, I get into a kind of a stressful situation, and a non-specific response of the human physiology to these demanding situations leads to a cascade of upregulation of HPA axis, release of cortisol, adrenaline, and we see that irrespective of the demanding situation, when the stress response gets activated, when the allostatic load builds up, on the immune system, it generates aberrant immune responses, accelerates the aging process, and brings disharmony in the mind and the nervous system. Now, yoga, 2 decades ago, yoga was considered as a very mystical science, only for chosen few who want to, go to Himalayas and, get away from the worldly life. But then from the year 2000 onwards, not only that it became popular among general masses, even in scientific and medical community, we see a surge in yoga research. So it is important to differentiate from what yoga is from what yoga is not. There can be different circumstances which can put you into a certain posture. So here, B.K.S. Iyengar, he is a father of Yogasana. He is doing a pose which is known as a bridge pose, And there is another person who has compulsively got into that pose. And he has been maintaining that pose throughout the night, So the mental state behind a pose is very important. So the same thing happens when we are in a gym, when we are doing a cardio, when you are going for a walk, the headphone is on, the cycle, the thinking process of the mind still continues. So what differentiates yoga from exercise, is that the physiological responses when you do yoga in its proper sense, not the modern, yoga corrupted kind of a yoga where it has become a fashionable thing where a very thin model will come and do a very complex kind of a posture, or power yoga. These are not written in any traditional scriptures. Whenever yoga was written, the asana was written, sthiram sukham asanam. You have to get into a posture within your own comfortable limit, and you should try to maintain with a pleasant state of mind. And you have to be completely mindful of your posture. You have to connect your body, breath and mind together. If that is not happening, it is not yoga, you know. So the last point, you know, here is that in exercise, the mind keeps wandering, whereas in yogasana, the pranayama, the asana and meditation all can happen together. So that's why we see that the physiologically also, if yoga is done in its proper sense, it has a different physiological response. Now people, you know, they ask me, especially diabetologists, you know, when you have to lose weight, you have to burn your calories. Otherwise, there is no weight loss. I agree with that. You know, so this is a BMJ article which said, when you lose fat out of the body, where does the fat go? How does it go out of the body? Is it going out in your stools? Is it going out in your urine or sweat? So when they did, you know, this stoichiometry and, you know, they traced each molecule of the triglyceride, they found out that 84% of it is going out in the form of breath, that is CO2, you know, and 16% of it is going out in the form of water. So the thing I want to say is that when you do yoga, there are certain kind of breathing practices, there are certain kind of postures. So yoga not only works only at the body, it has a mechanism through which it works through your breath. And basically the impact of yoga is on the mind. And when my mind gets slowed down, I get, you know, betterment in my mood. My adherence to lifestyle choices become better. So this is a study published in 2017 where adolescents were divided into two arms. One group went into a gym, other group performed certain Surya Namaskara and other yoga postures. Both of them performed at the same time of the day in the morning. What they observed was that both the group lost weight. BMI was lost in both the group without significant between group differences. But the yoga arm, you know, also showed certain positive regulations in their lifestyle. People who practiced yoga, there was no counseling or education component involved, only the practice of yoga. Adolescents who practiced Surya Namaskara in the morning, praying to the sun, they reported that they started sleeping early in the night, their junk food consumption reduced, they moved more towards more healthier kind of a dietary habits, their stress levels were less. Whereas the exercise arm, though lost weight, still the lifestyle component did not change. Then in the yoga arm, when they asked, why did you think that yoga helped you? You know, so people reported that it helped me, felt more relaxed, my stress reduced, my perception of my own body became better to me, you know. And if you look at, you know, all these things, greater awareness of myself. Yoga is fundamentally, you know, as a person who has been into this field for more than 15 years now, if you ask me what is yoga, I will say yoga is a science of self-awareness. When I become more aware of myself, what goes on within my body, what I am eating, how I am sleeping, what is going on within my mind throughout the day and throughout night, that awareness of me, you know, generates a sense of compassion in me when I deal with people around me, because then I understand what they may be going through. And second is, it generates a sense of compassion towards myself, you know. So, and I become more mindful and feel more connected with people. So that is why fundamentally, if you look at the definition of yoga by Patanjali, who wrote it 2500 years ago, he says, Chitta Vritti Nirodha, the repetitive thought patterns in the mind should come to a stoppage. You should be able to reduce the speed of the mind. If a vehicle is running at 100 miles an hour, I have to suddenly put a brake or turn, I will not be able to do it. But if I am able to gradually reduce the gear, then I will have complete control over my vehicle. So in this way, yoga reduces perceived stress and responses. This is the understanding of the body according to yoga. You know, in Katha Upanishad, Yama and Nachiketa have a dialogue. So Yama says that these 5 horses are your 5 sense organs. And if this sense organ become the deciding force of your life, if your life will go wherever the sense organs take you, then the whole chariot will lose its direction. So therefore, the whole journey of yoga is to calm down, close the sense organ, turn inwards. And there is a charioteer who is sitting inside us. Yoga says that our guru is within us. We should be able to calm down and ask the question. So sorry for this shloka. This is a shloka from Bhagavad Gita, which says that who will succeed in yoga? So Krishna says, Yukta Hara Viharasya, Yukta Chestasya Karmasu, Yukta Swapna Avabodhasya, Yogo Bhavati Dukkhaha. A person who eats too much or too less, who sleeps too much or too less, who is too much into work, workaholic, or he's not active at all. All these will not achieve a success in yoga. Success in yoga will only come to a one who understand the value of work, understand the value of rest, understand the value of doing things in moderation. So there are 8 limbs of yoga, and researches have happened. Now there are biological underpinnings. Fundamentally, the top-down mechanisms is through enhancement of GABAergic tone, and the bottom-up mechanisms is through the polyvagal theory, the enhancement of vagal tone, and bringing a state of parasympathetic dominance. So initially the effects are more psychological, you feel more calm, more relaxed, but then they do percolate into the physiology over a period of time. To see physiological effect change, you should perform yoga at least 3 times a week. There should be a 1-hour session, and the effect should sustain at least for 12 weeks for you to observe sustained changes. But we have seen that mood elevation can happen even within a week. Within 1 week, we have seen yoga improving mood. So different domains of yoga, from behavior to asana to the internalizing meditative domains, work on certain aspects of human behavior, from mindfulness to self-awareness to physical strength to enhancement in spirituality. So now, people ask me, how do you decide which posture is to be given in which condition? So I would like to ask you a question. What do you think? What kind of posture would a person adopt if he feels very sad, very gloomy kind of a day, feeling no hope in life? What will happen to his posture? This is a state of his mind. What will happen to the posture? Hunchback, very loose, very sad. So the person doesn't even want to look up. And if he's too sad, he will completely shut himself down and close himself. Now, why does a person, when he feels sad, adopts this kind of a posture? One is that he does not want to connect to anybody around. He wants to isolate himself. Number 2, all the vital organs in the body are in the front. My heart, my face, eyes. So I want to close them and get into a more secure kind of a posture. This is the posture which a baby adopts within the womb of the mother also. It is known as the fetal pose. It is one of the poses where person feels most secured and relaxed. If you do the same posture in sitting, it is known as Shashankasana. If you're doing it in a lying down position, it is known as Pavan Muktasana. What we have observed is that whenever you feel too much anxious, even the panic attack can be controlled by getting into this kind of a posture. It generates a sense of safety and security. ADHD children also calm down if you are able to put them into this kind of a posture. And what happens to a person, when he is very happy? Imagine a beautiful Sunday where you had a nice sleep with all your loved ones, friends. You go on a trek, you reach the top of the mountain, and beautiful river is flowing down, and cool breeze of air touches you. So which kind of posture would you adopt in that situation when you are very happy? Yes? So you will just, you want to hug the whole nature there. So the person is opening up, chest opening, backward bending, smile on the face. Now, if to a person who is having a low mood, I voluntarily make him get into a posture, we do something called as hands in and out breathing. Breathe in, breathe out. So there is a feedback to the mind that things are positive. The mood starts changing. So therefore in depression, we emphasize backward bending, chest opening asanas. In anxiety, we give them more grounding, more forward bending postures. Similarly, breath, is there an impact of my breath, my emotion on my breath? When I am angry, people scientifically report that breath becomes more erratic, more deep and more fast. Whereas when I am sad, it becomes more shallow, So breathing, if it is more thoracic, if inhalation is longer than exhalation and it is more shallow, it sustains the sympathetic drive. Locus coeruleus remains active, keeps secreting noradrenaline. Whereas if you consciously just become aware of your breath, shift it from thoracic to abdominal, prolong the exhalation double than the inhalation, and reduce your breathing less than 6 breaths per minute. It is scientifically proven slow-paced breathing generates a relaxation response within 20 breaths. and you are able to change the whole physiology. So the cortisol is reducing, noradrenaline is reducing. In fact, Bloch et al. Actually found out the pattern of different emotions. And as you can see here, the first one is sadness, where inhalation is more erupted and exhalation is abrupt. But if you see the last one, joy, then inhalation is abrupt, but exhalation is more prolonged and spaced out. So you have to just count and slow down. So inhale for 4 count, exhale for 8 count. Deep abdomen. Very simple things which can bring a change in your mind. People have found that if you do the same breathing through the mouth, you do not get those effects. The effect happen only when you do it through the nose. Because through the olfactory bulb, there are connections to the hypothalamus, anterior cingulate cortex, PFC and others. And towards the final aspect of my talk, I would like to bring the effect of chanting. There are 3 things that people chant when they chant Om. Om is a Vedic mantra which is recommended in all the, yogic texts. Om, if you split, this is a Vedic text known as Mandukya Upanishad. It says Om has 3 components, A, U and Ma. A, they say, is the movement of consciousness outward through the senses. U is when the consciousness is not projected out, but in the mental space, when you think or imagine, or you dream. Whereas Ma is when consciousness is not projecting anything anywhere, but is drawn inwards. The sound of that manifestation of consciousness is Now the question is, in your day-to-day life, have you ever felt when you unconsciously produce the sound Ah? Pain? So if you are walking and you something pricks you, you say ah, ouch. Or if a wrestler has to lift a very heavy weight, he says ah, he gathers more strength in the arms. So whenever in a spurt my consciousness is moving out, the sound is ah. Whereas, when a person is drawn inwards, say you are very hungry and you get a very yummy pastry and you put it into your mouth, you say yum. So the Brahmari comes because you want to draw it inwards. Even when a mother makes a baby sleep, the sound is So the sound has a inward kind of a movement. Whereas when you produce the sound oo, there is a thinking process. I don't remember somebody's name. I say churning in the mind. So what we did was we suggested that Om is actually a point of creation of consciousness from this wakeful dream and sleep emerge. When people are more drawn towards a personality which is our dominant personality, active, can't sit still. They are hyperactive, impulsive kind of people. We call them Rajasic personality in yoga. Other people who find it very difficult to take initiative, they are the last one to get up and you have to pull them to initiate any kind of activity. They are the Ma dominant people. They are the Ma dominants. And third are the people who are always into thinking. They are less of a doer, more of a thinker. So always they miss the bus, so think too much. So this is loss of touch with reality. So these are externalizing traits, internalizing traits, or psychotic traits, too much into imagination. Ultimately, what we need is a metacognitive awareness of all the 3 domains. This is what these mantras do. And yoga is all about giving you that freedom to reach that metacognitive awareness where you are neither drawn too much into wakeful dream or sleep, but are able to transcend them. In fact, in MRI scanner, we did a study in Imhans where we made the subject chant these 3 sounds, and we found that A recruited more attentional networks, whereas Ma activated more default mode resting networks, and U was in between. So there is a biological basis to what was written in Mandukya Upanishad thousands of years ago. So finally, as I said, the number of yoga researchers are increasing, yoga therapy is also increasing, and these are the various countries who are doing yoga research. And finally, towards the current evidence, there are 33 randomized control trials, 13 meta-analysis, and all of them, overall conclusion, I would say that yoga enhances health-related fitness, muscle strength, cardiorespiratory fitness among T2DM subjects, and there is a reduction in HbA1c, which is, people say that overall mean reduction is 0.84% if people perform yoga regularly for 12 weeks. and every additional day of yoga practice after that adds another 0.22%. So these are various researches which I can quote, but due to lack of time, finally I would say, in your clinical practice, if you have to recommend what yoga should I tell to my patient, there are so many styles, so much confusion. In all these meta-analysis, these practices are common. One is sun salutation. Start with 4 rounds slow, then go to 4 rounds fast. After that, perform Shavasana and do deep abdominal breathing in the ratio inhalation is to exhalation 1:2 for 5 minutes. 4 asanas, Vakrasana, Paschimottanasana, Bhujangasana and Dhanurasana. Agnisara Kriya is a flapping of the abdomen without exchange of the breath. Kapalabhati is exchange of the breath. Do not exceed Kapalabhati more than 30 per minute. It means 1 stroke in 2 seconds. Anulom Vilom 6 cycle, Brahmari and Om chanting, that for 10 minutes at the end. These are the final things that can be recommended to the patient. From pre-diabetes to diabetes, control can be inhibited. There was a pan-India trial. So this is what. And what are the practices you have to avoid? Kapalabhati, do not go above 30 strokes per minute in hypertension, heart disease, post-CABG, contraindicated in retinopathy, and inverted poses also you have to avoid in these conditions. Please go into asana slowly and come out slowly. And please have light snacks before you do yoga. If person has diabetes, and keep a banana and a biscuit during the yoga session. Do not take medicine, skip breakfast and come for yoga session. So thank you. Thank you.
Thank you, Dr. Hemant. I guess that was a good outlook about the principles of yoga and its implications into the disciplinary and its life. And I guess we are running really short of time, and we won't have any questions no more. Further, I'll ask you down the stage. Thank you, sir.
Thank you very much.
I request the chairpersons and the speaker to join for a camera photo moment. Thank you for highlighting the importance of integrated medicine with a focus on both body and mind. To moving on the last session, before this session begins, I'd like to request all the delegates, faculty to remember that this talk is going to be followed by the inaugural and the 20-year celebration and ending with a gala dinner. So please hold on. This seems to be like a long day, but it is going to definitely end with all the bang. So to talk on rheumatology in diabetes and diabetes in rheumatology, we have Dr. Vijay K. Rao. And to chair the session, we have with us Dr. Nagaraj S. and Dr. Yogita C. I'd like to hand over the dais to the chairpersons, please.
Without much delay, I would like to introduce Dr. Vijay Kairav, my good friend and colleague. He is practicing at Divisha Adharasan Medical Clinic, Medical Center in Basash Nagar, a senior rheumatologist of our city. Over to you, Dr. Vijay.
Thank you, Dr. Nagaraj. At the outset, I would like to thank KRSSDI for my second consecutive opportunity to interact about musculoskeletal aspects of diabetes. So, what I would be speaking is both on common musculoskeletal issues in diabetes, as you see here in the table, up to 50 to 60%, mostly in the upper limbs with shoulder, then hands, and also lower limbs with Charcot arthropathy and even spinal involvement. On the other graph, it's a rock curve analysis to show that a perfect control of arthritis or inflammation leads to very good diabetes control. So HbA1c does better in a known rheumatoid arthritis patient if arthritis is very well controlled. Coming to the common musculoskeletal complications with diabetes, so we can divide it into soft tissues, joints, bone and muscles. I would not be touching more on the bone and muscle aspect. So the soft tissue one is the common diabetic hand, then the diabetic foot and ankle, then carpal tunnel syndrome, then Dupuytren's contracture, which is very commonly seen. And the same thing is shown in this if you look at the classification based on joint involved. So it's the frozen shoulder or adhesive capsulitis, then calcific periarthritis, then flexor vaginitis or tenosynovitis or trigger finger, carpal tunnel, then stiff hand syndrome, and of course Dupuytren's disease. So due to neuroarthropathy, we see something called Charcot's joint in the foot, and very commonly mistaken for ankylosing spondylitis is DISH or diffuse idiopathic skeletal hyperostosis. The fibroproliferative complications come really from the advanced glycated end products or AGEs, which gets released from the reactive oxygen species and abnormal fat and lipid metabolism and protein metabolism, and of course the glucose. And these AGEs, they actually act in two folds. One is they are antigen presenters through dendritic cells and macrophages, and they help in chemotaxis or recruitment of neutrophils and lymphocytes, causing cytokine release and increase inflammation in these tissues. And the other, of course, it is known to activate fibroblasts and thickening of skin tissues or the characteristic shiny appearance of hands and feet we get in uncontrolled diabetic patients. So this is a commonly seen diabetic hand with a prayer sign, and the diabetic foot, of course. Both of these more commonly seen in type 2 diabetes up to 80%, and they are painless, easily mistaken for inflammation or rheumatoid arthritis, but there's no early morning stiffness here. The ESR-CRP is normal. There's no joint inflammation as such. This is just a skin thickening. But there is a limitation of movements. And foot, there's postural problems causing ulcers and callosities. So treatment is physical therapy, daily exercises, analgesics if the patient has pain, and injections if there's localized joint movement problems, and surgery in end case problems. So carpal tunnel is very well known, but the odds for a diabetic patient of developing carpal tunnel syndrome was nearly 1.6 or 7. So typically have the sensory manifestations in the radial third, and in advanced stages, the wasting of thenar eminence and grip problems. So diabetes is a major risk factor along with other inflammatory and autoimmune disease and thyroid as well. So injections are attempted first, and if severe, then surgical decompression. And again, diabetes are more likely to require surgery. So with trigger finger, it is due to repetitive friction that there is an inflammation between the tendon and the sheath, and that becomes a nodule and causing what we call as a flexion deformity in the finger. And forceful snapping leads to pain and sometimes rupture as well. Again, the prevalence is higher in 20% higher in diabetes, type 2 diabetes, than the general population. So it's common in women, and multiple fingers might happen. Again, easily mistaken for sometimes arthritis, but we do see trigger finger in inflammatory arthritis as well. But they typically have an early morning involvement, inflammatory markers are raised, which are neither seen in any of the diabetic patients. So again, injections to the nodule, and if multiple fingers are involved and hygiene is a problem, functionality is a problem, then surgery is recommended. Dupuytren's is a similar form, but involving the palmar fascia, where you see nodules on the palmar side, and that's the difference between an arthritis, where you see on the dorsal side. And you have a fibrous band resulting in flexion contracture, and it principally affects the fourth and fifth finger, whereas the trigger finger is the radial side, first and second finger. And injections help, intralesional collagenases help, and if again hygiene is an issue and functionality is a problem, surgery is attempted. Shoulder, frozen shoulder, we all would have seen, typically starts with a rest pain, difficulty movements in all the joints, more commonly seen in middle-aged females. Can be present in inflammatory arthritis as well, but diabetes is more common. In fact, in some patients, diabetes this can be a manifestation of diabetes. Usually insidious onset, limited examination, internal rotation, external rotation, abduction, flexion, restriction, and diffusely tended to all ranges of movements, difficulty sleeping on that shoulder, and can impair sleep quality. So what we have to reassure is it lasts for a long time, nearly 18 months. Self-limiting condition usually, but to enhance the quality of life, you may need injections repetitively, physical therapy, very important, and more importantly, reassurance to these patients. It doesn't require any surgery unless everything has failed, then manipulation under anesthesia. So it has the characteristic stages, 1 to 4 as listed here. Imaging is not an option here, where although most oftenly done, it is a clinical diagnosis, colleagues. And you educate the patient, inject. In stage 1 to 2, you can do multiple times. And you need some kind of sleep measures, analgesics, and last stage is surgery if everything has failed. You need the help of physio to do all these routine exercises, and they have to consecutively do for 6 to 8 months when relapse might happen. Charcot's joints is something we all see, but was first described by Charcot in syphilis. Prevalence is more common in neuropathy, diabetes up to 35%. Other causes could be cellulitis, septic arthritis, osteomyelitis, gout, rheumatoid arthritis, so on and so forth. So if stability is an issue, a lot of callosities are happening, patient is having frequent falls, this of course required surgery. Can be confused for a deforming arthritis, but you need to carefully elicit diabetic neuropathy here. Inflammatory markers are normal here, and there's not much of inflammation, it's just destruction. Lastly, regarding the spine, this actually can confuse even rheumatologists regarding ankylosing spondylitis. But it's kind of flowing calcification in multiple spine, and spinal stiffness, low back pain, limited movement can happen. 50% more common in diabetics. And surgery is only if there is myelopathy, otherwise it's mostly physical therapy. Lastly, it's about how do you manage or limit diabetic flare in a known autoimmune rheumatic disease patient. You have to think of what autoimmune disease the patient has. If on the induction column, you see these are high requiring steroids, polymyalgia rheumatica, large vessel vasculitis, ANCA vasculitis, lupus. The rheumatologists need to treat this with steroids for 3 to 6 months. So plan and speak to rheumatologists so that you can enhance the diabetic treatment for these patients. And if you stop steroids quickly, they flare. Same thing with maintenance. You need 3 to 6 months of treatment. Only with rheumatoid, we have moved away now with steroids, and mostly we are using steroid sparing agents. What I would say is use steroids if needed only. Keep the steroids as low as possible. Use minimum dose of steroids. Minimum dose is now less than 5 milligram per day. And hardly for other diseases, we don't use beyond 1 month. Don't use it as an SOS regime. Plan steroid sparing agents up front. And speak to a rheumatologist if steroids are required frequently, because there are quite a few targeted drugs and biologicals which they have their own safety concerns, and the rheumatologist would be the best judge to use them and indications and contraindications. The patient always wins when the diabetologist, rheumatologist, and the patient come together for better outcomes. Thank you. Lastly, I've put a slide because we are the host for our national conference next year in rheumatology. Dr. Nagaraj is the organizing secretary. So I welcome you all. It will be in the palace grounds. We would require all physicians to participate, as most rheumatology patients go to physicians first, they don't come to rheumatologists. So we require your cooperation and assistance. Thank you.
Thank you, Dr. Vijay Kumar. Any questions? Close the session. Thank you.
I firmly believe that diabetes is a painless disease, but it's a musculoskeletal disorders that bring the patient to the doctor. And thank you for enlightening us on that. I would request the chairpersons and the speaker to join on the stage for a photo. Thank you, sir. As we conclude this session, it is now a break, small break before we move on to the inaugural session. And probably our team will require 5 to 10 minutes to get the stage ready. While that happens, there is something interesting and exciting happening. And to do that, we have team from Syscon Pharma. They have made this exciting announcement that whoever has visited their stall, they will be having a lottery. And to pick a lottery, I would like our senior specialist, Dr. Nadgowda sir, to come here. Whomever two chits he picks up will be getting an exciting prize. Actually, I am surprised and I'm amazed. Could you please tell it? Okay, you'll be getting 1 gram gold. Can you please tell me the name? It is Dr. Abhaya N. If you're here, please. Dr. Abhaya N. Can you please ask them to take another chit also? Sorry, this is, I think, Akshaya N. ಗೊತ್ತಾಗ್ತಿಲ್ಲ ಅದು. And Dr. Nayana. Dr. Nayana, if you're here.
Is Dr. Akshaya there? Dr. Akshaya or Dr. Nayana? So it will go to someone else then. You can pick one more. Who is there? Oh, it's my name only. It goes to myself. Deve J. Gowda. Is he there? Oh my God. Dr. Nagaraj is there. I hope there are not 2-3 Nagaraj. Dr. Nagaraj? Dr. Balakrishna? So they are all unlucky people. Dr. Anusha? Who are all there? Dr. Vivek? They should have made a bigger announcement in the beginning. Dr. Venkatesh Reddy? Huh? It's over. You can write your name and put it now. Dr. Puneet Kumar? Yes, at last. Please get your Aadhaar card. Ibra. So with Aadhaar card. Dr. Girish Kumar. Two people are there. Oh, someone else should take it, I think. Dr. Neelkant Kote. Huh? Yeah. So, being sincere, I don't know whether he was inside or outside, but at least he was present. Matters a lot to all of us. Congratulations.
Dr. Raghuraman. As the stage is being set for the inaugural ceremony, I would request all the delegates to take their seats and also kindly note that this inaugural ceremony is going to be followed by 20-year celebration, cultural event, and a gala dinner. So we have a lot more coming up. Please enjoy the sessions. Namaskara everyone. I am Dr. Surekha Shetty, and it gives me an immense pleasure and pride to invite all of you, distinguished guests, delegates, and faculty to this inaugural ceremony of KRSSDI 2023. I truly feel honored and enlightened to have your gracious presence here. Before we begin our inaugural, we would like to sing a customary Nadagite of Karnataka. I would request all of you to stand up for this. Thank you, everyone. I would now take the opportunity to invite all the dignitaries to illuminate this stage with their gracious presence. I would like to call Dr. Manohar KN, Chairman KRSSDI, and I would like to request Dr. Pradeep Kumar to welcome him on the stage, please. I would now request Dr. Syed A. Jawad, Vice Chairman KRSSDI. I request Dr. Karnesh Kumar to welcome him on the stage. I request Dr. Ravi Kumar YS, the President-elect KRSSDI, to come on the stage. And I request Dr. Suresh to welcome him on the stage, please. I now welcome Dr. Suman R, immediate past President KRSSDI, and I request Dr. Ravi Kirti sir to welcome him on stage. Now I welcome Dr. Vijay Kumar K, our secretary, and I request Dr. Basuraj Patil to welcome him on the stage. And now I welcome Dr. Shekhar, our treasurer, and I request Dr. Balaji to welcome him on the stage. And definitely I must thank my young and dynamic team for having contributed to welcoming the dignitaries on the stage. And in the presence of all our dignitaries, I'm sure he needs no introduction, but it is customary to remember that he is an internationally acclaimed diabetologist and chairman of Dr. Mohan's Diabetes Center at Chennai. He is a pioneer delivering comprehensive diabetes care for more than last 40 years, and he is now ranked amongst the top 2% of scientists in the world. Last but not the least, he is also the author of so many renowned books, which we all had the opportunity to listen to and read. A hearty welcome. As we begin this program, it is again customary to start with an invocation, and I request Dr. P. Prabhu to lead an invocation.
गजाननयुतं गणेश्वरं गजाननयुतं गणेश्वरं श्रीगजाननयुतं गणेश्वरं भजामि सततं सुरेश्वरं श्री भजामि सततं सुरेश्वरं श्रीगजाननयुतं गणेश्वरम् अजेन्द्रपूजित विघ्नेश्वरम् अजेन्द्रपूजित विघ्नेश्वरं गणादिसन्नुतपदपद्मकरं कुञ्जरभञ्जनचतुरतरकरं गुरुगुहादिनुतप्रणवाकारं कुञ्जरभञ्जनचतुरतरकरं गुरुगुहादिनुतप्रणवाकारं गजाननयुतं गणेश्वरं भजामि सततं सुरेश्वरं श्रीगजाननयुतं गणेश्वरम्.
Thank you for the wonderful beginning. I now request our Honorary Secretary, Dr. Vijay Kumar K, to address us, please.
Good evening, everybody. On behalf of the Karnataka chapter of the RSSDI and the organizing committee, I would like to cordially welcome you all, delegates and the dignitaries of this annual state conference KRSSDI 2023. KRSSDI initially formed and established in 2003, and it's been 20 years, and the logo says it all. The KRSSDI has been working on empowering and imparting the knowledge of diabetes and its management to the physicians and diabetologists. Since today, we need more improvements in improving the reality and seeing the reality of the increasing incidence of diabetes, and even in the young people, more diagnosis is happening. So we see there is an incomplete achievement in reaching the target goal of diabetes management. So with the background of this, we have made this theme of this conference, prevention to precision. So it is taken in various stakeholders under one roof. We have planned to discuss the developments and needs for a totality in diabetes management as we move from glucocentric management. In this conference, we have put all the effort to drive the best exhibition and academic displays, including poster presentations that encourage and empower the young clinicians. The thematic talks and sessions will drive you through the multi-sectoral dimensions of diabetes, and also provides everyone an opportunity to showcase and present their ideas, thoughts that could lead to a meaningful approach to managing diabetes. The last 5 years, KRSSDI has achieved many accolades in doing many activities and also empowering the physicians. And several, in the last 1 year, KRSSDI has noticeably done innovative ideas and approaches to even reach the public at large under the chairmanship of Dr. K.N. Manohar. So I thank each and every one of you who are contributing to the success of this conference, and welcome you all for an academic extravaganza. Thank you.
Thank you for the enlightening words. Now, as we begin this journey of knowledge, we need the light to lead us. And I request the dignitaries to join us in lighting the lamp. I also request the central RSSDI members to join us in this endeavor. Dr. S.R. Aravind, Dr. L. Srinivas Murthy, and Dr. Arvinda Jain.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, everyone. Moving on with the session, I would now request all the dignitaries on the dais to honor our chief guest, Dr. V. Mohan. This is our humble way of thanking you for being with us. I now request Dr. V. Mohan to address and speak a few words as a part of this session.
Good evening, everyone. I thought I was supposed to speak later, but I've been called now. So, all the dignitaries on the dais, Dr. Manoharan, Dr. Suman, Dr. Syed Javas, Dr. Ravi Kumar, Dr. Vijay Kumar, Dr. Shekhar, and many who are off the dais, Dr. S.R. Arvind, Dr. Lily John, Dr. Srinivas Murthy, Dr. Nadaguda, Dr. Virmani, Dr. M.A. Shekhar, and many others, Sydney D'Souza, and many others who are in the audience. I'm afraid I will not be able to name all of you all. It's a great honor and privilege for me to be here today as you celebrate your 20th year of Karnataka RSSDI. It is one thing to start a branch. It is a completely different thing to continue its activities. And it's yet another thing to excel as a branch. The fact that for the last 3 years, at the national level, twice you have been adjudged as the best branch in the country. And for the third year, the 1 year which is missing, your second, means that no other branch has been able to equal you. I'm sure there's no bias because different presidents, different committees have chosen you. So this itself speaks volumes of the work that you do. In my keynote address, I will refer to the fact that diabetes is increasing very rapidly. I initially thought when I present my keynote address, I'll do it extempore. But then I had some statistics of Karnataka from the INDIAB study, which if any of you in this audience who belongs to Karnataka RSSDI, KRSSDI does not know it, you better know it. And that's why I'm showing some slides. So at this point, I don't want to take up your time. except to congratulate you on the great work that you're doing. You've had a fantastic program. I've seen the list of topics and speakers, the best of the best you have had. It's a nice mixture of science, basic science, clinical medicine, and I'm very glad that you're all rooted to the ground and not swayed by pharma. It's not that pharma is a bad thing, pharma is a very good thing, otherwise you'll never get good drugs. But I think back to the basics and being honest to ourselves is what this meeting is all about. Because at the end of the day, it's our patients who come first. It's not even us. It's not us and how much money we make or how much fame we have, but we are all here with a singular aim of improving the lives of people with diabetes. Let that be the underlying theme, the underlying current of all conferences, not just the KRSSDI event, but of all conferences. Let us never forget that. Let's put the patient in the middle of whatever we do, and everything else is secondary. I can see that this is already happening in this conference, and I wish both today as well as tomorrow all the very best. I'll come back to you. Don't worry, I'm not running away. I'll come back to you with the keynote address. Thank you very much for this opportunity.
Thank you so much, sir. Now it is time to recognize somebody who's been in the field of medicine and diabetology for a long, long time, and probably her lifetime has been spent in the field of caring for patients and being a teacher to many of us. And so, today we would like to honor Dr. Lily John, who is with us today. I request kindly, madam, to be on the stage with all of us. And I'm sure all of you would like to see on the slide that is in the background and wonder who this is. Fond memories, beautiful memory, and something that reminds us that Professor Dr. Lily John, internal medicine consultant and head of the department, Manipal Hospital. She has received Best Citizen of India award twice by Honorable President of India and has also received Great Achievers of India Award 2001 and also is a Vikas Ratan awardee. It is our proud privilege to have her with us.
Thank you so much for this day. All my colleagues who have been with me in my effort to teach them have really seen the fruit of it because they are all doing so well, caring for the patient. I mean, it has been my utmost duty to teach them what I have learned in my days very many decades ago. But I'm so glad to see that they're doing so well because medicine is such a noble profession. And I want all of us to think that it is not just money and as already mentioned, but it is the science. I mean, modern medicine is founded on solid ground of science and we need to follow that. And patients are the main thing. The art of the medicine is caring for the patient. As it is said, to care is caring. That means that we have to look at the patient's eyes, touch them, feel them, listen to them. all that is part of a duty, and that is what I have stressed in my teaching to all my junior colleagues and friends. And I'm glad to see that they are all doing the same thing. I'm so glad that things have improved so well. And you can see that the Karnataka RSSDI is doing so well because they're all aiming to become good doctors, good to the patients, so that the prevalence of diabetes and other illnesses decrease to some extent, so that we can use the better medicine to our knowledge, what is best to our knowledge, we can look after them. Thank you very much for this honor, and I'm humbly accepted. Thank you.
Thank you, Madam, for your gracious presence. Now I would like to request our scientific chairman, Dr. Ravi Kumar YS, to say a few words.
Dr. V. Mohan sir, Dr. Manohar, Dr. Syed Javas, Dr. Suman, Dr. Vijay, Dr. Shekhar, many of my teachers here, Dr. BG sir, Shekhar, dignitaries other on the dais, of the dais, my dear friends. It's both an honor and privilege to welcome you all to this prestigious KRSSDI conference. It was a momentous day. You have seen this day. We could really see so much of exchange of knowledge, and we could really plan that thanks to the efforts, great efforts of Dr. Manohar and his team, we could really do this so that we could attract so many audience. So we started this event in 2003 with a small group of around 200 people, and now it has grown. Now we have crossed the number of almost more than 800 people, and we stand almost second in the national this one. So in the membership, that's a great thing which we can see, and that says that our people are really interested in diabetes education, diabetes research, and it's nice that KRSSDI is contributing to that. Thanks to our patrons, thanks to our faculty who are really interested in getting involved in each of the events. Most of our events which we have conducted till now are really successful. For example, we started with Madhumeha Patashala, which was again a brainchild of Dr. Manohar, which wanted to educate the school children about pre-diabetes, prevention of diabetes, healthy lifestyles, etc., which we are really successful. We are glad to announce that we have covered more than 20 schools till now. And we are able to educate the children about the awareness of preventing diabetes, preventing obesity, and having a healthy lifestyle. So we have program called Doc Skills, etc., which are really beneficial for the healthcare community. So that way, KRSSDI is doing a wonderful job. As a chairman of KRSSDI, scientific chairman of the KRSSDI, this time we could really organize nice programs today. You could really see that the debates were really fantastic. The lectures were really involved. We could really look into the variations. Some talks really needed stand-up orations. So that says that the talks were really good. And that says that there's a lot of effort which is involved, and thanks to our team, which they have taken painstakingly done and seen that everything has been meticulously organized. Tomorrow also you tend to see a lot of symposia and panel discussions, along with a big debate with senior faculty who are going to involve you in the spirit of educating you in healthcare. I encourage all of you to actively participate, share your insights, and forge new connections. The success of this conference lies not only in the presentations, but also in the conversations that take place between these walls. Thank you for your commitment for RSSDI and our state chapter, KRSSDI. I have no doubt that knowledge shared and the connections made will last for a long time. I wish you a productive and inspiring conference. Let us embark on this journey together, united in our pursuit of excellence and diabetology. Long live RSSDI, long live KRSSDI. Thank you.
Thank you, sir, for your beautiful words. It is now time to announce 3D awards. What are these 3D awards? It is Diabetes Detection Drive Program, and many of our doctors have participated in this and have registered number of patients in this. And there have been 4 awards awarded for the doctors who have registered maximum number of patients. And I call upon Dr. Deepak Yammar, Dr. Kiran Nidagundi, Dr. Baswaraj Patil, and Dr. Amala Selvam to receive these awards. Congratulations for all the 4 doctors. I request Dr. Mohan sir to hand over these awards to them.
ಎಲ್ರಿಗೂ ಹೃತ್ಪೂರ್ವಕವಾದ ನಮಸ್ಕಾರ ಹಾಗೂ KRSSDIಗೆ ಸ್ವಾಗತ. As I sat and came to the dais, the first thought I got was, I wish my dad was here. Anyway, but I have the whole of KRSSDI family here. Today, as I stand before this exceptional gathering, I feel truly blessed to be in the company of distinguished individuals like Mohan sir and many of our senior colleagues who have been patting my back, motivating me, triggering the spark, as I keep saying, for my journey, very active journey in the last 5-6 years of KRSSDI. So we, Mohan sir, many accolades you have got, and heartiest congratulations on the new award which you received again from the President of India. And that was the Lakshmi Pat Singhania Award for Leadership in Diabetology and Research. As I was going through his Facebook page, someone had commented that the award deserves you. Well, as I took over the chair last year, two things were in my mind. First is the idea of motto of awareness, advocacy, and education. Secondly, we at RSSDI, which is doing phenomenal job in the last 5-6 years, I must accept that. We want to drive India as the diabetes care capital of the world, not just the diabetes capital of the world. But also there were challenges, as people who were close to me figured out, and even I figured out. I was reminded of this poignant leadership quote by Jack Welch, which said, if you accept the call to be a leader, you must be willing to be misunderstood, criticized, opposed, accused, and even rejected. But friends, the worldly wisdom from our patrons and senior members of the GC members made what a dramatic change in all of us, the junior colleagues, that what we put together is shown in the form of the award, which was actually not dedicated to all of our close GC members who made me wake up and work together. So this wouldn't have been possible without the camaraderie what we have drawn in this last year, in spite of initial hiccups, which I feel it was a good thing what happened, that we brought us all together so very well, and we have seen throughout this planning of this program for the last 2-3 months, everyone has chipped in so very well that it was heartening, and I'm deeply indebted to all of you people for being there with me. So as I took over the first program, what I started was Madhumeha Samvada. Thanks to Surekha, she's driving it so very well. Reached lot of audience to clear the myths and also to educate about diabetes. Many of them have been viewed, more than 5,000 viewership it has happened. And Madhumeha Pathshala, very dear to me. Well, school is a place where we need to learn, and a doctor says a person may not listen, but if his son or daughter comes and says something, they will definitely listen. So that was the thing what is happening in when I started this program, and I think the Mysore team actually has taken up in a much bigger way, and I thank everyone who are involved in this. So in this, we also started giving health homework. Try to teach the child what should be their weight for their age and height for their weight for their height, what are the normal BP values, and give a homework, find out in your house who is above this cutoff or below this cutoff, and get back. So I think that was much appreciated, and Madhuvani, our quarterly newsletter, also has been doing great work. And besides, previous predecessors, chairmen had started Doc Skills program and the monthly meeting program, which were also continued, and all this culminated in being awarded as the best state chapter, and I dedicate it to all of our GC members. Of course, there's a lot left to do. Somehow we didn't find time to get more into outreach programs, village adoption, and I'm sure the next chairman will do it definitely better, and we'll all be with him to support in this endeavor. And this time we also started one open mic sessions to stimulate the young minds to bring up their ideas and share it in front of the audience, which was also taken up very well. So even the Dr. Sedni sir keeps telling me, you should encourage research and you should put it in the main hall. So I tried my best to do it in the last 2-3 years as secretary and also as a chairman. So I must acknowledge the fabulous scientific agenda created by Dr. Y.S. Ravikumar and the tireless efforts by our dynamic secretary, very, very judicious and sincere secretary Vijay, and all of the GC members, not to name anyone else. And then any shortcomings of this are mine to bear, and I seek your understanding for that. Delegates make or break the conference is my strong point, and we always try and to get as many delegates. In the last two conferences has been very successful, with most of the times halls being full. So even at the fag end, 5 o'clock, I thought it will be much lesser, but of course Mohan sir's presence makes it even more intriguing audience. So strongly believe that knowledge is one entity which enhances as we share. With a prolific faculty, attentive, interactive audience like many of you here, I'm sure this will be a very successful, we had a successful first day, second day also will do better. And I welcome you all, because it's the inaugural function, so welcome you all heartily. All the students, scholars, scientists, stalwarts, spirituals this time also to this conference. So if knowledge is power, learning is superpower. Let us come together and let us learn, unlearn and relearn from each other. Thank you very much. Jai KRSSDI, Jai Karnataka, Jai Hind.
Thank you, Dr. Manohar, for that heart-touching speech. Before we conclude, we have two more events to happen. The first one would be something that would interest the young researchers among us. Today we had oral presentations and there have been two winners. And to present these winners, I would request Dr. Sydney D'Souza to join on the stage, please. The best paper oral presentation is being awarded to Dr. Preeti Prakash Prabhu. And the second best paper goes to Dr. Shah Nawaz.
Young people that they should start doing research. That's why our association, along with NFI Medical College, NFI University, we kept some money so that every year rupees 10,000 would be given for the best the paper that is being presented here or a publication. And for the past 2 years, this is the second time we are doing that. In all there are 5 papers. Dr. Manohar also had a paper, but he opted out for the prize because he was a governing council member there. So rest of the 4 people have done extremely well. Now I again give back Sureka for her announcement of the results. She has already announced, and it's a pleasure that Dr. V. Mohan will come over. Be hugely a scientific man. I think he would be the best man to present this award to. The best paper awardee, that is Dr. Preeti. And between two of them, They had a difference of 0.5%. So you could imagine both were competing, but somebody has to win, and Preeti won the game. Thank you.
Thank you, sir. And thanks to Dr. Pradeep Kumar and Dr. Swaraj for having chaired the session and decided on the students. Last but not the least, this is something that KRSSDI takes pride in, having won the best state chapter in the national KRSSDI event, and to hand over the memento that we received, the prize that we received, I would request the central RSSDI members, Dr. Pratap Jetwani, Dr. Anil Virmani, Dr. Amit Gupta, Dr. Rakesh Parekh, Dr. Arvinda J, Dr. L. Srinivas Murthy, and Dr. Vijay Vishwanathan to come on the stage, please. This will always remain as a motivation to do better, and that is why you can see the excitement on the faces. I would now request our treasurer, Dr. Shekhar, to rendition a word of thanks.
Thank you. Good evening, everyone. Like the saying goes, gratitude is not only the greatest of virtues, but it is the parent of all others. It has been such an honor to be a part of this wonderful event. On behalf of KRSSDI, I would like to extend my heartfelt gratitude to Dr. V. Mohan for having graciously accepted the invitation to be a part of this annual conference. Thank you, sir. A sincere thank you to the whole organizing committee of this conference who has handled the event throughout. I would also like to give a wide round of applause and thanks to all the participants, delegates, and the speakers who have made the day. Finally, I would like to thank all of you present here for making the time to be with us today and helping us make this event a grand success. Thank you, one and all.
Thank you all the dignitaries for making this event memorable for us. Now something that we have all been waiting for. This is a customary presidential oration by Dr. Manohar Kehan. We are now going to felicitate that program with
Vice President Oration, you ask him to serve as oration. Well, thanks for staying back. So this is my topic chosen, lifestyle as a prescription. So before I start, I think my respects to these great gentlemen. Many of them are here. I have worked with them directly, indirectly, and I've learned a lot from all of them, and I continue to learn from them. So my due respects to every one of them. So, disclaimer, I'm not an authority on lifestyle. Lifestyle is a very controversial topic. I'm not a six-packer. I'm not an early starter. I just started some 6-7 years back. And what I'm trying to tell is, if I can get into it, anyone else also can do it. And I also would like to thank Credo Health for partnering in this journey with respect to patient care. And that's the data what people were talking about. I presented about 500 odd patients' data on how lifestyle modification changed. And that will be there in the end of the slide. So lifestyle, as I tried to understand, is a very, very complex entity. And it reminded me of this quote, famous quote from William Osler. I'm sure every one of you know this quote. Why I say that is, when I started getting into details of it, I was getting more and more confused. And then we started looking at it, it should be more a precision or personalized approach to each patient. Why I say that, as we go around, I'll tell you. So the flow is somewhat like this. So lifestyle is a complex entity. The nutrition, the physical activity, sleep, stress, behavioral habits, what we make, and the environment in which we live, all composites our lifestyle. It's not just about working out or dieting. So mindful eating, restful sleeping, wishful exercise, and above all, mindfulness and self-discipline. Self-discipline is the greatest of all this entity, what makes us sustain. Many people are motivated with me, but if you have to continue that, including myself, we have to be self-disciplined to a large extent. Having said that, today is a cheat day, so don't worry about that. So, and our health is just a mirror of our lifestyle. Even ADA, everyone knows this slide very well. I won't dwell into it for too detail. So this is important, and it has been encapsulated by ADA also. So is there a risk of inactivity is the question what comes. If you look at evidence-wise, meta-analysis of the studies, including more than about 11,000 patients, type 2 diabetic cases, have clearly shown if you are overweight or obese and physical activity is becoming a major determinant whether you get into converted to diabetes or not. So the increase is about 7-fold increase in the risk of developing type 2 diabetes if you're obese and inactive. So ask for activity, and I think I saw Dr. Hemant trying to show the yoga postures. Here we all, when we sit, it's been a long day, we can always do a soleus push-ups as we continue to listen to me, and that will also keep us going very well. So if inactivity is a problem, does increasing activity or improving the diet helps? We are in the era of evidence-based medicines. I don't know who will win tomorrow in the debate, but then of course we are in the era of evidence-based medicine. There is definite evidence that physical activity, why do we say 150 minutes? Because that is the duration of time when we advocate it to people, it helped in preventing the diabetes and its associated complications. Nowadays, it also says that higher the dose of the physical exercise, better the outcomes, and risk reduction of developing diabetes also comes down. Same thing applies to dietary restrictions. So that's what I was talking about, the exercise dose response curve. Whether it is love in the care of patients, if you are not able to manage, they say increase the dose of your love and affection. It works definitely. That's how the exercise also would work. And what they have shown is,
if achieving twice the amount of recommended physical activity of 150 minutes per week, further risk reduction of 36% happens with respect to preventing type 2 diabetes in people who are at risk. We told that inactivity is bad, physical activity is good. We showed the evidence. How about our prescription says diet and exercise? I'll come to it in the next slide. But if you don't give a structured diet and exercise program, it is of no use. So this is the evidence what we have. Physical activity advice alone is not associated with any significant HbA1c changes. It's a composite of 14 studies. But if you give a structured exercise program along with diet, it works. So we are always telling you, you do some walk or this thing, but how much and what, it also has to come in our prescription. So that is the message I'm trying to give. So friends, we write a lot of prescriptions, which I've been discussing throughout the day. Lifestyle also should come as a prescription. And nowadays, we look at generic prescriptions, branded prescriptions. Now, beyond prescriptions, precision, which is the theme of our conference also, is important. Because there are hardly any takers for lifestyle measures when you come to manage diabetes. And if you look at, this is what we, at the most, in the time constraints, including myself, do diet and exercise, you do it, is what the maximum we tell. But that prescription is no different from showing that this antibiotic and painkiller. Because the previous slide I showed, if you are giving a structured program, it will definitely benefit. If you're not structuring it, it is not going to benefit as much as we assume it to be. So the components of lifestyle, we all know this. And I think this is a big WhatsApp forward. I'm sure everyone would have seen. One of the components of this lifestyle is the stool or the chair. We have been sitting for hours together even today. And also the sleep pattern and the screen, which is coming into a big way as our lifestyle problem. Actually, it was all started to help us, but it is going to be a problem for all of us if we don't regulate it. Let us talk about the most abused and addictive substance in the world. Which is it? Any idea? Food. Yeah, I have always a war at home when I talk about it. My wife is still smiling or grinning, I don't know. Anyway, food is the most abused entity. We don't account it. Exercise is the most underutilized antidepressant. Sleep, commonly impaired, uncommonly assessed, and rarely addressed. Screen, unfortunately, has become the new playground. This is what I told in the Madhumeha Patashala when I went to school. Unfortunately, the kids are playing on their screen. There is no physical activity, whatever we recommend it to be. So nutrition is very important entity. I won't get into the details, don't worry. What, how much, how, and when to eat, all parameters become very, very important. Some say love of food is the only pleasurable thing that can be enjoyed till the end, so let us enjoy it. My mom also says that many times. Other thing is we look for instant gratification or hedonic happiness rather than the eudaimonic gratification. So that is where the conscious works differently. Food also is an emotion. I come to your house and I don't eat, people feel so bad about it. Even if you've eaten and gone, you're forced to eat again. And for the loud ones, we tell you take more, you eat more, and then we actually are poisoning them. Sometimes I feel it is better to waste food. We should not waste. It is better to waste than to put on your waistlines. Especially the ladies at home, they do that. Why to waste? And then we have it, and then it comes on your waistline. So friends, kitchen is the largest pharmacy which is underutilized. So again, Sanjay Rao sir will keep telling you, take away all my sayings. So this is one of his, we are what we eat and also what we drink. And stop eating this crap is what the advice in simple terminology, what we need to give. So why did I say how much, how, and when to eat? We all know people come to us diabetics, I have stopped rice. Is ragi so good? Or wheat so good? Or rice so bad? Again, if you tell, this is an era of millets now. The same ragi, if you eat it as a roti, or a mudde, or the ragi ball, or ganji, or the porridge, it makes hell of a lot of a difference. And I had shown to my own family members, my mom, after putting CGMS, how a ragi ball can skyrocket your blood glucose much more than the rice. So because I always tell you, take away the ragi mudde and make ragi rotis in it. One mudde will have 4 rotis or plus based on the size, which we won't eat otherwise. So it goes easily. Whatever you can take it easily is always a poison. Again, we talk about sugar, jaggery, and honey, fruits versus juices. I will not get into the total details of it. Comparing cereals, if you look at it calorie-wise, there is slightly ragi has less calories, but it is not very significant. Why people talk ragi is good, very good, is because of the component here, the calcium and iron and the mineral content, much more than the carb or the fiber content, which is almost the same. Same thing with sugar, honey, and jaggery. Why is jaggery so good? Naturally available. Again, the vitamins and minerals component of it makes it a difference. Not so much of the calories or the carbohydrate component of it. So this is what in simple I would like to tell. Then we always ask evidence again. So is there evidence? The landmark lifestyle intervention program, we all know, the Look Ahead trial, where they looked at calorie-restricted diet and reduced intake of high glycemic index diets. What did it say? At 11 years, the participants who benefited, who followed this regimen, were losing 5% of their weight, and they were fit, at least physically and mentally more fit. And there's a significant difference in the A1C and the blood pressure and the lipid profile parameters. Of course, mortality didn't show much of a difference, and it requires possibly more data into it. I think it's cluttered there. So my medical nutrition therapy evidence in India, yes, there is evidence in India. Sorry for the slide. I think it also clearly showed the reduced risk of progression of impaired glucose tolerance into diabetic. We all the nurses study, nurses welfare program. Similarly, Indian evidence is also there to say that there could be a significant benefit by following the medical nutrition therapy. So I'll stop for nutrition there and move on to exercise. Exercise is physical activity is much more than exercise, plus what we do as activities of daily living. We also have a lot of people who do exercise for an hour and they are sloth bear for the further 23 hours. That's why they don't get the desired effect. So keep moving, and exercise is a planned, structured, repeated regularly with a purpose. When I was trying to run a marathon, I had a different exercise protocol. When I'm trying to build a body, it is a different protocol. So that precision component should come into it, is what I'm trying to say. And as we all said, nowadays, sitting is considered as the new smoking. So some people are fit, but they succumb to so many problems. Everything is highlighted, gym deaths and sports person's deaths. So marathon fit, mountaineer fit, or bodybuilder fit, but are you metabolically healthy also? At what cost are you doing it? So we need to strike a balance with all these things. I think for the want of time, I will not get into the aerobic versus anaerobic exercise. Nowadays, we are, especially in diabetes, talking about muscle building, because we all know it improves the lean body mass and also works better on the insulin resistance parameter to be curtailed. So again, benefits of exercise, they have acute and long-term benefits. For example, when we are doing acutely, we have a increased cardiac output on the cardiac. But if there is a chronic adaptation, even the VO2 max, that's the oxygen extraction capacity from the blood, is better. Pulse rate comes down, stroke volume increases. So similarly, many of the changes shown here happen here. Muscle building will also improve the muscle resistance and improves the glucose uptake, and improved muscle mass improves insulin sensitivity. So benefits of exercise is not just restricted to that. Name it, fractures, cancers, coronary artery disease, everywhere the benefit of exercise is seen. The latest thing in the Journal of Sexual Medicine, October 23. This is an interesting finding. I think Bobby Matthew didn't show just this slide and he told everything else maybe. So exercise is the new Viagra. What did they find is exercise is as good as adding Viagra. Aerobic exercise benefited more, and degree of ED correlates directly. If the worse the ED, better the exercise, better the outcomes. And they have an improvement 0.2 scale where it showed as much improvement as testosterone supplementation in the treatment of erectile dysfunction. Yoga, my good friend Hemant gave a beautiful lecture. This is copied from him. Again, I'm not an authority on it. I keep visiting him, but I'm still yet to convert to becoming a bit more yogic type rather than the exercise type. So is there evidence here? Yes, definitely. Total RCTs are 27, 13 meta-analysis. What they conclude is yoga is definitely beneficial. 0.84% is the HbA1c reduction because of yoga, as good as any of the available oral anti-diabetic agents. And every additional increase in yoga practice again has an additional reduction of HbA1c by 0.22%. So variety is the key. So always mix it up. If you keep running, you'll get into a lot of other injuries. If you're doing bodybuilding, you get other types of problems. So mix and match, flexibility. That's what the RSSDI guidelines also says, which I come to it. So if you're looking at the blood glucose in a diabetic during exercise, the level 100 to 250 is more reasonable for them to work out. If you go too low, better to supplement carbohydrate. If you are too high, with or without ketone bodies, it's a bit more risky to do the exercise. And of course, if you do intense exercise, more of the anaerobic exercise, you can have hyperglycemia also. It's not that every time the glucose comes down, because of the sympathetic drive, you can have hyperglycemia due to exercise. So avoiding hypoglycemia in diabetics, if you're doing a mixed exercise, it is shown that resistance exercise followed by aerobic exercise minimizes the risk of getting hypoglycemia. Avoid exercising in diabetics in the late evenings so that the nocturnal hypoglycemia risk comes down. So these are the two important points. The rest are all quite self-explanatory. And again, we are talking a lot about interrupted sitting, which is a promising exercise intervention. And the other one which I didn't allude to because of the want of time is the soleus push-ups. Again, still we need to have some data whether to how much of soleus push-up is useful, and we still are in the way to figure it out. So I do sometimes the crazy things. I usually sit in my clinic in the yoga ball. It helps me to keep my core tight. It also makes me get up and move around and examine the patient. As Madam Lily John was telling, touching, feeling is the most important crux of it. And it gives me a lot of balance, and even the core strength has improved because of that. Again, you can try it, but then you try it slowly, almost 2.5 to 3 hours. I sit on yoga ball and then see the patients. So what is the RSSDI recommendations? So we all know adults 150 minutes per week. No more than 2 consecutive days of break is important. At least twice a week include resistance training and avoid sedentary behavior. And again, off late, they include flexibility and yoga to be important ingredients. At least twice a week, we need to follow it. So American College of Physics, Sports Medicine is the one who started telling that exercise is a drug which is to be like a drug to be prescribed in the format of dosing, timing also, like how we prescribe exercise. Then comes the point of, are you fit to exercise? Fit for exercise is the most important entity. So we need to classify our patients if they're high risk versus low risk individuals. And we don't think about the mindset, if that person has really a mindset to exercise or not. So we need to work from there. No intention to already in training is what we need to categorize. I'll show it in a brief in the later part of the presentation. And basic tests are definitely must. One of our cardiologists said, do CT angiogram for everyone, definitely not needed. It is indicated in few of the people with a slightly higher risk, and my intention to run full marathon within 5 hours, I did CT angiography, but then I forgot to train for the marathon. So it also happens that, and it's good to accept that rather than brood over it. So pre-prescription is very important. We waste money on so many things. Always make it a point, if someone is getting into exercise based on the risk categorization, always get a clearance for exercise. And on special situations, yes, retinopathy, if someone has undergone laser treatment, try to avoid exercise for the first 3 to 6 months. We all know exercise can cause physiological proteinuria. That also has to be kept in mind. And if there is a heart disease and uncontrolled BP, extremes of temperature and extremes of pulse rate has to be modified. Motivation is the most important thing. We may get started. There are a lot of my friends, colleagues, patients who get inspired seeing me running, but to stay there is very difficult. So how do I do it? If you look at the WhatsApp group, the one group which I always connect to it is the fitness groups. And then keep variety to your exercise, participate in some events, and have some fitness gurus with you who are into this, and they keep motivating you to continue. So the exercise prescription has to go like this. You look at the mindset of the patient, if he is not at all active, but he has intention or not, and if he is active, what is the level of activity? And then the fit principle comes in, and then prescribing. Before that, the foot has to be seen very importantly, assessed for neuropathy, how he is, and selection of a footwear also is very, very important. I won't go into the details because of the want of time. So some people come up with diet versus exercise. It is always diet with exercise. You can't outrun your fork. Diet, individually, diet definitely matters much more than exercise. But I can clearly differentiate a day when I exercise to a day not exercise. When I exercise, I don't feel like eating junk. From my Manipal Hospital, -1 to 11th floor, I walk up. Few of my PGs don't like coming with me for rounds because of that. But the day I don't exercise, I don't do these two things. Because of the hormone, what happens, the happy feeling and the negative things about craving gets taken care of on the day when you exercise. Can exercise be stressful also is a question. Sometimes we get into this mode of too much doing and it can be stressful. It has happened to me also. You get more agitated. I'm sure Ravi Kirti can relate to it. So what I tell is, if you get up in the morning and if you don't feel rested, don't exercise. Relax. And don't brood that you didn't exercise. Enjoy that rest day. So mind over body is what we talk, especially in marathon runnings. Again, as I age, I'm thinking body is more important than the mind. So respect your body and listen to it. So always I say, choose from today's fitness or tomorrow's sickness. And exercise is $1 billion drug which never gets prescribed. Tobacco and diabetes. Quitting tobacco causes 40% risk reduction of developing diabetes. And alcohol, this is the levels what is recommended by the ADA. Strictly speaking, we don't recommend it, but when you take it, try to be in your limits and watch for hypoglycemia, especially for the diabetics. Again, one most important entity what we forget about is about sleep. The Irish proverb says a good laugh and a long sleep are the best cures in the doctor's book. That looks like my younger son actually, it is not. Yeah, but he does that most often. Sleep quality is commonly impaired, uncommonly assessed and rarely addressed. I won't get in there. Why I say that is 1/3 of our life goes sleeping. And how much do we take it into account when we discuss with our patient about the sleep? And if you look at the prevalence of sleep disorder is about 58% in type 2 diabetes. And if you look at the duration of sleep and the quality of sleep, again it has a U-shaped curve. 6 to 8 hours is possibly ideal. Obstructive sleep apnea is one of the entity which is strongly related to type 2 diabetes. Again, a large topic in itself, and it is also related to A1C. So again, I come back to my guru, Sanjeev Rao sir, the Mercedes-Benz sign he keeps telling. That's how we need to divide our day, 8, 8, and 8. But I don't know how many of us are doing it. And this is the sleep hygiene what we need to follow and also to recommend. So we have moved from diabetes pathogenesis to triumvirate, to octate, to sweet 16, to dirty dozen. But somehow I feel sleep was lost somewhere. So my opinion is in the pathogenesis of type 2 diabetes, maybe we have slept over sleep as an important entity and it has to come into the pathogenetic mechanism in a bigger way than what we talk about it. We looked at testosterone, ferritin, so on and so forth, but somehow sleep is being left behind. So is it all just the talk or is there a walk what Manohar has done? This is where I thank Credo for partnering with my patients. So precision medicine has been going on throughout the day. So I just look at the data what we showed. About 500 odd patients in the last 1 year I've been following up. And age is not a barrier. Again, I'm practicing in a 5-star hospital, so maybe the patients are more affordable. And then again, above 60 years also, many of the patients were enrolled into this. Duration of diabetes varied from new onset to many long duration of diabetic and pre-diabetic diabetics. So what actually happened with them, I would like to summarize in this slide. There was over a period of 3 months, some of them extended, many of them didn't extend the program because of the cost and whatever. So weight reduction in most of them were an average of 3.2 kilograms. Both systolic and diastolic BP also reduced. HbA1c reduced up to 1.2%, and even triglycerides showed a clinically significant benefit of reduction from the mean baseline of 58 milligram per deciliter. So it is not just the talk, there is some walk there, and there is a strong evidence to back up, provided we stick to it. So this is the 5 commandments or for a healthy lifestyle as a prescription, what we need to think amongst ourselves. Love yourself. I keep saying reserve an hour a day exclusively for yourself. Do your exercise or yoga or a hobby or something. 1 hour a day is for you. Nutrition, what you eat, when you eat, how you eat, and how much you eat becomes important. Fitness is not just the exercise plus physical activity. Mindfulness is very, very important. To be mindful, I can't be like someone else. Someone is someone else and his life is different from my life, so there's no point competing there. and self-discipline. All these things will work only if we are self-disciplined and try to do most of the days, except today is a cheat day. Anyway, so lifestyle disease needs primarily lifestyle solutions. Healthy medical fraternity is the key to healthy society. We all have seen the data where doctors' lifespan is lesser than the average human being's lifespan, even in our country. And simple measure what we need to do from today is just to practice what we preach, which is, we all know that doctors are the worst patients, and if we try to practice what we preach, that's good enough. And don't forget, we are the heroes of our life. Treat yourself like a hero, and that's how I conclude. Thank you very much for the patient listening.
Dr. Shekhar sir and Dr. Sanjeev Rao sir to come on the dais, please.
There is no chair.
Ladies and gentlemen, I am going to hold him responsible for not calling us earlier. So you all join your hands, we'll bash him to death. Now, I am reminded when I was sitting there and listening to many people, there were background noises and front noises. Silence is golden. You all agree? But when you open your mouth, see to it that the words that come out of your mouth will definitely prove this adage, silence is golden, it's wrong, and he has done this. Let's give him a thank you. And it's not just, I have been watching, I was telling another hero, I've been telling this stupid fellow, give up medicine, become a hero in Hollywood or Bollywood, you will do better. Ravin, please stand up. Let them agree with me. These guys in the past, almost 7 or 8 years, sir, I have been watching them. I'm old now. They have really, filled the shoes of very senior people of KRSSDI in a very able manner. Fantastic work they have done. And you are seeing the reality of the best work that has been done. Can we give this stupid fellow a stand up on the bench? Wish. Thank you very much. And his team, of course, not just, Srinivas Murthy is here. 16 years of clinical research, no hair on head. And 20 years of clinical practice, lot of hair on head in the head. This is, placebo effect or whatever you want to call it. This is it. Thank you, thank you, thank you.
Didn't have it positive without your voice.
Ladies and gentlemen, I stand before you rather tongue-tied. I have here some of them who have worked with me and probably learned. This fellow, after I have given him a bit of a mind at once or twice, Vijay, him, they're all successful consultants. And if they prosper in life, that I think is the greatest thing a teacher can do to a student. And a teacher does not need many more accolades than that. I think I have done my job. First of all. Next, unwittingly or unknowingly, Manohar now he has not taken this statement from me. As is the thought, so is the desire. As is the desire, so is the deed. As is the deed, so is the action. As is the action, so is the result. As is the result, so is the result, so is the desire. It's a circle. So if you do this, which he has done, you will succeed in life, in anything. So, ladies and gentlemen, I think we should all emulate this young man and do what is, we all should succeed and be a healthy, happy life. Thank you.
Thank you so much for this informal advices given to all the delegates and the faculty that have been here. I think it's always nice to have the best for the last, and I would now request Dr. V. Mohan to address us once again and enlighten us about his lifetime of learning and knowledge.
Good evening, everyone. I'm sure you're all tired at the end of a long day, so I don't want to take up too much of your time. However, initially I thought when you asked me to be here and to deliver a keynote address, I thought I'll just give you some general ideas. Then it struck me that I'm addressing the KRSSDI, and we have data from the INDAB study. When we publish the full results of INDAB, each state gets lost. In fact, I would encourage each state that has done this to publish your data separately. I think 1 or 2 states have already gone ahead and done this. Haryana and a few others are doing it. So I thought I'll talk to you a little bit about diabetes in Karnataka, which is very relevant to KRSSDI. So delegates, faculty, ladies and gentlemen, students, what I'm going to talk to you is about decoding diabetes in India with emphasis on Karnataka. I have no conflict of interest to declare. These studies are by ICMR. So just a word about the ICMR INDAB study. I think you have to give credit where it's due. First of all, I started off as a clinician, and I thought that was enough. And then suddenly one day I realized that I didn't know how a non-diabetic looked like, because I've seen only people with diabetes. So somebody asked me, how does a person without diabetes look like? I said, oh, that's a good one. I haven't seen one, So jokes apart, what I meant was, what does the normal cholesterol of somebody who doesn't have diabetes look like? So this started off on a small journey of trying to do epidemiological studies. So the first thing that we did, and Dr. Sidney D'Souza reminded me about this incident which happened. So we thought we were very good. We selected one middle income group and one low income group in Chennai, convenient sample. One of them we are doing some spiritual work with, the other one somebody came and invited us. So we said low income, high income, we'll just study that, just convenient sample. Fairly good sample size. And then we did studies. And at that time, before we published that, actually we went to, that's an incident which he reminded me about. So we took all our data to University of Wisconsin, where we met Dr. Ron Klein and showed him the data. He's a big epidemiologist. This is our first epidemiology sample. So I said, I want some time with you. And he said, yeah, sure, we'll spend some time. So he looked through the data and he kept quiet. He didn't say anything. So I said, so what do you think? So he said, I'm scared to tell you because you may get depressed. I said, well, I've come all the way from India to listen to that, so let me have it. He said, it's rubbish. It's total rubbish. So I said, why? He said, what's your response rate? So our response rate at that time was 40% or something. So we had one dietitian who was doubling up as an epidemiologist, and on Sunday she would go and do epidemiology. And so that's all she managed to do. One single person, Sunday, 1 year went, and that's all we managed to do. So he said, come with me, I'll show you my team. He had a team at that time of some 40 people doing only epidemiology. Now I have much larger numbers than that. So he took me around and he said, just talk to them and tell them what you do, he told the team. So I told them, see, we go there, but they're not coming. These are not my patients. We are going out into the community, people whom we don't know, we're knocking on their doors, and many of them are not participating, they're not there. When you go there, husband has gone somewhere, somebody's gone somewhere, and so I'm not able to get. He said, that's why I want you to listen to these people. Then that's where I learned epidemiology. In that next 15, 20 minutes, I learned epidemiology. They told me what to do. You have to go back again and again and again and again. And he said, unless you get a response rate of above 90%, it's useless. Don't even publish this. So I said, okay, I've learned that. And he said, the reason you're not doing it is because you're not giving importance to epidemiology. In a spare time, you're trying to do epidemiology. Epidemiology needs a full-fledged team. So with that, I made the person who was doing it full-time, first of all. I said, you're no longer a dietitian, you're an epidemiologist. So she started doing this 7 days a week. So that improved. Then we said that's not enough. So we had to build a second person and a third person. So with that, the CUP study got completed. So we finished CUPS, Chennai Urban Population Study. We were very happy. We said, for the first time, clinician has done a epidemiological study. We got it published, fairly decent journal, Diabetic Medicine or something, got it published. But then the criticism started coming, saying that it's not representative of Chennai. What have you done? You just picked 2 places in Chennai. Anything should be representative. So I said, what do you want me to do? He said, you have to study the whole of Chennai. Unless you study the whole of Chennai, take a proper representative sample, it's no good. And plus, with your sample size, you can't get any data on complications, which is what we wanted to set out to do, because my wife had a big interest in retinopathy. That was our first interest. So we then said, okay, then we worked backwards. Okay, we have to have so many people with retinopathy, then we need so many people with diabetes. My initial sample size was 1,500, by the way, in cups. So I said, if you have to get so many people with retinopathy, nephropathy, then we need so many people with diabetes, at least 2,000. To get 2,000, you have to screen about 26,000 people. So from 1,000, we went to 26,000. Total representative sample. This time, we were a little more seasoned. We took little help. And then the Chennai Urban Rural Epidemiological Study, or CURES, was planned and it was done. And I remember that conversation, one of the RSSDIs from Mumbai, we are coming back, and I had Deepa Raj on the flight with me. And so they said, CUPS had meanwhile produced about 8-10 papers. So she was asking me, how many papers will come out of CURES? So I said, 100, I said. So she looked at me and she said, surely that's a joke, she said. I said, it's not a joke. You write down the first 50, I'll tell you now. So on the flight, we wrote down the first 50 papers. Finally, CURES resulted in 162 peer-reviewed publications, which is, I think, a record. Now, it was at that stage that my daughter came in now, okay? And she said, just like Ron Klein had told me, she said, you know what, Papa, can I be frank with you? So I said, okay. She said, your entire work is rubbish. I said, okay, thank you very much. At least as a daughter, you had the guts to tell me that. So I said, can you tell me why it's rubbish? It's 150 papers have come, and you're saying it's rubbish. She said, because Chennai is not India. So now see, first it was not epidemiology at all. Okay. Then it became epidemiology, but it's no use because it's not representative sample. Finally, you get a representative sample of Chennai, 26,000 people, you produce 160 papers, and that's rubbish because Chennai is not India. So I said, what is India? She said, India is India. So I said, what are you saying? She was an MBBS at that time. So I said, what are you saying? I want to do this all India study. I said, you first finish your MBBS. Then we'll talk about all India study, okay? During MBBS, you're going to do all India study. Are you crazy? Then she finished MBBS. She said, now let me do. I said, don't you want to do MD? MD is a full-time job, and you can do some research, but you can't do all over India gallivanting. You cannot do during MD. You finish that also. My hope was that she'll forget. By the time MD and all is over, she'll forget, you know. It's like somebody comes and tells you, I love this girl. Okay, you get married after 3 years. The thing is, you think that you'll forget that girl in 3 years' time. Okay, my father did that to me, by the way. But I didn't forget. Okay, so she finished her MD, and she said, now I want to do the study. So there's a day when, I'm just telling you this because the history of all this you should know. So there's a meeting in Delhi, the Indo-French meeting, and Dr. Ganguly was there. So she told me, you better tell him about the study. I forgot. So we finished the thing, the cold winter day, I remember it was January, and he got into the car. Then I remembered, God, I'll have to go back and she'll ask me. So I went running to the car and knocked on the, on the window. Then he lowered. Oh, yes, Mohan. I said, sir, his daughter has this crazy idea, She wants to study the whole of India and do a study like that. Then he said, who said it's a crazy idea? Come next week, ask her to come and present. He said, we have not even thought about it. We only discussed that such a thing is there. He gave 1 week. So in 1 week we went and said, okay, this is going to be in-diab study. We didn't give the name then, that came later. He said India study. He said north, south, east, west, one in northeast, maybe one in the middle. That's it. We'll select one state in each place. So that is our plan. We went and presented to in-diab. We went and presented to ICMR. They listened to it and they said, no way. You either do the whole country or you don't do it. I said, why? We're doing north, so everywhere they've done. China they've done that. No study in the world has studied the whole country, by the way. US has not done it. Australia has not done it. Japan has not done it. Germany has not done it. China has not done it. Nobody has done it. When you say a national sample, it will be here, there, here, there. So I said, everyone is doing that, no? Let's also do that. They said, no. In India, state is a health subject. So each state, if you do Tamil Nadu and then bring it to Karnataka and say, here, this is the thing, Karnataka will throw it out. They'll say, no, we want our data. So no state will, it's like a country by itself, each state. So they said, you have to do the whole country. So I asked her, what do you say? We'll do it. I said, okay, you do it, not we, you will do it. So that is how 15 years ago this study got funded. It became the world's largest epidemiological study ever done in the field of diabetes. The original plan was to study 29 states and 2 union territories. That became 30 states because Andhra got divided in between, okay? And then 124,000, we couldn't do J&K because that got divided. We are doing it now. And all the islands got left out, we're doing it now. So we're doing Andaman, Nicobar, Lakshadweep, Daman, Diu, all that we're doing now. It's going on right now, it's almost over. And Jammu and Kashmir is also over. But that was not done. But for that, so INDIAB was also, we are not published as much as cures and so on because we wanted to finish the whole country before we start publishing. We start publishing in between bits and pieces. Then the final study won't get published. So halfway through we published one, when we finished 15 states. Then when we finished all the entire country, 17 states, this was published on 7th of June 2023. And I must tell you the reaction which happened when this paper got published, because the previous IDF report had shown that there were 72 million people with diabetes. Suddenly, the number increased to 101 million. This kind of shook everyone, including the Prime Minister's office, including the Health Minister's office. Early in the morning, I'm getting calls. Health Minister wants to talk to you. Somebody wants to talk to you. Prime Minister's office wants to talk to you. What is this? What's happening in India? What is this 101 million you're talking about? We said, that's the truth. That's the study of the whole country. What do we do now? People will start asking us what to do. I said, don't worry, I've got a solution for it. Tell the whole people that you've got 136 million people with pre-diabetes and you will prevent diabetes in all of them. Great idea, they said. Great idea. This will be our selling point. So within 1 hour, BBC and everyone were with the DG, ICMR and saying, in fact, BBC called us and said, India's finished. India's finished. Nothing is finished. How will you manage 101 million people with diabetes? How are you going to offer care? If they develop kidney problem, what will you do? I said, if we have the wherewithal to do a study like this, we also have the wherewithal to look after. You please look after your small country. Your small country came and ruled us some time back. You continue to be bothered about your own country and leave our country to us. We know how to manage. You don't have to get overtly worried about our country. You've got enough problems of your own. You stick to your own country. We told them that. And then the BB's going to put the phone down. They're trying to corner us. Okay? So this is what came out. The first metabolic NCD report of the whole country. And here are the numbers. 101 million people with diabetes, 136 million people with pre-diabetes, 315 million people with hypertension. Look at abdominal obesity, 351 million people. How many of you in the audience know of countries with more than 350 million? Countries, whole country, everyone included. How many are there in the world? No. How many countries in the world have a population of more than 350 million? Only India and China. No other country, even the United States is less. So we have got more people with central obesity than the entire population of the United States. That is why people are getting rattled. you know, and these are the actual numbers. And this is only the tip of the iceberg. It's now going to grow, grow, grow. We haven't even reached the saturation point. So you're going to see much, much larger numbers in the years to come. Let's look at diabetes. 16% urban India. Now this is not cities. Cities we have crossed 25% long ago. Delhi and Chennai, about 10 years ago, we already reached 25% of the adult population. This is, when you say urban, we're talking about tier 2, tier 3, everything put together. For example, if we did Karnataka, there'll be only a small contribution from Bangalore, a small proportion from Mysore, okay? Because urban is not Bangalore. It is proportion to Karnataka's population, what is in Bangalore only will get included. Belgaum will get included, everything will get included in that, okay? So 8 to 9, almost 9% is rural. If you remember Professor Ahuja's studies 50 years ago, it was 1% in rural. Today, whole country, we are talking about 10% of the 9% of the population in rural India having diabetes. That's huge. And those are the numbers. If you see red, it means high prevalence, more than 10%. Entire India, except one state, is red. Rural, there's still a lot of green, which means it is low, but it is going to go. This is only diabetes. If you look at pre-diabetes, you'll see that the rural is also red. Remember this figure of rural. Now let's come to Karnataka. The prevalence of diabetes in Karnataka is 10.6%. Now this is whole of Karnataka, urban, rural put together. That means the entire population of Karnataka, adults, about 20 years of age, almost 11% are already having diabetes. Okay, more than 1 in 10 are already having diabetes. This is from the poorest to the poor to the richest. All are included in this. Pre-diabetes. Pre-diabetes, if you thought diabetes is high, pre-diabetes is even higher. Now what does that mean? It means that the epidemic is not over. You're going to get more and more feeding into diabetes. It's from the pre-diabetic pool. When we can all celebrate is when the pre-diabetes numbers go down. That means you're not going to get anything feeding in diabetes. The epidemic is almost getting over, saturated. We have not reached that point. Over the next 5 to 10 years, you will find steady increases in diabetes because it's pre-diabetic pool. Unless we all start a huge campaign to prevent diabetes in those with pre-diabetes, okay? And you can see here the rural is 15%, and that's why a lot of red there. When you saw the rural map for diabetes, all green. There's hardly any red. Look at the reds there. Now, the southern states, which had a lot of red in diabetes, are already beginning to have lower rates of pre-diabetes. So we are beginning to saturate a little bit. But states like Uttar Pradesh, if it is a country, it will be the 4th or 5th largest country in the world, if UP was a country. Okay. Luckily for us, the prevalence of diabetes is lowest in UP today. It's 4.8%. It's the lowest in the whole country. If UP goes up by just 1%, 2%, the numbers will go up by millions. And it is going to happen because there's a lot of pre-diabetes. You can see that area is completely red as far as pre-diabetes is concerned. So you're going to find huge increases occurring in UP and all that quite shortly. Now Karnataka, 13% is the prevalence of pre-diabetes. And if we take the diabetes to pre-diabetes ratio, it is 1 to 1.2, which means there's more pre-diabetes. When that ratio becomes 1 is to 0.4 or 0.3, then we know, yes, now we're reaching, only those whom we have to look after. No new ones are going to come. Because by the time you treat these, more will come. By the time you treat those, more are going to come. So that is the problem that we are facing today. What about obesity? Can you imagine that if you look at generalized obesity based on BMI, 40% of urban India is obese, 40% of India is obese, and 23% of rural India is obese. We think they're all very thin guys in rural area. Think again. There's a lot of obesity coming in rural India. Rural India has more people than urban India. So a slight increase there will mean much more obesity and much more diabetes in rural India. This is abdominal obesity. If you take whole of India, all urban areas put together, 1 in 2 is obese. 50%, 51%. Half the population of urban India is obese. This is huge. And rural is 1 in 3. It's not far behind either, okay? And that's abdominal obesity, whole country, urban, rural. And you can see a lot of red in the rural as well. And here's Karnataka. Generalized obesity almost 27%, and abdominal obesity is 35%. 1 in 3 of everyone in Karnataka is obese. Everyone in your state, 1 in 3 is obese. Hypertension. Hypertension is 40%. Now, these are much higher than reported earlier by NFHS and other surveys. They've shown 28, 30, 32%. Here in urban, it talks about 40% hypertension, 33% rural, and overall for the whole country, 35%. 1 in 3 of all adults in India have hypertension. Karnataka, almost the same. 1 in 3 have hypertension. Cholesterol. This is defined as a cholesterol, total cholesterol more than 200 or an LDL more than 100. Urban, 27%, rural, 22%. And the overall prevalence of Karnataka, hypercholesteremia, is slightly lower than the national average. You can imagine how it is in Kerala and Goa, where coconut oil is taken. It's huge. It's one of the highest. And the other big state where cholesterol is very high is Punjab, where a lot of butter is eaten. So we think, and we are told, that this cholesterol thing is a myth, that you take saturated fat, nothing happens to you. Think again. You've got epidemiological data. The only problem is, these things are so politically sensitive that if I now go and say that in Kerala, due to coconut oil, it went up, I'll be probably killed by some activist or somebody, you know. So we're scared even to project our own data, you know. That's the truth. So here's your summary of the Karnataka data. 10%, 10.6% diabetes. You can take a picture of this. 13.7% pre-diabetes, 31% hypertension, 27% generalized obesity, 35% abdominal obesity, and 17%. The only thing you have a little lower is cholesterol. That will be worth studying. Why one state has only 17% cholesterol and a neighboring state has so much? Because oil is an obvious one, but there are other things. These are all things which can lead to next 20 years of research can go on based on these findings. Now the problem is, as already shown and shown by your president just now, the NCDs all are increasing, physical activity is low even among the rural people, rapid changes in diet are occurring in your own state, and 70 to 80% of what people eat in Karnataka is mostly carbohydrate, very little protein. So what can we do about it? I just put down 2 or 3 things generally, because in RSSDI you should be thinking about these. What can the patient do? We've talked all about that. The ABCD, let's not forget the ABCD. I think in every conference we should emphasize and re-emphasize the need for ABCD. I'm not going to go through all this. Your president talked about all this so well. At the provider level, that's at the patient level. At the provider level, screening, and we have given awards for screening today. I think that's very, very important, because diabetes is asymptomatic and pre-diabetes is totally asymptomatic. How are you going to pick up these guys who have even more than diabetes? And the heart risk is as much as those who have diabetes. Unless you go and screen, you're not going to pick them up. So in every district in Karnataka, you should have, and I know that RSSDI is setting up at every district NCD officers and diabetes screening and so on. In every district, you should have champions who will go and screen for diabetes, pre-diabetes, and spread the message. That's the only way you can make an impact. And of course, the need for ABC control and so on. At the government level, we need a lot of support. We need policy decisions. When we talk about fruits and vegetables, if you look at that map in Lab 17 published in the June issue of Lancet Diabetes, the fruit and vegetable intake in our country is horrendous. It's very, very low. Physical activity is even worse. If you look at it, it's completely red, which means near zero physical activity in every state in this country. And yet, we cannot afford even our tomatoes. We cannot afford onion. We cannot afford simple things in life. This is the government's job. This is not our job. They have to make healthy things cheap. If you keep healthy things very expensive, people will not eat that. They'll go to the nearest fast food shop and buy. That's what happens in the US. McDonald's is much cheaper than going to a grocery store and buying an apple. They can't afford it, the poor people. Can't blame them. That's what they get for $1, $2. They can eat all that they want. And that's why obesity is going up. Same thing is happening in India. It will continue to happen in India unless we change the policy. Laws, regulations, spaces, open space for people to walk. I just posted this morning, what a pleasure it was staying in the Indian Institute of Science guest house. And every time I go there, my morning walk is something I enjoy. Forest, nature, even there are footpaths within to walk. It is so safe and absolutely good. How many such places do we have? Maybe Bangalore has a little more. In Chennai, there is nothing. You cannot walk in Chennai. And all the floods and all you can expect, I predict every year we'll get the same floods. Because there's no place, everything is taken up. Construction, all the thing is gone, roads are gone, footpaths are gone, everything is gone. There's no city left. So when you have that kind of a thing, where are people going to walk? When I tell my patients to walk, they'll say, either a dog will bite me, or the pollution will kill me, or a truck will hit me. So they say my lifespan will go down if I go for a walk. It's probably true. Not everybody lives in Koramangala and Botlab, you know. So where do the poor people go? At least we have a beach, somewhere they can go, okay? There are no places for people to go. These are things which they should do, by cycling places and strengthening healthcare to look after. We say ABCD, but ABCD for 100 million people, getting that under control, it's not a joke. And by the time you do that, it will become 120 million. By the time you do that, it will become 150 million. It's a no-win situation at all, okay? So is there proof that if we do all this, they can live long and healthy lives? This is the paper for which I got the Harold Rifkin Award. I was surprised when they gave me this award. Then when I got it, and on the stage, Will Safalu was there, and he had published this paper actually, in Diabetes Care. He was the editor of the journal, and he was giving off the award many years later. 2013 I published, 2018 I got the award. By the time he was no longer the editor and so on. So when I went up to the award, he was announcing it. So I said, do you remember me? Because he came down to Chennai when he saw this paper, because he wanted to see it. And what he made me do was, I reported for the first time in the world on long-term survivors of type 2 diabetes with 50-year survival of type 2 diabetes. Type 1 is known. Children, you can live 40, 50 years. But type 2 was the first time it was shown. What he came to Chennai to tell me was, I like this paper, but I'm not going to publish it until you have a control group. And the control group is non-survivors. You must show people who died. And now only you can do it. You show how they lived and how the others died. If you're able to do that, it's a classic paper. It'll become one of the classics in diabetes, and it did. So I've forgotten all that. So when I went up 5 years later to receive the award, I said, do you remember me? He said, why do you think you got the award? You got it for that paper. I said, oh my God, I didn't even realize it. I didn't even connect. So, but what came out of the paper was very simple. Those who survived had better glycemic control. What is that? A1C. Better blood pressure control. What's that? B. And better lipid control. What is that? C. So my A, B, C came from this. It didn't come from anything else. We didn't make it up. It came from this paper. It's actually based on evidence, okay? And then we also showed that people can live up to 90, even 100 years. And this picture, which I'm very fond of showing everyone, is that there are two people in that room who are below 90 years of age. I hope you can spot them at least. I hope you can spot them. I hope you don't look 90. So there's one guy standing there and one lady, young lady next to him. That's my daughter. So two of us were below 90. Everyone else in this room, when the picture was taken, was above 95. One second sitting in the wheelchair was 101 years old, and he was our chief guest. He was a former vice chancellor of the university, and he was a chief guest. The one next to him was 97 years old. He was a chief secretary. He had worked with 3 prime ministers and 3 chief ministers of Tamil Nadu. And at the age, he was 97 when he came to the picture. At 96, he had written his book. His faculties were completely there. He walked in. In fact, he shouted at me because he was 1 minute late. I told him to come at 10, and at 10:01 I walked in. Not that I was late. I'm never late. But I told my secretary, sir, nobody in the hall, sir, nobody in the hall, sir, nobody in the hall. So at 10:01 I walked in. And he looked at it and said, what time is it? 10:01. What time did you tell me to come? 10. You should have been here at 5 minutes earlier. You didn't come, he said. So that's the kind of man he was. He continued, he finished his 100th birthday, and after 101 years, he recently passed away. Many in this group have already crossed 100 years of age. They're still alive, okay? So it's possible for people with type 2 diabetes to live up to 90, 100 years of age. And I keep saying this all the time. Some of you might have read my editorial in the Hindu on World Diabetes Day. I said reversal of diabetes, desirable but not essential. Desirable, yeah, you get it? It's great. Not essential. None of them had reversal. They're all taking treatment. They're all taking medicines, okay? And one thing they all did was they came regularly for follow-up. And they all walked, by the way. They all walked and came. Many of them walked up the stairs when they came for this. So it's possible to get that. So to conclude, ladies and gentlemen, the prevalence of diabetes in Karnataka is 10.6%, but we have more pre-diabetes. The ratio of diabetes pre-diabetes is still undesirable. We have a lot of hypertension, a lot of dyslipidemia, and the most important thing in treatment of type 2 diabetes at least remains lifestyle, and diet and exercise, sleep, and whatever else you want to put into it will come right on top. Before I end, I was listening to the debate, and Arvind had asked me to respond about the older drugs versus the newer drugs. All those guys whom you saw in the picture, not one of them had used a modern anti-diabetic drug. 60 years ago, 70 years ago, when they got diabetes, they had only metformin, and the cheapest was sulfonylurea, the oldest sulfonylurea is glibenclamide. That's all they had. Many of them continued that till now, even in their 90s. My grandfather got diabetes when he was 44. He died when he was 99, after 55 years. My father was treating him, and he was on glibenclamide only till he died. At the age of 99, he was still taking glibenclamide. Nothing happened to him. We never saw him once in a hypoglycemic coma. So, yes, it is true that these drugs do have side effects. Many of them are exaggerated. So it doesn't matter what drug you take. It's not because of SGLT2 that they survived. It's not because of degludec that they survived. Okay? They survived because they walked, they took their exercise, they took some small dose tablet, they came for checkup. I am not at all decrying the modern drugs. They are fantastic. They should get a Nobel Prize for all the discoveries that have been made. But that's not the main reason why people live. That is not why people live longer. Treatment of diabetes, management of diabetes has much more to it. So don't worry if your poor man in the rural area could not afford Ozempic. Okay? It doesn't matter. There are many other ways of treating. Okay? If you can afford it, give it to him, or give it free to someone, you give it. But that's not the one which is going to make him live a long and healthy life. It's common sense. It is our commitment to them. It is our guidance. We are mentors to them. So if we take care of that, and I want everyone in the audience today to take a pledge that you will reduce the A1C of all your patients who don't have the good control by at least 1%. That's a very easily doable target. If every one of you in this room, every one of your patient who has uncontrolled diabetes, just by 1% you reduce your A1C in the next 6 months, that's far more important than conducting the 21st annual conference of, or the 20th annual conference of KRSSDI. That's a far greater contribution to society. But that is what we are all living for. That is why we have become doctors. And in the process, also look after your B and your C and your D and E and F and whatever you want to do. But keep the patient on the top of your agenda. We are all working for the patient. I think Dr. Lily John said that. All the old-timers like Dr. Lily John and me will say that, because we always had our patients in mind. All other things came secondary. And I'm sure if you all work together, it doesn't matter if the number of people with diabetes went from 100 million to 200 million. So what? If they all are going to live up to 100 years of age, like 500 million people in India get diabetes, who's bothered about it? It's our duty to see that they all have a long and healthy life despite diabetes. Thank you.
I truly believe that I should not be speaking anything after what Dr. Mohan sir has spoken. And this is the concluding remark by KRSSDI 2023 for today, I believe. I leave all the audience to ponder over it and think over it, how we are all going to increase our contribution to diabetes care. Thank you so much, sir. Sir is available to all of you to interact over the next few hours. I would now request Dr. Pawan to continue the session.
Yes, thank you, Dr. Sureka. And truly, one of the best talks that at least I have heard in my short career so far. And I'm sure the seniors who are there would agree that probably one of the best that they have also heard in their life. So thank you, Dr. Mohan. Thank you so much for a wonderful, wonderful talk. Yes, now that we are done with the academics, Dr. Mohan is also here and all of us are also here. It's time that we try to look back on these 20 years that we have come through. It has been a journey with its own ups and downs, but yes, we have weathered through it. We have weathered through the storm, we have weathered through the rain, and now we have the sunshine. And that's why all of us are here to celebrate the 20 years of KRSSDI. I know we are coming to the end of all the programs, but bear with us for another 20 minutes, after which we will start with all the cultural programs and the gala dinner. So, yes, you can.
ಎಲ್ಲಾದರೂ ಇರು ಎಂತಾದರೂ ಇರು ಎಂದೆಂದಿಗೂ ನೀ ಕನ್ನಡವಾಗಿರು ಕನ್ನಡವೇ ನಿತ್ಯ ಕನ್ನಡವೇ ಸತ್ಯ. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಹಾಗೂ ಇಂದಿನ ಈ ಅದ್ಭುತ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಎಲ್ಲರಿಗೂ ಸುಸ್ವಾಗತ. ನಾವು ಯಾಕೆ ಇಲ್ಲಿ ನಡೆದಿದ್ದೀವಿ ಗೊತ್ತಲ್ವಾ? ರಾಷ್ಟ್ರೀಯ ಮಧುಮೇಹ ಸಂಶೋಧನಾ ಸಂಸ್ಥೆ RSSDIನ ಅತ್ಯುನ್ನತ ಘಟಕ ಅಂತಾನೆ ಹೇಳ್ಬೋದು, ಕರ್ನಾಟಕ ರಾಜ್ಯ ಘಟಕ. ಇದು ನಡೆದು ಬಂದ ದಾರಿ ನೋಡೋಣ ಅಂತ ನಾವಿಲ್ಲಿ ಸೇರಿದ್ದೀವಿ. ಮುಂದಕ್ಕೆ ಇದನ್ನು ಸ್ಥಾಪಿಸಿದ ಮಹನೀಯರು ಹಾಗೂ ಇದನ್ನು ನಡೆಸಿಕೊಂಡು ಬಂದಂತ ಹಲವಾರು ಜನ ನಮ್ಮ ರಾಜ್ಯ ಘಟಕದ ಬಗ್ಗೆ ಮಾತಾಡ್ತಾರೆ. ನನ್ನ ಅದೃಷ್ಟನೇ ಸರಿ, ನನ್ನ ಅಧ್ಯಕ್ಷತೆಯಲ್ಲಿ ಈ 20ರ ಸಂಭ್ರಮ ಕಂಡು ಬಂದಿದೆ. ಈ ವರ್ಷದ ಕಾರ್ಯಕ್ರಮ ಹೇಳಬೇಕು ಅಂತಂದ್ರೆ ಬಹಳ ಹೆಮ್ಮೆಯ ವಿಷಯ. ನಮಗೆ ಶ್ರೇಷ್ಠ ರಾಜ್ಯ ಘಟಕ ಪ್ರಶಸ್ತಿ ಕೂಡ ಲಭ್ಯವಾಯಿತು. ಹಲವಾರು ಕಾರ್ಯಕ್ರಮ ನಮ್ಮ ಗವರ್ನಿಂಗ್ ಕೌನ್ಸಿಲ್ ವತಿಯಿಂದ ಹಮ್ಮಿಕೊಂಡಿದ್ವಿ.
Can I request all the delegates to have their seats? It will just take another 20 minutes. I'm sure Mohan sir will be with us for another probably 1 or 2 hours. So all of us can have that little bit of talk and that memory back. But yes, it is important to finish the program that we have started so well. So please bear with us, please.
ಮಧುಮೇಹ ಪಾಠಶಾಲೆ, ಮಧುಮೇಹ ಸಂವಾದ ಹಾಗೂ ಮಧುವಾಣಿ ಅವೆಲ್ಲ ಈಗ ಸುತ್ತಮುತ್ತ ನೋಡಿರ್ಬೋದಲ್ಲ. ಬೇರೆಯವ್ರನ್ನ ಕರೆ ಮಾಡ್ಕೊಂತ ಇನ್ನು ಮುಂದಿನ ಕಾರ್ಯಕ್ರಮ ನಡೆಸ್ಕೊಡ್ಲಿಕ್ಕೆ ಡಾಕ್ಟರ್ ಪವನ್, ಡಾಕ್ಟರ್ ವಿಜಯ್ ಇಬ್ಬರು ಇಲ್ಲಿದ್ದಾರೆ. ಡಾಕ್ಟರ್ ಪವನ್ ಅವರು ಬಹಳ ಮೆಟಿಕ್ಯುಲಸ್ ಸೆಕ್ರೆಟರಿ ಆಗಿದ್ರು. ವಿಜಯ್ ಅವರು ನಿಮ್ಗೆಲ್ಲರಿಗೂ ಗೊತ್ತೇ ಇದೆ, ಇಲ್ಲಿ ಫೈರ್ ಇದ್ರೆ ಅಲ್ಲಿ ಐಸ್ ಇರಬೇಕು. ಸೊ ಆ ರೀತಿ ಕಳೆದ 2 ವರ್ಷದಿಂದ ಕಾರ್ಯಕ್ರಮ ನಡೆಸ್ಕೊಡ್ತಾ ಇದ್ದಾರೆ ನಮಗೆ. ಬನ್ನಿ, ನಮ್ಮ ಜರ್ನಿ ಹೇಗಿತ್ತು, 20 ವರ್ಷ ಹೇಗೆ ಕಳೀತು, ಮುಂದೆ ನಮ್ಮ ಪಯಣ ಹೇಗಿರಬೇಕು ಅಂತ ಈ ಎಲ್ಲ ಮಹನೀಯರ ಮಾತು ಕೇಳೋಣ. ಮತ್ತೊಮ್ಮೆ ನಿಮಗೆಲ್ಲ ಸ್ವಾಗತ ಕೋರ್ತಾ over to Pawan and Vijay. Before I hand over, friends, please don't miss the program what is scheduled at the end of this, and don't miss the sumptuous traditional dinner and entertainment line for all of us. Sit back, relax and enjoy. Jai KRSSDI, Jai Karnataka, Jai Hind.
SDI was started in 1971 by Dr. Ahuja, Delhi, Dr. O.P. Gupta of Ahmedabad, Dr. Vishnathan, and Dr. Moses of Chennai. But Ahuja was the only active person. He used to identify a person before the API conference across the nation and then ask him to organize a conference of RSSDI, which I did in 1985. And I was also president in 85, 86. By virtue of being an executive veteran, I was asked to nominate governing council of KRSSDI. Almost all the states in India has chapters, and the Karnataka chapter was one of them. I nominated Dr. Basan Godappa from Mysore as the president and Dr. K.R. Narsim Setti as the secretary. Narsim Setti was responsible for the growth of KRSSDI and increase in membership also. At the moment, Dr. Manoj is the president, Dr. Vijay Kumar is the secretary, and they are doing a wonderful job. Wish many more people take part in the growth of KRSSDI. And also, I wish the annual conference a success.
Hi, I am Dr. Prasanna Kumar, endocrinologist from Bangalore, former patron of Karnataka RSSDI and now the patron of RSSDI India. I would like to congratulate the Karnataka RSSDI on their 20th year of running this Karnataka RSSDI, which started with a very modest number of the membership, and now it has grown to 900 members under Karnataka RSSDI. I think last 20 years, all the executive committee members and elected members have worked hard, especially in the last 5 years. The Karnataka RSSDI has grown to a great extent, and it has done immense service to the patients and public of Karnataka in educating them, as well as to the healthcare professionals. Karnataka RSSDI got the best award for a chapter in the last RSSDI, which was held in Bombay. I wish to congratulate and thank all the members and the elected members and the executive committee of Karnataka RSSDI for holding their 20th annual conference of KRSSDI in Bangalore on 17th and 18th of December. I wish all the members and the office bearers all the best for the coming 20th annual conference, and have a great scientific feast and spread the knowledge and deliver the best of the care to all the diabetic patients in Karnataka. Thank you.
Yes, these were only few of the doyens of diabetes, as we call them, whom we heard just now. Before we go further, there is something that many of us here don't know about Dr. Surekha. We all know she presents well, she MCs well, she's a brilliant clinician, very kind-hearted soul. She's also a very good author. And to give a proof of that, I will call her on the stage.
Thank you, Dr. Pawan, for your kind words. As we celebrate 20 years of inception of KRSSDI, here is my tribute to all the doyens who have treaded this path of knowledge and contributed to diabetes care. It includes everybody in the past, present, and future. This I have written with the help of and guidance of Dr. Shekhar sir. Kindly pardon me if there is any mistake. This is in Kannada, and it is called as KRSSDI Gate. ಕಹಿಯಾದ ಜೀವನವನ್ನು ಸಿಹಿ ಮಾಡುವ ಕನಸು ಜೊತೆಗೂಡಿದ ಒಂದೇ ಗುರಿಯ ಹಲವು ಮನಸ್ಸು. ಎಂದಾದರೂ ನನಸು ಮಾಡುವ ಹುಮ್ಮಸ್ಸು ಇದೇ KRSSDI ಸಂಘದ ಸೊಗಸು. ಕೆಲವು ಭಾವರ ಪರಿಕಲ್ಪನೆಯ ಯೋಜನೆ, ಹಲವು ಕ್ರಿಯಾಶೀಲರಿಂದ ಬೆಳೆದ ಬೃಹತ್ ಸಂಘಟನೆ. 2 ದಶಕಗಳಲ್ಲಿ ನಾವು ನಡೆದು ಬಂದ ದಾರಿ ಎಲ್ಲರಿಗೂ ಆಗಿದೆ ಸ್ಫೂರ್ತಿಯ ಒಂದು ಮಾದರಿ. ಮಧುಮೇಹದ ಜಾಗೃತಿ ಮೂಡಿಸುವ ಗುರಿಯಿಂದ ನಡೆಸಿದೆವು ಮಧುವಾಣಿ, ಪಾಠಶಾಲೆ, ಸಂವಾದ. ಡಾಗ್ ಸ್ಕಿಲ್, ತಿಂಗಳ ಬೆಳಕು, ಗ್ರಾಮ ದತ್ತು ಕಾರ್ಯಕ್ರಮಗಳು ತಂದಿವೆ ನಮಗೆ ಪ್ರಶಸ್ತಿಯ ಗತ್ತು. ಜ್ಞಾನದ ಗುರಿಯತ್ತ ವೇಗದಲ್ಲಿ ಸಾಗುತ್ತಿದೆ ಈ ಪಯಣ. ಮಧುಮೇಹದ ನಿರ್ಮೂಲನೆಯೇ ನಮ್ಮ ನಿಲ್ದಾಣ. ನಿಲ್ಲುವುದಿಲ್ಲ, ಸೋಲುವುದಿಲ್ಲ, ಗುರಿ ತಲುಪುವ ತನಕ. ಮಧುಮೇಹ ಯೋಧರ KRSSDI ಘಟಕ. ಧನ್ಯವಾದಗಳು. All it says is, we will not stop, we will not be defeated till we find cure for diabetes. Thank you one and all.
I don't even want to say I told you so. Okay, so going next, yes, we have been through lots of ups and downs, including all the people, all the executive committee members, all the chairmen, all the secretaries that have been so far. They will have their own stories, and stories which tell us how KRSSDI was born, how it weathered the storm, and how we are and where we are at the present. So yes, we made a small video to show where it started, how it went through, and where are we. Can we have that, please? All started in 2003. We have had brilliant contributions to Center of RSSDI, some very big toys, and obviously 3 in a row, as Mohan sir was saying, cannot be just chance. All the people have been there tirelessly, especially in the last 5 years, as Dr. Surekha mentioned. We have had number of programs, and yes, we have some very good memories. I know 20 years cannot pass. We could not I will be failing in my job if we do not remember Dr. KRSSDI at this point. Right, and yes, for any organization to grow, there has to be a basement, there has to be pillars. We have had brilliant people who have formed both of them, and it is time to recognize that it is because of these people that I stand here before you today, and you people have come here to listen to some of the best in the field of diabetes. Can we have Dr. C.D. Srinivasmurthy, Dr. V.G. Nadgoda sir, Dr. Baswan Godappa sir, and Dr. Sidney D'Souza sir on the dais, please? Can we have the chairs for them? I would also request, we also wanted Dr. Munichudappa sir to be here, but I think because of many reasons he has not been able to come today. But we remember him as the Bhishma Pitama, who has been there right throughout, supporting us, telling us what needs to be done. Can I now call upon Dr. Manohar to felicitate Dr. Dr. Munichudappa sir is not there. Dr. Y.S. Ravi Kumar sir to felicitate Dr. Sri D. Srinivasmurthy sir. Dr. Vijay to felicitate Dr. V.C. Nagara sir. And yes, they really deserve everything that we can give them. have Dr. Ravi Kirti to felicitate Mrs. Farida, please, from USV Pharma. It's the working force, the pharma, that we have to recognize as people who have been behind us for the support, the constant support that we have been getting in the last 20 years. Can we have Mr. Nagraj from Micro Pharma? Mr. Nagraj, can I ask Dr. Suman to felicitate Mr. Nagraj, please? Dr. Suman is not there. Dr. Suman? Dr. Kiran, can you please come and felicitate Mr. Nagraj from Micro? Thank you so much for being there and understanding that, yes, thank you. Can we have Mr. Pankaj from Novo? Mr. Pankaj from Novo, can we ask Dr. KG Suresh to felicitate Mr. Pankaj from Novo? Thank you once again for everything. Last but not the least, can we have Dr. Chandra Kumar from Credo Health? Dr. Chandra Kumar from Credo Health. I would request Dr. Manohar to felicitate Dr. Chandra Kumar from Credo Health. Navneet? Navneet? Mr. Navneet? Please come back. Not there, not there. Okay, fine. Bunny madam, please come. As we come to the end of today's programs, I mean, it's not the end. We have a very special surprise for all of you. And as we all know, as Dr. Manohar has spoken so far, every doctor here has a hidden talent. And one of the most talented doctors that I have interacted with, Dr. Shekhar. Yes, he's ready. Can we have you on the dais, please? For a very special performance. Sir, your wish is our command. What do you want? Please come. Huh? Any Okay. So we can have the performance in another 10-15 minutes. Meanwhile, because we are coming to the end of the program, today's program, officially, I request all of you to stand up for the national anthem, please. National anthem. Can we give them 2 minutes, please? Give them 2 minutes. Can. Okay, just 2 minutes. There's an official announcement that the Zumba class tomorrow starts at 6:15 and the walkathon at 7 o'clock from the hotel. So people who are involved in that, please make sure, take note of that. Can we have the national anthem now?
पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Bolo Bharat Mata ki. Right. Now we are done. We will just give the DJ team 10 to 15 minutes. And yes, we will have a cultural program with singers. I would call upon Dr. Srihari to take over from here for the cultural events, which will be followed by a gala dinner. Thank you everyone for your patience.
Here is an announcement for the members of organizing committee. We need to take an official photograph. Can I have all the members of the organizing committee on the stage, please?
someone has wrongly parked the car bearing number 5968 KA05MT 5968. Please remove your car, it's obstructing the roadway.
turn, press.
Good evening. Good evening, everyone. On behalf of the Cultural Committee, I welcome you all for an evening filled with music. Music is not just a leisure activity, it also is a therapy. It has the power to make us feel relaxed, rejuvenated, and even heal our minds. Music is the shorthand of emotions. It's the best vehicle for expressing our emotions, fury and emotions. This evening, we have with us Mr. Shashi Kumar, who is an engineer by qualification, but musician by heart. We also have Mrs. Anuradha, who has sung with many national singers. Also, we have our own Dr. Shekhar to entertain you all. So, without delaying much, I hand over the mic to Mr. Shashi Kumar. Please give him a big hand. At the end, we have a DJ also. So please be patient and over the mic to Shashi.
Thank you so much, sir. Good evening, all of you. This is the singer Shashi Kumar here, originally from Bangalore, qualified engineer and professionally and a singer. Along with me, singer Anuradha, and a professional DJ. Pawan is also playing DJ music soon after our live performance. So I would like to request Dr. Shekhar ji, Shekhar sir, to please come on the stage and sing a song for all of us.
both Hindi as well as Kannada, and two